もう、だって、もう、少し。
今ビデオ開始してる。Hello?
Hi, Rokoya. How you doing?
Thank you.
Yeah, let me get my camera here.
Can you hear me?
Yes, I can hear you.
Okay. When we start the lecture?
15 minutes.
15 minutes. Okay. I'm ready.
Okay. Are you the first presenter?
Pardon?
Are you the first presenter?
I'm not sure. Depends on Samet,
Oh,
Professor
okay.
Samet. Yeah,
Okay.
but I'm informed my lecture will start at 4 p.m. Japanese time. It's 9 a.m. Cairo time.
Okay. Do you have any groups that want to have webcasts?
Well, what?
We want to televise more from Japan. I would like to set up a group that we have regular meetings with Japan. Would you like to do that?
Yeah, depends on the because still I'm busy, so I have to manage my schedule.
Okay.
Yeah.
Okay, I'll just contact you when you think about it.
Okay.
Okay.
Yeah. Yeah. You know my email address.
Yeah, could you put it in the chat? I'm sure Sam, don't worry about it. Sam will have it.
Yeah. Yeah. If I'm available, of course I can make a lecture.
Okay. Okay,
Yeah.
I'll be back. Okay, I'll be
Okay.
back.
See you later.
Yep. Hello.
Morning, John. How are you?
Good. How you doing?
All good, all good.
Are you one of the first presenters?
No, I think I'm the third presenter.
Okay, I think one else is first. That's okay. Hey, Sam, are you there, Sam?
Good day, John. Yes,
Hey,
I'm
Sam,
here.
how you doing?
I'm fine. What about you?
You got some sleep?
Not much, but
Yeah,
enough.
yeah, I know. I tell you, you put a great group of people. Man, you get them. You get the good ones.
Yeah, but going after everyone is something like crazy. You are catching everything from everywhere.
Hey, listen, Manas is first. Manas is first. I have his video.
Okay,
I'm sorry.
I have not tried him, but I think he's not here. So,
Oh,
Professor Chandra, are you ready?
yeah, I can hear you. You want to have someone else first? Because I'm ready to
Uh,
put the video on if you want.
Chandra.
Oh, Chandra, you want him first? Okay.
Okay, yeah.
And then
If he is ready,
Manas, and then Manas.
yes.
Okay, I'll run Manas again. 'Cause
Professor Chandra, are you ready?
Okay, I'm running to Manas order
Morning,
now.
morning. Can you hear me?
Yes,
Morning,
I
Dr.
think
Smith. Can you hear me?
Anas is not ready now, so we will start with you if you are ready.
Yes, yes, I'm ready.
Yeah, okay.
Okay, just give us 5 minutes.
We got 5 minutes. I just wrote to Manas. I guess he doesn't have a good connection. People will come along. People tend to come in late. Dr. Yang Dong from China.
Professor Tanikawa, how are you? Thank you for accepting our invitation.
Hello, Professor.
Okay,
Yeah, can you hear me?
Ahmed.
Thank you. Good afternoon.
good
Thank you for your
afternoon.
invitation.
Professor Tanikawa, how are you?
I'm good. Thank
Fine.
you.
I am
Thank you,
fine.
Dr.
Thank you for your
Dr.
invitation.
Shagat.
Good to see you all.
Pleasure.
Yeah, I'm happy to be invited.
Thank you. Likewise.
3 minutes. Dr. Dilip, where are you from? You're from India, correct?
Yes, I'm from India. I'm from Cochin.
Oh, okay. I only know the big cities, a few of the big cities.
Yeah, this is way down south on the west coast
On
in
the
Kerala.
west coast. Oh, okay, near what's that tourist place called on the coast of India on the west? It's a tourist resort, big tourist resort. What's the name of that in India? I forget.
Goa?
Yeah, that's it. That's it. Go.
Yeah,
That's it.
Goa is sort of on the middle of the west coast. We
Oh,
are further
middle.
south.
You're further south than that.
We are further south.
Okay.
Hi, Dilip. Can you hear me?
Yes,
Yes.
Sharat. Hi, good afternoon.
Yeah, good afternoon. How are you?
I'm fine, thank you.
So are you going to speak first or should I speak first?
Your choice, I'm fine.
But
Uh,
as per the schedule, you are supposed to go first, isn't it?
yeah, I think Manas is first according to the list. I'm next after Manas.
Okay.
Then I think
So
you follow
maybe
me.
maybe you can start first because
Sure.
I was about to start because nobody else was there. So
Okay.
you can start first. Professor Samay, is that okay?
Yes, yes, sure.
Okay,
Okay.
Sam. I'll just introduce you, Sam. Okay, we'll start in a minute.
Sure. So I'm ready
Okay.
to start. Just let me know.
Okay.
I'm free.
Yeah.
And we can go on from
Okay,
there.
we've got a few seconds here. Okay, Sam, you ready?
Yes.
Okay, here we go. 10, 9, 8, 7, 6, 5. Oh, hold on. 5, hold on. I forgot something. Okay. 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett televising the 4th annual Skull Base Conference. We had a good turnout yesterday, and we hope to do the same today. I'd like to introduce you to Sam, the irrepressible neurosurgeon from CAIRO, Egypt, that's put together, I don't know how he does it, but he puts together these great cast of neurosurgeons. Welcome, Sam. It's all yours. Go ahead, Sam.
Thank you, John. Thank you all. It's second day of World Skull. Okay, John, thank you. Thank you all for joining us in our annual Congress. This is 4th year, and this is second day. Thank you all eminent speakers who have joined us in past years and our eminent faculty who joined us this year. And now we will start second day by Professor Benikar. Please start sharing your screen. Thank you.
Thank you. Let me share my screen. And are you okay? Can you see my screen?
Yeah, you want to make it presentation. There we go. Presentation mode. Yeah, press play. Yes, plus that.
That's right.
Yeah,
Okay.
perfect.
Okay, fantastic. Thank you. Thank you, Professor Samay. It's been a pleasure to be invited on to speak at this prestigious meeting. I know this has been a very, very exciting and nice meeting. So thank you very much for the opportunity. My talk today is on the medial sphenoid meningioma, and I come to you from the South Indian city of Cochin in the city of Kerala, in the state of Kerala. Now, as we know, meningiomas are among the more common primary intracranial tumors, and amongst those at the skull base, the sphenoid meningiomas are again among the more common. As we understand sphenoid meningiomas, as usual, as with any skull-based procedure, it's very important to understand the anatomy, the bony anatomy of the sphenoid, especially the region around the medial sphenoid wing, which is our area of interest, and especially the anterior clinoid and its various processes, the neurovascular structures that are in the vicinity, the optic nerve, the internal carotid artery, all the oculomotor nerves that pass through the superior orbital fissure to enter the orbit, and the dural reflections, which add to the complexity as they split as a two layers of dura. They split around the clinoid, and they form the dural rings that encircle the carotid artery. Now, this anatomy is of great importance as we understand the meningiomas that arise in this region, because as we know, managing this requires this very knowledge of this very intricate anatomy. The types of meningiomas here, they can take many different forms. The earliest classification given by Cushing into the lateral, middle, and the medial sphenoid wing. The medial sphenoid wing were those described as arising on the medial third of the lesser wing of the sphenoid and the adjacent areas. They can take different forms, as we know. They can be globoid meningiomas, or they can be very typical, or they can be something that is very characteristic in this region, the arm plaque meningiomas, which are also often hyperostotic, associated with the marked hyperostosis of the sphenoid wings. And they can extend to adjacent areas and cause corresponding problems. They can extend to the orbit, to the cavernous sinus, to the middle fossa, to the sella, and to the adjacent areas. So, a word about about the distinction between the clinoidal meningioma and the medial sphenoid wing. The clinoidal meningioma per se, these terms are often used interchangeably, but this is a very specific subset of the medial sphenoid wing meningiomas that arise from the anterior clinoid. The difference being in how they grow and they develop. The clinoidal meningiomas often have a narrow base centered on the clinoid, and they tend to grow upwards. They generally do not get into the cavernous sinus or extend towards the middle fossa, and they have this marked hyperostosis of the anterior clinoid. These tumors are very commonly classified according to Almefti's classification, which is determined by the site of origin of the tumor and consequently the relation with the arachnoid fold that extends down from there. The group 1 tumors are the ones that arise from the infromedial surface of the clinoid, where there is no arachnoid pouch, and these tumors often are very closely adherent to the adventitia of the internal carotid artery, making them very difficult to manage. The group tumors arise from the lateral and the superior part of the clinoid. They have a good arachnoid plane between the internal carotid and the tumor, and these make them easier to manage and to remove. Group 3 tumors are the ones that extend into the optic canals. So this is a very simple practical classification. There have been many other classifications over time, and the clinical presentation of these tumors depend upon how they extend and in what direction they go, typically with headache, raised pressure, raised intracranial pressure, cranial neuropathies, usually visual or oculomotor affection, seizures if they extend laterally to the temporal lobe, and proptosis and diplopia as they extend forwards into the orbit. The radiology, as usual, is diagnostic, the MR becoming the hallmark of investigation. Now, a good MR can help try to differentiate between a group 1 and a group 2 tumor, depending upon the plane or the identifiable plane between the internal carotid artery and the tumor. And this can potentially prognosticate whether this tumor can be removed or whether there is going to be a residue left around the internal carotid artery. The management of these tumors, there are different ways, as most commonly it's surgical excision. For small tumors, there is also a potential role for stereotactic radiosurgery, but these are usually reserved for residual or recurrent tumors in this region. And for small tumors that can be incidentally found, sometimes there may be a role for observation in them. The surgical excision is the hallmark, is the standard mode of management for these tumors, and the steps are fairly uniform. The craniotomy, there are different types of craniotomies that can be used to access these tumors. Classically, there's a pterional or a mini-pterional craniotomy. Then, depending upon where the tumor extends, additional extensions like the FTOZ or the supraorbital approach can be, the supraorbital osteotomy can be added on. The skull base access with epidural bone removal, which is a standard procedure with any skull base lesion, which is absolutely important in this kind of tumor, completely flattening the sphenoid and flattening the roof of the orbit. Anterior clinoidectomy, optic canal deroofing to free up the optic nerve. The Sylvan and once a durotomy is done, Sylvan fissure opening, identification of vascular anatomy, devascularization, debulking, and the dissection and capsule dissection and excision. A few cartoons to show to illustrate these various steps. I will skip these and go straight to a video that illustrates this. Now, this is a fairly large tumor with the internal carotid and the branches engulfed within the tumor. So as you can see the steps, now this is my preference. Once a dura is open, I prefer to open the Sylvan fissure widely. And the first thing I do is to identify the vascular anatomy, identify the middle cerebral as it emerges from the tumor distally. This gives me a clue as to the location of the vessels. And once this is done, the dissection is carried further down. The tumor is separated from the brain, and then once we see enough of the tumor, detachment of the tumor from the skull base, and progressively detach, debulk, to gradually reduce the size of this tumor. Now, as we debulk this tumor, having the vessels, having the middle cerebral artery in control allows us to trace it down to the vessel that is within the tumor, as the lobules of tumor that surround the vessel are identified. You can see here the internal carotid artery comes into view as a tumor uncapped is around that is uncapped. So that is the anterior cerebral artery, the middle cerebral artery here, and the optic nerve is right there. So once the vascular anatomy is identified, it makes it the surgery can proceed, and again the same procedure goes: disconnect, debulk, dissect, and progressively the tumor is removed. Now, as the internal carotid artery is dissected, the branches from the internal carotid artery, the posterior communicating and the anterior choroidal, are identified as they come off the main stem of the ICA, and these are progressively dissected through. And this is probably the most difficult part of the dissection, where the vessels, the fine vessels, they have to be protected, and these are very meticulously traced through. And even if it means if these branches are adherent within the tumor, leaving behind a little bit of tumor adherent to these branches is not a problem at all, rather than risk injuring these branches, which can cause devastating deficits for these patients. Again, slowly and progressively, the tumor is gradually debulked and taken out. These are often very fibrous tumors, and it needs they have to be dissected, mobilized, and often cut away with a scissor to gradually mobilize these tumors. So all around, these tumors are dissected, and various parts are bit by bit, these are removed. And you can see the branches that are running through. This is the posterior communicating that is arising from the internal carotid artery, running through the tumor, and using sharp dissection, this tumor is gently shaved off the vessel, protecting the branches. And this is absolutely crucial, to protect all the branches that arise from the tumor. And leaving behind a small nubbin of tumor, again, is not a problem at all. This is at the end of surgery, complete resection, the optic nerve, the pituitary stalk, the internal carotid artery, and its branches, all identified. Now, this lady actually showed a good resection initially, but 5 years later had a recurrence of tumor, which was treated by radiosurgery. This is another short video showing the anterior clinoidectomy. I prefer to do an extradural anterior clinoidectomy for all these patients, but sometimes when you have a very bulky tumor, it may be difficult to mobilize and reach the clinoid, in which case the clinoidectomy can be completed intradurally once the tumor is debulked. Unroofing the optic nerve is very, very important because this mobilizes the optic nerve from its tether and allows and reduces the strain on the optic nerve. So this is again I follow very similar steps in all these cases, and it is, and again, as ever, mobilize the tumor, detach it from the dural attachment, mobilize it, identify the vascular anatomy and the branches that are in the vicinity of the tumor and the optic nerve, and if the tumor spills over, gets attached to the edge of the tentorium, the third nerve, which can be seen here, and all these structures have to be preserved. This is again after tumor removal. Again, the end of the surgery. So this is a scan afterwards. So this is another case very similar to that. I will not go into the details. A few more examples of these tumors, both large, small, of different types. Out of the 23 patients whom we have operated, we had no mortality. 9 patients had significant visual deficits at presentation, out of whom 3 improved, 2 remained stable, 1 worsened, and we lost 2 to follow-up. 5 out of the 23 needed to undergo radiation therapy. They were either given upfront when the histology was atypical, and or they were given at progression. In 2 patients, it was a grade 1 tumor recurrence, and 3 of them with grade 2 tumors. Now, sometimes you encounter a patient who has been partly decompressed and receives radiation and then worsens, but these tumors have to be completely excised. Having radiation given makes the dissection more difficult and the consistency of the tumor more stringy and difficult. But however, this still can be done. So in conclusion, these are common skull-based meningiomas. The involvement of the neurovascular structures and the size can complicate management. The outcome depends on the visual status and the vascular involvement at presentation, and systematic surgical approaches and meticulous microsurgical dissection will help achieve a good removal, an excellent removal in most of these patients, and very gratifying outcomes for both the patient and the surgeon. Thank you very much.
Okay, Sam?
Thank you, Professor Banical, for this excellent presentation.
Thank you.
Is there any question? We will shift to next speaker, Professor B.S. Chandra. Please start sharing your screen.
Okay, looks good.
Am I audible?
Yes,
And also-
it's good. It's good.
So thank you, John. So once again, congratulations to my dear friend Sameh for organizing this wonderful Congress online. I think it's quite a remarkable feat getting across so many speakers to put together such a good program. So I would be speaking here on my experience of tackling severe basilar invagination. In fact, I would call them as extreme basilar invagination with atlantoaxial dislocation, with the particular reference to the technique of DCER, which stands for distraction, compression, extension, reduction, which is my own technique which I have developed. It is well published and well practiced in several centers, both nationally as well as internationally. So this is the institute where I work, the All India Institute of Medical Sciences from New Delhi. I have no disclosures. So these are the kind of pathologies which we come across. So when you see such extreme pathologies, you start wondering whether it can get more severe than this or more difficult than this. And you can find a very severe degree of basilar invagination. And you can see here that the dens is completely turned backwards. In fact, leaving practically no space for the spinal cord. And that gives us a thought to think whether that can be, these cases can be done even transorally, because that itself would be a big challenge. So what is the technique which we can use in order to reduce and decompress such severe pathologies? So the technique of DCR is now registered with a US patent, and I have done more than 500 cases using this technique. It's become a very standard in my unit and department, and also several departments across the country. And when we consider when we consider the craniovertebral junction, it is a very vital junction. It is balanced on the, it is balancing the head on the top of the neck in a more delicate manner than Atlas is holding the earth. And anytime it can dislocate. In fact, it's a miracle why it doesn't dislocate physiologically during our time period. But when it does, it produces a very severe anomaly, which is very challenging to treat. And for several years, we were seduced by this image, the sagittal image showing compression in the midline. And we were moved away from the facet joints until Professor Goyal brought us that to the notice. So we are all well aware of Professor Atul Goyal's work, seminal work on the C1, C2 fixation. But the fact is that the C1, C2 fixation can only reduce anomalies where the C1 arch is not fused mostly. And B, it can only provide a technique of distraction by putting a spacer. It doesn't allow any other kind of maneuvering to happen. So DCR technique is something which takes it beyond just screw fixation and putting a spacer. It deals with 3 axes of maneuvering, both front to back and as well as in the axial sections, which I will be showing you shortly. So the DCR algorithm comes under various subsets. The first technique which we developed was adding a motion in the sagittal plane. So the fundamental technique of DCR is that you have the dens causing compression, something like this. And these are done in cases where the C1 is occipitalized. So C1 is fused with occiput. So whenever the C1 is not occipitalized, those are the cases I still suggest that we should do Professor Goyal's technique. But otherwise, DCR is meant for those severe anomalies, basilar invagination, atlantoaxial dislocation, when the C1 arch is fused with occiput. So when we put a spacer, we have to understand that the basilar invagination to some extent will be corrected, but not the atlantoaxial dislocation. In order to correct the atlantoaxial dislocation, we need to apply compressive forces between the OC1 and C2 so as to convert the spacer into a pivot joint, so as to allow an optimal reduction of not only the atlantoaxial dislocation, but also the residual basilar invagination. So this is the fundamental technique, and it is like Archimedes trying to lift up the whole earth using a lever mechanism. It is very similar to that of the DCR technique. Now, there is a very important caveat to this. If you are not able to reduce it completely, if you increase the height of the spacer, that again gives you a very good margin for reduction. So increasing the height of spacer by 1 time allows you to increase the margin of reduction by almost 5 times, which I'm going to show you some of the examples. The other major discovery was discovery of pseudo joint, which again we have described. And these are some of the papers we published, and we described 2 types of pseudo joints. So in type 1 joint, there is a partial articulation with both the true joint as well as the pseudo joint, because the true joint is not completely vertical. But in type 2 joint, the true joint becomes totally vertical. So as a result, the entire weight of the cranium is only going upon the proximal and the superior surface of the pars. We also did significant work to show what could be the underlying genetic cause for this. And in this, we published this paper where we showed that 80% of the cases which we operate, particularly in the Indian scenario, have mutation hits in the FPN1 gene, which encodes the Marfan syndrome. But it's not a complete Marfan syndrome kind of a mutation. It's about 80% hit. And that leads to weakening of the joints. So based on this, we proposed that there should be weakened ligaments as well as sloping joints. Both are necessary for the atlantoaxial dislocation and basilar invagination to develop. So are there any still indications of transoral odontocectomy? Yes, there are, as we have written in this editorial in neurosurgical focus. So if you have cases where you have clavicle segmentation anomaly or infective cases like tuberculosis, which we still see in countries like India, we have to do an anterior decompression followed by posterior fixation. So this was the original paper which we published more than 10 years back. And since then, we have done more than 500 cases. And these are some of the other papers which we have published. And again, this was an editor's choice in journal CNS and neurosurgery. So a few other papers, again, another article published in Neurology India. So how do we do? So we do not apply any traction. So traction may be applied only during surgery. Now, there is no conflict of interest with Dr. Goel's technique. So when the C1 arch is not fused, you need to do a C1, C2 with or without spacer. So there is no question about it. Now we use the technique of DCR only when the C1 arch is fused. So conditions like this, because these are the conditions which are associated with severe basilar invagination and atlantoaxial dislocation. So fundamentally, with our genetic studies, we have understood that the ligaments are weak and the joints are sloping. And these are the two factors which keeps on allowing the dents to keep on progressively slipping inside. And that is a cause of pathology. And sometimes we have seen it coming down even up to the level of C3. Now, 10 years, this is more than 20 years back, I was very proud of doing a transoral surgery. But now when we have techniques like DCR, I think it would be a very sad story if we still have to do transoral for such cases. So the idea is to prevent a sad story like a transoral and have an happy ending where not only you can decompress the cord, but also reduce the deformity and correct the deformity using only a single posterior approach. We also described a new algorithm for DCR, which is called as extra-articular distraction. So when we look at complex anomalies where the C1 arch is fused with basilar invagination and atlantoaxial dislocation, and we take a parasagittal cuts through the joints of the CT scan, we think that what we see is very, very complex and we cannot understand. But once we know what is the anatomy we are finding, it becomes an anatomical surety to find out what exactly is wrong with it. So we have to understand that when the joints slope out, the cranium comes and rests on the proximal and the superior surface of the pars. So in which case you have formation of a true joint and then formation of a pseudo joint. So whenever you see a complex anomaly, all you have to do is identify the true joint and then you will be able to see the pseudo joint. So this is a type 1 joint where there is articulation with both the true joint as well as pseudo joint, whereas this is a type 2 joint where the true joint is completely vertical and the entire cranium is only resting upon the pseudo joint. So whenever we use the pseudo joint only to reduce this anomaly using the technique of DCR, that is what we call as extra-articular distraction. So you can see here there is a very severe atlantoaxial dislocation with basilar invagination. And we have placed the spacers only in the pseudo joint. And using that as a pivot, we have completely reduced it. So the technique of using spacers in the pseudo joint is called as extra-articular distraction because you're not using the true joint for spacer mechanism. We then developed this unique screws which hold on to the spacers so that the spacers do not slip away. Now we come across to a third mechanism. We have talked about two mechanisms. One is putting a spacer and distracting. Second mechanism is compressing the OC1 and C2 together in order to reduce the AD. Now in severe anomalies, for instance, you have the severe anomaly where there is a basilar invagination up to the lower part of the C2. Over here, even if you put a spacer and correct it, you'll find that the AD has not significantly corrected. So what is happening here? So what is happening here is that there is a retrolisthesis of the C2. So whenever you have a severe craniovertebral junction anomaly, there is a retrolisthesis of C2 over the OC1 and the foramen magnum. So this is a photoshopped image that this is what you would like to do here. You would like to provide an extra mechanism whereby you need to push the C2 forward in order to reduce the AD so that you can get an optimal reduction of the deformity. So this is what you need to do. So the idea is, could we develop this mechanism? And in collaboration with Medtronic, we got it patented in the US. We developed this universal reducer. Now, if you see the universal reducer, there is a wire mechanism which allows you to provide compressive forces between the dens as well as the C2. In addition, you have this pivot here and a screw, which is called as a C2 translator, which can push the C2 forward. So for the first time in the literature, we were able to provide 3 axes of motion or movement. A, by giving a spacer by which we can do the distraction. B, by compression, by allowing a compression between OC1 and C2, which reduces the AD and BI. And C, by allowing a C2 translation by pushing the C2 forward. So this is the previous case where we were not able to reduce. And again, we came across a similar case. Now, in this case, we were able to apply the universal reducer and push the screw forward, by which we were able to reduce the AD and BI very, very optimally, unlike the previous case. And this is how the universal reducer looks like intraoperatively. So a few more examples. Now, in this case, again, it's a very severe BI with AD with, again, syrinx. You can see here, large syrinx. Now, in this case, initially, we put a 7 to 9 millimeter spacers. But despite doing complete compression, we were not able to reduce the AAD. So what should one do here? Now, if you remember in one of the first images, I had shown you that if your spacer is not enough to provide complete reduction, you need to increase the height of the spacer so that you will get at least 5 times more the margin for reduction. So that is what we did here. So when we did not get a satisfactory reduction with 7 to 9 millimeter spacers, we increased the height to 10 to 11 millimeters. And with that, we were able to reduce it satisfactorily. So whenever you don't get a satisfactory reduction, you should increase the height of the spaces. And we have increased the height of spaces up to 18 to 20 millimeters. And we have done it using the intraoperative neuromonitoring, D2-wave monitoring, and we have not found any deterioration. We find only improvement actually. So another example, you can see again very severe BI with AAD, the cord is practically absent. And again, you can see that the true joint is vertical, where the pseudo joint is the one which is articulating with the cranium. So initially, we used a 10 millimeter spacer. We were able to reduce the BI, but not so satisfactorily. But when we increase the height of spacers to 16 millimeters, that is when you can see we were able to satisfactorily reduce both the AAD as well as the BI. So that is the key that is the next thing to reduce. Next technique to reduce the AAD and BI satisfactorily. So finally, we added a universal reducer, which I have shown earlier, which added a third motion. So this is an example of a patient who underwent a very horrible wiring outside. He had a severe, so you can see it's a type 1 joint, partly pseudo joint, partly true joint, and some wiring was done outside. So this is the pre-op, this is the post-op. So we put spacers. And in this case, we had to again use the universal reducer to push the C2 forward. So when we do that pushing forward, again, it reduces completely. Now, DCR in our experience is a very stable process. It immobilizes the CV junction completely without any micro movements even. And that is what leads to a solid bone fusion. So whenever you do a CT scan, between 6 to 9 months, you'll find a solid bone fusion happening there. So that's why it's a very stable, it's a very powerful technique. And not only that, because it corrects the cervical deformity apart from decompressing the cord, it creates a plumb line correction of the entire spinal column. So it leads to an optimal correction of all the curvatures. So if we do not reduce this deformity completely in CV junction, the entire cervical deformity, these are young kids, they can go ahead and have a high risk of developing degenerative spine diseases elsewhere. So that's the reason you need to do a holospinal correction. And that is possible with the technique of DCR. So another example, again, complete reduction here. You can see this extreme AAD, the cord is practically absent. And again, using the technique of DCR with the universal reducer, not only we distracted it, but we pushed the dens forward using the universal reducer, and you can see the deformity reducing beautifully. I will skip the video. The reason is that we don't have much time here, but I will end with this case. We have used the variation of DCR to even treat old displaced C2 fractures. So if you look at deformities like this, where there is a C2 fracture, which is an old displaced fracture, logic would obviously dictate that one should do a transoral, but we used a variation of technique of DCR whereby we reduced it posteriorly. So this is a new technique which we have published recently. And in this technique, what we do is we drill the C1 lateral mass completely. So the C1 lateral mass is drilled completely bilaterally, and we put a spacer now which articulates between the C2 as well as the between the occiput as well as the C2. So we drill out the C1 completely and we put a spacer in space of that, and then we reduce it, and that's how we can reduce it. So my whole experience has been more than 1,500 cases tackling with craniovertebral junction anomalies for more than 25 years now, and it's been a long journey. It's been taken me to places. So this was an oration which I gave in South Korea, and they launched a wine in the name of DCR. And so it has been worth it because it helped me to travel to make new friends and strengthen old ties, like with our friend Samay here. So thank you very much for giving me this opportunity. I hope my slides were visible and I was also audible. I will stop sharing now.
Thank you, Professor Chandra, for this excellent presentation and for innovative management of such cases. Is there any question? Thank you. And now we will shift to next speaker, Professor Tanikawa. Please start sharing your screen.
Hello, everybody. Can you see my screen?
Yeah, yeah. Could you put it in present? There you go. Perfect.
Okay.
Yes.
Let's start. Okay. Thank you for your invitation, Professor Same. It's my pleasure to share my experience about the cerebrovascular lesions, especially intracranial aneurysm. Today, I would like to talk about the vascular reconstruction for complex cerebral aneurysms and microsurgical approaches for the intracranial aneurysm to treat the aneurysm safely. So nowadays, the background of the cerebral aneurysms, due to the development of endovascular treatment, it exterminates surgical clipping aneurysms. But in endovascular treatment, the higher recurrent rate is observed, and approximately 20 to 30% or more if the aneurysm is larger than 5 millimeter. The recurrent rate is increasing to approximately 50%. And additionally, the patient who referred neurosurgeons are complex cases, previously coiled, recurrent, giants, thrombos, uncoilable, or previously clipped, etc. On the other hand, we have already treated the cavernous giant aneurysms or intracranial internal carotid giant aneurysm. We have been treated these lesions with a high flow bypass as a therapeutic internal carotid occlusion. But the flow diverters as well, the flow diverters exterminate such high flow bypasses. However, the intracranial revascularizations must be done for peripheral small arteries. So I'd like to talk about it. The programs regarding surgery for complex aneurysms, always the most important problem is ischemic complication, especially in the perforating artery territories like choroidal, ventricular striate, anterior perforating arteries, which is coming from a PCOM, medullary branches from vertebral arteries. But these complex aneurysms always difficult to grip because of size, because of its location, and especially as thrombus, large or giant aneurysms are contraindication in for endovascular treatment. This is a principle. Now I'll show you the representative cases of the microsurgical approach. This is a right side unruptured PCOM aneurysm, which I am separating distal cerebral fissure. I usually perform the cerebral fissure dissection from the distal to proximal. Now, all the M2, M3 segment is exposed in a distal cerebral fissure. MCA bifurcation is confirmed, then the M1 horizontal segment is followed toward the internal carotid. And if the patient have the aneurysm in the carotid PCOM aneurysm, the brain spatula can hold the temporal uncus like this. And the arachnoid trabeculus between the not only aneurysm but also oculomotor nerve and the temporal could be incised sharply like this. Then you can secure the retrocarotid space to manipulate aneurysm or to detach the important perforators like anterior perforating artery in this case, the very proximal of PCOM, which includes the proximal neck, can be confirmed like this. This is a very important approach, and this is a fundamental skill to approach to intracranial aneurysms. And in the other hand, the patient who has the intracranial aneurysms, they usually have the severe atherosclerotic changes. Sometimes intracranial supracranial carotid has a severe plaques or calcification due to the atherosclerotic changes. Usually, securing the cervical internal carotid, external carotid, common carotid like this is a safe way to secure the proximal control. Another major approach is anterior interhemiscal approach. This is the approach to unruptured ACOM aneurysm, 69-year-old male, which I have just done 1 week ago. Unfortunately, the aneurysm is projecting the superior posteriorly. So I expected it is too difficult to confirm the hyperthermic branches. As I expected, you can see here, this is the left A1 is secured to perform the detachment of anterior thumb perforating artery like this, which is so strongly adherent to the aneurysm dome and the neck here. Very thin part of the aneurysm has a strong adhesion of anterior thumb perforating artery like this. I am securing the right side neck by performing the sharp cutting of the arachnoid trajectory. And I am confirming the left neck, but here, another very tiny hyperthermic branch is adherent, which is coming from the left A2 proximal. Now I am trying to detach this small perforator in order to save the hyperthermic function, especially the anterior commission something to avoid the memory disturbance. Now, very tiny connective tissue is held on the aneurysm, and indirectly you can detach such a tiny perforator from the aneurysm dome. Here you can see I could secure the space between this tiny perforator and the aneurysm. Then it makes it possible to put the first grip to occlude the aneurysm tentatively. And right side larger hyperthermic branches, which was adherent, could be spared, and a tiny perforator spared as well. And now the temporal occlusion time was more than 5 minutes, so I release it and confirm. Unfortunately, the left neck is still remained, so I am replacing the first grip to occlude the left neck. Now, you can confirm almost the neck is occluded. But another problem is the still tiny branch is adherent of the aneurysm. During dissection, the aneurysm has a small hole and small bleeding comes even the neck gripping. This means that the thinner part still patent. So after detaching all the important perforator, I could coagulate aneurysm and occlude aneurysm completely. And all the important, the tiny perforator, even such a tiny perforator is patent in ICG video angiography. Now, this is a final view, and the dura is closed watertightly. And opened frontal sinus managed with the abdominal fat graft. And this is a CT angiography immediately after surgery. And this is the illustration by my young colleagues, how the anatomical structure of ACOM complex was, and it is illustrated. Another example, this is a 69-year-old man, a female, the larger ACOM unruptured aneurysm. Here, this is the separating interhemisc fissure. The aneurysm is very big, and the dome is very adherent to the right A2, as I expected. In this case, I expected that the accidental apparent artery of A2, either one might be happen. So I made A3, A3 side-to-side anastomosis beforehand. And after exposing the aneurysm, both A1, A2 is occluded, and the severe adhesion of aneurysm to the right A2 is sharply detached like this, and try to do a neck clipping here. And I remove the temporary occlusion of a parent artery, but here you can see right neck has a very thin wall, almost breathing, but not yet breathing. So I decided to reinforce this very thin part in order to avoid the delayed rupture here after the neck clipping, because by the neck clipping, this part has a pulling tension by the neck clipping like this. So the right A2 and the neck should be directly stitched, and this part should be reinforced. Now, with this condition, you can complete the neck clipping angioplastically, and you can confirm all the patency of the important perforators. The diffusion image immediately after surgery shows no high signal area, even in the hypothalamus, anterior commissure, anything. When we perform the clipping or surgical clipping for complex internal carotid aneurysm, the reticular suction decompression is very, very useful. This is a 67-year-old female. This surgery is performed in 2008, approximately 16 years ago. Now, the aneurysm is elevating the left optic nerve, and the patient came with a left visual disturbance. As I mentioned, the cervical common carotid, external carotid is secured, and the suprathyroid artery is cannulated by a 5 French infantile feeding tube in order to perform the reticular suction decompression through the suprathyroid artery. Anticrinoidectomy has been done, and C3 internal carotid is secured epidurally. Then you can open the dura, frontal dura, toward the optic canal, opening the optic canal. Next, harvested the frontal branch of STA is on a smooth to an M3 segment in order to secure the blood flow as a backup bypass during the temporary occlusion of neck clipping. And here, during a dissection of the dural ring, I made an injury of the ophthalmic artery like this by scissors. But the releasing aneurysm, the bleeding could be stopped. Now, external carotid, common carotid, and the intracranial ICA distal to the aneurysm is occluded. Then you can perform the reticular suction decompression through the suprathyroid, and the aneurysm is decompressed, and optic nerve could be detached with this procedure, and injured part of ophthalmic origin could be repaired with direct stitching like this. I used 8-0-prolene here. Now, the decompressed aneurysm by a reticular suction decompression easily clipped like this. And aneurysm, the optic nerve is decompressed, and CT angiography immediately after surgery shows a complete neck clipping and the diffusion image shows nothing. This is a 50-year-old female, ruptured aneurysm left, the carotid aneurysms, supracrinoid proximal to PCOM aneurysm ruptured. As well, the cervical neck internal carotid, common carotid is secured, and the dura is open. The temporary hematoma is evacuated, not to rupture the aneurysm, and carefully expose and rinsing the subarachnoid clot in order to expose the M4, M3 segment, M2 segment of MCA to perform the STMC bypass. This is a super acute surgery of subarachnoid hemorrhage. Even in acute stage, you can perform the STMC bypass like this to do the backup bypass for the temporal occlusion of internal carotid. Now, the anterotemporal artery is detached from internal surface of temporal lobe. Then the aneurysm is exposed like this, and you can secure the internal carotid distal to the aneurysm. I am looking for the PCOM just posterior to the aneurysm. Now, both A1 and M1 is occluded, and common carotid, external carotid occluded. Suction decompression is performed. Then you can make the space to put the temporal clip on the internal carotid distal to the aneurysm. Then the anterocorridal artery secured by the STMC bypass and the ACOM cross flow. Now, fortunately, in this case, the anterocrinoidectomy was not necessary. Without anterocrinoidectomy, you can perform the reconstructive neck clipping with the fenestrated clips. Then ICG angiography shows the good obliteration of aneurysm and the good patency of the internal carotid. And additionally here, there was a tiny aneurysm at the corridor artery bifurcation. Then all the aneurysm is occluded and the patient recovered well. This is an example of the 74-year-old female, the previously coiled to an unruptured PCOM aneurysm like this. Here, you can see the coiled thrombosed giant PCOM aneurysm is not feasible to perform a neck clipping. So I decided to perform the therapeutic internal carotid occlusion with the high flow bypass using a saphenous vein graft like this. Between the external carotid and the left M2, I have made the high flow bypass. And the high flow bypass provides a good flow as the flow reversal toward the anterocorridal artery. The proximal occlusion of internal carotid in the neck could be performed, and aneurysm is decompressed with the flow reversal. The patient tolerated well and discharged with no neurological deficit. Another case, this is a previously clipped 78-year-old female. The previous clipping was done 4 years ago, but unfortunately, all the clips is slipped out like this, and the aneurysm recurrent, and a patient and a patient daughter came to me and begged to reoperate. Unfortunately, in a previous surgeon, the sacrifice is the superficial temporal artery already. So the remained the superficial temporal artery in the skin flap is harvested in order to perform the real-time MCA monitoring, pressure monitoring to the M3 segment, and I carefully exposed the Sylvian fissure and the aneurysm. But too much clips is so adherent as a granulation. So I have done the saphenous M2 bypass first, then the saphenous vein graft is guided toward the neck. And I am doing the saphenous, the left external carotid end-to-side anastomosis to make the high flow bypass like this. Then the STA is cannulated to perform the MC pressure real-time monitoring. Now you can observe the MC pressure and the systemic pressure real-timely. Then I am trying to remove the previous adherent clips. This removal of clips on the aneurysm is so scary, but without this, you can't occlude the aneurysm as well as you can't secure the choroidal arteries. This is a expected rupture. So immediately my assistant occluded the common carotid, and I am doing the point sucking, and the assistant helps me. And in this case, still a lot of clips remain, so the rupture point should be occluded with the direct stitches with running suture like this. I am using 8-0 prolene like this. And then you can stop the bleeding, make the aneurysm unruptured. And now at this moment, you can open the high flow bypass to secure the blood flow. The temporal occlusion time approximately 5 minutes, no problem. Then the MC pressure monitoring shows the good working of a high flow bypass with the appropriate blood pressure. Now, in the neck, I am incising internal carotid and cannulating the 18 gauge needle tube, and in order to perform the lateral suction decompression. At this moment, the distal internal carotid could be secured, but the previous clips is so adherent to the M1 like this, so it was difficult to confirm the choroidal artery, but fortunately, I could secure the choroidal arteries. You can see choroidal artery is a rising aneurysm itself at the distal aneurysm here, but I could secure the anterior choroidal artery, and the choroidal artery has a blood flow through the high flow bypass. And this is the proximal clip to trap the aneurysm to secure the PCOM. The PCOM is secured by the anterograde flow, and the ICA is opened. The anterograde ICA flow can flow the PCOM, and the retrograde high flow bypass flow feeds the choroidal artery. And you can see the aneurysm could be completely trapped and blood flow secured by a high flow bypass to the left hemisphere. The diffusion image shows no new high signals. In a high flow bypass, the graft placement, graft route is very important. We need to understand that the anatomy in subtemporal pterygoid muscles. The graft must be run just medial to a temporal muscle, just lateral to a lateral pterygoid, then coming down to the medial pterygoid muscle, penetrating it. Then the graft should be come out to the digastric muscle. Then the graft can be anastomosis to external carotid like this. This is a very important placement of the high flow graft. On a CT angiography, after surgery, you can observe the graft is the lateral to a pterygoid, medial to a temporal muscle. Here is a mandibular in the lower the slice of a CT scan. The graft is running just medial to the mandibular. this is the correct course of the hypobypass when you use a submandibular route. So I think it's a time to finish my presentation. So I skip this. So in conclusion, the revascularization still remaining to treat the complex aneurysms. So neurosurgeon have to train continuously, not only microsurgical approach, but also the microanastomosis. And we need to understand the anatomy to perform the exact neurosurgery. Thank you very much. And the information, if you have an interest of the live surgery course, I held the live course every July next year. The Saturday 5 we start the live course 2025 July. If you come, you are welcome. Thank you very much.
Thank you, Professor Tanikawa, for this excellent presentation and insightful videos. Is there any questions? Thank you, sir. And now we will shift to next speaker.
Thank you.
Thank you.
Dr. Bahar. Please start sharing your screen.
Good morning. صباح الخير. Let me figure it out. Hello, it's my turn, right? I think it's my turn, isn't it?
Dr. Bahar, then you, Professor Tianmin. Thank you.
Okay. Thank you, Professor Sami, and I will show my screen. And I think he did not get the point. I think is my screen, is it clear? Did everyone see my screen? Good morning.
Yes, we need to be on presentation mode. There you go. Play. Yeah, perfect.
Right. First, good morning. Thank you for the invitation, Professor Sami, and thank you, John, for this wonderful meeting. I will shift you away from Professor Tanikawa presentation, which was very excellent, to switch you back to the tumor and the skull base, away from vascular this time. So my presentation is about skull-based tumor in the context of evolution in radiosurgery. My name is Bahadin Mohsen. I'm a consultant and neurosurgeon working in Saudi Arabia in Dr. Sulaiman Al Habib Hospital. So I have no disclosure in my presentation. First of all, there is no routine skull-based tumor. Many of the previous presentation, we just show I would say a lot of nice straightforward cases, but no one speak about the recurrent tumor. No one speak about, I would say, extraordinary tumors. So some historical perspective, I went to some places. There is a good neurosurgeon, Harvey Cushing. He's a very excellent brain tumor surgeon, and he's utilizing the up-to-date technique in all his places, from the functional MRI to the navigation-guided MRI to the intraoperative MRI to the awake surgeries. So this is one of the wonderful places that I visit and get some training inside the United States. On the other side, we have some historical legacy in my country, my home country, Jordan. We have been having the neurosurgery service in our country for more than 70 years. Started with the Dr. Anton Tarazi in 1950s. followed by establishing the first neurosurgery unit in my country, Dr. Ishaq Maraka, like 50 years ago, where he did some transsphenoidal and spinal surgeries. He had established the first unit with around 650 cases per year. And Apocalypse, he was, I mean, one of the old ancient Arabic neurosurgeon who did the first trephination and I would say like the craniotomy. All right, so I will, before I go to the details, I would just like to revisit some of the fundamental skull-based technique to reinforce the fact of the skull-based dissection and its application on our in our like daily surgical cases. As you see in the first picture, this is the anterior skull base. Starting anterior from the olfactory groove, cristagali, and the planum sphenoidale, which consists the roof of the sphenoid sinus, and the tuberculum sella. And the other picture is for the key structures in the middle cranial fossa. So my presentation basically about the anterior and middle skull base. Again, this is a view that so many neurosurgeon has shared, I would say, similar slides. As we see, this is a completion of OZ in the first picture, then the peeling of the middle cranial base posteriorly to anteriorly, followed by cutting of the middle meningeal artery and exposure of the Gesserian ganglia quasi-triangle, the GSPN, I mean, after peeling. And the last picture is for the anterior petrexectomy and how much is enough to have the proper exposure of the not only the middle fossa but the key structure of the posterior fossa. As you see, there is a lot of literature about how much should we take of the petrous apex in this cadaveric dissection. I think I would say around 1 centimeter in depth is good enough to see the 7-8 complex and the trigeminal nerve. Again, this is a paper that we did during my training time. We dissected the carotid artery inside the cavernous sinus, but this is, as you see, this is an extensive dissection that we don't do, and at least, I mean, in the real life, but it's very important for the, I would say, the research standpoint. As we see in the first picture, the petrous as it's across the carotid artery as it passes as a vertical segment in the petrous bone, then the posterior bend in under the foramen lacerum, as we see the geniculate ganglia and its relation to the carotid artery, and followed by the precavernous carotid artery. Then we can go to the cavernous carotid artery branches as depicted in this picture. As everyone see, this is a clear dissection for the cavernous sinus, shows all the branches of the cavernous carotid artery starting from the posterior bend, vertical segment, horizontal segment, anterior bend, and the supraclinoidal segment of the internal carotid artery. We described in this paper the superior lateral trunk. I would say it's not really well demarcated, and we demonstrate all the blood supply of the cranial nerves inside the cavernous sinus. So this is, I would say, it's very important to read and very important to apply, so we can really have like a real anatomical navigation when we operate inside or around the cavernous sinus. I mean, we have to believe that we need to update our techniques from time to time. What was acceptable? This is like pictures by Walter Dandy. It's a well-known American neurosurgeon. I mean, some techniques was described in the books 50 years ago. It was very acceptable at that time, but we need to change our perspective, like I would say, from time to time. So again, the management of the skull-based cases, it's a personalized approach. I would say, like, you cannot, like, I would say, like, make guidelines all the time. I mean, some of them, like, we see guidelines from the North American skull base, from the European Society, but I would say in most of real life, you find yourself you find yourself just like trying to find the proper approach for these cases. So it always there is always some factors that play a role, like the tumor size, whether it's malignant or benign, the size of the tumor, and the degree of the invasion of the critical structure. Overall, I would say there is an observation option, there is an surgical resection open or endoscopic approaches, stereotactic as adjunct or as an upper-front approach, and sometimes multidisciplinary. I'm not against, despite being a skull-based surgeon, I also believe in applying technology in my cases. One of these cases is the gamma knife. It's minimally invasive, same-day procedure, and we can reach deep lesion. This is a paper that we did during my time, during my training time. It shows a small meningioma in elderly patient, extremely sick. It was a growing tumor that we just like did a gamma knife. Despite it's a very small tumor, it's an easy, quick access to do surgery. But if this is, I would say, my head or one of my relative head, and he's like extremely sick, I would choose, I will accept to use the gamma knife as an option. The paper came about the safety of a fractionation, not to use as single day treatment in like we instead of doing, I would say, 4 or 5 days of treatment in a small fraction for this lesion. Again, this is another paper that came with a well-renowned neurosurgeons around the world, multi-center, showing the safety of the gamma knife radiosurgery, 10 years with a good local control around the 80% when we apply gamma knife in trigeminal schwannoma. I would say again, the application would be for the extremely sick patient growing small size schwannomas. This is one of my patients that with, it's like a plenum sphenoidally meningioma with a bilateral optic canal invasion. Like in this case, it's very hard to apply. There's no room for the gamma knife, specifically if you have a PL invasion. This is the approach and the technique that apply. It's the retractorless skull base. I would say I will just like do a more extensive than the terional, like trying to apply modified OZ approach to dissect the tumor. I don't apply retractors in my practice. I use the dynamic retraction, trying to minimize the trauma for the manipulation on the brain. This is again a nice case. It's a sarcoma brain metastasis attached to the skull base, outpouching from the face of the patient. There is no room for radiotherapy or gamma knife in this case. So we have to apply the techniques of the skull base with the, I would say, with the frontal craniotomy. This is another sphenoorbital meningioma with optic canal invasion. I did, as many skull-based surgeon around the world, I just drilled the sphenoorbital rim and I opened the optic canal with anterior clinoidectomy. Again, this is a very nice case. Many neurosurgeon has shown, I would say, smaller or quite similar to this case. This is one of my patients with 1 year follow-up after tumor resection. It was very extensive. It was crossing to the midline between the anterior cerebral artery branches. I mean, I know it's like it's an extradural approach, but it's still there is some invasion to the brain. I took it very nicely, and the patient on the follow-up, it was like, I would say, very wonderful. I left some residual in that patient, and we address that with the gamma knife radiosurgery. This is the cases that I would say no one show. This is recurrent with the patient who had 2 previous surgery for his skull-based tumor that come to my practice. This is the cases, as you see, like in the first line, there is a trauma and ischemia in the previous surgery. This is the cases that sometimes we don't know what to do for this patient. He has like 2 previous surgery, he got some radiation therapy, and he came to my practice with a decreased vision in both eyes. So what I did is just to reoperate on this patient despite the high risk and the chances of wound infection, dehiscence, and all that stuff. So as you see, there is like a reasonable resection, and for the some residual that I left, I just apply the gamma knife. As you can see, like this is the previous surgery in the first picture. What I did, I just complete the OZ and I make an monitoring to the abducent nerve. just to make sure that I am not gonna hurt it when I go inside the cavernous sinus. This is a different tumor that I would say most of the skull-based neurosurgeon that deal with. We apply it here in my institution with the four hands technique. This is me and my colleague doing the endoscopic endonasal approach and utilizing the four-hand technique to remove this tumor with a reasonable resection, and the patient has a good recovery. Again, the key to happiness is to pursue the skill and excellence with deep sense of satisfaction, the autonomy, the feeling of the freedom, and the lack of economic hazard and the legacy. At the end of the day, all of us try to leave an impact or contribute to make some contribution to have a powerful source of fulfillment. Again, this is some cases that has been like presented by some colleagues. This is one of my recent cases. It's also related to the skull base. I did some reduction technique as well as the occipital-cervical fusion for this. I would say it was an nasopharyngeal carcinoma complicated by a infection after resection. And I find out myself doing some reduction technique alongside with some lateral approach, and I have achieved a reasonable decompression. Again, this is a picture of the Michelangelo, and this is a picture of Mecca here in Saudi Arabia. I would say we have, to keep, we have I would say to keep some faith in our science as well. This is our upcoming meeting happening next January. I would like to invite everyone to attend this our virtual meeting. And thank you again for the opportunity, Professor Sameh and John, for this wonderful meeting all around the world. Thank you again. Bye.
Thank you, Dr. Bah, for this nice presentation. Is there any question? Okay, we will shift to next speaker, Professor Tianmin. Please start sharing your screen.
Okay, thank you, Professor Sami. It's my third time attend this great meeting, and also I'm very glad to be here to share my some technique about the 3D high definition ventriculoscopy in pediatric patients. I am a pediatric neurosurgeon working in the Huashan Hospital, Fudan University. So this is my talk about the 3D ventriculoscope. Can you see my screen?
Yes, perfect.
Can you see
Yes.
my screen? Okay, thank you.
Yeah.
Okay, thank you. So I will talk from the indications. Usually we use this technique to treat the hydrocephalus, including the obstructive hydrocephalus and sometimes the cystic loculations. And also we use it to treat some very huge cyst. And at the same time, we will do the biopsy, use this technique. And sometimes it is, we will say about the contraindictions, including the when you have a very small or scaled interpedicular system or prepuncting space very small, and when the basal artery linked to the clivus is very small space, at that time you will be very careful to do the ETV. And if the cyst is very dense, it's very difficult to do the fenestration. And when the tumor is highly vascular tumors, it is very strange. And sometimes when you do the ventriculoscope, if the ventricle is very small, it's very difficult to do it. And sometimes we will do some preparations, including drawing a very detailed plan prior to the surgery, what's your goal or approach, and what is your alternative procedures when you have some very difficulties during operation. And also you should confirming the applications, including the orientations focus and something like that. And when you do the ventriculoscope, when you have very small ventricle, we should use the neural navigation to help you. And this is some key points of the procedure. And I will show my illustrative cases into about different kind of situations. First, I will say that the ETV to do the treat the hydrocephalus prior to the posterior fossa tumor, and this is a 12-year-old boy, headache. You see the lesion in the fourth ventricle. We know maybe this is a medulloblastoma. Before the tumor resection, it's a very severe hydrocephalus. The patient very severe headache, nausea, and before the tumor resection, I do the ETV and relieve the hydrocephalus, and the patient recovered very well. And then we do the tumor resection and the very low ICP. This is the tumor resection. After that, the patient suffered very well, recovered very well. And the second case is ETV for postoperative hydrocephalus. And this is an 11-year-old girl. Before the surgery, you see the AFP and the beta CG are both very high. And we see that the lesion at the pineal region, this is an NGGCT. So for this case, the tumor is about 2 centimeters. I do the open surgery to remove the lesion totally. You see this is the third ventricle, and this is the membrane here. This is the post-operative CT scan. The patient recovered well, but 1 month later, the child had the hydrocephalus. At that time, I do the ETV using the ventricoscopy and to release the hydrocephalus. This is the post-operative scan. And the third case is a tumor biopsy case using the ventricoscopy. You see this is a 13-year-old girl, headache. You see the lesion, a very huge lesion at the pineal region, and also at the same time, the very severe hydrocephalus. And I do the surgery 1 time to do the 2 steps. First, I do the ETV, and then at the same time, I using another hole to do the biopsy at the tumor located at the pineal region. You see this is, and after the biopsy, the patient had the radiotherapy. This is postoperative MRI, and this is the MRI after the radiotherapy. You see this is a geminoma. All the tumor has gone after the radiotherapy. The fourth case is a tumor biopsy at the pineal region, and after that, I do the open surgery, and this is also a 13-year-old girl, headache, and you see the lab test were both normal, and this is the lesion at the pineal region, and you see the hydrocephalus. So at the same time, I do the biopsy and the ETV. You see the pathology is pineal parenchymal tumors of intermediate differentiation. So this lesion cannot be treated using radiotherapy. So after the first, I do the tumor resection after the biopsy. So using the Popping approach, I remove the lesion totally. So you see this is the postoperative MRI. So the also the patient recovered very well. And the 5 cases case, I used the ventriculoscopy to do the ETV and at the same time to do the biopsy at the cellular region. And this is a 10-year-old boy, headache. You see the bifocal lesion, 1 lesion in the pineal region and the other lesion at the supracellular region. And also the patient had very severe hydrocephalus. So you see when I using the ventricoscopy, I first do the ETV, and after that, I do the tumor biopsy at the supracellular region here. And also, this is geminoma confirmed by. And the 6th case is a case for very complex hydrocephalus. This is a young girl. She had a very severe car accident about half a year ago, and do 3 operations in local hospitals. When the patient came to my clinic room, you see very severe hydrocephalus and hydroma here, and also a very severe situation, and the patient have very severe headache at the same time. So I do the surgery using the ventriculoscopy because this is a very complex hydrocephalus. I do the ETV, and at the same time, I did the pellucid septostomy here. And also at the same time, I do the plastic. And after the surgery, you see the girl recovered very well. The hydrocephalus has gone, and the patient had no headache anymore. The seventh case, I will show my failure case after the ETV, because this is 11-year-old girl. The girl had the brainstem high-grade glioma before my surgery. The pathology is glioblastoma, and this is the MRI before the tumor section. And after tumor section, about 3 months later, the girl had the very severe hydrocephalus. And at the same time, I think that the fourth ventricle was compressed very severe, and I do the ETV for this case. Immediately after the ETV surgery, the patient recovered well. This is the 2 days post-operative CT scan. But about 4 weeks later, the patient had headache again. You see the hydrocephalus come back again. So this is a failure case for ETV. And after that, I did the VP shunt for this girl. And this is my 8th case. I did the tumor biopsy at the wall of the ventricle, because this case has a very small ventricle. You see, this is a 14-year-old boy, had a polyuria and a polydysplasia before the surgery, and the lab tests were normal. This is a lesion you see at a lot of locations, at pineal region, suprasellar region, and also the lesion in the ventricle. And also at the same time, you see the ventricle is not so large. It is a very small ventricle. I used to do the biopsy under the neuronavigation here. You see I get into the ventricle, and after irrigation, the ventricle a little bit large, and I can get the biopsy on the ventricle wall here. The pathology, it is geminoma, and after that, the patient had a radiotherapy, and now the patient is very good and get CR after the radiotherapy. This is the post-operative scan. And now I want to share the case. I do the pellucid septostomy and the biopsy at the thalamus. You see, this is a 9-year-old girl. The lesion at bilateral thalamus. So I think this is a bilateral glioma, and at the same time the hydrocephalus. And you see the hydrocephalus is not in the right side, so I think this side the hydrocephalus is much more severe than the contralateral side. So at the same time, I did the pellucid septostomy here, and at the same time, I did the biopsy at the thalamus. This is astrocytoma. After the surgery, you see the ventricle get smaller before the operation on the right side. And the last case I want to show is a VCC for suprasellar arachnoid cyst. You see, this is a 5-year-old boy, headache and vomit for 2 weeks, and the test before the operation is very high. You see, this is a CT scan. This is a Mickey Mouse sign here. So I think the diagnosis is very obvious, that is suprasellar arachnoid. So for this case, you see the hydrocephalus and the suprasellar region cyst here. And I did the case to using the endoscope to do the ventricular cystostomy. 2 steps here. This is the cyst, and this is the cistern to do the 2 holes here. And after the surgery, the hydrocephalus has gone. I want to get to the conclusion. The teamwork is very important important, and I think the indications and the contraindications we should control very well. And deletion is always more important than incision, and our procedure selection and the salvage manual preparation before the surgery. And also, I think the preoperative, the communication with the parents is obviously important. Thank you very much. And this is our hospital, Huashan Hospital, Fudan University. Thank you very much, Sami.
Thank you,
Professor Sami, thank you.
Ming, for this excellent presentation and for sharing with us your. Thank you.
Okay. Okay, thank
Is
you very
there any
much.
question? Thank you both, Chairman.
Okay, thank you again.
And now we will shift to next speaker. Thank you. And now we will shift to next speaker, both to three of us. We'll start sharing.
Can you see my screen? Hello, can you see my screen? Can you hear me?
Yes, welcome.
Yeah, thank you. So thank you, Professor Sameh, for the invitation, and it's been a wonderfully organized meeting, and it's yearly, and it's really been a grand success. So I will be speaking specifically on the posterior transpetrosal approaches, but before that, we need to know how they are classified, either based on the origin or based on the displacement of the trigeminal nerve, because this is what decides which approach we are going to use apart from the attachments. So, of course, the retrosigmoid has been the workhorse. It's still the most frequently used approach. It is simple, fast, familiar, but because of the narrow operative field, there is a risk of postoperative facial palsy. And also because of the narrow working field, there's also an increased chance of cerebellar retraction and retraction-induced injuries. Transpetrosal has its own advantages in that it reduces the working distance. There is early devascularization, and you get multiple corridors. But the disadvantages, of course, it's a time-consuming surgery. The risk of injury to the vein of labia is real, and the cranial fourth nerve deficits. Transpetrosal for ease has been divided into the anterior transpetrosal approaches, the posterior transpetrosal approaches, and the combined transpetrosal approaches. The main difference on how you select the approaches is based on the zonal classification. Anything above the IAM can be approached by the anterior transpetrosal approaches, but any tumor going from zone 2 and zone 3, it's preferable to approach it posteriorly because you can excise it completely. So when do I use these approaches? If they are in, like what I said, if you can divide them into 3 zones, you will know that the tumors have to be approached either through an anterior or a posterior transpetrosal approaches. So this is a simple tumor which is predominantly in zone 3 without much extension above. So this patient can be approached through a standard retromastoid, and it shows excellent results postoperatively. I'll skip the video and concentrate only on the posterior approaches. This can also be modified into the this can also be modified into the RISA approaches, where you can go suprameatally by drilling, and then also take a tumor which is extending above, and also go transtentorial and take a bit of the supratentorial component through the posterior approaches. While a predominantly zone 1 tumors this can be approached, ideally should be approached through a Cavaz's approach, because it's got an epicenter on the petrous apex. It's all about the internal acoustic meatus. The one important thing which all surgeons should notice is the T2 densities. So if the brainstem is showing T2 hypodensities, that means that the patient has bile invasion. It's better to leave a bit of the tumor and then do gamma knife postoperatively. Similarly, this patient, there's not much T2 signal changes. You can go and remove the tumor almost completely. Similarly, this is another anterior transpetrosal Kawase approach for a petroclinoidal tumor. You go through an anterior transpetrosal and remove the tumor completely. So coming to the focus of this talk, which is the posterior transpetrosal approaches, it is either retrolab, translab, or transcochlear, depending on whether the hearing is preserved or not. If the hearing is preserved, you need to go through the retrolab approaches. And this is a patient, if you can see the basilar is displaced, the PCS are pushed above, the left vein is dominant, and jugular bulb is below the IAC. And if you can see the attachment, it is going below the internal acoustic meatus. So the key surgical steps of a retrolab pre-sigmoid subtemporal transtentorial approach includes a standard temporo-suboccipital craniotomy. Then we do a mastoidectomy and skeletonize the sigmoid sinus. We do a posterior petrosectomy, identify and preserve the canals, open the pre-sigmoid and posterior subtemporal dura, ligate the superior petrosal sinus, internal debulking, and closure with fat penicillin graft and bone flap. So this is the video which is showing the bone work. So this video is self-explanatory. What we have done is we have done a temporal craniotomy, then we have done a retrosigmoid craniotomy, and then joined the two. And then the petrosal sinus has been skeletonized. So once the petrosal and the sigmoid sinus has been skeletonized, we are going to drill the petrosal bone. So the petrosal bone, you have to be very careful in drilling and you need to identify and preserve and not enter the semicircular canals, and also not drill too inferiorly where there's a chance of injuring the facial nerve in the facial canal. So the whole idea of this is to expose the Trotman's triangle, which is by the sigmoid sinus, the superior petrosal sinus, and the petrous apex. So once we know what we are going to identify, we are trying to get the facial nerve in the facial groove. Once we have identified this, so that we know that so that we know where to stop drilling. And this is, so I'll just show this, sorry. So here, if you see, this is at the end of the exposure, you can see the pre-sigmoid area, which is our region of interest. This is your sigmoid sinus. This is the petrosal sinus. This is the temporal lobe. This is the petrous drill. This is the root of the seventh nerve. And this is the semicircular canal. So we are interested in this and we are going to approach this, ligate the superior petrosal sinus and get a good exposure. So once this Trotman's triangle is exposed completely, we open the dura. Yeah. So once the dura is exposed, both the pre-sigmoid dura and the subtemporal dura is exposed, we ligate the superior petrosal sinus, cut it, and then we start cutting the tentorium. The tentorium has to be cut completely. And once you cut the tentorium completely, you reach on top of the fifth nerve. And then the standard principles of meningioma surgery come into play. You can see the fifth nerve is mostly inferior to where you have approached. And then you devascularize, decompress, and dissect the tumor out. Then once you start decompressing and devascularizing and decompressing the basilar artery, then once the basilar artery is exposed, you can do it in any way. This is the fourth nerve being exposed. The fourth nerve is dissected off, and the tumor is being dissected gradually off the brainstem. So here you can see this is the, once you have removed a significant chunk of the tumor, here you can see the vein of Labe. Sorry. Yeah, so this is the vein of Labe, this is the fifth nerve, and this is then you see the seventh and the eighth nerve complex. sorry. Yeah, that's the fifth nerve. Below that fifth nerve with the seventh, eighth complex. And after that, you go and the complete basilar and the basilar, the ICA and the basilar perforators are exposed. And once this visualization is done, you know that you have excised the tumor fully, and then you do the hemostasis. Yeah, that is the complete vertebrobasilar system. This is after hemostasis. This is the postoperative imaging. This is the immediate postoperative imaging, and this is the delayed one, which shows a small residual for which gamma knife was given. These are other cases in which we have done the same approaches. This is case 2, this is case 3, for which all we have done the standard approaches. If you find that the tumor is too hard, you can leave a bit of the tumor in the cavernous sinus like we leave here, and you get very good cosmetic results without causing ptosis. This is very important cosmetically for these patients. Again, these are some tumors in which you have done the same approaches. If the tumor is too hard or if there are signal changes, it's better to leave a little of the tumor and give gamma knife postoperatively. So when do we do the combined approaches? These are huge tumors which are difficult to approach through a single stage. So we stage the surgery over here. So what we did in this patient was, first we did a retrolab pre-sigmoid subtemporal transtentorial approach and removed the posterior fossa component, left the supratentorial component. And after 3 months, we went anterolateral transcavernous with an anterior petrosectomy and removed the significant chunks of the tumor and left a little bit of the tumor around in the cavernous sinus, and which is encasing the basilar system. Then this patient was given SRS, and this is the postoperative scans 2 years down the line. So what are the predictors of extent of resection? These are tumor margin, brainstem pile invasion, infiltration of the adventitia or encasement of neurovascular structures, and firm tumor consistency. Clinically include history of radiotherapy. So when you compare the retromastoid and transpetrosal, what are the advantages and disadvantages? The main disadvantage of the retrosigmoid is the risk of postoperative facial palsy, which is around 16 to 20%. While the main disadvantages of a transpetrosal are the posterior transpetrosal are venous infarction, and that it is time consuming, as well as cranial fourth nerve deficits, which is around 8%. But transpetrosal gives a huge advantage in that it reduces the working distance. You get early devascularization, and you have multiple corridors for removing the tumor. Again, compared to the posterior approach, the anterior approach is limited anatomically by the internal acoustic meatus. So any tumor which goes below the internal acoustic meatus, you need to combine with the posterior petrosectomy or a second stage retrosigmoid approaches. It is also not suitable for lesions in the premedullary system, and it's a narrow corridor. And again, here you have a risk of injury to the vein of laving. So what are the good things you feel happy about in the surgery? One is, of course, isolating the fourth nerve, good bone work, seeing the Dandy's vein as well as the seventh, eighth, and the fifth complex, and then at the end seeing the basilar and the basilar system and its perforators. We have had complications include venous infarct, hemiparesis, meningitis. In heart tumors, it becomes very difficult. And in this patient, the tumor was very hard, and we accidentally injured the vessels, and this patient developed a brainstem infarct and became hemiplegic. So in such cases where the tumor is really hard, you can plan for subtotal resection, and then after 3 to 6 months, plan for gamma knife. So I would like to conclude by saying that the approach is decided by the extent. Large tumors below the internal acoustic meatus, if the hearing is preserved, use the posterior petrosal approach. If there is no hearing, you can do a total petrosectomy. But if it is a very large tumor, then you might have to do a combined petrosal approach. So I would like to end by saying that this is a highly complicated anatomy. Pre-operative understanding of the radiology is very important. Do not have a one approach fit all, and you need to make a decision based on the radiological characteristic of the tumor before deciding upon the approaches. And this is my hospital in the southern city of India, Bangalore. Thank you.
Thank you, Professor Srinivas, for this excellent presentation. Is there any question from panelists? Thank you.
Thank you.
And now we will shift to next speaker, Professor Dahan Bani. Please start sharing your screen.
Cannot hear you, Dandapani. Unmute.
Okay. I would like to thank Professor Same for this opportunity and for sharing our experience on endonasal endoscopy for NOS4 ICA encasement in pituitary tumors. So I hope you can see the screen. So
Perfect.
thank you. So cavernous sinus invasion is an important prognostic factor in pituitary tumors. And sometime back when we did a meta-analysis, we noted that intentional opening of cavernous sinus per se doesn't lead to increased morbidity. And in fact, the risk of ICA injury is not that much high when you intentionally open cavernous sinus. And the more number of cases we operate for pituitary tumors with cavernous sinus invasion, the likelihood of gross total resection keeps increasing. And we have been doing pituitary tumors with cavernous sinus invasion for a long time. And we noted that navigation is also an important tool which increases the extent of resection, because even a small bit of, that means even a 2 millimeter extra bony opening you can do, it results in better gross total resection rates. So all these cases we do with CT angiography loaded in navigation, so that we understand the cavernous ICA and the extent of tumor better. And NOS4, we all know that it is a complete encasement of cavernous ICA. So this is one case which shows all the compartments of cavernous sinus in one view. As you can see, this is the ascending segment of cavernous ICA, and this is the posterior geno, and this is the horizontal segment, and this is the anterior geno. And this was done with a simple transcellular approach without any expansion, because the tumor itself has expanded the cavernous sinus and given a corridor. So many such tumors we can get into cavernous sinus purely by conventional transcellular approach. You can use 30-degree or 45-degree angled optics. But as you can see, we can see all the compartments which are labeled. This is the posterior compartment, which is posterior to the geno of ICA. And this is the superior compartment, which is above, superior to the horizontal segment. And this is the inferior compartment. And you see the lateral compartment here, where the sixth nerve is here. So in tumors which expand the cavernous sinus without much loculations, this can be just opened up by a conventional approach and expose all the compartments and then start removing the tumor. And these are the trajectories which we can take. As you see, this is the superior compartment, and this is the inferior compartment, and this is the posterior compartment. This is the posterior geno, ascending, horizontal, anterior geno. So for whenever there is a complete encasement, first we can try to go from this trajectory and try to tackle the superior compartment and posterior compartment. It is a conventional, slightly angulated, you can use angled optics. Then we can get into a lateral entry, inferolateral entry, to get to the lateral compartment of the cavernous sinus. So understanding this in a CT angiography, navigation, and MRI becomes very helpful. And this is a cadaveric dissection which we did in our institute some time back, I'll just highlight the relevance of the cavernous. See, as you see, the posterior part of the cavernous sinus is the easiest to enter first, because here always there is lots of area between the dura and the ICA. So, and when we enter here, we see the meningohypophyseal trunk here. So this can be coagulated and sectioned, and then this is the posterior compartment of the cavernous sinus. So whenever we explore the cavernous sinus, always better to give a dural incision as lateral as possible. When we have a CT angiography navigation, just medial to the carotid artery, we can give incision to go lateral to the medial wall of the cavernous sinus, because peeling of the medial wall from within is difficult. But when we give the incision lateral, it becomes easy, because there are strong paracellular ligaments which are otherwise difficult to mobilize. And then we do the conventional, the cellular part of the tumor resection, and then we can enter the lateral part. So this is where we entered first. We can enter first, and then we can enter laterally. Lateral, the only challenge is that the sixth nerve is often within is in the cavernous sinus, and in a giant tumor it becomes difficult. See, third nerve involvement is easy because it is having a fixed anatomy. When you identify the posterior clinoid and just lateral to the posterior clinoid, the third nerve enters the roof of the cavernous sinus. From the cisternal part, it enters into the interdural part. This is the third nerve. This anatomy is fixed. So whenever the patient is having a third nerve deficit, it is better to explore here and decompress the third nerve. But laterally, sixth nerve can have a various kind of variable anatomy. Depending upon the tumor extension, the sixth nerve can be pushed to any side. So here you need neuromonitoring in especially giant tumors. So I'll just go to some illustrative cases. This was the cadaveric dissection. So our strategy is, there are different types of exploration. Either we can have a medial cavernous sinus exploration, which can be of open or closed type, or we can do anteroinferior or lateral exploration. For these two, we need a tailored transpterygoid. A complete transpterygoid approach may not be needed for every case, but depending upon the situation, we can have a tailored transpterygoid approach. For the medial exploration, transpterygoid is not needed. So I'll just show one example of a closed type medial cavernous sinus exploration. As you see here, we can see there are lots of loculations. There are multiple rooms. These things have to be opened up, because in contrast to the case which I showed previously, here there are multiple loculations which have to be intentionally opened. This becomes very cumbersome. A kind of endonasal Doppler is very much essential to identify the carotid, and then each loculation of the cavernous sinus should be entered and then tumor decompressed. So then I'll go to another type. This is open type. This is what I think some time back I showed. This was a case of refractory prolactinoma. Patient had severe adverse drug reaction, so we had to operate. As you see, this is the ICA, posterior genu. So here the tumor has expanded and there are not much loculations. This becomes very easy. So you don't need to do a very expanded approach. Here we are seeing the superior compartment, and this is the dural roof of the cavernous sinus, where posteriorly the third nerve enters. You may not be able to see it clearly, but monitoring is not needed, and for third nerve. So the tumor usually has a very good plane in most of the compartments, except in lateral compartment. So the superior and posterior compartment, you can gently do decompression and then peel off the capsule of the tumor, and then go to the lateral compartment. As you see, this is the post-op result. And then we have anteroinferior cavernous sinus exploration, in which we do a tailored transpterygoid approach. Here, this was a case of a growth hormone secreting pituitary tumor. Here we have opened the cavernous sinus anteroinferiorly, and then most of the time, if the tumor has expanded into a large lateral compartment, the bleeding comes in the last part, which can be controlled by gentle compression using cottonoid or using Surgisil or gel or Flow-Seal. So the entry, we have to open the cavernous sinus as broad as possible. Opening should be done in the initial part itself, because once the tumor gets decompressed, it is difficult to localize using navigation. So the opening should be done first, and then we can use the anatomy. This is the post-op end result. A little bit of the tumor is remaining. Growth hormone has decreased from 50 to 1.4, and IGF has also decreased significantly. This is another case of cavernous sinus invasion, and this is the post-operative this thing. So now I'll come to lateral cavernous sinus exploration. So this is an example of a case in which there is a left ICA encasement. This standard, we always try to take a vascularized flap whenever possible, so that CSF leak risk can be avoided. And it may not be necessary for every case. Whenever we think that there is a high risk of CSF leak, we take. And then this case, we did a tailored transpterygoid approach. As you can see, the lateral recess of the sphenoid has to be nicely exposed. This exposure becomes very vital when you want to enter into the lateral part. So, and the contents of the pterygopalatine fossa are mobilized laterally, so that we have a very good access. There should not be any compromise. And posterior ethmoidectomy is done, and this is the end result. You have a good bony opening, and as much laterally as possible, which is relevant for the particular tumor. And once we have done a good bony exposure, as I have told, see, there is some tumor getting down. This is the dural invasion of the tumor. We are using navigation to localize. I am not trying to remove. You should not remove the tumor first, even if it is bulging out of the dura, because when we decompress the tumor, the carotid will become close to the dura. So that becomes difficult when we are opening the dura. So we leave the tumor till we open the dura completely. And posterior drilling is done, and a wide lateral opening of the cavernous sinus is done. And once we are very sure that we have exposed the whole of cavernous sinus, then we give incision. I give the first incision laterally, vertically, and then I try to connect this part which is already open to the lateral over the carotid artery, because we have not decompressed the tumor and we have used navigation to confirm that there is enough depth of tumor. So there is nothing to worry. And then using this forward angle scissor, we try to open the dura all around anteriorly and then onto the contralateral side as lateral as possible as a flap. We always try to send this dura for histopathological evaluation to understand the invasion of the tumor. So this is the whole of the dura. The whole of the dura is taken out in one piece and we send for histology. So the whole cavernous sinus, everything is exposed. Then we start decompressing the cellular part of the tumor first. Once the cellular part of the tumor is decompressed, then we use the medial trajectory to get into the superior compartment. And another thing is that we should not remove the supracellular portion in the early part, because the descent of the diaphragm and arachnoid will impede our entry into the cavernous sinus. This is very important. Or otherwise, we'll have to keep using cottonoid to keep pressing it. It becomes very cumbersome. So once we have decompressed this part of the tumor, and then we enter into the lateral part. This is the and this is where the carotid artery is there over underneath the tumor. So we are decompressing the lateral little bit, and then we try to dissect the tumor over the cavernous carotid artery. This was a non-functional tumor. In functioning tumors, we are very aggressive, but in non-functioning tumors, we try to do whatever is safe and easy. And if the tumor is very bad, we can always give radiosurgery to the lateral part. But in functioning tumors, we try as much as possible, because we aim to achieve a prolongation of life expectancy for these patients. So as you see, now we are trying to expose the carotid artery, and this is the medial wall of the cavernous sinus with lots of kind of thick membranes and paracellular ligaments. So these things are opened up and cut, and here we get the branch from the posterior genome, meningohypophyseal trunk, that is identified, and then we can coagulate, and then we can cut this. And this is the superior compartment we see once we coagulate this meningohypophyseal trunk and cut, and then posterior and superior compartments, any tumor is gently decompressed, and little bit of tumor over the carotid artery, we are still keeping it, because sometimes there may be some adventitial invasion which can be tackled last, or in non-functioning tumors, we should not try to totally expose the bare carotid artery. And then laterally, now we are getting more deeper to identify the sixth nerve. So this case was done under neuromonitoring of the sixth nerve. And then the tumor decompression is continued after the sixth nerve is identified all around. And gradually, we come all around the cavernous carotid artery, and then we keep the cottonoid wherever there is venous oozing. So once we have satisfactorily removed the tumor from the cavernous sinus, then we go into the suprasellar portion. So the suprasellar portion is removed in the conventional manner. Here, as you can see, as we are removing the suprasellar portion, there is descent of the diaphragm, so which will make it difficult to get into cavernous sinus later on. So this is the preserved diaphragm, and this is at the end of surgery. And again, once we confirm the lateral extent, and we fill the cavernous sinus area with a surgical covered fat, and then the conventional multi-layered closure is done. So this is at the end of surgery. As you see, you can see that near total resection has been achieved. This was done within a few days of surgery. So there may be some contrast enhancement. I am not very sure how much is the tumor. So we'll follow this patient up. So this is another case of a complete ICA encasement. As you see, the sellar portion has been decompressed. Now I am cutting the dura over the cavernous sinus dura, over the cavernous carotid artery, and then we are trying to decompress the tumor laterally. So because this we have already discussed, this is the end result. This was a growth hormone secreting tumor. How you can see, this was a giant. It has a both suprasellar and complete ICA encasement. This is the post-op. The growth hormone and IGF both have got decreased. This is this patient has already undergone surgery somewhere else, and patient came with a large growth hormone secreting tumor in the cavernous sinus. This we did direct lateral entry, and both growth hormone and IGF are under control now. So these are some of the other cases. So the left cavernous sinus invasion. Sometimes we have cavernous sinus invasion with subarachnoid invasion also. These are the worst of the tumors. As you can see, it is getting almost till the sylvian fissure, multilobulated. It is going lateral. So these are the tumors with subarachnoid invasion. You have to be extremely careful. Under angled endoscopic visualization, we'll have to gently roll these tumors, because these are likely to be around perforators of vessels. So these lobules should not be taken lightly. And as you see, the tumor is rolling around the ICA bifurcation. This is the post-op result. So these things should be done under complete vision. The endoscope is taken fully inside. And these are some of the other tumors with both subfrontal and cavernous sinus invasion. So you can see the post-operative. So these tumors, we can be conservative. Sometimes when we think the tumor is very fibrous, we leave behind, and then we give radiosurgery or radiotherapy. So see, the consistency of the tumor becomes very important whenever there is encasement. Firm, very hard tumors, we should not be very aggressive. I have already highlighted the first part is this, then cavernous sinus, then the suprasellar portion. So this video I'll skip because of lack of time. So this is the giant tumor with both cavernous sinus invasion. As you can see, the end result. So so we understand that most of these tumors, we can have a reasonable extent of resection, except when the tumor is fibrous, or very rarely the tumor capsule is calcified in pituitary. So these are the tumors which we have to be careful. Otherwise, most of these tumors can have a good extent of resection, even in case of ICA encasement. So I'll just skip this fast. And we had 51 cases of NOS4 ICA encasement, and this is the distribution. So for non-functioning tumors, we have 10 cases of near total resection, 15 we had a subtotal resection, we have follow-up, no regrowth, and for 5 cases we did resurgery in 3 and 2 radiotherapy. In functioning tumors, we are more aggressive, like 10 cases had a near total resection, 5 were in remission, 2 were on medications, and 3 we gave gamma knife. So aggressive lateral transcavernous resection is effective in expanded endonasal surgery for functioning tumors. A conservative medial transcavernous decompression may be sufficient for non-functioning tumors. Thank you.
Okay, thank you. I guess Sammy stepped away. Hi, Sammy, you there? Yeah, he has some internet issues. Any questions for the doctor? Any comments? Okay, well, very good. Thank you very much, Doc. And I'm just guessing, Abby looks like she's biting at the bit. So I think it's probably her next.
Hi, John.
It's all yours, Abby.
Okay. I think Samay stepped out, but anyways, we'll continue the show. And thank you, John, for this organization, and thank you, Samay, for this invitation. And today I'm going to be talking on meningiomas of the anterior skull base. So as we know, the anterior skull base is bounded here by the lesser wing of the sphenoid laterally, and posteriorly here by the planum sphenoidal and the tuberculum sellae. So this is the anterior skull base. You have the cribriform plate, the crista galli, the orbital roof, the sphenoid, lesser wing of sphenoid, the planum sphenoidal, the tuberculum sellae, the dorsum sellae. So meningiomas of the anterior skull base can be midline and can be lateral. So today we'll be just discussing the midline and clinoidal anterior skull base meningiomas. We'll not be discussing the orbital roof meningiomas and those that originate more laterally. So this is another view from the back where you see this is the planum and this is the tuberculum. So just to give an distinction, so this is the chiasmatic sulcus where the optic chiasm rests. This structure is the planum sphenoidal, and this one is the tuberculum sellae, and posteriorly here is the dorsum sellae. So when you're operating on these meningiomas, there are certain anatomical structures that you have to take care of, and we'll see them as in the course of the presentation. So here you see a variety of anterior skull base meningiomas, and I'm going to be discussing tuberculum sellae, olfactory groove, and anterior clinoidal meningiomas. As you can see, we have a large experience on these kind of tumors, and a lot of complex cases do present to us. So this, when we published this of olfactory groove meningiomas, this was the largest experience or largest series of olfactory groove meningiomas. So here you see that they lie here in the region of the cribriform plate, anterior to the planum sphenoidal. This is a small olfactory groove meningioma, however, has a lot of edema. This is a largish olfactory groove meningioma extending posteriorly to the region of the planum sphenoidal. And you can see it is quite huge and extending all the way posteriorly to the frontal lobes. And then you see this tumor, which has a lot of calcification and a lot of vascular blush. You can see the vascular blush from the CT angio that was performed. And this is a highly vascular olfactory groove meningioma. This one has more of a unifrontal extension and going into the paranasal sinuses here. And this one is a completely calcified meningioma that you can see on the CT. And they are quite formidable tumors. Again, another large olfactory groove meningioma going posteriorly up to the planum sphenoidal. And these are the critical neurovascular structures that come into play when you're operating on these tumors. Again, another one that is going right up to the convexity. So this olfactory groove meningioma is coming up right to the skull base. So how do you deal with these tumors? So first of all, preoperatively, you have certain parameters that we have devised that help you decide about how difficult the surgery is going to be. So these patients normally present with loss of smell. They are present when the tumors become quite huge because they're in the frontal region. the symptoms may be subtle in the beginning. So sometimes when they present, they have personality changes, they have frontal lobe signs, and more later on, they have visual deficits. So we all know that the Foster-Kennedy syndrome is a presentation of large olfactory groove meningiomas. So how can you grade these tumors? You look at the size, you look at the visual deficit, you look at the duration of the visual deficit, you see if there are any higher mental functions affected, if there is a lot of edema surrounding the tumor, whether it is involving and going into the anterior base, going through the anterior cranial fossa floor, and lastly, encasement of anterior cerebral artery, and some other things like age and calcification of the tumor. So we graded the tumor into 3 grades, and this helped us decide how difficult the excision would be, and also how much of an excision we'll be able to achieve. So earlier, a lot of patients we used to operate by bifrontal craniotomy, but now exceedingly as our experience has increased, you can see that a unifrontal craniotomy is being performed, and we use a subfrontal approach while approaching the tumor. So you first open the dura, you can sometimes you have to just go through the little part of the frontal lobe because the tumor is so extensive with a lot of edema, or you can open the sylvian cistern laterally and then release the CSF. Then you retract the frontal basal brain and you start debulking the tumor. You go to the basal attachment first, start intratumoral debulking, and then go ahead and remove the tumor. The structures at risk would be the anterior cerebral artery, especially the A2s as they are coming on the superior extent of the tumor, and the internal carotid artery. So this is the region where then olfactory groove meningioma will come. And at the posterior aspect, you will have the optic nerves. You will have the A2s as they turn up and go over the corpus callosum. So once you're performing a unifrontal craniotomy, this is the burr hole. The extension of the craniotomy is up till the midline, not right up till the midline, but going quite medially. And if you're performing a bifrontal craniotomy, this is the exposure that they can use. So sometimes we take a bifrontal exposure, but do a unifrontal craniotomy, only necessary of doing a craniotomy on the side if needed. When you're going to the base of the cranial floor, anterior cranial fossa floor, when the tumors are extending, you have to remember that you have to have a good reconstruction material ready. So this is actually an extended bifrontal approach. We don't use this normally. And here you see that flaps have been raised, and this is a vascularized pedicle flap, which should be raised when you have to go through the anterior cranial fossa floor into the paranasal sinuses so that you can reconstruct it adequately and prevent any problems. So this was described, of course, by Professor Goel, extended subgaleal fascia flap that we use when we are performing these kind of surgeries. So these are a few examples of preoperative and postoperative images. Here you can see this large tumor that was resected. Another tumor more on one side where there is a paranasal extension. We have gone through and removed the paranasal extension also. Again, another huge tumor. This was operated very long ago, and this is about 20 years after surgery. So little residue was left behind. And even after 20 years, this is the extent of tumor that is remaining. Again, another large tumor, which you can see has been removed nicely. Again, another tumor on one side, but this edema, there is a lot of edema in this patient, and that can make the surgery difficult as it is one of our parameters for grading. But here you can see the paranasal extension has also been removed. Going further backward to the tuberculum sellae, and I think now the experience on tuberculum sellae meningiomas of Professor Goel goes to about 300 cases. And of course, we have also done quite a few. So this is the tuberculum sellae meningioma. This is a small tuberculum sellae meningioma. They can be moderate and sometimes they can be huge. So here you see how it is based on the tuberculum sellae. So olfactory groove will be here. Planum will be more anteriorly, not going all the way here and not coming over the tuberculum. So this is a classic tuberculum sellae meningioma. And here you see the relation of this tumor to the ICA and also to the anterior cerebral arteries. And the next relation is the pituitary gland, which has to be preserved, pituitary stalk, which has to be preserved during the surgery. So you see this is a small tumor, but it is densely adherent to the undersurface of the optic chiasm and also to the pituitary stalk. And we have to be careful during the surgery in preserving both these structures. This is a tumor with extensive anostosis. As you can see, the whole tuberculum has become hyperostotic. So this is a tumor with a calcified rim. And even though they appear calcified, when you're actually resecting the tumor, there are soft calcifications and they can be easily removed. This is a tumor which is calcified, but again, as I said, there are soft calcifications and you can remove it. So this is a tumor in which the artery is in the tumor, and you have to be very careful when removing this. This is again a tumor with huge edema. The extent of edema actually suggests the vascularity of the tumor. So the higher the edema will suggest that the tumor is more vascular. Again, the grading of suprasellular meningiomas, we have devised certain parameters. So visual symptoms, the clinical symptoms, and also the age, and radiological, how much is the edema, which arteries are encased, whether there is calcification, and whether there is any hydrocephalus. So as I said again, grade 1, the extent of total excision is higher, grade 2 rather than grade 3. So in grade 1, you are able to achieve a more total tumor resection rather than grade 2 and grade 3. Now coming back to the anatomy, which is important. So as I said before, this is the tuberculum sellae. The structures that you have to be careful when performing surgery in this region is the optic nerve, the internal carotid artery, the pituitary stalk, and the anterior cerebral arteries. So this is the view that you commonly see at the end of the excision of the tuberculum sellae meningioma. Here you see the carotid artery coming with the ACA, turning into the A2 here. This is the region of the pituitary stalk, and this is the optic chiasm. So coming back to the approach, just a little anatomical orientation. So this is from this side. Here the frontal lobe is retracted. Here you see the optic chiasm. Here you see the pituitary stalk. Here you see the anterior cerebral arteries, the A1 and the A2. This is the ACOM. This is the chiasmatic cistern. This is the lamina terminalis cistern, and this is the carotid cistern. So these are the three cisterns that you will play with when you are operating on these tumors. This membrane thickening that you see here is the anterior leaf of the Lilliquist membrane. Once you go through that, coming from the optic carotid cistern, you can see here the leaf of the Lilliquist membrane. Here the optic nerve is being retracted, and inside you can see the third nerve, the posterior clinoid process, the basilar bifurcation. This is the anterior clinoid process, and the ICA going into the MCA and ACA. So this is the anatomy that will come into the picture when you're operating on these tumors. And of course, this is at the end of resection. So this is where the tumor will lie, the tuberculum sellae. So at the back of the tumor, you must remember that there will be the pituitary stalk, which has to be preserved and maintained while operating on these tumors. So what is the surgical strategy? A unifrontal subfrontal craniotomy, unilateral subfrontal craniotomy. This is the position of the patient with a mild head extension and rotation. This is our incision. If it is a hairline, if there is no hairline, we sometimes use a skin crease incision, as you can see here, to perform these tumors. This is the incision. So this is the size of the craniotomy. And mind you, the craniotomy has to be very basal. So when you lift the dura, you are right on the orbital roof. So that gives you a very good exposure. I'll just show a few steps. So this is the small craniotomy that you can see. This is the frontal lobe. First step is releasing CSF from the Sylvian cistern here. So laterally you go in and you remove the CSF. So once the brain becomes lax, then you can start attacking the tumor. So mild retraction of the frontal lobe just to show the tuberculum sellae meningioma. And then you go on to the attachment. You start the basal disconnection from the attachment. As far as sometimes the tumors are huge, so that time you have to go in and debulk the tumor, and then the aim is coming back here to this basal attachment, and then slowly remove the tumor. Identify the optic nerve early during the surgery. So you see here, this is the optic nerve. Once you have identified the optic nerve, you have to preserve it, and then slowly you have to go on debulking the tumor. See, sometimes they're pretty firm, as you can see here. They're not suckable. So you might have to use some sharp instruments to actually cut the tumor and remove them. Every time you have to keep the optic nerve into picture and then going laterally. You have to also preserve all the perforators that come in this region, because damage to one perforator will cause some kind of problem, neurological deficit to the patient, or it may also cause hypothalamic and pituitary insufficiency. So you have to be very careful when you're dissecting in this region. So now this is the bulk of the tumor that is being removed. And you can see in the depth all the structures, the pituitary stalk. Let me see if I can show you. This is the last bit of the tumor. You see how densely adherent it is to the optic nerve. So this patient had a very huge visual deficit. This is because the tumor is adherent to the optic nerve, as you can see in this image. And here also the pituitary stalk was preserved and the patient did well following the surgery. Going further, so this is the post-operative image of this patient. You can see that the tumor has been completely removed. So just a few examples of pre-operative and post-operative images that you can see here. And they come in various sizes and shapes. They come with calcifications. They might extend to one side more than the other. They may extend posteriorly all the way where it comes in contact with the liquid membrane. And you have to know the anatomy of that region. Here you can see that it is dipping down and going close to the pituitary stalk. So here you can see that it is so closely adherent to this anterior cerebral artery complex. Here you see the A1s, the ACOM, and the A2. So this is the most defining part of the surgery, preserving the pituitary stalk and preserving the anterior cerebral arteries, and then the internal carotid arteries. Here you see this is a tuberculum sellae meningioma, but more extension on one side. This is, of course, a little bit straightforward tumor. Again, a tumor with a lot of anastosis. And here you see the arterial relations. And again, here the artery you can see in the picture, you operated by unifrontal approach, and you can see that the tumor has been removed very radically. And here again, operated by I did this patient recently, unifrontal approach, and you can see that the tumor has been removed completely. Again, another tumor with a lot of anastosis. We do not normally handle the anastosis unless it is coming in the way. We just coagulate over the basal attachment and then leave that. This is a tumor that we did 15 days back. And you see how huge it is and how the vessels are involved in the tumor. And you can see the post-operative image, unifrontal approach, the tumor has been removed radically. Now, before I go to clinoidal meningioma as the last part, here you see this tumor, it can be mistaken for a pituitary tumor, but you see that the sella is small in size. This is actually a tumor, a meningioma of the diaphragma sellae. So it is arising from the dura of the diaphragma sellae and going up. So this is another example of our anterior skull-based meningioma, diaphragma sellae meningioma. Coming to anterior clinoidal meningioma, these are a little more difficult to operate because of their intimate relation with the internal carotid artery. And again, we have devised this method, this grading system, where we use vision and the ICA relation with the tumor to decide the difficulty in resecting. So here you see the tumor is just abutting the ICA. Here it is encasing the ICA without narrowing the lumen. Here it is encasing the ICA and narrowing the lumen. And here it is going to the contralateral side. So of course, these are more difficult tumors to operate. And as the grade increases, the tumor difficulty of excision also increases. For anterior clinoidal meningiomas, you use a standard frontotemporal craniotomy or the pterional approach because you need a lateral exposure also, again, going through the Sylvian fissure or going through the chiasmatic cistern to release CSF. And then this is the anatomy of the exposure. You're working within these cisterns, the Sylvian cistern and the carotid cistern. Identify the ICA early in the surgery, identify where it is branching, both the ACA and the MCA. And it is most critical to preserve these three vascular structures when you're operating on anterior clinoidal meningiomas. So just a few examples before I end my presentation. Here you see how the vessels are encased, and here you see the complete resection. Again, another patient with a clinoidal meningioma. This is a classic radiological picture of an anterior clinoidal meningioma. Here you see the tumor, how it is resecting, and the post-op. Again, another tumor where the ICA is encased by the tumor, and this is post-resection. This is again another anterior clinoidal meningioma, more extending towards the medial side, and this is the post-operative image showing the resection, another meningioma. Lastly, coming to endoscopy, we do not recommend endoscopic excision of these anterior skull-based meningiomas because of their intimate relations with neurovascular structures and their lateral extension. But just to show you a picture, this is the endoscopic view that you will see if you're using that for operating on these tumors, but we don't recommend it. Thank you very much.
Thank you, dear Avida, for this excellent presentation. Is there any question? I have greetings here from my family to you, Avida.
Thank you, Samaya. Tell your wife hi also. And nice to see you.
Thank you.
You disappeared from.
Nice to see you. Thank you.
Thank
and
you.
now we wish to next speaker, Dr. Abraham. Please start sharing your screen.
Yes.
Can you see my screen and am I audible, sir?
Yeah.
Yes. So, good afternoon from India to all the august audience, and thank you, Professor Same, for giving me this opportunity. I'm going to present an endoscopic superior eyelid transorbital excision of a sphenoid-cavernous meningioma. So this is the city of Hyderabad and the hospital where I work. It's the city of Nizams and city of pearls with excellent city architecture and wide range of culture. So coming to the case point, so this is a 50-year-old female patient. She presented with a right-sided visual blurring for the past 6 months. She had headache and giddiness and also vertigo. Peripherally, patient was treated by some otologist and neurologist, thinking it as a viral encephalitis, and she showed gradual worsening with the mild right eye proptosis, as we can see in this image that she's having a mild right eye axial proptosis. On evaluation, she was found to have scotomas in the visual field and also grade 5 papilledema on fundus examination. Coming to the imaging, we can see that there is a extraxial lesion which is contrast enhancing and mainly in the right temporal fossa, which is encasing the right cavernous ICA, and a small part of it is going into the right posterior ethmoid. And the majority of the lesion is in temporal fossa and also infratemporal fossa, as we can see in the coronal images also. And here we can see how the lesion has encased the right cavernous ICM. So based on this, if we see the literature review, these are multiple recent papers which shows that progression-free survival and prognostic factors based on different surgical approaches to the sphenoorbital meningiomas. The approaches, these lesions are like carpet-like infiltrative diffuse lesions, and also they have wide hyperostotic bones spreading along the sphenoid crust. And also, there are multiple surgical approaches. We can do a pterional craniotomy. We can add an orbitotomy and zygomatic osteotomy to these approaches. But the another important factor we have to consider here is when we do these approaches, there is a lot of temporalis muscle dissection, big craniotomies, big incisions, postoperative edema, and all. So for the recent approach that is being followed in neurosurgery is the transorbital, endoscopic transorbital approach. When we see the anatomy of this approach, this is an anterolateral trajectory which gives the same trajectory as we are coming up from the pterional craniotomy or orbitotomy or zygomatic osteotomy. So it takes us straight by drilling the greater wing of sphenoid, that is the lateral orbital wall, and it takes us straight almost near the anterior clinoid process, and not only that, it takes us to the cranial fossa, and also we can go till petrous apex. There are studies that are underway which showed that we can even drill the petrous apex and reach lesions to the posterior fossa. So when we see this in the second image, as we approach from the orbit, we can go till the anterior clinoid process. We can even drill the optic strut, and also we can go till the dorsum sellae, the yellow lines, and also till the posterior clinoid process. And coming to the virtual planning video, like what made me choose this approach is, as we can see in this virtual planning, that the lesion is involving the greater wing of sphenoid, the lateral orbit wall, and also the temporal bone, temporal base bone. And as we can see through the orbit, through the volume of the orbit, we can see that the lesion is majorly in the temporal fossa and it is going into the infratemporal fossa. It is below the optic now. And we can see that the lesion is encasing the right ICA. when we see it from the front, we can see that there is a small part of tumor in the posterior ethmoid. And this is the opposite ICA, cavernous ICA, and the lesion is completely away from the optic nerve, optic chasm, and optic tract. So this is an ideal case for endoscopic transorbital approach. So this is the patient position. I usually turn about 20 degrees away from my surgical field with navigation, optical navigation. This is the small curvilinear incision that is based on the superior eyelid crease. So the dissection will be suborbicularis plane, and once the periosteum is identified, we'll sharply divide the periosteum. And then in the fourth image, we can see how I have exposed the lateral orbital wall without damaging the periorbital. So coming to the surgical video, so this is a pure endoscopic approach. As we enter the orbit, when the globe is retracted, we can see the recurrent meningeal artery. It always points towards superior orbital fissure. Once this is done, we can start drilling the greater wing of sphenoid, that is lateral orbital wall, from the lateral to medial direction. And this is further drilling of greater wing of sphenoid. So this is an important landmark called sagittal crust. Sagittal crust is where the coronal orientation changes into the sagittal orientation, and that points us towards the orbitomeningeal artery. Orbitomeningeal artery is which we can coagulate and cut to expose the frontal and temporal dura. And this is towards the base where I'm dissecting towards the orbital floor and infratemporal fossa, which can also be drilled to go into the infratemporal fossa. And now I'm drilling towards, now we can see the superior orbital fissure and also the inferior orbital fissure. So this is the exposure from superior orbital and inferior orbital fissure, and the bone is drilled off completely from superior to inferior orbital fissure. Now I am taking off the bone from the frontal base. We can see the temporal lobe dura. As this is a meningioma, I'm exposing more towards the frontal base. Now we can see that the dura is hypervascular, which is being coagulated and then cut. After this, we can see the separate arachnoid being separated from the sylvian veins without damaging it. And now I'm doing a durotomy to further increase my space. And now the lesion is coming into place, that is the biopsy. And once biopsy is taken, I further proceeded with the CUSA, taking out the tumor. Tumor is quite vascular. With CUSA and with coagulation, further tumor dissection. Now we can see that the cavernous part of lesion, there is a mild bleeding at this cavernous part. So a hemostat has been applied there to control the bleeding. And once the bleeding is reduced with minimal coagulation, the bleeding has stopped. And we can see here the petrous apex also. And after confirming safe maximal excision of the lesion, hemostat has been applied. And this is the postoperative scan showing the axis and removal of the lesion. And this is the postoperative CT showing the complete removal of greater wing of sphenoid till optic strut and optic canal, and also the hyperostotic temporal bone also has been removed. And this is the post-op reduction in proptosis to the patient, and patient was discharged on second post-operative day without any significant swelling. There is no big incision or there is no significant craniotomy. So on concluding, I have taken a right superior eyelid crease incision, lateral orbitotomy has been done, greater sphenoid wing has been drilled from superior to inferior orbital fissure, temporal dura, infratemporal fossa and periorbital were defined. Temporal dura has been opened and tumor was excised. Infratemporal fossa part of the tumor also has been excised. There is a residual tumor at cavernous sinus wall and also along right cavernous ICA. Sphenoid sinus, small part is very difficult to access from this approach. So patient's scotoma has been improved. She was discharged on postoperative day 2 and her biopsy came as transitional meningioma. There were no restriction and extraocular movements noted after surgery. One important thing I want to emphasize is for every 20 minutes, our anesthetist keep an alarm asking me to take out the retractor from the periorbita to prevent any globe injuries or compression on the optic nerve. So coming to the post-operative clinical status, this is 3 months post-operatively. We can see that there is no visible scar. It has blended nicely with the superior eyelid crease incision. And in the post-operative MRI, coming from topmost cuts to lowermost cuts, showing the resection cavity with only a small bit of tumor at the cavernous ICA and posterior ethmoid. Thank you.
Thank you, everyone, for this excellent presentation.
Okay, I have a question,
you.
Sam. You see the question in the chat?
Yeah, I have checked it. It was about internet connection, nothing more. Is there any question?
Yes, there's the one in the chat, Sam.
Sir, I'm not able to see the chat.
Okay, when you encounter cavernous bleeding, how do we continue the surgery?
Yes, that is why I have used a hemostat material that is thrombin and log, and once it has stopped, because of cavernous bleed is majorly of venous ooze, so it will stop with the hemostat materials.
Thank you.
Thank you.
Okay, Sam.
Dr. Said, you have a question?
Yes, just to tell, it's thank you for this wonderful presentation. I think I do meningioma of sphenopetrosal meningioma for many years with craniotomy, but actually about probably 10 years I do mini surgery, look, with the mini incision, like less than 1 centimeter in the orbit, and that allow to access to all the lateral wall of the orbita and the frontal region and inferior temporal fossa. It's less invasive, but with good results. Thank you very much for your presentation.
Thank you. Thank you all for giving me this opportunity.
Thank you. And now we will shift to next speaker, Professor Kuntal Das.
Yes, Dr. Sam, can you hear me?
Yeah, sure. Please start sharing your screen.
Sure. Can you see the screen now?
Yeah, perfect.
Yes.
Perfect.
Right then.
Please go ahead.
Yes, good afternoon from India. First and foremost, I'd like to thank Dr. Sameh for including me in this prestigious 4th World Skull-Base Congress. So I shall be presenting this lecture, Extended Exposure of the petrocleval region using the combined Dölling-Kawase approach. Right. So whenever we talk about pathologies in this circled area, that is the area of the central skull base and in the upper retroclival area, we have several hurdles that we are looking at. These include the bony prominences over there, the anterior clinoid, posterior clinoid, as well as the petrous apex. We have several cranial nerves which are straddling this area, lying on the lateral wall of the cavernous sinus, as well as the petrous apex. Then we have several important arteries, namely the antral carotid artery, the petrous segment, the laceral and the cavernous segment. And we have important veins as well, which make surgery in this area quite complicated. So we have two traditional transcranial approaches to deal with these lesions. And although we know that many of these lesions are amenable to endoscopic endonasal approach in the modern times, but still some of these pathologies would require one of these traditional transcranial approaches. In the first picture, you see an anterolateral approach or the transcavernous approach. This approach essentially gives exposure to the suprasellar area, the upper clival area, the upper CP angle, medial to the fifth cranial nerve. On the other hand, the posterolateral approach is one which takes us to the same area from a more lateral perspective, lateral to the fifth cranial nerve. So each of these approaches have their own advantages and disadvantages. In this elegant study from the Barrows group, these two approaches were actually compared, and it was found that in terms of area of surgical exposure and linear exposure of the basilar artery, the Dolling's approach had greater superficial exposure. On the other hand, the Kawas's approach provided more linear exposure of the basilar artery. So the exposure was different with different approaches. In particular, the Dolling's approach, it provided a more caudal exposure of the vertebro-basilar system, which is around 6.1 millimeter. And in terms of the angulation of the approach, it was found that the Dolling's approach, that is the transcavernous approach, it provided more vertical angulation. And the differences in these approaches have been eloquently described, and I would be happy if the listeners can go in and read this paper. So coming back to the topic of my presentation, it is about joining the two masters, Professor Dolling and Professor Kawase. And as we all know that when the adversary is a formidable one, it always helps to have your best players on the field together. So what is the rationale of joining these giants? First and foremost, it gives wider horizontal and vertical exposure, as we have seen. Then it gives a distributed temporal lobe retraction. This is something that we tend to ignore. But whenever we're talking about subtemporal approaches, be it intradural or extradural, we have to minimize the traction and the contusion of the temporal lobe. And in this regards, a wide exposure by combining these two approaches gives a distributed temporal lobe retraction. Then as I will show in my videos, one can release the CSF from the basal cisterns early, and one doesn't have to put in a lumbar drain whenever such a procedure is being planned. So combining the two approaches allows you to let out some CSF without having to make another puncture in the spine. Then extended exposure of the petroclival junction, which is necessary in some large pathologies, can be obtained through this combination. So in our experience, we generally use this approach in multi-compartmental lesions like petroclival meningioma, trigeminal schwannoma, and epidermoids. Then certain vascular pathologies like large aneurysms involving the vertebro-basilar, the basilar apex area and the basilar trunk. Then in some localized lesions of the anterior petrous area, for example, the anterior petrosal lesions also, we sometimes use a combination of these two approaches because it gives a wider exposure. And as I said, it gives us an option to release CSF. And this relaxation of the dural tube, it makes our extradural work much easy. So this is the incision that we use, nothing special in here. But our group, we tend to no longer use the orbitozygomatic approach. What we do is we do the zygoma lowering, and in our experience, this is more than sufficient to give us the superficial access. In our experience, it is the deeper access and the deeper expansion of the surgical corridor that is more important than the surface. So I'll take you through this short video of a patient just to show you the steps of how these two approaches are combined. This is a right-sided frontotemporal craniotomy. You can see that the meningioorbital band is being divided. Now, this is the first step because this is the beginning of the dural peeling. The dura is tethered over here. And once this is incised, we can start the peeling. You can see the sphenoparietal sinus. The sphenoparietal sinus is a very important structure, and in order to preserve it, we have to use sharp dissection and elevate the sphenoparietal sinus with the temporal dura. As the dural peeling is done, the clinoid gets exposed. And as I showed in the beginning, this is one innovation that we have done. We tend to release some CSF from around the optic nerve at this stage. This relaxes the dura. Then the optic nerve is deroped. Now, the only attachment that the clinoid still has is the optic strut. The optic strut is drilled under direct vision, end on. And when these three connections are disconnected, the clinoid comes out pretty easily. We can see the clinoidal cone, the optic strut. Once entry-clinoid has been removed, the peeling is continued posteriorly. We can see the V1, we can see the V2, and we can see the sphenoparietal sinus draining in between V1, V2 into the entry-cavernous sinus. We use sharp dissection here because it is vein-friendly. We inject glue inside the cavernous sinus with simultaneous compression of the sphenoparietal sinus to achieve hemostasis. The dural peeling continues posteriorly by a combination of sharp and blunt dissection. We can see the V3. We can see the GSPM, and the petrous apex is exposed. We can see the free edge of the petrous. This is the free edge. We can see the trigeminal impression. So this is the area of the petrous apex. The outline of the petrosectomy, the Kawashi's rhomboid has been shown. And in this landmark, utilizing this landmark, the enteropetrous is drilled away. Now, by elevating the trigeminal ganglion, as we're doing here, one can extend the petrosal removal more towards the clivus. And we get such an exposure, the posterior fossa, the middle fossa, and the superior petrosal sinus in between. Then the dura is opened close to the skull base. This is very important because the rest of the dura, it keeps the brain covered. And we are working at an area where we really need to work. Until you can see the second cranial nerve, the carotid, third nerve. We can see the fifth cranial nerve here. And the fourth nerve. So you can see the kind of exposure, horizontal exposure that we get. And one can utilize the windows in between these structures to take out the pathology of interest. Coming to a case of a right-sided petrous apex lesion with predominant posterior fossa extension. Pre-op radiology suggested the diagnosis of a petroclival meningioma. This patient presented with headache and facial pain. We took her up for a right-sided combined Dowling-Kawashi approach. After frontotemporal craniotomy, we did a small posterior orbitotomy. The roof of the optic nerve was removed. We let out some CSF at this stage. The CSF release, it makes the dural peeling easier. We can see the tumor has occupied the cavernous sinus. We're in the area of the petrous apex. The tumor has done some kind of remodeling of the petrous apex. The tentorium is divided and the tumor comes into our view. When the tumor is large, the steps of decompression and devascularization, they can alternate. And the petrosal remodeling that was done by the tumor was not sufficient. Then we did the proper enteropetrosectomy in the Kawashi's rhomboid. And the posterior fossa and the middle fossa dura were connected. We can see the fourth cranial nerve. This is the area of the Michel's cape. The tumor had gone inside the Michel's cape. And it is very important to clear out the tumor from this zone. This is the part of the tumor that is going into the posterior fossa with the fifth nerve draped over it. The fifth nerve has been flattened, as you see. It is very important to dissect the tumor sharply and in a way that the fifth nerve is not endangered further. Superiorly, we can see the interpeduncular cisternar area, the third cranial nerve. We can see the PCA. Using sharp dissection, this arachnoid bands are divided. And using a combination of attraction and counter-traction, this tumor is gradually delivered into the main surgical field. We can see the brainstem below. We can see the stretching of the fourth nerve. The fourth nerve undergoes a lot of stretching when the tumor grows insidiously, as is the case here. The draped fourth cranial nerve has been mobilized and the tumor is gradually debulked. Dissected, we can see the brainstem. Small inseparable adhesions onto the brainstem must be left behind to be taken care of by stereotactic radiosurgery. We can see the basilar artery, which is dividing into the posterior cerebral arteries. We can see the kind of extended exposure that combination of the two skull base approaches has provided us here. The dura is closed with a combination of direct suturing and fat plugging. Postoperatively, the patient developed transient third paresis, but otherwise she was neurologically intact. And at 10 months follow-up, she has completely regained her ocular movements. The facial pain has resolved. Some trigeminal numbness still remains, and the postoperative scans show complete tumor resection. Coming to another situation where we use the combination of such an approach is lesion, which is more centered on the posterior cranial fossa in the region of the petrous apex without much middle fossa extension. This was a 43-year-old gentleman with headache and diplopia. And as we see, compared to the previous patient, this tumor is more in the midline, and it has more extension into the posterior cranial fossa. So this is a case which can be removed by the standard Kawas's approach. But in our experience, the standard Kawas's approach gives us a limited exposure. So in such a case, we like to combine it with the transcavernous exposure. We see the surgical video here, right frontotemporal craniotomy was done, and the optic nerve was deruled. We see the extradural optic nerve, and we release some CSF from a small window in front of the optic nerve, as is our practice. This relaxes the dura. We can see the anteroclinoid process. The optic strut is drilled under vision, and the clinoid is reduced in size and finally removed. We can see the reduced size of the clinoid. This is the clinoidal cone. The dural peeling continues posteriorly, and we expose the area of the petrous apex. We can see the area of the petrous apex, the trigeminal impression, the free edge of the petrous, the GESPN here. We can see the arcuate eminence. The fifth nerve is further mobilized so that we can remove the subtrigeminal part of the petrous apex. The landmarks of the anterior petrosectomy are shown again. It is very important to expose the seventh cranial nerve posteriorly and to remove this block of bone below the trigeminal nerve in order to have an expanded anterior petrosectomy. The tumor has come into our view. The tumor is relatively soft. The sixth nerve is seen draped on the tumor. The tumor is relatively vascular, as you see. As we decompress the size of the tumor, we are able to get to the periphery. The basilar trunk comes into our view. In order to have the cranial exposure, we open the temporal dura and we cut the tentorium. Division of the tentorium is conducted till we reach the free edge behind the fourth cranial nerve. So you can see the fourth cranial nerve here. In order to have a further mobility of the fifth nerve, we divide the Michel's cave dura. Now we have the tumor above as well as below the fifth cranial nerve. Using a combination of dissector and suction, the tumor is gradually reduced in size until we are able to roll the tumor off from the underlying important structures. We can see the basilar artery here. And we progressively reduce the size of the tumor, sharply divide the attachments. And this is the final attachments onto the clivus. We can see a nice exposure of the retroclival area here. The basilar trunk, we can see. We can see the fifth cranial nerve, which was at the center of the exposure. And the postoperative scans show complete tumor resection. This patient did have some transient right ophthalmoparesis, which recovered in 2 months. He had post-op meningitis, which resolved with antibiotics, and at 2 years follow-up, he's independent. Biopsy revealed the diagnosis of intradural chordoma, but the tumor was completely resected, so we are following him up. This approach was utilized in our experience in multicompartmental epidermoids like this, as you see, as well as in anterior petrosal meningiomas, which can otherwise be removed by a Kawas's approach. But by combination of the two approaches, as we have shown, we get a wider exposure and we're able to deflate the dural tube by releasing CSF without the need of a lumbar drain. We have used this in some complicated vascular conditions as well, like this post-coiled large basilar trunk aneurysm. There are, of course, certain disadvantages unless it is done carefully, like temporal lobe contusion, but positioning, CSF release, as we have shown, and suture retraction of the dura are useful. Venous infarction can be minimized by superior petrosal sinus management and evenly spread distribution, like we have highlighted. Cavernous sinus bleeding can be an issue, but it can be controlled very well with glue injection between V1, V2. Cranial nerve dysfunction sometimes is there, but it is most often temporary. But properly releasing these cranial nerves could lessen the chances. CSF leak can be a problem. So studying the preoperative CT scan is important, and sealing the opened up bony, the air sinuses with the help of fat and bone bags is crucial. Therefore, to conclude, even in this era of endoscopy and stereotactic radiosurgery, we should not abandon these approaches. They can provide us excellent multi-angle and wide exposure of the central skull base area. And in our understanding, they still remain relevant, and we should not forget these approaches. What is necessary is to maintain expertise in this field and to further refine these approaches so that they suit our contemporary needs. So thank you again. I'm thankful for this opportunity. I'm open for questions. Thank you.
Thank you, Dr. Des, for this excellent presentation. Is there any question from panelists?
Yeah, myself, Dr. Vinod.
Do you know, I cannot hear them. Do you know why?
I can hear you. Can you hear me, sir?
Is your sound on? Speakers is on.
I can hear you, Dr. Sameh.
This is Professor Lanzino.
Okay. Sir, I can hear you. Please go ahead.
I think he is trying something.
Can I ask?
Yeah, sure, sir. I can hear you.
Go ahead, Vino. Go ahead, Vino.
Yeah, very nice presentation.
Thank you, sir. Thank you.
Well, a simple comment. Basically, while we are doing this drill work at such a, you can say, a remote area.
Right.
Okay. When at very depth of the brain skull base.
Yes.
So what I do, I basically put these gel foams around those drilling areas. I don't use cottons. Basically, cottonade, what happens? The cottonade, those get stuck with those drill bits many a time.
Yes, sir.
So I use this gel foams.
Right.
So the bony fragments, that those also being caught there, and the like cotton, these gel foams are not stuck with the drill bits. Okay, just a comment. Nothing else.
Yes, sir. I think I couldn't agree more with you. I think using cottonoid could be tricky there. It can get stuck to the drill bit. So one has to be careful and minimize the use of cotton. And as you have suggested, gel foam could be a good replacement. And I think your point is absolutely valid. Thank you.
Thank you. Thank you.
Any more questions, Dr. Sameh?
Thank you, Professor Des, for this excellent presentation and discussion. Thank you.
Thank you. Thank you. It's a pleasure. Thank you.
And now we'll shift to next speaker, Professor Lanzino. Do you hear us?
Hey, Sam, I have Manas's presentation. Do you want to have Manas speak first, Sam?
Yeah. We will take the speakers first.
You gonna come into the panel? So I can share his screen now.
Professor Lanzino will start sharing his screen now.
Okay, do you want me to start the presentation? Hello, Sam, do you want me to start the presentation?
Yes, he is here and
Good morning, and I apologize for the issues. I'm traveling. It's a pleasure to be here with this esteemed panel. And my presentation today is on surgery for tentorial dural AV fistula. These are very interesting lesions that might appear quite intimidated at first, but when decodified, they can be easily treated, and surgery still has a fairly important role in the management of these lesions. I'll try to share my screen here, and okay, you can all see my screen.
Yes, perfect.
So, as I said, tentorial dural AV fistula have very well-defined patterns. At times, even though endovascular embolization is today often the first line of treatment, endovascular might not be the safest or might not be visible in some situations. And as I said, once decodified, the surgery for these lesions, it's fairly straightforward. So as I said, that there are very well-defined patterns, and the most common one being the so-called lateral tentorial dural AV fistulas. These lesions, they have exclusive retrograde venous drainage. Typical, the draining vein, which emanates from the dura at the level of is where the superior petrosal vein system joins the superior petrosal synods. This is an example of a lady with a 69-year-old with a history of imbalance, dizziness, and diplopia. So in patients who present with the neurological deficit, it's fairly typical, this history of progressive, slow clinical deterioration. And you can see here that there are prominent flow voids on the MRI with the venous varices, and one can hint here the place where the draining vein is emanating from the dura. And here is this an external carotid artery injection with the filling of the dura fistula from tentorial branches of the middle meningeal artery, and supply also from the occipital artery. And this is on the expert CT. There is supply from the internal carotid artery through the meningo-hypophyseal artery. And this is the surgery through a right-sided retrosigmoid approach. It's fairly straightforward. As I said, you go down at the level of the junction of the tentorium with the petrous ridge, and you can see all this network of arteries joining into forming a nidus, which eventually drains through a large arterialized draining vein as it emerges from the dura. And this originally is one of those veins being part of the petrosal system. It's important to identify very well the point of emergence of the vein from the dura. And then once identified, the treatment is pretty straightforward, and it consists of closure of the proximal portion of the arterialized draining vein. And this is the comparison with the, this is the post CT showing, CT angiogram showing the clip and the thrombosed venous varix. This is the comparison between the pre and the post-op MRI, with the post-op MRI on the right. And you see progressive resolution and involution of the large arterialized draining veins. This is another similar case, a short video again to drive home the message that once these fistulas have a well-defined pattern, supply from the meningoepiphyseal artery and occipital and middle meningeal artery branches. On the CTA, we can see here the point of fistula, retrosigmoid approach, and again, you see different case, but exactly the same similar intraoperative appearance. The junction of the tentorium with the petrous ridge and the large arterialized draining vein which emanates from the dura, with the treatment being pretty straightforward, the occlusion of the proximal portion of the draining vein. And this is the pre and post-op angiograms confirming complete obliteration of the fistula. So from the lateral tentorial dural AV fistulas, which are the most common types, we'll go to a different type that is the second most common. And these are defined as medial posterior tentorial dural AV fistula. This is a case of a 61-year-old which was followed with serial MRI scans for an incidental CP angle meningioma that was treated elsewhere with gamma knife. But as this patient was being followed, you can see on the right-hand side the progressive evolution and formation of fluovoids with barrix. The first thought that could have been an aneurysm, but the angiogram reveals, you can see here on the lateral, you can see supply from tentorial branches of the superior cerebellar artery and the posterior meningeal supply from the vertebral artery. And you can see you can identify the point of fistulization, which is in the posterior inferior aspect of the tentorium. You can see the venous barrix that we saw on the MRI. The AP is very important because these fistulas, the draining vein, it's usually immediately on the side of the midline. So in this case, it would be on the left hand side. And you can see here, this is the patient in the semi-sitting position. So as we open the dura, the falx cerebelli, and you can see that immediately to the left of the falx cerebelli, there is a large arterialized draining vein which emanates from the dura immediately underneath the straight sinus. And again, here it's important to isolate the draining vein for 360 degrees all around, so that you are able to identify ECG fluorescence, confirms early filling of the arterialized draining vein. And once again, they might look intimidating on the angiogram, but once understood the pattern, then the treatment is pretty straightforward with the clip ligation of that arterialized draining vein. And then the last type I like to underline is the so-called anterior medial or the galenic type. So these are fistulas that are localized in the proximity of the midline, but unlike the previous type, they are anterior along the tentorial incisura and therefore involve a vein that is part of the galenic system. 44-year-old presented with increasing headaches, and on the MRI you can see the presence on the right of some large flow voids, and the angiogram which confirms arteriovenous shunting in the region of the galenic system, supply again from tentorial branches of the middle meningeal artery with convergence at the level you can see here, where the vein of Rosenthal is joining the vein of Galen. The AP here, it's important because it shows that the fistula is on the right side, but there is a secondary involvement of the contralateral side, and but the actual point of fistula is off to the right side of the midline. You can see, you can localize the point of fistula very well in these dural fistulas on the CT angiogram, and you can see here the arterialized vein emanating at the level of where it's supposed to join the superior sagittal, the galenic system. Here is the patient again in the semi-sitting position. We are opening the quadrigeminal system to the right side, and you can see immediately in the depth of the field the arterialized vein as it emanates from the dura at the point where was supposed to join the galenic system. And again, temporary clip placed on the arterialized vein, ICG fluorescence, which confirms occlusion of the, here is the arterialized vein. And to confirm, make sure that everything was okay, that I understood the fistula correctly, I placed the temporary clip first, and then ICG fluorescence to confirm that there was no early filling of the vein, while everything else was still filling at the right time. There was no abnormal swelling and eventually complete occlusion of the fistula. And here is the comparison of the pre and post. So in conclusion, tentorial AVA dural fistulas have well-defined patterns. Endovascular embolization, even today, might not be necessarily in some situations either the safest option, or at times might not be feasible. And once defined and decodified, once you understand that these patterns, then the surgical treatment becomes fairly straightforward, even though the fistulas might appear quite challenging looking at the angiograms. I thank you for giving me this opportunity. I apologize for the technical issues. Unfortunately, on my computer, I cannot hear the audio, so I won't be able to participate in the discussions. But again, thank you to all my colleagues and friends for giving me this opportunity, and congratulations once again to Dr. Morsi for another successful neurosurgical marathon.
Thank you, Professor Lanzino, for this excellent presentation. Please, if you have any question, just type it in chat box and I will send it to Professor Lanzino. Thank you. And now we'll shift to the next speaker, Professor Alvaro Cambero. Please start sharing your screen.
Okay, Sam, do you want me to share Manas's screen, right?
Cambero will start.
Yeah, let me do it right now, Sam.
Cambero.
Are you ready for it?
Hello, how are you?
Hello, please go ahead.
Okay. Can you see the screen?
Yes, perfect.
Okay. Hello, everyone. First of all, thank you very much, Dr. Morsi, for the invitation. It is a big pleasure to be here. I'm going to talk about the petroclival region meningiomas and the useful of the retrosigmoid approach. The petroclival region is around the petroclival fissure. So a meningioma that starts in this region, we can say petroclival region meningioma. And it is important to understand the position of the meningioma in relation with the fifth cranial nerve. So we have petrous apex meningiomas that is lateral to the trigeminal nerve. And we can see one example of the petrous apex meningioma. The true petroclival meningioma that the origin is medial to the fifth cranial nerve, and we can see a case of a true petroclival meningioma, but also some tentorial meningioma that grow to the inferior part and mobilize usually the trigeminal nerve to the inferior portion, is also at the level of the petroclival region. And we can see one example of tentorial meningioma in the region, in the petroclival region. And also we have another kind of meningioma that also is in the petroclival region, but also in the posterior portion of the petrous bone, like this tumor. And sometimes we have meningiomas in the petroclival region, but also go to the middle cranial fossa, cavernous sinus, and so on. And another case in the posterior fossa and also in the Meckel's cave. So we have different situations. We can see another different situation in the petroclival region, in the foramen magnum region, and also in the spine, in the superior cervical spine region. And I am going to talk now in this lecture about the retrosigmoid approach, the useful in this kind of meningiomas. And in the retrosigmoid approach, we always use the semi-sitting position. We can use the supracerebellar view, a laterocerebellar view that is the more that usually we use, and of course the infracerebellar view. But we have also some accessories from the retrosigmoid approach, and that's the drilling of the internal auditory canal that usually we use more in the vestibular schwannoma, but also in some kind of meningiomas. The drilling of the suprameatal tubercle, that it is very useful in some kind of petrous apex meningioma and sometimes in some true petroclival meningiomas. Also the drilling of the petrosal apex in some kind of tumor that go to the Meckel's cave, and also the tentorial opening. So I am going to share with you some cases. The first case, a very small petrous apex meningioma in a lady with an atypical trigeminal neuralgia. We can see here the trigeminal nerve in the left side, but not in the right side, because the meningioma mobilized the nerve. And we can see this is the suprameatal tubercle that sometimes it is need to drill. And this is the view in the surgery in the semi-sitting position. This is the suprameatal tubercle that we are drilling in order to expose the meningioma. And now we are coagulating and then cutting the attachment at the level of the petrous apex and a little bit in the lateral portion of the tentorium. And this is the final view with the nerve, the fifth cranial nerve, all completely free of tumor. And we can see the pre and post-op MRI also in the T2, and the patient after the surgery without the trigeminal neuralgia. Another case, also a petrous apex meningioma that go a little bit to the Meckel's cave in the left side. We can see here in the T2, and the same thing in the semi-sitting position, left side tentorium. We have a big petrous vein, but we try to not to perform any damage. We remove first the portion of the tumor in the sepal angle, but then we are drilling the petrous apex from the posterior view in order to mobilize the tumor that go to the Meckel's cave, because the patient has an atypical trigeminal neuralgia. Final view, this is the tentorium, fourth cranial nerve, the superior petrosal vein, fifth cranial nerve, ICA, and the 7 and 8 cranial nerve. And we can see the pre and post-op MRI in the axial view, in the coronal view, and also in T2 with the freedom of the fifth cranial nerve and the patient after the surgery. Another case, a tumor with the posterior, this is the attachment in the posterior portion of the petrous bone, in the sepal angle, anterior portion of the petrous bone, and also a little bit at the level of the clivus and petroclival region. We can see some kind of edema, but at the level not of the brain stem, but at the level of the middle cerebellar peduncle. We can see the upper portion of the tumor at the level of the mesencephalon, and in the coronal view, and in the sagittal and parasagittal view, and also in the T2, we can see the relation with the tentorium. So we use also the retrosigmoid approach in the semi-sitting position. This is the 7 and 8 cranial nerve, now performing the debulking of the tumor with the ultrasonic aspiration. Now we are drilling the suprameatal tubercle in order to have a better visualization of the petrous apex. And now we are removing the superior portion of the tumor, final view, with the basilar artery, fifth cranial nerve, sixth cranial nerve, the 7 and 8 cranial nerve. And we can see the pre and post-op MRI in the axial view, in the superior portion of the axial view, with a good visualization of the mesencephalon, and also in the coronal view and in the sagittal view with a good visualization also of the brain stem and the patient after the surgery. Another case, similar case in the left side with some involucration of the vertebral artery, the before portion of the vertebral artery, also in the posterior portion of the petrous bone and the anterior portion of the petrous bone, and also at the petroclival region. We can see some kind of hyperostosis here at this level and in the upper portion of the tumor, with some amputation of the left side of the mesencephalon, and also in the sagittal and parasagittal view, we can see a upper portion, a portion above the tentorium, but also we can use the retrosigmoid approach in the semi-sitting position. The difference we can see here, the position of the mesencephalon here with the tumor, with the meningioma, and also we use the semi-sitting position with a classic retrosigmoid approach. Now we are performing the debulking. This is the supracerebellar view that it is very useful in this kind of tumor. So not just the lateral cerebellar view, but also here the supracerebellar. Now again, we are using the laterocerebellar view. This is the 7 and 8 cranial nerve, and this is the lower cranial nerves. We are separating the nerve from the tumor. And also it is very important, the ultrasonic aspiration, in order to perform the debulking. Now we are separating the tumor from the middle cerebral peduncle and trying to use the arachnoid in order to avoid the damage of the brainstem and also the nerves. This is some branch of the vertebral artery that is going to the tumor. And in the semi-sitting position, it is comfortable because the bleeding go down and we can work comfortable. This is the sixth cranial nerve that sometimes it's very difficult to recognize and to preserve, but we have to try to do that. We are following the sixth cranial nerve from below, from the brainstem to the skull base in order to avoid its damage. Now we are working in the superior portion of the tumor. This is the tentorium. So we are cutting the interface. This is the fourth cranial nerve, the interface with the tumor and the tentorium. This is the fifth cranial nerve. So we are cutting the attachment at the level of the petrous apex. We are following from below to up the fifth cranial nerve using some water in order to clean the operating field. And this is the most superior portion of the tumor. Sometimes we need to cut the tentorium. Sometimes it is not necessary. This is the third cranial nerve. So we are mobilizing the uppermost portion of the tumor. This is the third cranial nerve. And we are removing the tumor inside the internal auditory canal that it is in front of the 7 and 8 cranial nerve. This is the final view: sixth cranial nerve, fifth cranial nerve, third cranial nerve, 7 and 8 cranial nerve, brainstem, and so on. I don't have yet the MRI because I operate 1 month and a half before, but we can see the freedom of the mesencephalum and the patient with the little facial palsy that probably he will recover in a couple of weeks. Another case, very difficult case, patient that was operated before in another hospital, and with this subtemporal approach, he has also a shunt, and this is the tumor, tentorial meningioma with a big mobilization and of the brainstem. We can see here the mesencephalon and the tumor, and also in the coronal view and parasagittal view. So usually in this case also we use the retrosigmoid approach, but with the almost all the time with the supracerebellar approach. Now we are cutting some attachment, not just to the tentorium, but also to the petroclival region. This is the basilar artery. And now we are cutting the interface between the tentorium and the meningioma. And this is at the end of the surgery, but we can see that this a supracerebellar view of the operative field. And we can see the post-op CT scan, and we are now the patient in rehabilitation. Another case, a real petroclival meningioma, but a little bit small. This is the fifth cranial nerve and the tumor medially to the fifth cranial nerve. We can see also in the coronal and parasagittal view. This is the fifth cranial nerve, tentorium, suprameatal tubercle, 7 and 8 cranial nerve, Tübingen line. This is the ICA. So we are now drilling the suprameatal tubercle in order to have a room to can operate the tumor. We are coagulating the attachment and cutting the attachment. And because it is not so big tumor, we can remove in one piece. Sometimes we need to use the ultrasonic aspiration. And finally, we can see, because the patient also had an atypical trigeminal neuralgia, we can see the freedom of the fifth cranial nerve, the petrosal vein, the 7 and 8 cranial nerve, and the drilling of the suprameatal tubercle. And we can see the pre and post-op MRI in the coronal view and the patient after the surgery. We can see this case in 3D in operative neurosurgery in this year. Another case, a real petroclival meningioma with some hyperostosis. We can see the upper portion of the tumor at the level of the mesencephalum, and in the parasagittal view with the hyperostosis. And the same thing, retrosigmoid approach in the semi-sitting position, the fifth cranial nerve, 7 and 8 cranial nerve, tumor, and also the tentorium. So we are mobilizing the tumor using the ultrasonic aspiration. This is the sixth cranial nerve. Now, in this case, we are cutting the tentorium in order to remove the uppermost portion of the tumor. We can see this portion of the tumor, and at the end of the surgery, the third cranial nerve, lilicus membrane, basilar artery, clivus, and below the fifth cranial nerve, 7 and 8 cranial nerve, and pre and post-op MRI in the coronal view and also in the sagittal view, and the patient after the surgery. And the last case, another real true petroclival meningioma with a big displacement of the middle cerebral peduncle. We can see from below at the level of the inferior portion of the brain stem, and also in the sagittal and coronal view. Same thing, semi-sitting position, retrosigmoid approach using the ultrasonic aspiration. Now we are working above the 7 and 8 cranial nerve. Now we are mobilizing and separating the tumor from the brain stem. Now we can see the basilar artery. This is the sixth cranial nerve that usually we have to try to recognize at the brainstem level. And the final view, this is the clivus, 7 and 8 cranial nerve, 6th cranial nerve, and the remotion of the tumor. And we can see also the pre and post-op MRI in the axial view, in the coronal view, and in the sagittal view. And the patient after the surgery, at the beginning, she did a 6th cranial nerve palsy, but then she recovered. And in conclusion, by default, usually for the retrosigmoid, for the petroclival region meningioma, we use the retrosigmoid approach. Sometimes we choose the presigmoid approach, usually when the tumor have a little displacement of the middle cerebral peduncle, so we don't have good room for remove the tumor, and also when the tumor had a lot of brainstem edema, because with the presigmoid approach we have a better visualization of the interface between the tumor and the brainstem, and we choose the anterior transpetrosal approach when the tumor has a large extension to the middle fossa. But we have to remember that simplicity is the ultimate sophistication. Thank you very much for your attention.
Thank you, Campbell, for this excellent presentation and for sharing with us all these difficult cases. Is there any question?
Dr. Sami, can I ask one question?
Yeah, go ahead.
Dr. Campbell, it was an excellent presentation. There's Dr. Kuntal from India. So what I want to ask you is, in the first two cases you showed the tumors were pretty small, very small. So don't you consider stereotactic radiosurgery in such patients rather than a surgical removal?
To consider what, sorry?
So would you not consider a stereotactic radiosurgery for such a small lesion rather than resecting?
The problem is the patient had atypical trigeminal neuralgia, very, very high, and with the medication, the medication was not useful for that case. And we don't believe that the radiosurgery or stereotactic radiosurgery is so useful in that case. So I think with the simple surgery, with the resection, I think it is good. I didn't think about the radiosurgery. I prefer in that kind of cases to remove the tumor and give freedom to the trigeminal nerve. But of course, it is an option, of course.
Thank you.
Can I ask a
Thank you.
question?
Okay, go ahead. Thank you.
Hi, it's Sanjeev Jairana from Oxford. You have a very nice presentation, especially the last two cases, the sort of true petroclivals. Can I ask, what are your trigeminal nerve outcomes for the smaller ones where you came retrosigmoid, where the other option is to do a sort of Kawase and come, you have a nice sort of view of the trigeminal nerve, you come in front of it and you can just peel the tumor off rather than coming from behind and having to work on the trigeminal nerve. What's your view on maybe coming with an anterior petrosectomy rather than retrosigmoid when the tumor is medial and small to the trigeminal nerve?
It is an excellent option also. And of course, you can perform a better freedom of the trigeminal nerve because you cut from the anterior petrosal approach, and you have a 360-degree opening of the. But I feel very comfortable with the retrosigmoid approach, and in some cases, like in one case, I drill the petrous apex from posterior in order to not so much, in order to can remove the portion of the tumor that go to the Meckel's cave. But of course, it is a very good option, the Kawase approach. I think it is more simple to perform a retrosigmoid approach than the anterior petrosal approach. So, in my opinion, but of course, it depends the surgeon. We use a Kawase approach, but just for the tumor with a big portion in the Meckel's cave or also in the cavernous sinus, I mean in the middle fossa. But some surgeons prefer in that kind of tumor and Kawase approach, and of course it is a good option. I feel more comfortable with the retrosigmoid, but it is a good option.
No, thank you. It's very nice presentation.
Can I ask one more question, please?
Yes.
Dr. Alvarez? Yeah. So in Kawase's approach, you have to, by default, remove the anterior petrous, right?
What? Sorry?
Whenever you're going middle fossa approach, what I'm asking is, whenever the middle fossa Kawase's approach versus his approach, what we do is we remove the bone by default, okay? Whereas whenever we go retrosigmoid, we may or may not remove the suprameatal tubercle. It may or may not be necessary, right? So what do you think? If you don't drill this bone, does it contribute to recurrence later on in terms of neuro-oncological outcome?
At least in our cases, we don't have a recurrence of the you mean a recurrence of the meningioma?
Yes. Because in terms of Simpson's grade, I think Kawase's gives you better option of Simpson grade 1 resection compared to retrosigmoid.
Could be a good point to choose Kawase approach than the retrosigmoid approach, but at least in our case, we don't have a lot of cases of that, but at least we didn't have. But the lady had 77 years, so it is difficult to have time to the recurrence. And in the other case, I operate 2 years ago, so maybe we have, but at least all the cases that I operate with the retrosigmoid, at least now we didn't have a recurrence. But could be a good point to choose Kawase approach. I think for a small tumor, in my opinion, it is too much to do a Kawase approach with a very classic retrosigmoid approach. In a very short surgery, you can remove the tumor and so on. But it's, you have different many of do something in a good thing. I mean.
Thank you.
Thank you for this presentation and discussion. Thank you, Cambio. Now we will shift to the next speaker, Professor Abio Antonis. Please start sharing your screen.
Well, okay. Is that okay for you?
Perfect, perfect.
Okay, good
Yes.
morning. Good morning, people from South America. Good afternoon to you in Cairo, etc. And I'm going to show you a small series of cases of pituitary tumors, secreting pituitary tumors that we operated on in our university hospital here in Porto Alegre. Porto Alegre is south of Brazil. And this is a very homogeneous series because is operated by the same surgeon, is operated by the same ENT surgeon, and is followed up by the same endocrine group. This is the point. We have no disclosures. The series have a whole amount of 166 patients. We have small preponderance of female patients. The whole series is about 350 cases. All the patients have complete clinical, endocrine, and image workup, so it's a very homogeneous series, as I told you. And for the whole group, including secreting and no secreting, you can see some things which are quite common in university hospitals in Brazil, which is the whole group has at around 20% of panhypopit patients. And C, the most striking thing is that 47% of the patients have some kind of visual failure. We had 42 cases of acromegaly, 26 cases of Cushing's disease, and 9 cases of prolactin secreting tumors. The average age of symptoms, you see, is 46 years old, the patients, but their age range goes either from 17 to 80. And the follow-up, the mean follow-up is 4.5 years, but you can see you have patients follow up for 10 or perhaps 15 years. In all our approaches, we use the endoscopic endonasal, and as for the closure of the operation, if we don't see CSF fistula, we simply close the sella with small piece of cartilage, small piece of mucosa, and use the endoscopic endonasal. And if this is a enlarged sella, then we can use a piece of fat, of course, and the same closure as cartilage, mucosa, and fibrin glue. In the case of we find CSF fistula during the operation, then of course we use the so common mucosal flap. We usually closes perfectly the sella and stops the fistula. And sometimes in case of high flow fistulas, we use lumbar drainage in the postoperative period. This is the closure we use with free mucosa without flap. This is the sella at the end of the operation with diaphragm. This is the small piece of cartilage. This is a small piece of mucosa. And in the case of nasoseptal flap, you can see at the right side the nasoseptal flap. The treatment of functioning pituitary tumors, we have to consider the first thing is that we should never say cure of the patient, but clinical remission. But because these patients have to be followed up by the endocrine people for the most of their lives. So we should always use the clinical remission term. And the other thing which is quite important is that normalization of the hormonal function. This is the key point of the operation. You mean patients have to be completely controlled, either only with the operation or perhaps in some cases with endocrine treatment and perhaps with the surgery treatment. The biggest series almost published in the world is the group of John Jane and Ed Laws, and we can see in his paper, that's from 2022, that in GH secreting tumors, microadenomas, the remission is 88%, but in macroadenomas for GH is 65%. If you look for the ACTH adenomas, microadenomas have a 91% remission index, and for macroadenomas, 65. So this means that even in very, very, very specialized hands like Dr. Laws, the remission rate, especially in macroadenomas for functioning tumors, is 65 for GH tumors and 65 for Cushing's disease. So this series has 36 cases of GH secreting tumors, 23 ACTH, and 8 prolactin secreting tumors. Prolactin tumors, of course, patients present with amenorrhea, galactorrhea, and see 40% of them with visual field or visual acuity defect, and almost 30% of them had a preoperative panhypopete. As for the size of the tumor, you can see we had NOSP2 30%, NOSP3 20%, and NOSP4 35%. So all of them were big macroadenomas. And most of them, as considering immunohistochemistry, they were at least secreting GH and prolactin in 40%, only prolactin in 45%. And some of them had preoperative medical treatment with no success of cabergoline, and postoperative patients had no need of medication in the postoperative. Why we did operate prolactin secreting tumors? Of course, for the known reasons, 22% for apoplexy, 33% because they had resistance to medication, so the ladies decided to be operated on, and 22% because although clinically treated, they had this gross visual impairment, like you can see, 22%. We had a total and subtotal resection rate of 64%, and partial, we consider partial less than 90% in 36% of the patients. Most of them, as you can see, 90% had macroadenomas and 50% of them with serious visual manifestation. For patients, we decided to do also a craniotomy on reoperation because we couldn't get most of the tumor out from endonasal approach. And one patient decided primarily to do a craniotomy because the patient had a macroadenoma and also an anterior communicating aneurysm. In the case of prolactin secreting adenomas, we had no remission, yes, remission in 20% of your complete remission the case. 65, we did not a complete remission because they were invasive, including both bilateral cavernous sinus. So these patients were debulked the tumor, and then besides using cabergoline, they were submitted to radiosurgery, and one case was submitted to extra medication with temozolomide. The GH tumors that were 55% patients, you can see also in GH secreting tumors who had a 21% rate of visual field or visual acuity defect. You can see the level, GH levels, the average was 29, and the IGF level was at the average of 900. Most of these patients, or some of these patients, have some preoperative medical treatment with somatostatin analogs. 12 of them had no treatment before, but 3 had octreotide, 4 had cabergoline and octreotide, etc., etc., etc. These patients who had preoperative medication were the ones who didn't had a good response to the medical treatment, so they were sent for operation. this is one case in which the medication was quite successful. You can see on the left side, patient was submitted to octreotide and cabergoline, and you can see at the right side the very successful reduction of the volume of the tumor. And so this patient is being followed up instead of being operated on. The tumor size of GH tumors were 79% were macroadenomas. And as you can see, at least 46% of them were NOSP3 and 4. So this means they were invading the cavernous sinus either unilateral or bilaterally. The surgical approach was, we had 44 cases endonasally, 1 transcranial, as I mentioned before. As complications, we had 1 patient and recently 1, so 2 patients with CSF fistula and meningitis, but both of them were submitted lumbar drainage and antibiotics, and both of them with completely and full cure after the medical treatment. Here's a clinical case very typical of Cushing or acromegaly. A patient who had IGF of almost 2,000 and cardiological problems like left ventricular hypertrophy. Sorry for the mistake here. The MRI was a NOSP1 pituitary tumor, hormones, as I said, almost 2,000 IGF and GH10, normal visual fields. This patient had a total resection. Pathology showed an only hormonal secreting tumor, GH tumor, and as you can see, GH postoperative was 0.37. This is the preoperative MRI, coronal and sagittal images, and then here you can see the coronal and sagittal postoperative view of the pituitary gland and the rest of the cell free of tumor. And the other case, which is quite a good result, which is on the left side, a macro GH secreting tumor with deviation of pituitary stalk on the left. And on the right, you can see removal of the tumor. This is the black hole on the cell, and also the sagittal image post-operative and preoperative. And this is a case we had recently, very complicated, because at the end of the operation, the patient, as soon as the anesthesia cleaned up, he referred bitemporal hemianopia. And what happened is that we had, as the patient had a very big cell, we had to fill it up with the fasciolata and fat. And the cases was that we had a bit too much, and so we had to reoperate the patient the same day. We had to remove the fat, and then patient got better as soon as the operation finalized. Visual symptoms in patients with AGH, with GH secreting tumors with preoperative manifestation. We had 9 patients presenting with visual failure. 5 of them didn't get better, which is quite important. What that means? That means that these patients had been with visual problems for many, many months or years. So this means that when you operate a patient with a long-standing visual defect, many of them do not get better. We had to reoperate 3 patients in which we saw tumor remaining and that we considered that we could take the tumor out. When we see tumor that we consider we are not able to remove the remaining tumor, we send them from radiosurgery. So patients, all patients except 3 had clinical remission after operation and perhaps in some cases use of somatostatin analogs. In 3 patients, we had to send them for radiotherapy. 2 of them are in clinical remission. 1 was just recent, so we still don't know the final result. ACTH tumors were 28 patients. You can see that 88% were female patients. Visual failure, this is the visual failure in ACTH secreting tumors is much less frequent, so we had only 6 patients. of course, all of them in macroadenomas. The tumor size in ACTH tumors were 57 micro and 42 macroadenomas. And of course, considering the size, NOSP classification, 77% were grade 1 or 2. In almost 30% of the patients were treated preoperatively with ketoconazole, but these patients showed no response to the medication. On the right side, you can see the MRI pre- and postoperative 1 microadenoma operated on. This is postoperative follow-up. We had a 60% follow-up clinical remission in the immediate postoperative. Some patients do have clinical remission in the long run, but the ones in which you have an immediate clinical remission manifested by GH and CTH levels, these are most of the cases that do well on the long run. 5 cases we had postoperative diabetes insipidus, but all of them get free of that in few weeks or months. We had to reoperate 2 patients. 1 patient in which we didn't have success with the operation was submitted to bilateral adrenalectomy. And 5 cases in which we had no control of the disease were submitted to fractionated radiotherapy, and 3 of the 5 are under clinical remission. This is one typical case, hypertensive diabetic patient, 61 years old, presented with visual failure, progressive visual failure, and the clinical picture of Cushing's disease, panhypopete, which is not unusual in patients presenting with Cushing's disease, high ACTH, midnight cortisol, etc., urinary cortisol, ACTH more than 1,000. The catheterization of the petrous sinus was positive for Cushing's disease, and this is a quite uncommon example of Cushing's disease, a very large, partially or almost cystic tumor with a small nodule up there in the sagittal and coronal view. And this is the postoperative image with complete remission of the case. This patient had a CSF fistula, as I mentioned before. She had meningitis. She was treated postoperatively. She completely cured. And as you can see, was in cortisol and CTH progressively normalized in 12th postoperative day, normal urinary cortisol, normal serum cortisol, normal CTH. Urinary cortisol late was undetectable, no prednisone on postoperative period, normal blood pressure, normal glycemia, and considered clinical remission. This is one of the cases of microadenoma, and in our institution, we are happy to say we have a 3 Tesla MRI for these microadenomas, not the macro, but microadenomas. 3 Tesla MRI is quite helpful because sometimes in smaller 1.5 Tesla, we don't see the microadenomas. This is also another tumor operated on, hypertensive, diabetic, 52 years old, cortisol 19, postoperative cortisol 6. She's under control and clinical remission. I would like to thank you, the organizer, and Dr. Hassan for the invitation. Congratulations for his great effort in organizing such a long, extraneous meeting. Thank you.
Hello, Sam, are you there? Some internet problems. Thank you very much.
Look, I have a question.
Go ahead, Saeed.
Yes, thank you very much for your presentation. It's very interesting. So I have some question. One question about the septal flap. Do you do it systematically after CSF leak during the operation or secondary with it appears weeks or months after surgery?
I'm not sure I got the complete question, but if I understood, we use the nasoseptal flap in every case where, first, we see clearly the patient's going later on for radiotherapy. Second, when during the operation we see a high CSF fistula, we use the nasoseptal flap. In case we don't, it's a microadenoma, and we don't see CSF fistula in the operation, and it's quite easy to see, we don't use the nasoseptal flap, we just use a fragment of cartilage, a fragment of mucosa, and simple closure.
Yes, thank you. It's a clear. Thank you very much.
Okay, thank you.
Thank you.
You for this excellent presentation and for discussion. And now we'll shift to the next speaker, Professor Sanjeeva. Please start sharing your screen. Thank you.
Thank you very much. Thank you, Sami. A great meeting as always. I enjoy coming here every year. So thank you very much. I will just share my screen. Great. Well, thank you for this very kind invitation. So I'm from Oxford in England, and I'm going to be talking about our view on clinoidal meningiomas. It's obviously a very important area to operate on, but also a very anatomically beautiful area to operate on. So understanding clinoid anatomy, understanding this unlocks not just clinoidal meningiomas, but of course the cavernous sinus, petrous apex, orbital tumors, tubercular meningiomas. These are all areas where we would consider or routinely do a clinoidectomy. I think you understand this anatomy quite well. The important points, of course, are that it's the junction between the middle cranial fossa and anterior cranial fossa. And it has three attachments: the optic strut, which you can't see until you remove the clinoid, the wing of the sphenoid, and of course the roof of the optic canal. It's an important area of attachments for a number of ligaments: tentorial, anterior, posterior interclinoid ligaments, petroclinoid ligaments, all of these areas. And depending on your tumors, depending on the type of schwannoma or meningioma, you can open all of these ligaments to get access to, say, for example, roof of the cavernous sinus. The important thing to understand also when doing this is, of course, there are air cells, that can connect into the sphenoid, and it's important to repair the time of the operation to prevent CSF leaks. The other major consideration is the anatomy of the carotid and how it winds around the clinoid, both inferiorly and medially. But this focus of the talk today is really on clinoidal meningiomas and not of some of the other parts. And the important thing to understand with the clinoidal meningiomas is their origin. We've known this, this amazing work from our MEFT about 34 years ago, very nicely presented in his book as well. But there are three types of clinoidal meningiomas. And this is really, really important to understand because they are very different. So just running through the anatomy again, clinoidal process, you understand where the optic canal is, and the type 3 meningiomas, which in a Western population are usually quite small, present early, originate here. They originate at the optic canal. They will cause visual compression early. For us, they're usually small tumors. Then you have the one everybody understands, that's type 2. So these are on the lateral aspect of the clinoid, the superior aspect. These will have very good arachnoid layers. These are the ones we're very used to doing. Very straightforward to do, and you should expect to get complete resections in those and in type 3. I'm going to talk about type 1 and show a video of a type 1 meningioma. These are the difficult ones to operate on. They usually don't have a good arachnoid layer, and they're very different to the other two. And this distinction is really important to understand. Okay, so let's just go through them in a bit more detail. For us, type 3s are usually very small. So these MRI scans here on the right, you see this small meningioma. arising from the location of the optic canal. The blue arrow just shows the tumor going into the optic canal, and in all clinoidal meningiomas, all juxtacellular meningiomas, of course, you would open the optic canal and remove tumor from within the canal. For us, they present early, usually with visual deterioration, and we would expect to get a complete resection and protect their visions and sometimes make it better. Nice little another roton picture here, just showing that anatomy with the clinoid removed. You can see the picture of the strut. Important to understand this type 3 is an intradural, unlike the type 1. So it has nice arachnoid layers. Its origin is slightly more distal, and you'd expect to get, as I said, a complete resection. So this is just I won't play the whole video in the interest of time, but this is that same picture I just showed. It's a very small tumor on the right-hand side, frontal lobe, temporal lobe. I'm going to skip forward. Obviously, at the start of all of these operations, you would split the cavernous sinus to expose the clinoid here. You do an extradural clinoidectomy. I'm going to skip forward to the, just exposing more of the lateral wall, taking the dura propria of the temporal lobe off the cavernous sinus to expose the clinoid. We wouldn't perform a complete clinoidectomy here. I think that's unnecessary in these small tumors. We're just going to drill out the base, open the optic canal. Skip forward. We're just going to drill out the base of the clinoid. We want to open here's the optic canal. We're going to deroof the optic canal extradurally, and we would open and remove some of the tumor, decompress the optic nerve early before opening the dura. As in this case, you can complete that intradurally, but you must decompress extradurally in all clinoidal meningiomas. Lots of irrigation, of course, to protect the optic nerve during the drilling. I'm going to skip forward because it's a small tumor, so you see some of the anatomy. That's just the complete deroofing there and opening of the canal extradurally. We're going to go intradurally. Except for the very proximal clinoidal meningiomas, you see this. You can see that a beautiful arachnoid layer. So you can do a very nice, arachnoidal dissection. We never use any retractors, whatever the size of the tumor, and you're draining CSF the whole time. Draining CSF, the brain is relaxing down. It's a completely arachnoidal dissection. So you'd expect these patients to be very well, whatever the size of the tumor at the end of these operations. No retraction, or no fixed retractors. CSF being drained the whole time around the tumor, arachnoidal dissection. I'm going to skip forward. Yeah, so very small tumor. Most of the tumor is coming out. You see the carotid there, lateral, as you'd expect, to the optic nerve. So we complete that resection, and then still within nice arachnoid layers, follow it into the canal for the last bit. We've really decompressed extradurally. So, very, very straightforward. Small tumor, you'd expect good results. I'm going to skip forward. Just that's showing the tumor coming off the optic nerve there. Oops, sorry. Yeah, so that's the sort of final bits. This is tumor going into the canal. You'd always sort of open the canal. And we're just completing the intradurally. We've obviously done that part of it extradurally. And I'll skip right to the end just so that final view. So tumor's completely gone. That's optic nerve there. You'd expect these patients to do very, very well. This patient's vision got better, as you'd expect. Small tumor, very, very straightforward. This is the one we're used to doing. So we do lots and lots of these. We have type 2s. These are on the superior and lateral side of the clinoid. They can extend into cavernous sinus. I'd say we don't always chase grade 1 meningiomas in the cavernous sinus. We would for more aggressive tumors. Again, you'd expect to get a complete resection here. Very nice arachnoidal planes. We're all used to doing this. You can combine it with the clinoidectomy to take its blood supply. I won't go into that in further details. It's just another example. Another one, we do lots and lots of these type 2 clinoidal meningiomas. We just do them through a very straightforward pterional craniotomy. You do not need to do an orbitozygomatic craniotomy for any of these. Obviously, you'll drill the sphenoid wing, you'll do an extradural clinoidectomy, an extradural optic canal decompression. We also use clinoidectomies, really favor them for, petrous apex, sphenoorbital meningiomas. We find it extremely helpful in terms of decompressing the petrous apex because separating the meningioma out of the petrous apex, orbital apex, I apologize. separating meningiomas out of the orbital apex can be very, very challenging. We're very keen not to have any cranial nerve deficits postoperatively. So we find actually we get very good results by doing a clinoidectomy. We don't have to necessarily remove the tumor completely at the orbital apex, but we get an excellent decompression. Obviously, we will remove the intraorbital tumor, as is shown at this bottom. In these pictures here, we would take the intraorbital tumor up, but not necessarily the orbital apex tumor in all cases. And a clinoidectomy is a big part of allowing there to be space to decompress the cranial nerves, and then postoperative radiotherapy is needed. That's a sort of completely separate talk, so I won't show any videos on that. The final one, and really these are the most difficult clinoidal meningiomas, are the type 1. So these are tumors that originate from the subclinoid dura, and they don't necessarily have arachnoid layers. As far as possible, we try and recognize these preoperatively, but that's not always possible. And here we're very careful, particularly around the perforators, say the PCOM perforators and things, that we don't necessarily want to go for a complete resection of these. Of course, we want to remove the vast majority of this tumor, decompress the optic nerves, and resect usually to the caudal extent of the internal carotid artery. They're located, or the origin in the clinoidal space. You don't have the arachnoid layers. I'll show you the anatomy of that, and can be adherent to carotid or perforators. This is probably the best picture I've seen out of this paper here of why there isn't this arachnoid layer here. And it's this picture on the right, this naked area between the optic nerve and the carotid at the very proximal clinoid, where you don't have, that's the same area shown here on the picture on the left, where you don't have that nice arachnoidal layer around the origin of these meningiomas. And these are very different to the other clinoidal meningiomas, and it's very easy to damage patients operating on these, because you don't have nice arachnoid plane separating you, not just from the vessels, but more importantly from the perforators coming off vessels such as the PCOM. We've tried to do some work to see if we can really tell this preoperatively. We have a photon counting CT, so extremely high resolution CT that can visualize perforators and things preoperatively. But even with this, it can be challenging to tell. So I'll just show you a case where we were considering whether this was this sort of clinoidal meningioma. So 72-year-old lady, again, with poor vision, on the sort of lateral cavernous and clinoidal. You can see the carotid is within the tumor there. I'll just skip forward. We're obviously very interested in the blood supply and things of these tumors. As you know, they're supplied by recurrent branches and infralateral trunk. I'll show why that's important in the video. Here again is the angiogram, CT angiogram of the same patient, just demonstrating those recurrent branches and infralateral trunk supplying this tumor. And importantly, again, you can see the anatomy of the carotid PCOM within this tumor. And that's, I think, important to understand. See a very hypertrophied infralateral trunk there. I think in the interest of time, I'm going to skip forward just to show you the carotid and things within it. Okay. So this is the video of that case. Again, same thing, right-hand side, going down the anterior fossa there. Frontal lobe, temporal lobe. I'm going to skip forward. As always, you obviously start with the clinoidectomy. Now, this is the important bit here. You can take the blood supply very early. So this is now the temporal component here. We split the layers of the cavernous sinus. So this is the dura propria there of the temporal lobe. This is cavernous sinus. The feeders come that way. Same thing, splitting here along the floor of the anterior fossa. We're going to completely split here, take all the feeders and devascularize the tumor extradurally. Drill the clinoid, decompress optic nerve. All of that's going to happen. I'm going to skip all of this in the interest of time. All of that's going to happen extradurally. Okay, so tumors now essentially devascularized, temporal lobe, frontal lobe, no retractors, arachnoidal dissection. I'm going to skip forward again, and then we're debulking this tumor. So going forward, start skipping forward. Yeah, so same again, always the same. This is the edge of tentorium. This tumor was all quite easy to take quickly. We devascularized it extradurally, understand the blood supply. and we're just dissecting in the arachnoidal plane. I'm going to come on to the vessels in a minute. So there we go. So optic nerve A1, M1, carotid. And we're still going here because actually the plane appears reasonable. The only point where the plane didn't appear reasonable was along the PCOM and the PCOM perforators. There was that concern preoperatively. You could argue you could keep going, but patients in the 70s, the vast majority of the tumors were removed. So I elected to leave a small amount of tumor that I didn't feel I could separate it safely. But did come off the rest of the vessels in a very straightforward manner, obviously decompressed into the optic canal as well. So just that's the tumor medial to optic nerve. Obviously all of that will be removed. I'll just skip forward to the view. That's all the tumor medial to optic nerve coming out of the canal. Medial and lateral, all of it is removed. Let's skip forward. Yeah, so that's the final view. So I left that small bit there on the BCOM. Optic nerve's completely decompressed. Carotid A1. So that's that tiny residual there. But again, vision is much better. Grade 1 meningioma. She's very well. So no need to risk her, I think, in that case. So there are different types. Obviously, 2 and 3, definitely complete resection. Always, preserving, possible improving vision. We think the challenging one is that type 1. That's an area of interest for us. I'm sure do some of our work looking at photon counting CTs. So both preoperatively and intraoperatively, we're interested in recognizing this and treating those appropriately. But as always, it's the anatomy that's really important for these, and you can always, go for a safe resection in these tumors. Thank you again, for this very kind invitation. It's always a pleasure to speak here. Fantastic meeting. Thank you very much.
Thank you, Professor Sanjeeva, for this excellent presentation. Is there any question? Thank you. And now we'll shift to our next speaker, Professor Stephen Florian. Please start sharing your screen.
Thank you very much, Sameh, for inviting me. It's always a great honor and pleasure to be with you. Let me try to share my screen. I hope so this is the presentation. Do you see my presentation?
Yes.
Yes. So it's a pathology which is rare, and I will focus in my presentation on an even rare location, the craniovertebral junction. So I have no conflict of interest, but I have to disclose my close relationship with real neurosurgery, of which I'm a fervent advocate, and you are also, and I thank you for organizing such a nice and interesting meetings. I will not insist on the area of the craniovertebral junction. It's quite well defined, and there is an agglomeration of the vital structures, vessels, nerves, brainstem. So we all know this anatomy. I will skip this. But regarding the cyst and cyst-like tumors, I only want to underline that in this region, we can encounter neuroenteric cysts, which are arising from embryonic remnants of the notochord and endoderm, epidermoid cysts, which are ectodermal inclusion, and dermoid cysts, which contain elements of ectoderms, but it's a combined malformation. So these lesions are considered generally benign, but they can cause significant symptoms, and their surgery, it's not at all so simple like it sometimes appear. They can cause variety of the symptoms, but most of the cases are presenting with headache and neck pain, sometimes with cranial nerve deficits, and the onset of the symptoms could be, and usually are, gradually, but in some instances, we can have also acute onset of the symptoms. On MRI, neuroenteric cyst typically presents with hypointense and hyperintense on T2 weighted with no enhancement. The epidermoid cysts, we know that the best imaging study, it's the DVI, that present a restricted diffusion, and dermoid cysts are inhomogeneous lesions with hyperintense T1 weighted because of the fat. So how to deal with? There are a lot of, in the craniovertebral junction, we have a lot of opportunities and not a lot of approaches, but mainly these are dependent on the surgeon's preference and certainly the location and type of the lesion. So considering the surgical consideration on these particular lesions, once they are discovered, they are already symptomatic. So a rapid growth, it's not an exception. We can judge about taking in consideration the indication for surgery. Approach, it's dictated by the location. Simple approaches are recommendable once most of these tumors are cystic, and complete removal, it's recommendable, but not always possible. So this is a case with neuroenteric cyst, 2 years old boy. We admitted with this cystic lesion. We were prepared to have, it was an older movie. We were prepared for a more complicated surgery. So we perform a posterolateral suboccipital approach. In sitting position, we are fan of sitting position. Doesn't matter the age of the patients, if there are no real contraindications. So after the dissection of the lateral part, paramedian part, we discover the cyst. You can see it. And then we simply open the cyst. And once we open, the capsule came out completely and quite easily. So it was, in fact, a quite simple surgery with very good results. Regarding the epidermoids in asymptomatic cases incidentally discovered, it's maybe wiser to follow them. In symptomatic cases, we recommend, and all the experienced surgeons recommend, a complete removal if it's possible. We succeed gross total removal only in 74% of the cases. In recurrent, which are rising up new additional problems, if they are asymptomatic, we can observe them on a long term. In symptomatic, we recommend surgery. In malignant transformation, which is rare, surgery and adjuvant radiotherapy. We encounter and we re-enter in 27% of the cases we operated on, and they recurred. So in epidermoids, the same principles. Sitting position in this lesion, we are in favor of. Intraoperative monitoring and sometimes endoscopic assisted cases. This is a case with a lesion that extend toward the pontomedullary angle. So we use the posterolateral retrosig approach, and you see, taking advantage of the space created by the tumor itself, you don't need a quite large opening, a large opening and skull-based resection. You will see in our study, we made a literature review and meta-analysis, many of the authors are in favor of transcondylar, extreme lateral, far lateral transcondylar approach. I don't see any reason for, because you have enough space in many of these cases to remove completely the tumor, and working in between windows created by the tumor itself, you can resect. And if there are parts of the capsule that are too adherent, we recommend not to insist, but rather to leave the capsule adherent to the vital structure and to follow then the patient. This is another epidermoid cyst. Once you open the capsule, the content, which is clearly identifiable, can be removed easily. Sometimes you can use the serum and in order to leverage the cavity. Other authors are not in favor of this technique because you can produce aseptic meningitis, or you can produce a drop metastasis. I never encountered this kind of metastasis, and in this position, I like to have a clean operating field. So again, take advantage of the spaces created by the tumor itself. You can remove from any little space, you can enlarge it. And you see in this particular case, we left in place that was too adherent to the structures, to the brainstem, in order not to produce neurological damage. So this is a dermoid. In dermoids, you should remove the capsule and the entire content. And these are rare cases. This is a case that was discovered and became symptomatic at 73 years of age, which is quite rare. And it has a dermoid. We, again, in sitting position, we made laminectomy and a small craniectomy around the foramen magnum, and we completely removed this lesion. So regarding our study, we published recently this year, we made this is the article published in Cancers. Based on our study, and we included our cases. There were only 7 cases in our statistic. You can say that it's a small series, but if you compare with the literature, that data, and taking in consideration the fact that we are in a quite small center, in a center of Transylvania, which has a population of less than 3 million. And if you compare this statistic with larger publication of Professor Atul Goyal, who works in Mumbai, and the population in Mumbai is around 25 million. And he also has 7 cases in this series in this region. We can say that it's not so rare. So we operate, and this is a case that we operate quite recently with cystic lesion in the posterior fossa, and it was a surprise that the pathology, the result came as an neoenteric cyst. I rather believe that it's an other kind of tumor, but it was in fact a cystic lesion, quite adherent to the fourth ventricular flow, unusual location for a neuroenteric cyst. But we, with a dissection and with great attention, we succeed to completely remove this lesion, also in the sitting position through a televelar approach. So As I mentioned, Atul Goel and also Professor Xu Wang from China had the largest series, about 6 to 7 cases. And I underline that the chances for a neurosurgeon to encounter more than 1 or 2 cases of this type at the craniovertebral junction in the entire career, it's extremely low. So early diagnosis and meticulous surgical planning are essential in the management of this lesion. Complete resection, it's associated with excellent long-term outcomes and low recurrence rate, but it's not always possible. This is a even rare case, a case that was admitted with this hyper-intense lesion. We thought that it's a dermoid, but in fact it was anatomical pathology. It was an ectopic craniopharyngioma. We also operated through a midline approach, suboccipital. It was a bilateral extension, and you can see we remove on the left side firstly the capsule and the content of the capsule, and then we move to the contralateral side. So having the midline approach, we can even if the tumor is located anteriorly, you can take advantage by the space created by the tumor itself, and you can remove completely this kind of lesion. So I will not insist that in the literature a study pool that we made because I don't have enough time, but I have to mention that based on our study, most of the lesions on this region are neuroenteric cysts, contrary to the what we encounter in, generally speaking, in posterior fossa, where the epidermoids are the most frequent. So in the craniovertebral junction, if you see a lesion, it's probably more probably to be a neuroenteric cyst than, and also ventrally located, it's maybe a neuroenteric cyst than an epidermoid. The surgical approaches, as I mentioned, most of the cases were operated by a midline suboccipital craniotomy, but far lateral transcondylar approach was largely used. I don't see the reason for, but also endoscopic endonasal approach for a cystic lesion, which is anteriorly located. So gross total resection was obtained in the statistical we made in the meta-analysis in 63 cases, percent of the cases, and the rate of recurrence was quite frequent. We also identified some key predictive factors for recurrence: subtotal resection location, patient age, and especially in older patients, there is a higher risk of recurrence, an imaging feature. These are the multivariate analysis, and based on meta-analysis we made, we discovered that the rim enhancement of the cyst increased the odds of recurrence by 14 times, and poor outcome also increases the odds of recurrence by 130 times. So these are findings that are novel in the literature. In conclusion, gross total resection is strongly correlated with a reduced recurrence and a better patient outcome, especially in cases with neuroenteric cyst and epidermal cyst. Subtotal resection are associated with a significantly higher risk of recurrence. Older age is a predictor factor for higher postoperative complication and recurrence, and rim enhancement also a predictive factor. My recommendation is, based on this study, do not add supplementary risk factor on a patient that are already at risk, especially older patient. Avoid complex skull-based approaches, extreme lateral, transcondylar, transoral for lesions that are mainly cystic. Once you open the cyst, the capsule can be removed through a simple unilateral or suboccipital median approach. Use simple approaches and take advantage by the space created by the lesions. long-term follow-up with regular imaging is crucial for early detection of recurrence. There are no guidelines how to treat these rare lesions, so treat every single case with a deserved individuality. So there are few lesions more gratifying and yet potentially more frustrating to operate than cyst-like tumor in this region. Thank you for your attention, and apologize if I prolong a little bit my presentation. Thank you.
Thank you, Professor Florin, for this excellent presentation. Is there any question? Thank you again, Professor Florin.
Okay, thank you very much.
And now we'll shift to next speaker, Professor Tandon. Please start sharing your screen.
Thank you so much. Okay.
Hello, Ashish.
Yeah, hi, John.
Hi, welcome.
Thank you so much. So, can you see my screen?
Perfect.
Okay. So, extremely thankful for the invitation. Today, I would be going through endoscopic excision of giant and large pituitary tumors and certain tips and tricks. And basically, I'll focus on how I do it. So before going to that, I'll just share this one case. As you can appreciate, it's a large pre-op cellar and clival lesion where the clivus has been eroded. The whole sphenoid sinus has been eroded. This is showing pre-op T2 weighted coronal with areas of cysts and hemorrhage. So generally, some of these tumors can have a heterogeneous view. And this is the post-op image where we have got a gross total excision with the flap and fat in the sinus. But as you'll appreciate in the post-op T2 weighted axial, a complete excision with in the pre-op, I hope you appreciated that the tumor was nearly abutting the basilar artery. So I typically use the NOPS grading and sort of helps me. All of grade 2s, simple to giant tumors, microadenomas, macroadenomas. So all of those, anything less than NOPS grade 2, no problem, go endoscopic. The problem arises when there is grade 3 onwards, where you need to really scratch your head for the options available. However, even for grade 3A or B, I would tend to go through endoscopic endonasal approach. Now, I've brought this, I would be focusing on each of these subheadings, which I would like the audience to focus on. So right from lumbar drainage, then two-surgeon forehand view, wide cellar opening, use of Doppler, how I open the dura, the types of scopes and instruments that I use, and reconstruction and extracapsular dissection. So I would first start with lumbar drainage. And if you look at this paper published in 2021, it categorically states that pre-op CSF diversion may be used to manage associated hydrocephalus, or if there is problems with the mass effect. In another of this paper published in 2018, it concludes that controlled intra-op CSF drainage significantly reduces the incidence of intra-op CSF leak. Thus, for me, I use almost in all of my patients with large cellular supracellular tumors or giant pituitary tumors, I regularly use lumbar drainage. However, this paper from Edward Law's team of 811 cases finally said that lumbar drainage was not helpful in achieving gross total excision. So it'll sort of make your life easy, but it doesn't guarantee that you will have a gross total excision. For me, the reasons why I use lumbar drainage is first, placing the drain prior is easier because once if you have a leak, then you will have a dry tap. And so it makes your life more difficult. Second, lower incidence of CSF leak is well known after you put in a lumbar drain. Don't need to push the arachnoid when I'm excising the tumor for most superior part. And in our institute, we sort of tend to remove the lumbar drain within 2 days if there is no evidence of leak. I'll skip on positioning. I generally use Mayfield and the patient's head is pointing towards the surgeon. Coming to two-surgeon and four-hand technique, again, we have certain papers to substantiate that four-hand technique has greater advantage when you're removing a large pituitary adenoma. So four-hand technique is better over two-hand with better clearance of the disease and minimal morbidity. So again, in all of my large tumors, I would go in for two-surgeon four-hand view. The next is, again, whether it is a macroadenoma or a giant tumor, there is a need for wide cellar opening. So I would typically open from carotid to carotid and superiorly at times I would go in for opening or drilling part of the tuberculum as well so that I can push the anterior intercavernous sinus and inferiorly or caudally up to the clivus. So I do need a complete lateral as well as craniocaudal exposure. So, but one has to study the MRI prior to drilling, especially near the clivus, so that we are not damaging the carotid arteries because they tend to come a little narrower as we go down. The next important tool that I use is use of Doppler. Again, in all of my cases, I use Doppler. So here I was just trying to show that I would go in for a wide cellar opening and then confirm that I have reached to the carotids on both sides prior to engaging in the dural opening or if I do require any further bony window. And again, I use the Doppler. Again, I use the Doppler after I have excised to confirm that there's no tumor in between the carotid and the tumor. So my Doppler should be touching to the carotids. Coming to the technique of dural opening, I leave a superior leaf. So this is the sella, and I would be opening the dura in a V fashion to sort of keep this leaf of dura supporting the most anterior part of the tumor. Somehow I tend to believe that it prevents the diaphragma from falling, and it is an additional layer of protection for the surgeon. The next technique that I use is a combination of intracapsular and extracapsular dissection, sort of helps me with a complete clearance. So I would start sharing my videos and my cases. This patient is a 34-year-old male with sudden onset severe headache, vomits, visual decline. And as you will appreciate, it's a huge tumor reaching to the third ventricle, and it has compressed the nerves. However, lateral extension is not that much. It is on axial views, it has almost eroded the clivus. So here I'm using a 0-degree scope, and first I'm going for internal decompression from within the capsule, and thereafter I would be going for extracapsular dissection. Now here, I hope you are able to appreciate that I'm sort of peeling off the tumor with the capsule. So this tumor has been excised, I'm sorry, with the capsule, and then you can see the diaphragma. This is the post-op. Another patient with a giant pituitary tumor, middle-aged male presenting with visual deterioration, again, almost reaching to the third ventricular floor, NOPS grade 2. Here as well, the clivus has been thinned out, very poor vision, especially in the right eye. So again, going in for a 0-degree scope, wide exposure, initially decompressing the tumor from the clival side, the use of straight suckers, and thereafter when the adequate decompression towards the clivus has been achieved, I would sort of typically start dealing with the anterior part just under the dura. Now in here, I have changed to a 30-degree scope and brought in, as you are watching in here, angled suckers to sort of really go into the deep part and suck out the tumor. Once I'm happy with the extent of excision, I typically tend to shrink the dura and deal with the absolute final part of the tumor. At times, I tend to use 45-degree scope as well. Here you are appreciating dura all over. There is a remnant of tumor on one side, on the right, which again is being excised with the help of a 45-degree scope with an angled sucker. And finally, we are filling in the cavity. So we are injecting saline into the lumbar drain to just confirm that there is no leak, and then sort of reconstructing. This is the post-op of this tumor. So quickly onto some more cases. This is again a huge tumor with extensive erosion of the clivus. And here on coronal, you'll appreciate that it is sort of gone beyond. So inferior extent is towards the basitemporal and clival carotids here. On axial contrast, it is showing inferior and lateral to the clival carotids. And we could again achieve radical excision through the same technique. Here you will appreciate that the whole tumor, nearly whole tumor, has been excised, except there is a small residual towards the clavicle carotid. We are following this patient, and till date, we have not had any recurrence. Here, it is not a very large tumor. However, there is quite a lateral extension with sort of infiltration of the cavernous sinus. And again, here, I would like to draw your attention towards this part of the tumor on the right side. And this here is post-op near complete excision, except for a very small part of tumor, which is the residual. However, again, these small tumors, perhaps because of devascularization, not many would tend to grow, and you need to keep a follow-up. Again, pre-op coronal large tumor and a complete excision. So basically what I'm trying to suggest is even large tumors, NOPS grade 3A, 3B, at times you can handle easily with, or with certain extent of experience, you can deal with such tumors. Now, this tumor here was mostly fibrous and firm tumor, though not very big, with headache and hemianopsia. And I'll quickly just show the last part here as we are excising the tumor in here. And this is the diaphragma falling. Okay, but not all has been hanky-dory for us. We have had our share of complications. Here is a 45-year-old female with headache, severe visual decline. This was T1 and contrast. And this was after the contrast, severe visual decline. And here, though we managed a complete post excision, however, the patient did remain visually compromised for a long period of time. Not very sure the exact reason. Perhaps the damage was done. In the interest of time, here there's another complication after the excision of the large tumor. Because of our overzealousness, there has been a lot of packing. This was unnecessary, and one has to be observant that you do not tend to sort of push in a lot of fat here, as you'll see. Though the patient did not have complication or any visual symptom, and he was totally symptom-free, but you know, I had miserable nights thinking about all this. This was another case. You just see the hydrocephalus, one of my initial cases, and I had lost this patient because of hydrocephalus, despite a good excision. And but still, one has to be aware that you need to treat the complete disease, so the tumor as well as hydrocephalus. So okay, as far as a CSF leak is concerned, there has been a significant reduction in our cases of CSF leak after we've started using lumbar drain. And I would sort of try to suggest you to sort of try this out, and we have been pretty happy. Though there are another school of thought which does not suggest that in a lot of cases or in all cases one needs to use lumbar drain. In here, this is a residual. This was a large tumor, but the diaphragma fell, and we thought that we have excised it completely. However, there's been a residual which was abutting, but the patient's vision improved, and sort of the patient was not wanting a repeat surgery. We have kept the patient under follow-up. So to sort of bring things into perspective, case selection is very important. Please stage the patient with the knob staging. I feel life is much easier with the lumbar drain and two-surgeon technique. We regularly use Doppler ultrasound, suction aspirators, and a combination of intracapsular and extracapsular excision. Many thank you.
Thank you, Dr. Tandon, for this excellent presentation. Is there any question?
Hello. Hello.
Thank you. Very nice very nice presentation. Is there any question?
Hello.
Go ahead.
Yeah, hi.
Go ahead.
Am I
Thank you.
audible?
Yeah. Seems you don't hear us. Okay,
Yeah,
we'll
now
shift
I am
to
able to hear you.
Okay, no questions. Thank you.
Okay. Thank you. Thank you so much.
Now we'll shift to next speaker, Professor Agiz Nair. Please start sharing your screen.
Okay. Hello.
Perfect. Perfect.
Can you see my screen?
Yes, perfect.
Yeah. Thank you. Thank you for inviting me to this scientific event. Today I'm talking about dural architecture around cell and its endoscopic perspective. It is just an anatomical perspective and a mechanism of so many anatomic studies, because I find the dura around the cella has a double layer and a single layer, and it splits to enclose the structures like a carotid, sinus, nerves, etc. So to understand the anatomy, how this dural splitting helps, and how you can analyze the anatomy, and how you can it's helpful in during the surgery, I will explain in this talk. Cella, as you know, it has got a double layer and a single layer. Cella as anteriorly, inferiorly, posteriorly, and the diaphragm is a double layer dura. Whereas when it comes to the carotid sulcus, the anterior part, it is a single layer of dura, because the dura there, the meningeal there splits, and the periosteal layer covers the dura over the cellular part. That is the anterior wall of the cavernous sinus. So this picture clearly shows the dural disposition here, because here you can see the whole area is a double layer of dura. But if it comes to the anterior wall, it splits into two, and above the splitting, you can see the above the cavernous sinus, that is above the proximal ring, you can see the double layer of dura split in some areas, and it is single layer in some areas. So infralateral part of the anterior wall is a periosteum, and this dura extends downward, and this part is now loosely called the paraclavial part. This area, the dura, is a single layer, and that enters the carotid canal. So coming to the medial wall, actually the medial wall is the meningeal layer. Medial wall splits, and it split the single layer of the anterior part of the cellular floor splits, and the one layer continues as the anterior wall of the cavernous sinus. This is the anterior wall of the cavernous sinus in the open surgery, and another layer that forms the medial wall of the cavernous sinus. So the importance is the periosteal layer that forms the anterior wall of the cavernous sinus is a single layer. So this is the endoscopic perspective. You can see whole is the medial layer, and this medial layer is a single layer, and the medial layer splits and over the carotid form the single periosteal layer, and in between there is a proximal ring that attached from the medial wall and that attached to the carotid, and this forms the proximal ring through which the carotid enters the clinoid space. This is actually a supraclinoid space that is a split dura with the two double layers. And the one clinical importance of this is the medial wall has to be removed in certain cases of pituitary tumor where it has invaded. And according to Pittsburgh study, the invasion of the medial wall is common even in the nose 1 and 2 cases. And this picture shows how the medial wall, because I am doing a pituitary surgery, and in the left side you can see the medial wall. And this medial wall is you can see it is a single layer, and it is split, and it just continues as a anterior wall of the cavernous. After removing the cellular part, after removing the medial wall, we are going into the anterior wall. Anterior wall is removed, and you can see the carotid, the short vertical of the carotid, and this all layer has only single layer. And posteriorly, you can see the double layer of the meningeal that encloses in the posterior part of the cella. And then now come the proximal and distal dural rings. These are very important because proximal ring and the distal ring, there is some areas it is split, some areas it is a single layer. So where it is a double layer. Double layer is a dorsal clinoid space. It is a split layer. You can see there is a split area where sometimes the cavernous extends into this area. This is the dorsal area of the dorsal clinoid space. Whereas if you go laterally in the oculomotor triangle is formed by the anterior clinoid, posterior clinoid, and interclinoid space. This area, it is a double layer of dura. And this is a carotid, and around the carotid, the dura is split. But in the diaphragm area, it is a double layer dura. So this all pictures show how this double layer is split and form different pockets around the carotid. You can see here you can see the interclinoid ligament. This interclinoid ligament is from the anterior clinoid to the posterior clinoid. Here the lateral to that is a dura is a single one, whereas medial to the interclinoid ligament, the dura is a single layer. So this picture shows the disposition of this proximal and distal ring. You can see the yellow CR. Yellow CR is the optic strut that joins the supralateral part of the carotid sulcus. So superior to that is a single layer of the distal dural ring, and inferior to that is the proximal dural ring that covers the carotid there. And this is the proximal dural ring, and here it's the distal dural ring. So anteriorly the dura is split and the layers are separate. So that's what is the importance of the optic strut. Optic strut is a structure that connects the posteromedial part of the anterior clinoid with the posterolateral, supralateral part of the carotid sulcus. So this in the anterior clinoid and optic strut, superior portion of both these contains the proximal dura, whereas inferior portion contains the superior part contains the distal dural ring, and the proximal inferior part contains the proximal dural ring. That this is an open view. Open view also you can see the prosected optic strut in the ventriculateral space, which cannot be visualized through the endoscopic technique. So this is endoscopic appearance, and the endoscopic appearance you can see the bone there, and also the dural splitting here. This is inferior to optic strut from the proximal ring, and superior to the optic strut from the distal ring. And this also continues here and encircles the carotid, whereas the proximal ring continues and it may be sometimes deficient in the medial part. So the superior wall is oculomotor triangle, clinoidal triangle, and carotid triangle. These three layers, oculomotor triangle is a double layer dura, whereas in the clinoidal and carotid, the dura splits. You can see the falciform ligament, even in the first time it splits and it encloses the optic nerve there. and below that, this forms a single layer. It is the anterior part. Anterior part, the single layer extends from the anterior clinoid, anterior to the carotid, and it goes medially. And sometimes this medial part, there is a medial clinoid space, medial clinoid process to which it is attached, and that goes posterior to the posterior clinoid. And also the fibers from the anterior clinoid attached to the posterior clinoid and form the interclinoid ligament. These are all single layers of dura. And this is an open view of the carotid oculomotor membrane, which collect the carotid with the third nerve that enter lateral to the anterior genu of the carotid. This is also a single layer. So this shows the superolateral part through the superior compartment. Here the third nerve enters the cavernous sinus, and it is the anterior part of the cavernous sinus. It enters, and this whole layer is almost a double layer of dura in the carotid triangle. Posterior wall, as such, is anterior to the clival dura, and it is a double layer and of this split and of this contains the basilar venous plexus and the sixth nerve. So these are all the periosteal bony anatomy, because when the carotid enters, there is a ring of bone around it, that is the petrosal process sphenoid bone, and this is a lingual process sphenoid bone, and actually this is the pterygoid process, and the petrous apex. All this here, there is only single periosteal dura that enters the carotid canal and encloses the entry of the carotid into the cavernous sinus. And this also shows what is around the carotid and disposition of the different structures. That is anteriorly the pterygoid process, posteriorly the petrous apex, and laterally the lingual process and petrolingual ligament, medially the petrosal process, which are all covered by single layer of dura. So in all these structures, you can, if you go for a pterygoid approach to the foramen laxum, you encounter the single layer of dura, which can be reflected and removed to enter the foramen lacerum. And about the lateral wall is one of the newest approach, transpterygoid approach, transorbital approach to the lateral wall of the cavernous sinus. Here you can see this is the fourth nerve. You can see the V1, V2, V3, the serium ganglion, and the third nerve is there. All these are double layer of dura, and this dura can be easily peeled off from the neural layer there. So another concept regarding is the trigeminal membrane, which forms the inferior wall of the inferior portion of the keel of the boat-shaped cavernous sinus. That is, it is a membrane that is attached to the superior part of the V2, and this structure is around the origin of the cavernous sinus inferiorly. And about double layers and single layers, cella, anterior, posterior, inferior, and superior, it's a fused double layer. The lateral cellar wall is a single layer. Cavernous sinus, medial wall, cellar, and sphenoid last. Remember the Yasuda, all cellar, all single layer. Lateral wall is a double layer. Clinoid and carotid triangle, double layer and fused. Oculomotor triangle is a double layer fused. Thank you. Thank you for your patient listening.
Thank you, Professor Nair, for this excellent presentation and for illustrative slides that you have mentioned. Is there any question? Thank you.
Thank you, Samesh, your kind invitation and for participating. Thank you once again.
Thank you. And now we will shift to next speaker. My dear friend, do please start sharing your screen.
Okay.
Welcome, James.
Good morning, John. Good morning, Same. How are you?
Very good. Looking forward to
Fine.
this.
Terrific. Well, thank you for, again, hosting this spectacular potpourri of skull-based surgery topics by my esteemed colleagues and friends. This morning, I'm going to talk about skull-based approaches to the trigeminal nerve and look at all the different aspects and nuances in decision-making and also techniques. So just from a historical standpoint, microvascular decompression, which we know today, really originated from Walter Dandy's time. And, he was doing a approach similar to the retrosigmoid approach as depicted in these illustrations to get to the trigeminal nerve. But interestingly, he was not doing decompression. He was doing lesioning of the nerve. But each time he would notice that there was a vessel compressing the nerve. But it wasn't until Janetta's time where the move was made to move the vessel from the nerve. So I think that's an interesting historical aspect. But there are some lesions other than neurovascular compression that can cause trigeminal neuralgia. And as such, could be an epidermoid tumor such as this. You can see this is the DWI signal. And this is the Fiesta scan showing a large CP angle epidermoid, in this case presenting with type 1 trigeminal neuralgia. And here's the tumor. You can see the pearly white droplets of the keratin debris in the CP angle here. And then after decompression, you could see that here's the trigeminal nerve that is free, but there is also a secondary component, compression from the SCA. And this is one that has dual pathology. So when you see these cases, it's very important to inspect to look for additional neurovascular compression, even after tumor removal. And we often like to use the endoscope here to inspect the cavity. You could see a beautiful, spectacular view of the basilar artery, the AICA, and here's the sixth nerve going into Dorello's canal. And he did quite well in complete resolution of his trigeminal neuralgia. Here's another example. This is a recent case I did. You could see a large CP angle epidermoid compressing the pontomedullary junction, displacing the 7th and 8th nerves with some IAC extension. Again, you could see after removal of the tumor, you could see that there's a secondary neurovascular component compressing the root entry zone of the 5th nerve. This is a classic position for idiopathic trigeminal neuralgia. And you can see here we've transposed the artery towards the tentorium and wedged it with a piece of Teflon, and the endoscopic inspection view showing a spectacular view of all the cranial nerves. And here's a post-resection inspection of the cranial nerves. Again, you can see here's the 5th nerve, 7 and 8, 9, 10, 11, and here's 6th nerve going into Dorello's canal, and here's the vessel being decompressed. Here's the post-op scan showing the Fiesta. I always use the Fiesta to inspect. I think it's more refined than a standard DWI. You get finer slices and you can see the keratin droplets. So there are other approaches other than the retrosigmoid to get to trigeminal nerve lesions that one should be aware about. And it's very important, I think, to have these in your armamentarium. We often talk about the middle fossa approach or the Kawase's approach. And interestingly, before there was retrosigmoid microvascular decompression, historically there was the subtemporal middle fossa approach to the Gasserian ganglion, which was largely popularized by Fraser and Spiller and Hartley and Krause, where it was lesioning of the Gasserian ganglion using the subtemporal extradural approach. And so with that said, the Kawasi's approach is a very analogous type of approach to the Gasserian ganglion, to the upper petroclival junction, namely between the 5th and the 7th nerves. And then here's the other avenues that you can get to the petroclival region that one should have in their armamentarium. So when navigating the middle fossa, it's important to know where the neurovascular structures are. Here's the carotid artery along the petrous horizontal segment, the petrous, along the deep to the GSPN, the cochlea, which is just anteromedial to the geniculate ganglion, and the arcuate eminence, and this is the IAC. And so when you drill out Kawasi's triangle and you open the dura, cut the tentorium, you get this spectacular view of the brainstem between the 5th and the 7th nerves. So here's an example. This is an upper petroclival meningioma. You can see a supratentorial and an infratentorial component, some brainstem compression. And if you look at the fiesta, it's important to study the relationship of the tumor relative to the trigeminal nerve. If the origin of the tumor is medial to the trigeminal nerve, these are true petroclival meningiomas. If they're lateral, then these tend to be posterior petrous or anterior petrous meningiomas. So we'll do this through a supine head turn approach, frontotemporal incision. After a middle fossa craniotomy, the first step typically is to ligate and divide the middle meningeal artery. We then peel the dura propria off the floor of the middle fossa from a posterior to anterior fashion to expose the GSPN. You follow it anteriorly to the back of V3, and there it is going into foramen ovale. And here, the dura tends to have very dense periosteal adhesions to the lateral wall of the cavernous sinus, so I tend to use sharp dissection to really peel that dura off. And then you get a broad exposure of the middle fossa rhomboid. And when you start drilling, it's best to do from medial to lateral using a high-speed diamond drill with copious irrigation. We drill underneath the Gasserian ganglion. This is the area of the true petrous apex, anterior to the tubercle of Prince Toe. And we open the dura subtemporally, identify the tumor in the supratentorial compartment. You can see it's right along the tentorial edge. And then we'll debulk the tumor and then start peeling the tumor off of the brainstem. And then once we debulk the tumor to the tentorium, we'll then divide the tentorium. We'll ligate the superior petrosal sinus here. You could use clips, suture ligature, and here I'd like to just use simple bipolar to close off the superior petrosal sinus. Open up the posterior fossa dura so you now have control of the tentorium above and below the tentorium. We cut the tentorium to the free edge of the incisura and then find the root of the 5th nerve. So here's the root of the 5th nerve. And then we follow the 5th nerve into Meckel's cave. And you can open this sharply, open up this fibrous ring of the porous trigeminus. And here's the tumor situated in Meckel's cave. And the advantage of this Kawasi's approach is that you land anterior to the brainstem, medial to the 5th nerve, and you have this wide exposure into Meckel's cave. This type of exposure is very difficult to get through a simple retrosigmoid approach. And this approach, the Kawasi's anterior petrosal approach, really gives you this advantage of dissecting directly on the brainstem. You're looking backwards on the brainstem. Beautiful access to Meckel's cave. There's the basilar artery. And the 5th nerve is completely intact. It's barely touched. There's no manipulation. And we do a multi-layered reconstruction to prevent CSF leak using a little fat graft. And here we'll use a pericranial flap at the end that you see here. Okay. So here's the post-op scan, a complete removal. This is a dumbbell trigeminal schwannoma, type D. Patient presented with facial dysesthesias. Here we've done a Kawasi's approach again, and you can see we're now dissecting the tumor away from the brainstem, debulking it with an ultrasonic aspirator. And then here is the 7th and 8th nerve. So you see this coming from the coosseous approach, 7 and 8 is going in this direction. And the 5th nerve is draped over the tumor here. And this is the CP angle component of the tumor. You can see it's adherent to some small fascicles. And the key for trigeminal schwannoma surgery is that you want to preserve as many of these fascicles as possible to prevent any injury. And here we are rolling the tumor, carefully dissecting it from the trunk of the trigeminal nerve, and then finally freeing it up. And then there is the main trunk and portia minor going into Meckel's cave. Here's Meckel's cave wide open. This is the anterior portion of the dumbbell, and a complete removal with minimal trauma to the trigeminal nerve. This is another trigeminal nerve lesion. It looks very reminiscent of a trigeminal schwannoma. Interestingly, this patient had a previous thoracic spine clear cell meningioma resected over 20 years ago, and she began developing this new tumor in the trigeminal nerve that was growing significantly within 6 months. And if you did a retrosigmoid approach, you would looking from the posterior pole of the tumor and looking anteriorly, whereas if you come from the coosseous approach, look how I'm able to expose the tumor from front to back and have a panoramic view along the longitudinal segment of the tumor. So here I am, we fillet open the nerve capsule, and we're mobilizing the nerve rootlets off to the side. So we now have a free zone to core out the tumor, much like a canoe. And then I can work from the anterior pole of the tumor and carefully dissect it from these nerve rootlets very precisely. And you cannot get this type of exposure through a pure retrosigmoid approach. You're going to be curetting the tumor, suctioning the tumor. You don't have this ability to dissect it from those Gasserian nerve rootlets that I showed you. And you can see it's very precise, using sharp dissection, carefully preserving all of these nerve rootlets, and then dividing, the ones that are attached to the tumor. And here is the Gasserian ganglia. Here's Meckel's cave. Here's the CP angle, and a complete removal of this tumor. And this is an aggressive tumor. This is a clear cell meningioma. This is type 2, so you have to be aggressive here. And we followed it with radiation therapy. Here's another an example. This is another meningioma going into Meckel's cave with a little CP angle component. And this patient presented with trigeminal neuralgia, very terrible trigeminal neuralgia. It's not a very big tumor, but it's causing a lot of big problems for the patient. So you could do radiosurgery, perfectly acceptable, but this is a curable lesion. So here we've done a coosseous approach, and we've opened up Meckel's cave here, like I showed you, opening up this fibrous ring, following the root of the 5th nerve into Meckel's cave. And look at this tumor. This tumor is quite compressive. And removing out this tumor, it's a soft and suckable tumor here. We can mobilize the trigeminal nerve laterally, and you can see the tumor is all medial to the trigeminal nerve in Meckel's cave. This is Meckel's cave. We've opened it up. You can see the dural reflections here, and we can deliver all of this tumor. Here's the rest of the tumor that's in the CP angle. You can see the nerve is preserved. The Meckel's cave is cleared now. And now we're just working on the tumor that's in the cisternal segment of the trigeminal nerve. And then cutting out the dura. You can cut out the dura much, much easier of the fibrous ring than you can with a retrosigmoid approach. Here is the nerve. And look, here's the SCA. The SCA has some neurovascular compression component here. And then now we'll simply decompress the trigeminal nerve using a middle fossa subtemporal approach as opposed to a retrosigmoid approach. So this is a different view of the trigeminal nerve, looking from above as opposed to looking from behind. And there it is. And you can see here's the endoscopic view. You can see here's the nerve decompressed, and nerve is completely free now. So this was a gross total, and the patient was off meds without any further trigeminal pain. You can extend your Kawasi's approach with a posterior petrosectomy. Here's the otic capsule, and this gives you additional room and additional viewing angles, looking from not only from front to back, but back to front, and looking from down to up. And you could get this beautiful view using a combined petrosal, which Dr. Al-Mefti calls the double martini. And you can use multi-angles of attack to get to the petroclival region. And we'll use it for these larger tumors. This is a large cystic trigeminal schwannoma. And this is a case that we published in Operative Neurosurgery some years ago, you can reference. But you could see, look at the view. This is a left-sided approach. This is the temporal lobe. We're working in the pre-sigmoid corridor originally, and we're landing right in front, looking a short distance to the petroclival region. This is the 7th and 8th nerves coming into view right here below the tumor. And we're peeling the tumor off of 7 and 8, and then we can start to define it. You can see we'll debulk the tumor. It's a very soft and suckable tumor. And here's the trigeminal nerve. Here's the 4th nerve looking subtemporally. And then we'll open up Meckel's cave by following that fibrous ring of the porous trigeminus. And here's the tumor in Meckel's cave. This is the Meckel's cave component. And we can work medial to the 5th nerve and identify the tumor. And then the most difficult part, I think, in these cases usually is the most medial aspect, is finding the 6th nerve. There's the 6th nerve in basilar artery. It's very easy to injure if you forget to look for it. Here's the basilar artery with the endoscopic view. And then there's small tumor remnants adherent to the 7th nerve, which I left intact. And these ended up to be very radiographically silent, but an excellent decompression, radical near total, and no recurrence in 6 years. Here's another example. This is a dumbbell trigeminal schwannoma. This I did through a combined petrosal approach, a complete removal. And then lastly, I want to show you some variations of the combined petrosal. Here you could see we're going to drill off the common crus, which is the superior canal and the posterior canal, and you get this extra room of the petroclival angle. And we published this some years ago in Neurosurgical Focus. You can reference it. But here's the drilling. Here we have the otic capsule, and now we're going to do the transcrusal petrosectomy. You have to do this under copious irrigation, where as you're drilling off the canals, you have to wax off the ampulated ends. The ampulated ends are the ends that are going away from the common crus. And once these are waxed off, you can take everything in between, drill off the common crus, and look at how much more room you have without this bony obstruction of your line of sight. We'll open up the dura in the classic way, subtemporally and pre-sigmoid. Watch out for the veins of Lebet. You must preserve them. So in this case, we're going to make the cut anterior to the insertion of vein of Lebet, and then expose the lower cranial nerves. And then here's the tumor, largely situated between above 7 and 8 and around the 5th nerve. Here's the 5th nerve being pushed down, and we're dissecting it off of the brainstem here. Now, with this transcrusal approach, you can potentially preserve hearing. You must not lose the endolymph when drilling. And in this case, we were able to preserve her hearing. And we'll open up Meckel's cave. This is a recurrent theme, opening up that fibrous ring of the dura. And then now we'll dissect the tumor off of the fourth nerve. The fourth nerve is very vulnerable in these petroclival meningiomas. So, and there's the sixth nerve. So we typically will cut the arachnoid right on the tumor surface. So it releases the arachnoid adhesion from the cranial nerves so that the arachnoid rolls to the side of the cranial nerves and you hug the tumor capsule and release all the arachnoid adhesions. And then here, this is how you can deliver the rest of this tumor. And then there's a spectacular view of the cranial nerves microscopically, endoscopically, inspecting all the corners. And you could see there's the sixth nerve and Meckel's cave. And this was a radical near total removal. I left a few droplets attached to the trigeminal nerve rootlets and an excellent decompression, and our gait function dramatically improved. The trigeminal nerve is not confined to the CP angle. Remember, the trigeminal nerve has branches that goes all the way anteriorly to the face, and you can use endoscopic endonasal approaches to get to Meckel's cave. This is a case of a dermoid cyst that presents itself right to the back of the sphenoid sinus. This is ideal for an endoscopic endonasal approach using the front door to Meckel's cave. Always remember the course of the carotid artery. I use a CTA image guidance. And so we'll do a transpterygoid approach here. Open up the bone over the periosteum of the tumor and mobilize the pterygopalatine ganglia laterally. We can now drill the top of the pterygoid wedge to get to that lateral aspect of the sphenoid sinus. And then we'll use a microdoppler to map out the region of the carotid. Find a safe zone of entry. Open up the periosteum over the tumor. And you can see this is the classic dermoid cyst contents. This is keratin debris with some hair follicles and sebaceous glands histologically. And, very suckable tumor. Removing it all out of Meckel's cave. And then here's a small piece of bone calcification that is partially obstructing our view. And we'll go ahead and drill down that tubercle to get a little bit of extra better visualization towards the back of Meckel's cave. Ensure that we've removed everything. And you can see this is a nice clean out of the dermoid cyst lesion. And in this case, there's a bit of CSF seepage coming from the trigeminal cistern. And so you have to do a good repair here. So we'll do a multi-layered repair and nasoseptal flap to prevent CSF leakage. Here's the complete removal. Here's another Meckel's cave. This time, this is a schwannoma. Again, look at how there's a nice presentation to the back of the sphenoid sinus. Again, opening up the bone using transpterygoid approach, and then debulking the tumor and peeling it off and dissecting it off the ICA. Here's the sixth nerve and a complete removal. Patient had a transient sixth nerve palsy, but made a nice complete recovery. So the retrosigmoid is our workhorse for these CP angle lesions, but I think it's important to know that when we reach the limits of it, we have to be ready for all the different types of approaches to trigeminal nerve lesions. And with that, I thank you for your attention.
Thank you, Professor Lu, for this excellent presentation. Is there any question? Thank you. Always nice to see you, Lu.
Yes, always nice to see you guys.
I'll send you that YouTube link, James.
Oh, terrific. Thank you. This will include both day 1 and day 2, or can you send me day 1's link also?
Yeah.
Okay, great.
Now we'll shift to the next speaker, Dr. Shyam Sandar, please start sharing your screen.
Good evening, everyone. Thank you, Dr. Professor Some, for giving me this opportunity. So, I'll be talking on the limits of endoscopic approaches to large invasive pituitary adenomas. How far is too far for when you approach large lesions of the suprasellar region via the endonasal route? Now, the limitations for large lesions would be essentially the coronal and sagittal orientation of the lesion. Just a minute, let me, why is it covering half the? Okay. Depth of the lesion, length of the instruments that you have, the angle of attack to the lesion, the bony exposure that you can actually achieve by the exposure during the exposure, and the ability to achieve hemostasis. The specific instruments that we've been using for these cases are specifically designed. It's right now available along with the sets. But earlier, this specific instrument was given by the ENT colleague. They use it for the laryngotomy surgery, microlaryngotomy surgery. Now, for these cases, if you can see, the lesion is actually towering up, posteriorly tilted, but strictly in the midline. These cases are difficult to get, but it is possible to get these tumors out because these are actually towering up and in the midline. Just small video of the same case. You can see the sella being drilled, the carotid being identified by using the Doppler. And once I identify the carotid on both sides, continue the drilling. I drill the tuberculum sella region also. And then I open the dura at the sella and take off the tumor in the sella itself first. I'll run the video a bit fast because, yeah. So that's a lesion coming off from the sella itself, slightly firmish tumor because this patient was on cabergoline for some time. Cabergoline and bromocriptine for some time, for God knows for what reason the physician, his physician had given him this without actually referring for surgery. So the lesion was a bit more firm than usual. So that's a dorsum sella coming into view. Lesion from within the sella is being taken out bit by bit. And then we turn our attention to the dura at the tuberculum sella. We cauterize the anterior interhemispheric fissure, anterior intercavernous sinus, and then open the area, the dura there. That's the anterior intercavernous being cauterized. And cut. So once you cut that, you get above the diaphragm to get a better view of the tumor, which is going posteriorly. And then it is gradually dissected. The lesion is gradually dissected off the from within. And then, because as I said, it's a bit firm, so I can actually go around the lesion. Step by step, the dissection is done. And the tumor is gradually removed. Decompression is done from within, and then the lesion is taken out. There's a tumor that is coming out gradually. That's the infrachiasmatic part. It's not suckable, so it's not completely suckable as a general pituitary was coming off. So I had to literally roll it out. So that's the third ventricle. aqueduct and the foramen Monroe on both sides. This infrachiasmatic part that I'm seeing. Then I go to the part that is not moving. Okay. Then I go to the part which is above, which is then gradually removed. Most of the vascularity is from below this. So after decompression, the capsule actually can be rolled out. So this is a final view after the resection. You can see the chiasm above with the intrahemispheric and the vessels above, the third ventricle below. And then this is plugged with multilayer to close the defect. So this is the view. Okay, so this is a post-op image. This is at 3 months. You can see it's a complete excision. We are just following this patient up, not done any, not given any radiation or anything. You can see the amount of bone drilling that is done to get to the lesion. Now, as I said, all the lesions which are in the midline vertically oriented, it is possible to remove this way. Even though it is large, they can be removed completely. But the the lesions that can be attempted via endoscopic approach, even though they are large, are those soft suckable lesions arising from the medial cavernous sinus without adherence to the neurovascular structures, medial to lateral growth pattern, and a general tendency to displace rather than adhere and infiltrate, and an absence of pile invasion. Pituitary fits in for most of these cases. We need to have a careful review of the MRI and CT to see the extent of tumor in 3 planes. We have to note if there are any arachnoid breach points, pattern of involvement of cavernous sinus and the neurovascular structures, anatomical position of the structures, sphenoid septations, their attachment, any potential distance, and these cases we should have navigation sequence imaging so that can use it during surgery, and a Doppler. Just a few images. I think I'll skip this anatomy slides just to say that the lesions which is going into the cavernous sinus also can be chased into it. If you know the anatomy, the medial superior and the posterior cavernous sinus anatomy properly. So after bone removal, you can see the once you see the carotid, you can see the nerves coming up there, and then depending on the extent, the way the tumor is extending, you can tailor your excision also. So what is needed in these cases are experience in handling and working with angled endoscopes. 30 and 70 degree scopes are needed. It's generally a 2-surgeon, 2-nostril forehand technique. I have an ENT surgeon along with me who's been working together for the last 14 years. So the position of the patient at the monitors are pretty standard. We have to have a provision to raise the head, and because if there is a venous bleeding, it might help raising the head of the patient. Navigation system is mandatory, as I said. Doppler helps. Extra long instruments are required for these cases. Hemostatic agents have to be ready, and you should be ready for a craniotomy and an angiogram. If cavernous sinus exploration is planned, ipsilateral middle turbinate is removed, nasoseptal flap to be harvested from the opposite septum. Ipsilateral pedicule is most likely to be sacrificed because the sphenopalatine, the pterygopalatine drilling, you have to sacrifice that sphenopalatine artery. It is easier to manipulate and reconstruct the defect with the contralateral flap. Just another case. It's quite a large lesion that I showed there. NOS grade 4, it's extending quite laterally into the temporal lobe also. And the thing is, the plan was to do an endoscopic excision first, attempt an endoscopic excision first, get an immediate post-op MRI without extubating the patient, to shift the patient for MRI, and if there is significant residual, to do a craniotomy. So this is what we did. So that's a drilling of the cella being done. Once a cella is drilled and exposed, the bone is exposed, the tuberculum cella is being opened. Sorry. The bone of the cella is being removed meticulously. The lesion, the bone over the cavernous sinus on the left also is being removed. You will have troublesome bleeding happening from the cavernous. You can pack and wait. Generally stops by itself after some time once you pack and wait, or you can use Surgiflow or hemostatic agents like that. So once we expose the cella and the cavernous sinus, you can actually start opening the dura on the cella. That's the cavernous area being exposed further. There's a Doppler being used to identify where exactly the carotid artery is turning off. This doesn't show any impression there because the tumor is there anterior to the lesion of the carotid also. So all the bone is drilled off. As laterally as is possible into the lateral extent of this sphenoid sinus. Navigation. Now the cella dura is being opened. You can see the tumor coming out from there. Standard resection techniques, I use the inferior, lateral, and then superior, posterior and superior. Part of the tumors are being resected step by step. Soft suckable tumor here. So it's much more easier here. But problem with soft suckable tumor is that if it starts bleeding, the hemostasis, getting hemostasis also is difficult for such patients. Because if it is in a deep area. So that's a biopsy is being taken, then we'll start curating and taking out the lesion. The inferior part being cleared. I'll move this a bit fast. Yeah. So you can see gradually the arachnoid is actually descending down. So behind you know that there is lesion behind the arachnoid. So we lift the arachnoid backwards and start dissecting behind the arachnoid pouch. These patients have a lumbar drain, so at this stage I generally try to keep the lumbar drain open so that there is some decompression of the arachnoid system. So the arachnoid descent. Using a patty to hold the arachnoid up and completing the resection further. Keep resecting laterally. Now the problem is now the depth is going to be a problem at this stage. But bit by bit the tumor is coming out. As in front of the arachnoid. There is lesion behind that, we know that, so we are continuing to further trying to go behind the arachnoid to get further tumor out. Eventually, you see that corners, the tumor in the corner, the left side corner, and going into the temporal lobe. Now we open the anterior cavernous region, so we get a approach further above the diaphragm. So that's cut. Then you go above the diaphragm and gently peel it off from the. Once the arachnoid is diaphragm is open and the arachnoid is open, it becomes a bit more easier to get the tumor from the lateral part because the arachnoid is collapsed. So that's a tumor. That's a suction that I showed earlier. I used that to get the lesion from the lateral part. Bit by bit, the tumor is being removed. A suction or a curette and suction is used to get those bits of tumor. You see the undersurface of the lobe there. So the medial surface of the lobe there. And gradually the tumor is being removed. You can see the tumor coming out bit by bit. So this is towards the end of the surgery. We are taking out the capsule. Now getting hemostasis in this condition can be tricky because it's quite deep. The cavity is actually deep. I mean, that's the posterior cerebral artery. So trying to achieve hemostasis with the gel forms first. Then we go to the cavernous sinus part, opening the cavernous dura laterally. Exposing the carotid artery and the tumor in front. That's the carotid artery. Gradually, the tumor from the anterior and the superior compartments are being removed. Further and further exposure laterally is done to get as much tumor as is possible. Using navigation and Doppler, we can figure out where we are in relation to the carotid and the trigeminal nerves. And the tumor from within the cavernous sinus is being removed. That's the sixth nerve coming into view. So now at the depth. So this is towards the end. We can see the chiasm there. So we are filling the area with hemostatic agent to try get hemostasis, and wait and then use multi-layer flap, multi-layer repair to get the. But problem is in this case, patient had as I said, I do an immediate post-op MRI. I don't extubate the patient. I shift the patient directly to the MRI, and this patient had a hematoma in the cavity, as I did fear that will happen. So I ended up doing a small mini craniotomy and evacuating the hematoma. This is the post-op patient actually had a hydrocephalus, meningitis in the hydrocephalus in the post-operative period. Ended up having a shunt. So this is a post-operative scans. You can see there's a significant, there is a small residue in the lateral compartment of the cavernous sinus, but otherwise it's a good excision in the intracranial part. It's the 3 months. So this amount of bone removal, you can see the amount of bone removal laterally to get to the cavernous sinus and to the temporal part. So most worrisome complications of these cases are carotid artery injuries. It's rare but potentially life-threatening. You need to have a contingency plan in place before embarking for these surgeries. Avoidance is the key. You need to know the anatomy thoroughly inside out. We need to know what exactly to expect and where. The steps has to be deliberate. The movements has to be deliberate. If it does occur, the plan to control bleeding with packing and muscle plug has to be in place swiftly and deliberately done. You panic and you will lose the patient. Once the bleeding is controlled, angiogram is done to rule out a pseudoaneurysm formation, and if needed, flow diverter and all that may be needed. The complications like CSF leak, meningitis, pituitary dysfunction, worsening of vision, ophthalmoplegia, nasal mobilities, these are common for all pituitary surgeries. As I said, this is one thing that I've been following for last 10, 12 years. For large lesions, I always do an immediate postoperative MRI. I do the surgery without extubating. I shift the patient directly for MRI. We have an MRI suite right next to our theater. So we get the MRI done. And if the scan is looking okay, we'll shift the patient to ICU and extubate. If it is not looking okay, if there is significant residue, I go in and do a craniotomy or endoscopic, completion endoscopy if need be. So in conclusion, do your homework well, have a good idea of the images and anatomy and the instruments required before getting these cases. Have contingency plans in place, be prepared to convert to craniotomy, and have a clear plan for carotid injuries. And if possible, do an immediate post-op MRI. These are my references. Thank you very much.
Thank you, Dr. Shyam, for a very nice presentation. Is there any question? Thank you.
Thank you, sir.
And now we'll shift to next speaker, Dr. Sambas. Please start sharing your screen.
Good evening, everybody. Can you guys hear me? Hello?
Yes.
Good evening. Good evening,
Hello,
everybody.
we are hearing you.
Yes. Thank you so much to the organizers. Thank you so much, Professor, for your kind invitation. And it's a pleasure and honor for me to be here with all of you. And for me to present my mandate here, which is skull-based paraganglioma. And that's my favorite topic. And that's something that's close to my heart. And I was in CAIRO yesterday for 3 days. And I was a faculty at the CAIRO, and I just happened to come back and just touch down back in Bangalore. And it's a pleasure to do another event here at CAIRO. I think I'm ready to share my slides, and I hope you can see me now. Yeah, can you see me?
Yes.
Can you see my slides?
Yes.
Yeah.
Yes.
Hello?
Can you make a presentation mode, please? There you perfect.
Okay. Can you see me? Okay. Right then. So I'd like to begin by noting some paradigm shifts in paraganglioma management. So what has changed over the years in paraganglioma surgery, paraganglioma management? We are now able to comprehensively map the skull base. I keep telling all my fellows, my students, and for those attending my lectures that there is no millimeter in the skull base that is not mapped today. I think we all know every tiny bit of the skull base, and that's what really has changed the game in skull base surgery. We all, once anatomy is clear, the natural way forward is to develop rational and safe surgical approaches, which too have happened over the last couple of decades. It's very important to note here that we are no longer in the era of seeing scans using films. I keep telling everybody that, those days are gone when you could take up a film on your CT or X-ray console and see the films. We need to have the DICOM reading softwares, and you need to load the entire presentation and make sure that that is studied in great detail, and hence effective neuroradiological solutions have really changed the game in skull-based surgery. neuronavigation, neuromonitoring, and all of these have greatly aided skull-base surgery. And I would like to close this slide by making this comment that carotid involvement is no longer considered inoperable. A lot of people, I think, refrain or sometimes mention passingly that the carotid is 360-degree involved, and hence, it's difficult to take out this tumor, and hence people should either go for a subtotal resection or go for irradiation. That's not really the case. I think there are effective preoperative and intraoperative carotid management strategies, and one needs to know them to effectively manage the carotid. I show the slides not only to this particular picture, not only to my students, but also to my patients. So this is a good picture representing the entire skull base from below. And and in this slide, I always make this point that for me, this tiny piece of bone called the tympanic bone, the tympanic bone is the single most important bone in lateral skull base surgery. In the lateral part of lateral skull base surgery, so you see this tiny piece of bone. This is a weird shaped bone, which actually houses the ear. The aortic capsule is within this, the middle ear and the middle ear cleft is within this bone. And if you see this piece of bone goes all the way medially to touch the sphenoid spine. This is the temporomandibular joint. You have the tympanic bone forming the anteromedial aspects of the carotid canal, the anterolateral and the anterolateral aspects of the jugular bulb, and also forming most of the anterior aspects of the stylomastoid foramen. So when you are talking about the lateral skull base, you will be able to effectively open up the lateral skull base only when you have completely removed the tympanic bone. From an otological perspective, the tympanic bone is effectively looked up as the bone of the external ear canal. This is not true. Look at the deeper communications. It goes right up to the sphenoid spine. This is the Eustachian tube. This is the greater sphenoid foramen ovale, foramen spinosum. This is the petrous apex, and this is the clival bone. So this is the anatomy which one needs to understand. The tympanic bone is the first and the most important bone to be resected out completely. Every millimeter of the bone has to go for you to be effectively able to control the carotid, the jugular bulb, and the stylomastoid foramen. I would like to ask John if my pointers are visible, if this is enough, or should I be using the red pointer? Is this pointer visible?
Yes.
Yeah?
Yes, it's
okay.
visible.
Right.
Yeah.
Okay. So now this is the mastoid tip. We all know that the mastoid tip is something that needs to be resected out to be able to get access to the deeper areas. But then there is another important part of the occipital bone which needs to be addressed. That is this. Now this is the digastric groove, and you have the mastoid bone and the occipital bone behind. Now the entire jugular process. The jugular process is this thick undulated bone which is between the mastoid tip and the occipital condyle. So the entire jugular process needs to be resected out. That is when you can go under the jugular bulb and effectively reach up to the low cranial nerves in the neural compartment or the vasa nervosa of the jugular foramen. So this posterior part of the bone behind and under and medial to the jugular bulb has to be removed, drilled out completely for you to be able to access it, get a good access to the paraganglioma. So in effect, this here is the tympanic bone. This goes out and you have direct access to jugular foramen. Next in line is the hypoglossal canal. The hypoglossal canal in this view is here, going across the occipital condyle and then the occipital condyle foramen magnum. So that's the direction, the trajectory that's something that we're going to take. So when we are going for the jugular, there are three important things again: the jugular process, jugular tubercle, jugular spine. I will deal with the jugular process. Again, I'm emphasizing on this piece of bone that needs to be completely drilled out. The jugular process as it appears from the intracranial view needs to be completely taken out for you to be able to adequately control the jugular bulb. Otherwise, you'll be just nibbling and you're not looking at total tumor resection. So I've been told several times that in lesions like big paraganglioma, C3, C4 paragangliomas, total resection is never possible. That's wrong. You're not able, and the blame is always shifted on the lower cranial nerves. And they say that if you're totally resecting, then the lower cranial nerve takes a bait, and they are destroyed, or they are compromised, and hence it's not really wise to remove the paraganglioma in toto. The real reason why paraganglioma is not removed in toto is because of lack of exposure. You can still leave behind a small piece of tumor on the nerves and irradiate them, basically follow up, but if necessary, irradiate them later on. But the rest of the tumor needs to be effectively removed by the kind of exposure that I'm describing here. So this is the mastoid tip. This has to be completely removed. Then you get the jugular process. So here you see the mastoid tip. You drill this, you get to the jugular process. This bone has to go. Only when this bone is gone, you get posterior and medial to the jugular bulb. That is when you can control the tumor well. Otherwise, then you almost reach up to the occipital condyle. Of course, you don't drill through the occipital condyle, and then you have the anatomy of the suboccipital area, and then the atlanto-occipital joint, vertebral artery. That is if the tumor goes up to the vertebral artery. So what's happening here? I have problems moving the slide. Okay, so this is a more, I would say, intense picture of the atlanto-occipital joint and the jugular process area. Again, this is where the mastoid tip has been removed, the jugular process. You see this? This needs to be removed to completely expose the jugular vein and the jugular bulb. And then that goes as a sigmoid complex. You see, this is the foramen magnum, occipital condyle, atlanto-occipital joint, transverse process of C1, the vertebral artery is here. This is a bone that is not often removed. Only when you remove this bone, you get access to the jugular foramen. You see how this bone is compromising the complete exposure of the jugular bulb. The other thing is obviously the jugular tubercle. When you're coming from laterally, you need to respect the jugular tubercle, because if you cross the jugular tubercle, you're in the foramen magnum. That's something that is... so this is a lateral view. Now this is the jugular bulb. This is the labyrinthine block. This is the petrous bone. This is the facial nerve. You're looking at the right side. The facial nerve is here, the jugular bulb. Now this part, this exposure I've got only because I've taken out the jugular process in toto. So the entire jugular process has been removed, a part of the occipital bone, thereby exposing the jugular tubercle, hypoglossal canal, and the occipital condyle. If you go further, you're in the foramen magnum. So I'm going to skip. So most of what I'm going to talk to you about here is coming from this paper, which is from several papers that I've written on paraganglioma. So suffice it to say that there are two major skull-based paraganglioma. The third one is more like a medial cleft paraganglioma, which is called the tympanomastoid paraganglioma, the glomus tympanicums. So the glomus tympanicums are purely otological surgeries. I don't think the neurosurgery has a role there. But in temporal bone paragangliomas, there is another subsection, which is something that we are all going to discuss about today, which is the tympanojugular paragangliomas, which are often called the glomus jugularis. But this is a misnomer. It has some glomus cells, but it's not really a glomus tumor, because the tumor has three distinct varieties of cells, which is a base of connective tissue, neural elements, and vascular elements. So it's not, although it has glomus, it is in the glomus set of cells. The tumor itself is not a glomus tumor. So the tympanojugular paragangliomas can be divided into C class and a D class. I'm going to come to it later. And then you have the neck paragangliomas, the vagal paragangliomas, and carotid body paragangliomas. The tympanojugular paragangliomas, which is probably of interest here. So the tympanojugular paragangliomas can be divided into C and D class. C is all related to the carotid. So since these tumors arise from the jugular bulb and the immediate relation is the carotid, any tumor which is within the bulb obviously is related to the parapharyngeal carotid up to the entry of the parapharyngeal carotid into the carotid canal, the picture that I showed. So that's a C1. If it's limited to the bulb with maybe a small extension, most of these tumors have an extension into the middle ear. C2 is when the bulb expansion is such that it follows the vertical petrous. Most neurosurgeons would not really focus on the fact that the petrous carotid has a small vertical portion horizontal portion, a geno and a horizontal portion, then it ends at the lateral portion. So there's a small turn. So any tumor that's following the vertical portion of the carotid is C2. Anything that's crossing the geno is C3, and thereafter it is C4. It's a very easy classification only if you understand that there's a small vertical portion before the petrous becomes horizontal. So that makes all the difference in this classification. Okay. C1 is when it doesn't enter the carotid canal. C2 is when it enters the carotid canal, goes along the small vertical portion. C3 is when it is crossing the genu. C4 is when it is along the horizontal. The D is when it goes intracranial. DE is extradural, I is intradural. Okay. Now I want to talk to you about radiation. I wrote a paper several years back when I was with Mario, and we did a study on all our wait and scans. Those tumors where we didn't operate, where we didn't irradiate. So what was our criteria for wait and scan? Elderly patients, low cranial palsy in the elderly patients, we don't want to complicate that, Normal lower cranial functions in the young, you let them compensate. Let the lower cranial paralysis happen, and then you operate, Insufficient venous collaterals. This is very important. If there is a paraganglioma in a jugular bulb where the opposite jugulosigmoid complex is compromised, hypoplastic or absent, it's very important that you do not touch these tumors, because then, resection of these tumors would lead to, loss of venous drainage of the brain, leading to disastrous consequences. And then, of course, poor general conditions. So I did this study of tumors. So we found that in 92% of the tumors were stable for up to 3 years. Tumors started growing, from the 3 to 5 years period. That is when we saw, the numbers dip to 83%. And in a 5 years time, the local regional control dropped to 45%. But in any case, there was no sudden spurt of tumor size in any, like sometimes we see in vestibular schwannomas and cystic vestibular schwannomas. So these tumors there was no massive spurt. They always grew slowly. And these were all the series that we, so I'm going to summarize this whole study. And when I went through all those studies, I found that the radiotherapists themselves, did not standardize their studies. We all have the fish classification for paragangliomas. As surgeons, we generally stick to our classifications. But when you saw the radiotherapists, there was no pre-op standardization. So some of these tumors, some of these studies had tumors coming in after surgery. Some of them are primaries. I personally feel that every tumor has to undergo a wait and scan approach before radiation, if at all it is recommended for radiation, because most tumors do not grow in the first few years. Lack of consensus. Now, this is the most important, I would say, essence of that paper. So most of the radiotherapists themselves mentioned that contraindication for radiotherapy were large tumors, tumors involving the bone, extension below the skull base and neck, encasement of vessels. But then all these characteristics are all these things are the very characteristics of head and neck paragangliomas. And I don't think we see a single tumors that are not large. I mean, the smaller tumors don't need to undergo radiation. They can undergo, be operated. It can be taken out very easily without any neural deficits. It's the larger tumors that we are talking about. And these tumors obviously involve bone. They extend below into the skull base, neck, and the encase vessels. So if that is a contraindication of radiation, then I don't know why we should be in a hurry to recommend radiation for some of these tumors. Now, again, a couple of my, so this was a patient when I was with Mario. We saw this case. It was a 70-year-old male who was recommended to undergo a wait and scan approach. We didn't offer radiation as a protocol. We don't offer radiation protocol right in the beginning. So this tumor was irradiated. The patient went to another consultant who subjected the patient for radiation, and post-radiation, within 6 months, this was what we saw. The patient came back to us. This obviously looks like a malignant transformation, because when you compare to what we saw earlier, you see there's a very big increase in size. So this is something that must be kept in mind. And we did a study, a multicentric study, when I was at the group O, and our studies indicated the head and neck paragangliomas are generated and maintained by a population of paraganglioma stem cells expressing the Notch1 receptor and the ZEB1 transcription factor. Notably, the Notch1 and the ZEB1 are major inducers of radioresistance. So we could effectively be looking at a radioresistant tumor, and hence I would like to mention or emphatically state that we should not jump at radiation for these tumors. And once the patient is radiated, you know, it's going to be a very difficult surgery later on, and it's going to make life very difficult in a already difficult case. So I'm going to skip all these things for the lack of time. I've spent a lot of time already. So this is about So let me talk about stenting. Now, by definition, these paragangiomas involve the carotid, and in C3, C4 tumors, they are very intimately related to the carotid. They can be infiltrating the carotid. They could be drawing blood from the carotid. And if it is involving the carotid by more than 270 degrees, then it's a problem. Now, one must make sure not to be cowboyish and go into these surgeries without any preparations. And the pre-op management is for carotid management is well defined. If there is frank and a difficult carotid involvement, I think one needs to think of balloon occlusion, and if the balloon occlusion is negative, then the only option available is to stent the carotid. So if the delay between the artery and venous is more than 2 seconds, then one can effectively stent the carotid. So this is something that is now a regular part of most centers, part of in cases, again, in sufficient collateral blood supply, that is, if the opposite, and the single ipsilateral ICA, the opposite vein is deficient, and if the opposite ICA has been taken off for whatever reason, these tumors can be bilateral, these tumors can be multiple. So if there's been a surgery wherein the carotid has been closed accidentally or wantingly, then we are looking at a tumor related to a single ipsilateral ICA on the opposite side. So if there's such a presentation, then what would you do? You definitely need to manage the carotid, because if we radiate these tumors, they're going to come back, especially in young patients. They're going to come back to you at a later stage, and you have to do something about it. So in such cases, stenting has a role. So so this is a case where I had to remove 4 tumors in one patient. So there were 2 vagal paragangiomas one on each side, and 2 carotid body tumors, one on each side. And I could remove all 4 tumors in a young lady who came to me from another country, only because I could stent the carotid. And I could stent the carotid bilaterally. I mean, once you stent the carotid, the patient has to be on a single antiplatelets for the rest of it. So, so we are okay to stent the carotid on the other side as well. So I went in and I could remove all 4 tumors. This patient was considered inoperable. And in fact, in our centers, we get a lot of such reference. We are a quaternary referral center now for most skull base, lateral skull base, anterior skull base lesions, and especially paragangiomas. So we've done more than 250 paragangiomas now. And ever since I came back from Mario Center in 2018, and we have set up a state-of-the-art skull base center here at Manipal Hospital in Bangalore. So now I'm going to take you through a video through what is called the fish type A infratemporal fossa approach, which is a classic or a workhorse for paraganglioma surgery. But then we have done some modifications, which is something that I'll talk about in the course of my lecture. So the incision is postoral like this, and we take out the flap. Of course, the incision goes down to the neck, and we'll show that in a minute. The flap elevation is in the subcutaneous planes and in the musculoperiosteal layers. So that's the T-shaped incision I apply and use it to stitch it back for closure. So this flap must be well respected, especially if there's a CSF leak. So this is a cadaver. So this is done in a kind of a normal way, but I use a lot of monopolar and bipolar here. So the flap elevation goes up to the posterior limit is the emissary vein and the digastric muscle. And the drilling is commenced. Do a mastectomy. So once the mastectomy is done, you get a nice shape there. That's the facial nerve. That's the lateral semicircular canal. That is the epitympanum. This is the posterior canal wall, which will be taken out eventually. And we do what is a canal wall down mastectomy. Now you see the posterior canal wall is taken out. I'm drilling the tympanic bone. So this is the tympanic bone. So this is what I was mentioning about. So the tympanic bone is drilled out. So that's the tympanic bone. Needs to be completely drilled out to get an effective control of three important structures: the stylomastoid foramen, which is here, then the jugular bulb, which is deeper, and the carotid, which is even more deeper. So now I've identified the carotid. Identified the facial nerve. I am drilling on the facial nerve, skeletonizing and then decompressing the facial nerve. You see the facial nerve is decompressed. Okay, the facial nerve is come. This is the stylomastoid foramen. Facial nerve is decompressed. This is the lateral semicircular canal, posterior semicircular canal. Jugular bulb will be here. This is the sigmoid sinus. And then I reroute the facial nerve. Okay, so I reroute. In this case, there is no tissue glue. So that's how you reroute. So it's a cadaver, so we don't have tissue glue. So I cut it eventually, but this is how I reroute the facial. That's how you reroute the facial nerve, the parotid, and the facial nerve is completely reroute, of course. And then here I go in and I expose the neck. I'm exposing the neck. Somewhere before I would have probably dissected this is the dissection of the great vessels in the neck. This I think can be skipped. The IJV, this is the hypoglossal nerve. All the nerves will be exposed in the neck. So that's something that we can skip for the moment. And then now you have the styloid process. This is the styloid process. This is the last part of the tympanic bone that needs to be drilled out. So once you drill out the styloid process, the entire jugular bulb areas. Now you see the jugulo-sigmoid complex is exposed. This is the sigmoid sinus, jugular bulb and going down into the neck. You need to drill out and take out some of the soft tissue here. And then you are getting control. So the styloid process to be taken out. This is the base of the styloid. I'm drilling out the last bit of the tympanic bone here. Tympanic bone, that's the gateway to lateral skull. Now I'm removing the styloid process. Once you do that, you get complete access to the skull base. Okay. So you take out the styloid completely, and now you identify the carotid. The view here. The carotid comes into view. So now you see the entire skull base. So you have the 9th cranial nerve, you have the 11th cranial nerve, that's the jugular bulb, all the lower cranial nerves. It's not that's the carotid. That's the carotid. Okay, so all of the great vessels are now in continuity from the infratemporal fossa. No, that's IJV, sorry. The in continuity from the infratemporal fossa up to the temporal fossa and up to the middle cranial fossa. So you can do whatever you want. Now that's the IJV. I'm showing you the lumen of the IJV. And that's the carotid. So this is the carotid here. This is the carotid. That's the petrous bone around the carotid that's being drilled out. So you have the entire exposure clear and you can take out. This is how we close the sigmoid. A lot of things to be shown here, and then, so that's the jugular bulb. Okay, so that's it. The inferior petrosal sinus going up into the cavernous sinus. So systematically the entire jugular. So this piece of bone has to be removed to go under the jugular. This is the jugular process. This piece of bone has to be removed. Okay. So now let's move from dissection to some surgical pictures. So this is a case with a C2 bar going into a C3 jugular paraganglioma. This is a lady who came to me. Now, this lady had undergone a canal wall down mastectomy because somebody had mistook this case for a tympanomastoid paraganglioma, which is a glomus tympanicum. So this is the bane of a higher center like this. You get a lot of cases which are mismanaged, and then you deal with their problems. So this is a canal wall down. What is the problem with the canal wall down mastectomy? The problem is, so I have modified this incision. This is not a classic fish incision. So I do a incision just enough for me for exposure, and which can be covered by the ear. And then I go down the neck very gently without really making a big exposure like in the classic fish incision. So I open the flap, and when I open the flap, I see the mastectomy. But what is more important is that because there's been a mastectomy, and with mastectomy comes a concomitoplasty, which is what we do to open up and keep the middle ear open. That makes it very difficult for me to do what is called a blind sac closure. All lateral skull base surgeries need a blind sac closure because you're doing a very large drilling of the temporal area and the infratemporal area. So that needs to be closed. So I do a blind sac closure, and then I attack the tumor. So this is the tumor. This is the skin now. Now this is the skin. In mastectomy, they let the skin epithelium grow into the cavity. This is a major problem. This can lead to cholestoma. It has to be removed nicely and gently. This is the 11th cranial nerve. This is the vagus nerve. This is the 11th cranial nerve. This is the internal jugular vein, all the great vessels in the neck. And then you see the internal carotid artery dissection. This is the hypoglossal nerve. This is the descendens hypoglossalis. All of that is identified, and then you move. Now you have to make this cavity and this cavity one single cavity. Okay. So you go, I do a classic rerouting. This is a fish approach. I have now stopped doing classic reroutings for smaller tumors. That is a C2. And I'm pushing the limits towards C3. For a C4, it is impossible. You have to do a classic fish. Now, this is a facial nerve being rerouted. This is facial nerve being branching into the parotid. This is rerouted completely. I'm rerouting the nerve, rerouting using tissue glue. And now you have the entire tumor ready for resection. So this is the lateral semicircular canal, posterior semicircular canal, middle fossa dura, left ear. So the left sigmoid sinus, presigmoid dura. Now I need to take out all this bone. This whole thing has to go now. So I go, before that, I take out the styloid process. Styloid process and the muscles attached to the styloid process. So that's the whole styloid coming off. Now the IJV is being clipped, ligated in the inferior, in the distal segment. This is the proximal portion, where in the sigmoid, I close the IJV, the sigmoid complex, by doing what's called a extraluminal packing. Now, the IJV is closed, sigmoid is closed. I need to take this out. Okay. So I obviously there'll be bleeding. I embolize all my tumors. And I make sure that and I have a fantastic neuroradiology team, which gives me practically a bloodless field. Nevertheless, the posterior condylar veins and the inferior petrosal sinus. These are the two things that give rise to problems. So you need to pack it with Surgicel. Then you start taking out. You take out all this. All this is tumor. Okay. So this is the dome of the jugular valve. You take it out. Now the IJV and the tumor have taken out all this. There is bone now, no tumor. This is a benign tumor. So when you take it out, it's a cure. So this is the carotid here. This is complete resection of the tumor. And this is complete resection of the tumor. And we have, you see that we have gone right up to the petroclival junction. And we have been able to completely. This is temporary facial nerve palsy. This is due to rerouting. I should be putting the long-term follow-up. This lady came to me recently. So in about 6 months' time, this will be practically grade 1. I'll show you another case. Okay, I'm going to show you maybe this case. So this is a young boy who came with intact facial nerve palsy. Again, rerouting of the nerve and the great vessels and the nerves in the neck. So I'm not going to go through all the slides, but this is his immediate post-op. Rightly. So that's his immediate post-op. Loudly. And that's him at 2 months' time. You have a grade 2 bar 3. Grade 3 is forceful eye closure. And this is after 4 months, practically normal nerve. And now, I mean, this was almost a year back. And he's got an absolutely grade 1. That is no facial, grade 0. That is no facial nerve palsy. Absolutely no facial nerve palsy. Okay. So this is another case that I'll just show you the surgical steps. Another guy recently that I did with what is called the intact fallopian bridge technique. So in this case, I keep so this is the tumor. It's a C2. Okay. C2 may be going into and becoming a C3. Okay. So this is, this is the geno. This is the geno. Okay. So that's just about stops there. So C2 bar C. Okay. So in this case, of course, I do an embolization for my cases. That is pre-embolization. This is after embolization. I get practically a bloodless field. I have a fantastic neuroradiology team that gives me all these things. I'm sure this is something that. So nowadays, over the last 50 cases of paragangliomas, I do what is called a simultaneous ipsilateral bone-anchored hearing implant or a ossia. Now, these are devices which are bone conduction devices. All these tumors have normal cochlear reserve, which means that they only have a conductive loss. So the tumor is in the middle ear mastoid, and that's why they have a hearing loss, complete hearing loss. But the cochlear reserve, the cochlea is okay. So if you put a bone-anchored hearing implant, not a hearing aid, bone-anchored hearing, because all these patients undergo a blind sac closure, then you can restore hearing to normal through the implant in the same sitting. So nowadays I go in for a total removal with hearing implant. So their hearing loss is also rehabilitated. So this is a T-shaped incision, open up the mastoid, and then this is the lateral semicircular canal, posterior semicircular canal, superior semicircular canal, middle fossa dura, sigmoid. Now I identify the facial nerve by what's called the facial dimple. Lateral canal, posterior canal, just at the junction, bifurcation, I drill, and immediately anteriorly will be the facial nerve. So that's for another day. So that's the blind sac. I do a two-layer blind sac, and then I expose the great vessels in the neck. The 12th cranial nerve is here, carotid, internal carotid, IJV, 11th cranial nerve, much better pictures in this case. So the neck dissection is complete. I think this is beyond the scope of this discussion. So now this is the tympanic segment of the facial nerve, mastoid segment of the facial nerve. All this is tumor, this is tumor, this is tumor. This is the jugular process. This is the mastoid tip. The digastric muscle is between the two. And now I take out the mastoid tip and make the infratemporal fossa and the temporal fossa into one cavity. So this is how that is achieved. So what have I done here? I've taken out the entire mastoid tip, and I also drill out the jugular process. I keep telling this again and again. That is when, so this bone here is drilled out with the muscular attachments in the suboccipital area, which is splenius capitis, semispinous capitis, sternocleidomastoid, anyway is pushed back, and then you have the rectus muscle attached to the transverse process of C1, superior rectus oblique, inferior rectus oblique. Part of that is detached. You create a plane. If you go deeper, you have the vertebral artery to be careful. So you have to dissect all this, and then you have the IJV, jugular bulb, sigmoid sinus, all in one straight line. This is the picture one needs to achieve. If you're able to achieve this picture, then you are doing a good paraganglioma surgery. So I always look when people show me paraganglioma surgery, if I don't see this picture, because I know that it's important to show this picture. And if this picture is not shown, then I know that this person has not reached the epitome of paraganglioma surgeries. IJV, jugular bulb, sigmoid sinus in one straight line. This is possible. So when you're doing this, you can keep the facial nerve because you get a lot of space posteriorly. So this is the carotid, anterior to the facial nerve, stitching tube is here, middle fossa dura, and I'm going anterior, posterior to the facial nerve. It's called an intact fallopian bridge technique. I am able to create space. I have now closed the sigmoid. I'm closing the IJV. I'm bringing up the IJV. This is all tumor. This is the vertical petrous. I told you the petrous has a small vertical limb and a horizontal limb. So this is tumor resection. Tumor resection, I'll just go to the very end. This is tumor resection. This is the jugular process. The sigmoid sinus is closed. IJV is closed from below. Jugular process. This is the dome of the jugular bulb. I take out tumor. I pack the posterior condylar veins, which come at this point. Then the inferior petrosal sinus, which is anteriorly, tumor being removed, more tumor being removed. And this is tumor and removed, and this is the medial wall of the jugular bulb. This is the medial wall of the jugular bulb. Through you can see the nerves, okay? The medial wall of the jugular bulb. And then, so you see, this is the carotid. This is the cuff of the carotid. This is not tumor. This is cuff of the carotid. This is the vertical petrous carotid. I've taken out most of it. I've burnt out the rest. So that's total tumor clearance. And I close it with fat and I stitch it up, and the ear is completely closed. I do what is called a bone anchored hearing implant. So the person is able to completely hear. So this is his facial nerve, which obviously recovers. Again, it's a grade 3 because immediate post-op, because I know if it's a grade 3 immediate post-op, it becomes grade 1 in about 4 months' time. So that's this post-op. That's the post-op. The facial nerve is in the center. Everything else has been taken out. Now, what I have to show you now is very important. This is another case. This is what is called the extreme fallopian bridge technique. So this is another guy. So I'll quickly open this, skip the first few steps. Now, the first few steps are the same, the T-flaps. In this case, I'm doing an ossia implant. So this is mastectomy. I'm doing an ossia implant, okay? Ossia implant is a bone-anchored, new portfolio of bone-anchored hearing implants, which is developed by Cochlear, the company from Australia. And I did the first ossia alongside skull-base surgery in the whole of Southeast Asia, Asia-Pacific, immediately after it was launched. And we have the largest series of ossia in all. But the problem with ossia is it has got a magnet, and a magnet on MRI is a problem. We all know that. And I'll tell you what I do for this. So I'm doing an ossia in the same sitting, which is an upgrade from a Baha. Baha doesn't have a magnet. So this is an ossia. These are steps of ossia. I can't discuss this in today's lecture because it's going to take a lot of time. That's the implant, and that's placed horizontally like this. I go ahead with the master. We'll talk about it on another day. People can write to me. My email is sampathcp@gmail.com. You can always discuss more things online, offline. So this is the tumor. This is the incus, mastectomy being done right side. Sigmoid sinus, that's the facial dimple. Lateral semicircular canal, posterior semicircular canal, facial dimple. So I'm doing a blind side closure now. This is the ear canal being closed. The first layer is already closed. The second layer is being closed completely. And then I go ahead and bring the canal wall down. I expose the tumor. So this is the tumor being exposed. So there is tumor in the middle ear. Facial nerve is being exposed. Tumor behind the facial nerve. This is the sigmoid sinus, right ear, lateral canal, superior canal, posterior canal. And then I go ahead, decompress, and then skeletonize the facial nerve completely. Now you have the tumor, complete dome of the jugular bulb involved by the tumor. Carotid is somewhere here. This is the eustachian tube. Okay, so that's the tumor. That's the tumor. That's the facial nerve being separated. The undersurface of the facial nerve is having the tumor. This is the neck dissection complete. You see tumor down in the neck. Okay, this is the jugular process. The hypoglossal nerve, the descendens hypoglossalis, the vagus, and the interjugular vein. Interjugular vein is here. This is the rectus inferior, and this is the tumor. So this is all tumor. Now I'm going to slowly resect the tumor, and this is the intact fallopian bridge technique, but it is what I call the extreme fallopian bridge technique, and I'll tell you why. It's very important to understand the difference. And I'm sure this is not particularly described, but it's something that we will come out with the publication. So here I've closed the sigmoid. I'm going to close IJV. The tumor is well circumscribed. I have not mobilized. This looks like a partial mobilization of the nerve going to the parotid. It's not true. I have left the nerve where it is. I've closed the IJV. I am now dissecting the tumor. I am dissecting the tumor, debulking the tumor, debulking the tumor, debulking the tumor. Now you see these muscles. These are the stylohyoid, styloglossus, stylopharyngeus set of muscles. This is stylohyoid. The medial muscles are styloglossus, stylopharyngeus. Now this is attached to the styloid process. The styloid process is medial to the facial nerve, on the other side of the facial nerve. Now, if you want access to the carotid, you need to remove the styloid process like in the fish approach. But traditionally, the facial nerve had to be rerouted. Now, I am going to do this without rerouting the facial nerve. I'm going to go under the facial nerve. I'm going to show the styloid. This is the styloid process. I'm going to excise the styloid process. This is the monopolar on the styloid. The base of the styloid has been disengaged from the rest of the bone. Complete resection of the tympanic bone has been done. I'm going to go, and this is the styloid process and the muscles. Now you see the additional exposure I get with the facial nerve in its place. I have not mobilized the facial nerve. I have not even partially rerouted the facial. You see this exposure you got immediately because you have mobilized. I go ahead. I have complete access to the carotid also. Now I'm going to take out tumor. I'm going to take out tumor. I'm going to take out. Now you see I'm dissecting the carotid. I have to follow the carotid upwards. This is the glossopharyngeal nerve. You will be seeing the glossopharyngeal nerve only if you take out the styloid. So this exposure was not possible in the first few slides. So this is the hypoglossal descendens, the 11th cranial nerve. Now I'm going to dissect the carotid. Now you see the carotid. I'm going to dissect the carotid. This is the carotid going. There is tumor. I have complete access to all parts of the tumor. The carotid is here. And this is, I've done almost total resection. I have to now show you the last part that is here around the carotid. Around the carotid, the last part, the dome of the jugular, all this has been taken out. All this has been taken out. Okay. So now I go to the last part of the tumor, petrous apex and carotid. Carotid is here. That's the entry of the carotid in the carotid canal. This is the petrous removed. Now this complete resection of the jugular bulb petrous. This is the portion I need to take out. The carotid is here. Now I remove this. Now this is total clearance of the carotid. The carotid goes like this. This is the geno, the vertical portion, and the geno of the carotid, and I have complete total clearance. This is cure. Okay, this is cure. Facial will return back to normal. This is complete resection of the tumor, and the facial will come back to normal. And this patient, now you see, you may tell me, what about the magnet? So the magnet obviously gives an infarct, artifact. So this is how the magnet looks like, but we have what is called the artifact reduction sequences. So I deploy the artifact reduction sequence and I see my post-op cavity perfectly well, perfectly well. So these are the small areas of artifact, which is not in the area of where I've operated. So this is what I do for my magnetic implants. What I do for my magnetic implant. So that's his post-op facial. He's got a grade 3. This is all recent cases. So I have been able to take out tumor completely in and achieve it. Now I'm going to show you the last case where I do what is called a stage resection.
Oh,
Now,
sorry. Close
this
your
is,
eyes.
can I
Lift your eyebrows. Say E.
Professor Samay, can I
Okay,
take
say
2 minutes? Can I take 2 minutes?
Loudly.
Okay.
Loudly.
So this
Put your tongue
patient
out.
came to me with total paralysis of the facial nerve. Came to me with total paralysis of the facial nerve, low cranial nerve palsy. I took him up for surgery, 6 centimeter tumor. Professor Saleh, can I take last 1 more minute? Can I take 1 more minute, Professor? Professor Samay, can I take 1 more minute?
Okay. Okay.
Okay. So I would like to show grafting and the results of grafting of a facial nerve. Now this patient, Professor Samay, came to me with complete facial paralysis. 1-year-old facial paralysis, complete paralysis of the lower cranial nerves. He's a young guy with one of the biggest tumors I've seen. So I go in, and these are for the first few steps which I've already shown you. Now I have been able to separate the nerve, but the nerve is absolutely unviable. With neuromonitoring, it's unviable. This is all tumor. So I decide to cut the nerve, sacrifice the facial nerve. I go ahead, I do an extracranial resection. That is, I stay beyond the dura. This is pre-sigmoid dura, right side. I take out everything. This patient is stented. I put a stent into the carotid. I've gone all around the carotid. So this square piece of resection is all extradural. The interdural I have left behind. And I did a sural nerve grafting. Now this is the stent you can see. This is post-op. And the residual you can see here. I was following up the residual for 6 months. So you can see the intracranial residual, which is intradural. So it was growing. So I decided to go 6 months later and take out the residual intracranially. Okay. So that's the stent. You can see the stent here and you can see the residual. So this is his facial nerve after grafting. Professor Samay, you see that this is practically grade 3. I have done a 6 centimeter grafting and you can see that he's able to close his eyes and his face is, the shape of his face is, this is after 6 months. You know, so grafting gives good results, and that I know I'll skip all the other things. Now I go intracranially, I do a BAHA, bone anchored hearing implant. I do, this is my theater neuronavigation. I skip all this. So I go intracranial. So this is the lateral semicircular canal. The extradural part has been taken out. Now I'm going intradural. I'm doing a labyrinthectomy. This is pre-sigmoid dura. I remove the pre-sigmoid tumor on the pre-sigmoid dura. This is the internal auditory meatus. So this is the internal auditory meatus. There is tumor all from the internal porus down intracranially. So I go inside. This is all tumor. I go inside intracranially. You see the cerebellum. And then I'm taking out all of the tumor attached to the dura. This is the ICA loop. I'm seeing the ICA loop. I'm resecting the tumor from the internal auditory meatus here. This is all tumor. This is the internal auditory meatus. And I have exposure to the ICA. I need to preserve the ICA loop and the labyrinthine cochlear arteries. And this is the root exit zone of the facial nerve. This is the root exit zone of the facial nerve. So I've been able to completely resect the tumor in the CP angle. So that's complete resection, and I burn the base of the dura from where it is attached. So that's the root exit zone of the, I'm showing the root exit zone of the facial nerve, and this is total tumor clearance intracranially as well. Okay. So I close it with fat. Okay. So that's the post-op. Okay. So that's the post-op. So I'd like to, I can show you a lot of other cases of vagal paragangliomas, carotid body tumors. So all this is, I've got several cases. I told you this is an interesting case of a lady where we took out 4 tumors. Okay. So 4 tumors. I'll just show you the pre-op and the post-op scans. So this is the pre-op using stenting of the carotid. Yes. So this is 4 tumors. Okay. So I'm going to show you the last post-op. Yes, I will conclude now. And after 2 stenting of the stenting of carotids, bilateral stenting of the carotids, we have been able to remove both the all 4 tumors, and this is the post-op, you see absolutely no tumor, 4 tumors taken out of this patient. So once again, thank you, Professor Sameh, and this is a wonderful opportunity. Thank you for your kind invitation, and I invite all of you to Bangalore for some of our courses. We do some of the largest courses in skull base surgery anywhere in the world. So all of you can write to me or visit our websites. We have individual websites for each of these courses. Thank you, Professor Sameh. It's been an absolute pleasure and honor to join all of you and share with you some of my work. And thanks for the opportunity.
Thank you, Dr. Samas, for this excellent presentation. And for the sake of time, we will shift to next speaker directly. Professor Carlos Eduardo, please start sharing your screen. Thank you.
Thank you. Can you see my screen, please?
Yeah.
Yeah. Okay. First of all, thank you, Dr. Sam, for this wonderful opportunity and the invitation to be in this amazing and outstanding course and Congress with a lot of big men of the neurosurgery and the skull-based surgery. I have no disclosures to talk about the cavernous sinus, except for my passion in this issue in the last 20 years. And an historical report about the cavernous sinus is interesting that it was considered until the 60s the no man's land, but the man reached the moon in the 60s, and Parkinson, with this wonderful pioneering work, introduce us to the cavernous sinus, and following the next decades, amazing surgeons construct and make possible to do a very safe and effective surgery in the cavernous sinus. Dolenk, Mefti, Hakuba, Evandro de Oliveira, and Ali Christ. It's very important when we are talking about the cavernous sinus to think that we can divide the cavernous sinus in meningiomas and all the other tumors. And when we talk about the cavernous sinus meningiomas, we have to think that the meningiomas primary originated inside the cavernous sinus are completely different of the secondary invasion of the cavernous sinus. Meningiomas coming from clinoid, middle fossa floor, petrosal apex, and so on. The natural history of the cavernous sinus meningiomas are very benign, and we have to think that most of these tumors will never have to touch them. 83% of these tumors remains stable for more than 10 years. 8% of these tumors recover totally his symptoms with corticosteroids. And major symptoms as oculomotor and neuralgia also responds to corticosteroids in 70% of the case. So the first thing is to understand that the biological behavior and signature of these tumors are essential to decide which one we have to remove. And we know that for more than 10 years that the signature in the skull-based tumors are completely different from the other locations. So we all have cases like this with 10 years, with 20 years of completely stable meningioma around the cavernous sinus. And so these tumors can be dark, but they have a very good biological behavior. The thing that we have to fight against and to be prepared to fight is with this kind of tumors. Giant meningiomas coming from the other places or inside the cavernous sinus, and the patients with intracranial hypertension and several symptoms that completely disturb the quality of life. Even in the molecular era, we know that the most important tool to control the meningiomas are the surgical remove. And that's the point, because we have one key to understand how effective can be the removal of the tumor inside the cavernous sinus when we are talking about meningioma. And this is the stenosis of the internal carotid artery. If you have stenosis in the internal carotid artery, it means that probably you cannot remove safely this tumor from inside the cavernous sinus because the invasion of the adventitia of this vessel. Okay, that's a really important trick for young surgeons coming from other places inside the cavernous sinus. This is the most important idea for me. The principles of meningioma surgery are totally different of the other tumors. When we're thinking about meningioma in the cavernous sinus, we are not talking about chordomas, chondrosarcomas, adenomas, craniopharyngiomas, that they have a completely different behavior, and it's easier to remove. But the meningioma have some principles that I have been learning from the last 20 years with from my masters, and I remember with a acronym, FIBER. F, first time. The first time is the best time to remove the meningioma. We have all the arachnoidal planes, we have all the anatomic reference that can help us to remove this safely. Exposure. Meningioma, it's a surgical disease. So you have to expose all the limits of the tumor in order to remove it completely in the first surgery. Bone removal. We have to understand that more than 90% of the meningiomas, which involves the bone, really are involvement of the tumor inside the bone. So we have to remove the bone to keep patient free from the disease in the recurrence. The arachnoid plane and the attachment of the tumor, we use the arachnoid plane to see and to preserve, as in all microsurgical techniques for all the tumors. We have this key to remove, preserve, and the function. The irrigation in surgery of the meningiomas is much more important than coagulation. When you irrigate with warm saline, we can see all the arachnoidal plane all the time, and this allows to remove the tumor safely using the plane all the surgery. And the last one, the reconstruction. I'm very concerned about the reconstruction in skull-based surgery, and I have some difficulties with some numbers that I see in the literature, according with the CSF leak. CSF leak is a dangerous and mortal complication in skull-based surgery, and the reconstruction is essential for effective work in the skull-based surgery and in the cavernous sinus. I have been published with these principles in the last years in the Spanish and English literature. I used to operate this cavernous sinus meningiomas using the FIBER principles in a 4-step surgery. First is the exposure, and I choose the exposure according with the tumor. To the extradural work, for me, is the key to removal completely safe the cavernous sinus. And the third step is the intradural part of the surgery. And the last one is the reconstruction. We all the time operate in this case, we are using the same principles and the same steps in a way that we can reproduce the surgery in any department. The first step depends on the extension. If the tumor is going to the opt canal, orbita, temporal or infratemporal fossa, or going to the posterior fossa, we are combining and changing the approach around the area to expose completely the tumor. So we can go from the simple pterional, cranioorbital, or cranioorbital zygomatic, that are variations of this pterional, that which is the most important in the first skull-based approach. The middle fossa peeling is the key for the extradural, and for me is the most important step of the surgery. Usually neurosurgeons are not so concerned about this step, but this is the trick to remove completely safe the tumor and avoid recurrence. So the middle fossa peeling from the lab to the OR is essential for this step. The intradural is the most popular one. Sometimes I saw that people open the craniotomy, go directly to the intradural step of the surgery, and this is the reason for we have some recurrence in these tumors in the big departments. In the reconstruction, I usually use the autologous pericranial flap, temporal fascia, and fascia lata with a lot of fat. I use a lot of fat to avoid the complications in the skull-based surgeries around the cavernous sinus. Let me show you some case exempling to the from the extradural, intradural steps of the surgery. Here we can see a large sphenoorbital meningioma of the lateral cavernous sinus invasion and the infratemporal fossa and pterygoid fossa. You can see here how big is the tumor in the inferior portion of the orbita below the eye globe and go into the lateral part. We use the cranioorbital zygomatic approach in this case because we are going through the middle to the infratemporal and also to the pterygoid fossa. And this case is selected because this example is the example for the extradural work. You can see here the removal of the lateral wall of the orbit. We are extensive drilling, coagulating and cutting the meningioorbital band and doing the middle fossa peeling from the anterior to posterior way, removing extradural the anterior clinoid process, exposing the clinoidal and ophthalmic segment of the carotid artery. The lateral wall of the cavernous sinus is the triangles of the middle fossa, open the optic canal from the extradural way, from the extradural route, drilling the anteromedial triangle, the anterolateral triangle, removing the bone involved by the tumor. You see here the posterolateral triangle, and now we are working removing the tumor in between V1 and V2. Small pieces of tumor, now working medial to V1 and V2. Opening the sphenoid sinus. Now the intraorbital portion of the tumor. You can see that all the work is extradural, removing the tumor from laterally to the eye globe, piece by piece, in a microscope view. The trouble in this is that part of the tumor is below the eye globe. So we have to use sometimes another tool to see. And we do that, I don't know what's going on with my video. We do that using the endoscope. Now we are removing the tumor from the pterygoid fossa and checking the lateral wall of the cavernous sinus, all the triangles with endoscope to check if the radical removal was performed in the first surgery. This is the immediate post-operative that you can see the preservation of the extraorbital. This is another case of lateral invasion of the cavernous sinus from the sphenoorbital meningioma, and I would like to show you how we combine the intradural step of the surgery. And the extradural is exactly in the same way, removing after the peeling of the middle fossa, skeletonizing V2, open all the triangles of the middle fossa, lateral to the cavernous sinus, and removing all the bone involvement of the tumor. And this is the intradural step. Look, that we are just communicating the extradural step of the surgery with the intradural removal of the dura around the cavernous sinus. We open the falciform ligament. We are communicating the peeling. You see here that the last piece of the tumor is the piece that I work around the superior orbital fissure, because the risk to the damage of the nerves in this portion is the most important one. You can see here how beautiful is the exposition and the final view of the intraarachnoid portion of the nerves and the cavernous sinus traveling of these nerves completely free of the disease. And this is the reconstruction and the postoperative. Look, this is immediate postoperative period with the patient preserved all the extraocular motor movements. It's important. This case was published in a skull base. And the last case I would like to show you is this kind of, cavernous meningiomas that's coming from anterior clinoid, but the invasion of the skull base is amazing. And you can see how the hyperostotic bone should be removed. Unfortunately, this patient was already blind when it comes to us, and I would like to show you this work and the limitations in this case. You see here the extradural step of the surgery, exactly as I show you in the case previously. Here we are using just a mini peeling of the lateral wall of the cavernous sinus in the intradural step of the surgery. And we are removing tumor using the arachnoid plane around the internal carotid artery, communicating the peeling of the extradural step with the intradural step, open the falciform ligament, and removing the tumor around the superior and lateral walls of the cavernous sinus, opening the oculomotor triangle and removing the tumor. Here we can see how tough is the tumor and hard, and we have to use the drill intradurally to remove the optic strut that was hyperostotic and firmly adhered to the tumor, attached to the tumor, and the reconstruction. So after this idea, we can have a very nice first time result. But you can see in the coronal that the medial portion of the tumor was very hard and attached in a squeezed internal carotid artery. So that's why we should preserve this piece of tumor and follow. This is the extradural attack. And here, the myth that we cannot remove and safely around the cranial nerves and cavernous sinus, you can see a lot of cases with the same, all the same evolution. In 3 weeks to 3 months, the total recovery of this patients in terms of the cranial nerves function. This video also was published in Skull Base, and here's our recent publications with our experiences with, for example, sphenoid wing meningiomas invaded and cavernous sinus with 90% of the KPS 190 and only 8% of definite new cranial nerves deficits. Our publication in this year's with the giant meningiomas with incredible volumes and intracranial hypertension, also with patients with completely compromised quality of life in preoperative and in postoperative, we can have very good results in terms of extension of the removal with only 20% of the new definite cranial nerves. In conclusion, I think that for cavernous sinus meningioma, especially for the youngest, the laboratory is the essential key to do a transcranial approach. We can choose between terminal and cranial orbital. Usually I use this two approaches to remove these large tumors. The extradural step is the key, and the middle fossa peeling is essential for total exposure and safe exposure of the tumor limits and the cavernous sinus. The intradural step, we should do the sharp dissection of the cranial nerves inside the cavernous sinus and control of the internal carotid artery. Reconstruction with autologous tissue, CSF leak prevention, and cosmetic results. Our limitations, remember that ICA squeezing and compression and the tumor consistency, of course. Thank you so much, Sam, for the opportunity. Thank you.
Thank you, Carlos, for this excellent presentation. Is there any question? Thank you. Now we'll shift to next speaker, Professor Paulo Cadri. Please start sharing your screen.
Good morning, everybody. It's always a pleasure. Good morning from Brazil, right? It's an amazing opportunity for us. I'd like to congratulate once again Samet for his efforts. It's really a great job. It's really an outstanding program, and it's really something that we need nowadays to bring together not only our community but the whole world. Hope you can see my screen now.
Yes.
Okay. So after this presentation of Professor Carlos, which is amazing, and if you notice, there is barely a touch in the brain. If you see how he presents his post-op images, where you really, the respect to the brain, there was no retraction. We're going to change a little bit the subject and we're going to talk about the fourth ventricle lesions. But the principles, although it's not really a skull-based approach for that, but the principles is more or less the same. We have to focus on the preservation of the brain. And as Professor Almefti always said to us, if you had to remove the bone, you leave the brain alone. One neuron is way more value than 100 or millions of osteoblasts. So to focus on that, I choose one case. This was a case that presented in our department, and there was a lot of discussion, especially because would that come to the floor of the fourth ventricle or not? Should we choose a lateral approach, or should we go through the floor of the fourth ventricle? At the very beginning, I was favoring to come from the lateral. But then looking at the images, I said, that's a very long approach. Maybe we should try to go in a different way. As we know, it's a long history of the approaches to the fourth ventricle. If we talk about the fourth ventricle, you do have to think about the floor and the roof. I'm going to focus about the floor because there is where we have the most difficulties. But even from the history, from the very first time, Craig said to us that complete remove would have a relief of the symptoms and a lower operative mortality on the follow-up. Then there is a discussion if we should do craniotomy or craniectomies, push in favor one thing. Then you're going to see, especially the French and the Germans already at that time, pointing out that craniotomies would be better. And Professor Yashagil finally showed us that to focus or to approach those, the craniotomies would be better for us. We did a little bit of the contribution, let's say, on that, how to preserve all the structures until we get there. And this is the advantage of doing a craniotomy over the craniectomy that we all know about that. Then finally, we get to the brain. And then we are seeing that at the very beginning, some people favoring to split the vermis. Some, especially Dundee, say that we wouldn't have any complication of that. But we do know nowadays that although the cerebellum is only 1/10 of the brain, it has more than 50% of all neurons. And it is involved in all kinds of functions, especially high functions of the brain. Then we come to the microneurosurgery, with Professor Yashagir always favoring the pure lesionectomy, our favoring to protect and respect the brain, where he described the uvulotonsillar approach that was later studied and renamed by Professor Rotto and his team as the telo-velo-medullary approach in beautiful, beautiful anatomical studies, as we know. As we know, we do have to favor the less damage to the brain, right? So here is a little bit of the anatomy of that. We're going to see that the way is between the posterolateral fissure between the pyramids, the uvula, and the tonsil. So this is the way where we go through. Once we split what we call the vermian notch, and we can see the inferior velum, we know that the velum is attached all the way up to the tila, and that's where we're going to face going in this posterolateral fissure between the uvula and the tonsil. We're going to face the pica, and the choroidal point of the pica will be the reaching point that we want to get there. Once we split that and we open that, we're going to face the floor of the fourth ventricle. One important thing is that the velum is attached to the tila within what we call the flocculonodular peduncle. This is very important, especially because this is one of the key points where you put sometimes your spatula. You do have to respect that retraction, because we know that under the uvula, under the tonsil, you face the dentate and the peduncles of the dentate with the inferior peduncle as well as to the flocus. So this is avoiding retraction and actually open up very well the inferior velum. So the retraction will be less damage, especially to the deep nuclei of the cerebellum. So once you open that space, you can retract and have the floor of the fourth ventricle open to you. Then now we're going to go further, especially with the work of Professor Bricklow, the late Professor Bricklow, where he described what we call nowadays, and we face those, the safe entry zones. We did work on that a long time ago, but then we never published that work. But then we have, especially the publications of Professor Rotten, where he and his group could show us this deep anatomy. So in a brief, if you can divide by the median sulcus, you have the pontine, the medullary, and the intermediary zone marked by the very well identifiable acoustic, or what we call the medullary stria nowadays. Then you have the limiting sulcus that divides the motor from the lateral, more sensitive portions. Within this area, within the limiting sulcus, you have the superior and the inferior fovea that you can identify. And very high up, you can see a different color, that is the locus coeruleus. Just above the medullary stria, we have an eminence that we call the facial eminence or the facial colliculus, that, as you know, actually this is not really related to the facial, although the facial is turning around, but the eminence itself is the nuclei of the sixth nerve. I'm going to skip a little bit of this anatomy, but just in the inferior triangle, we have the hypoglossal and the vagus triangle. And then here you can see the sixth nerve nuclei, the seventh nerve nuclei, the turning of the knee of the seventh nerve nuclei, and also the contribution with the superior lacrimal. This is the intermediate portion of the seventh nerve. Now the sixth nerve, it's lateral to the medial longitudinal fascicle, and it's medial to what we call the central tegmental tract. Here again, you can see the hypoglossal, the vagus. This is the locus coeruleus, the intermediate fibers of the locus coeruleus, and this you can see then the inferior fovea the superior fovea that will be related especially to the five nerve. All of this anatomy, it's very complicated anatomy. Of course, we don't have time to speak all of this on this short lecture. I don't want to take that long with you guys. But this is the medial longitudinal fascicle that integrate all the motor nuclei. And all of this, we had the opportunity to publish in this atlas. So let's see now our case. We favor to go through the median, inferior median craniotomy. So we're going through the floor of the fourth ventricle. We respect the arachnoid because at the end we try to close the arachnoid. We know that this will avoid the tension and the adhesion of the brain with the dura. We split the vermian notch. Now you can see the obex, you can see the margin di foramen and the obex. So we're starting the lower portion, the medullary portion of the fourth ventricle. Then we are splitting the fissure, the posterolateral fissure between the uvula and the tonsil. We follow it all the way up. We go all the way towards what we call the choroidal point of the pica. We mobilize the pica. Once you free, you're going to be able then to place a retractor. I would favor the same sitting or the sitting position, but in this case, we couldn't do that. Now we place there the medullary striatum. So now we know that we are in the transition of the inferior half and the upper half of the fourth ventricle. And this is the most reliable landmark that we have, at least for me. Then you can see also the midline, and then you can trace where you have the limiting sulcus. Once again, you keep splitting that fissure all the way up. We are seeing the midline and the stria on both sides, the medullary stria on both sides. We can start to see now. We were lucky that our lesion came to the surface. Now that we free completely, we can place the spatula. This is a cavernoma. So first we drainage the hematome. Then now we careful with contrasection, retraction, of course. We go around. Important thing is try to identify the live portion of the cavernoma. So with gently counter retraction, we go around. We're going to see the drainage vein. As you know, you do have to preserve because that is normal vein. So we slowly go around the lesion. And then now we start to identify the live cavernoma, the grape-like appearance. If you don't remove that, you can have recurrence of the bleeding, right? See that there is a minimum of coagulation only when you see the grape-like sphincter. Once you remove the hematome, you do have to check the cavity. And then now you have to coagulate the little portion with very low power. Here you can see the DVA, the venous. And then by the end, we fill the cavity with the hemostat. And then we reattach or we close the arachnoid plane. As you can see here, you reattach the arachnoid plane. This will avoid the dural attachment. Now notice here the post-op, but what I want to show you is see the minimal manipulation of the tonsils, the respect to the brain tissue itself. This is the patient in the early post-operative. She did have a minimal gaze but then this is 3 months later. And you can see that she's almost back to normal. So in conclusion, we do have to take our microanatomy knowledge towards the microsurgical technique. Neuromonitoring is essential. You notice that we didn't have that. Sometimes we don't have that, but in any ways, we try to do our best. And sometimes endoscopy and intraoperative images are also very important in this kind of tumor. So I thank you very much for the opportunity. Thank you, Sam, and again, I congratulate you for all your efforts.
Thank you, Paulo, for this excellent presentation and for emphasizes about the importance of neuroanatomy to gain full success. Thank you. Is there any question? Thank you, Paulo, again. And now we will shift to next speaker, Professor George Moura. Please start sharing your screen.
Hello, for good morning or good night, good afternoon. It depends of who is listening. Thank you very much for the invitation. Can you hear me good? Nice?
Yes, yes, all are good.
Excellent, excellent. Today we are going to share with you as short as possible our experience in a little bit different way to do cavernous sinus surgery that we are developing for the last 10 years. And I share with you a little about history. And I want to give the proper acknowledgement to the people that, of course, developed this. For me, it's an honor to talk in between Brazilian colleagues, because most of my experience is after follow Brazilian neurosurgery. And I'm very proud to be the first international member of the Brazilian Society of Neurosurgery. The first thing I always do in all my presentations is acknowledge the influence that Dr. Evandro de Oliveira had with me. I made a fellowship with him in 1998, very long time ago. In that time, Dr. Evandro had the same age that I have today, 53. And I was so impressed when I knew him in 1996. I knew him in Chile. About his philosophy, his knowledge, and all the charisma that he can show for all of us. And he unfortunately left us in 2021 after a terrible disease. And recently, I made the same lecture went to the laboratory where he worked, and he called me an Evandro boy because I didn't went to Roton, and I always regret that. But I can unfortunately went to Roton to make a fellowship in neuroanatomy. But he said, Jorge, you are not a Roton boy, but you are an Evandro boy. I'm very grateful for two of my main teachers, Elder Tedeschi, excellent microsurgeon who worked with Dr. Evandro in that time, and Wen Hung Zhu. Now he's the president of the Roton Society, and he teach me a lot about neuroanatomy. He already gave me his dissection in 1998, and in this dissection you can see all the principles of the cavernous sinus surgery and transcavernous sinus surgery. Is the subject that we will talk a little bit today. We published this in 2021. We named Mi Plata. Mi Plata in Spanish means my money in English. Is acronym of the way that we see the transcavernous root. We see the transcavernous root using the lateral wall instead of Professor Dolenz that he used the roof of the cavernous sinus. All this work was developed for one of my fellows, Rafael Martinez Perez. He works in the United States now, and he talked to me about that we can develop using a less invasive approach that we already use since 2015, the mini-pterional approach. We can develop the use of the extradural corridor combined with the mini-pterional and develop a new concept that will be published this month. That is the mini-pretemporal approach. I show you why we call mini-pretemporal approach. Okay. This is the first publication that will be done about this. The mini-pretemporal will publish this month in operative neurosurgery. If you see now the mini-pterional publications, you can see that we now up to date is 99 results. The last publication is mine about bypass that I did in a child with using a mini-pterional, because mini-pterional is so versatile approach. You can do all the kind of surgeries using this, and you can see there that the mini-pretemporal today I made this screenshot from the today PubMed is 0, but will be 1. And in a short time, we will have more. If you see mini-pterional, it's not a fashion. It's about a kind of approach that was developed recently, 2007. The first name was put for a Brazilian neurosurgeon as well, Verbal Gadelha Figueiredo. And you see that in 2020, the more publications of mini-pterional were developed, because in that time, we described the extradural mini-pterional approach. That is the variation of the Hakuba approach. And the best things are always done for the fellows, and this is the levels that we try to teach to them. The level 1 is the extradural mini-pterional. The level 2 is the Mi Plata basic, that is mainly for small tumor, pituitary tumors, and tuberculum cella tumors. And the third level is the transcavernous root that we use for posterior fossa, for meningiomas, for vascular lesions, or for a giant epidermal cyst. The good thing about the Mi Plata, you can combine with endoscopy using both techniques. It's very interesting. And now we are trying to develop with, of course, Brazilian colleagues too, the transorbital Mi Plata. The combination between these principles with transorbital endoscopic approach, that is now a very good approach, less invasive, that you can take out incredible lesions. But still today, the transcavernous root is not perfect for that kind of approaches, because I think the management of the cranial nerves is difficult. We will publish these principles in 2023 with Arnaud Benet, a neurosurgeon who was from Phoenix, Arizona, from the Barrow Neurological Institute. We published these videos, and we show the principles, the You can see there the Hakuba method for the transcavernous dissection, the transtentorial use combined with Kawase partial petrosectomy. I prefer to use the complete anterior petrous remotion in order to have a transposition of the fifth nerve. That is the key for the transcavernous route. This is the QR code that you can take the videos from the internet, from operative neurosurgery, master series. And this is the levels that I show you, but now more refined for Arnau Benet. And the basic miplata is the mini-terional extradural approach. The real miplata is the miplata extend, and the last version, the miplata full, is when you combine with lesions in the posterior fossa and you use endoscopy. Of course, you need monitoring in all of them, but it's mandatory to have an intraoperative monitoring in the last two versions, the real miplata surgery, because we can drill the internal auditory meatus and reach up to the foramen magnum, foramen jugular of the patient using endoscopy. It's very interesting what we can achieving now with the new technologies association. But everything was described in 1982, a long time ago, for Professor Hakuba from Japan, the lateral dissection of the wall of the cavernous sinus, the opening of the Parkinson triangle, the extradural anterior craniodectomy, and even the transpetrosal approach before the authors that were called that approach was of them. Now everybody call, for example, the peeling of the middle fossa for anterior to posterior, the Dolenz-Hakuba approach. When I was in my fellowship, everybody only recognized and acknowledged Professor Dolenz, but now everybody knows that it's a technique that they describe at the same time in different journals. Hakuba in the Neurología Médico-Quirúrgica and Dolenz in the Journal of Neurosurgery. And this is the miplata. It's a same way in a small kind of view, that the same anatomy. This is a section for Maxi Núñez, a very good friend from Argentina. You can see this, the mini pretemporal craniotomy. What's the mini pretemporal craniotomy? I'll show you in a couple of minutes. And we have this kind of view. What we can tell here is the frontal lobe exposure is almost nothing, and the temporal lobe is complete. And we have half of our surgery is using the extradural route. That's why we don't need retractors. That's why we don't need take out the orbital rim or the zygoma. The orbitozygomatic approach we don't use in any patient of this series. And the other thing is the management of the nerves, mainly the glamour nerve, the fashion nerve. What is that one? The fourth nerve. Because the fourth nerve is tiny and is a little bit hard to dissect if you don't have the proper neuroanatomical knowledge. The third nerve, everybody knows how to release, because it's the classic releasing from Professor Dolenz and the followers of his philosophy, mainly the masters Ali Krish and Professor Evandro, of course. And the lateral view requires the freed of the fifth nerve that you can achieve partially with the Kawase approach. You need more. And the most difficult nerve is the fourth, but the fourth you can get the proper releasing using the Coimbra philosophy. Another Brazilian, Professor Coimbra, made a splitting of the tentorium, and that's the key to free the fourth nerve, because you can go, like Ali Krish said, from normal to normal in any pathology. And then it's very important to have that philosophy I show you later. And this is the view that you can achieve. This is actual dissection for Maxi. After take out the dura, you can reach the posterior fossa. After you open the sellar region, you can see all the perforators, the Gruber ligament, the sixth nerve. The sixth nerve is a tricky nerve, but you can find with this kind of knowledge of the cavernous sinus, you can go through the sella to the opposite side. And this is actual see in a patient. We have now 103 in between extended and full miplata. And the last one in October 24th. And this is a craniopharyngioma operated before for another surgeon. You can see here the carotid, the anterior cerebral artery, the middle cerebral artery. You can split the Sylvian fissure, the basilar artery in the middle portion. You can see, of course, the basilar tip. This is anterior choroidal, the third nerve release, the fourth nerve release, the posterior vein of the carotid artery, the opening of the Meckel's cave. In this case, in the craniopharyngiomas, Seldom I use the Kawase technique or petrosal apicectomy. Most of the time you don't need that because the caudal extension is above the internal auditory canal in most of the cases. If you associate the endoscopy, you can see up to the foramen magnum, but you need instrumentation, but only you need to see. You need to do something with what you see. And then the philosophy is the mini pretemporal, published for Rafa in this or the next month. Is 1/3 is frontal and 2/3, okay, are temporal. That's the difference. That's the difference because we use the extradural corridor using the lateral wall of the cavernous sinus. That's why in the mini pretemporal you don't need to split the sylvian fissure unless the pathology make you open the sylvian fissure. In the technique you can go below the temporal lobe, below, protected for the dura mater. Okay, this is a verbal on my right side, and Professor Natal, who made the first description of Mediterranean in 2005, but was we used the verbal description because for us the reconstruction is very important, and we use the interfacial dissection that I learned with Dr. Evandro. Verbal was his resident, and in this kind of patient, you need the temporal fascia pediculated in order to reconstruct. This technique is very important because the opening of the dura mater, like Ari Krish, is in the front. And then if you go above and in the front, the opening of the dura mater, when you're going to close, you have nothing to close. That's why if you, for example, do an orbitozygomatic and you violate the periorbita and you have the fat going outside, it's very difficult because you need to put a lot of stitches in order to control this. And then that's why we left the bone and we were not use orbitozygomatic because the extradural corridor give you what you need. This is for me to, I want to show you proudly this Radovanovich. He's a very good neurosurgeon for Canada, for Toronto Western, and he talked about the two directions that the minimal invasive philosophy is going. One is the size of the craniotomy, and the left side of this slide, you can see the re-expansion of the skull bases. That's very important concept, re-expansion, because we are using the extradural corridor more efficiently. And he showed this transterional endoscopic because I love the transorbital route. And you can see here the philosophy that can be used, for example, in terional or mid-terional, you can go for the orbit, okay? And you can clip MCA aneurysm, for example. This is not my work, it's a work of a colleague that but he showed that the reference that he used for the skull base is the extradural mid-terional approach that we described with the verbal, with the Kiko from Spain, with the Rafa, of course. And for me, I'm very proud that always be related to the Brazilian neurosurgery. And we did the same classic surgery for 15 years. Since I arrived from Dr. Evandro until 2014, I did the Tollens or Hakuba approach. Okay, the same classic surgery. Classic is not obsolete, but for me, I try to find another way, a little bit different, less invasive. I respect completely the people who do the classic way because the classic way is certain and is proved. But when you go to do less invasive approaches, you need to prove that it's good, as good as the classic without the complications and with all the advantages. Okay, and we developed this concept named key exposure. I will explain you now. This is a combination between the classic and the keyhole. The keyhole is only about the size of the craniotomy because you use endoscopy. But if you combine the extradural corridor with the keyhole concept, you have a key exposure because the craniotomy, the philosophy is do the craniotomy that you need, not the craniotomy that were described for a pathology. You need to be versatile. You need to do tailored approach for each patient. I can do all the approaches since orbitozygomatic, transzygomatic, terional, extended subfrontal, interhemispheric, transbasal, with orbit, without orbit, everything. But I think that if the patient needs less outside, you can consume all your time of the surgery in the bottom of the surgery. And the bottom of the surgery is, of course, the transcavernous route. This is the figure that Rafa made for his publication. And you see that he understands much better than I how is the combination of the extradural corridor concept and the key exposure. We publish, of course, all of this in paraclinal aneurysms. We did the same for sphenopetroclival meningiomas. Our series of sphenopetroclival meningioma is the largest published. We have 70 cases of sphenopetroclival meningiomas. Some people call posterior clinoidal meningiomas. Some people call caverno-tentorial meningiomas. But the thing about this is the combination of a meningioma of the cavernous sinus, petroclival, tentorial, and lateral wall, and clinoidal sometimes. And then it's very complex pathology. But if you see at the pathology based in neuroanatomy, you can divide the pathology and treat terrible tumors. The other thing is develop of instruments. I developed these rongers with Takayama instruments because I believe in the no-drill technique for anterior and posterior cranioidectomy. You can take both clinoidal process without drilling. And then not all the cases, of course, I never deal in absolutes. I think that sometimes you need to drill, you need to use the drill. I can do a subdural cranioidectomy as well, intradural. I can do both, but I think the no drill technique is safe. Most important is reproducible for the young neurosurgeons. All these concepts that we use in the cavernous sinus were developed for William Caldwell. He made this publication with James Liu, a good friend. And the good thing about this paper, not only the anatomy, he described the names, Dollens, Kakuba, Kawase. For me, it's very important the people who acknowledge what the people that came before us to do the surgery that we developed. And this is the extradural mini-pterional pretemporal, but the real name is mini pretemporal. But in that time, we didn't know. Okay, you see, I put in the blue block that mini pretemporal approach. Now we finally can publish with the paper for Rafa, the more fair thing, because he was the one who worked in this since he started the fellowship with me. And this is the typical example of this kind of meningiomas. It's a meningioma. If you see the left, you can see, and you can believe this is a CP angle meningioma. If you see the middle, you say, okay, it's the lateral wall. Okay, it's a petroclival ossification, the tentorium. Okay, in the right side, compromise of the orbit, like Carlos Eduardo showed, that it's very difficult. The cella as well. You see, it's a very complicated case. But this is the actual patient. The first thing is this is a mini pretemporal craniotomy. That's why the mini pretemporal is not a keyhole. Of course, I agree. It's not 2.5 centimeters. The venous drainage is not a problem. You can see there the sclerosis of the superficial sylvian vein, and how we open in the bottom the dura and start of course we did a peeling, but this combination between the dissection of the nerve from normal to normal, Ali Chris said, with the resection of the tumors. You use the tumor as the corridor. We are taking out here the exophytic portion. After that, we take with the rongers the tentorium, and we can, of course, after that, cutting the tentorium that was very, very, very big, and in order to expose the fifth nerve, and finally we have the carotid, the third, the fourth, the basilar, the fifth nerve, and the petrous apex. Why I show you this? Because this is a mini pterional craniotomy. I use only the retractor to show to you no exposure of the frontal lobe, using the extradural corridor, and you can achieve a very good resection. Of course, not complete, but it's very well tolerated for the patient because you decompress the brain stem and you decompress the optic nerve, the oculomotor nerve, sorry, and the optic. And the trigeminal nerve is completely decompressed because most of these patients have trigeminal neuralgia. And then if you go after that with I said to Professor Tatajiba, another Brazilian, Professor Tatajiba operate the same philosophy, but 180 degrees opposite. He went for the posterior fossa, and after that he take the middle fossa. I said to him, I prefer go to middle fossa, and after that I go for a simple retrosigmoid approach. We can take all the tumor out. Look at the CT, only a small change in the temporal lobe. The MRI, the control MRI, we have, of course, a remnant in the posterior fossa related to the interior anterior meatus. And I want to show you just the last video, because in this video, you see here the temporal lobe, here the cerebellum, the facial nerve, a small remnant of the tumor in the petrous bone, and the decompression of the lower cranial nerves, the sixth nerve, everything. This is a very old case, one of my first cases, because now I follow the philosophy of Almefti, of course, and I drill everything. I drill anterior meatus, I drill all that I can in order to have better resection of the patient. But today in the 21st century, you need a functional neurosurgery. What is functional neurosurgery? It's a good resection, but with good function result for the patient, okay? Because most of these patients that I see now, were sent to radiosurgery or made very small resections following for radiosurgery. For me, make no sense. I follow the concept of Professor Almefti, try to take out everything. Okay, I'm not always can achieve that, but I try. And always taking into account the resection and the good thing. Why I do the second portion of the surgery, retrosigmoid? You can see here the 6. And then what I did in this way, because if you go for the posterior fossa and you have a huge tumor, you need to deal with a hypertensive posterior fossa, with the compression of the brainstem, and the worst thing, you need to deal with the fascial, with the lower cranial nerves, a lot of morbidity nerves. If you go first for the middle fossa, the only thing you need to be concerned is the oculomotility and the trigeminal. But all of the rest of the nerves will be decompressed. I used to do, of course, for 15 years, one stage surgery. I check everything in one stage, but the patient not tolerate so well. For me, in this case, we create a very good relation with the patient. The patient tolerate very well the middle fossa, and to finish the patient in the second stage is much easy because everything is much more decompressed. You can see the space here. This is the MRI, only a thick dura in the clivus. Why? Because you need to preserve the Dorello canal. If you take all that tumor, the best way, of course, and Daniel will talk later than me, is the transsphenoidal extended approach. For me, the 6th nerve, the decompression is much better for anterior. I don't do that. A colleague of mine, of course, studied with Daniel Prevedelo, Christian Naudi made that decompression for external endonasal, because they can see much better the 6th nerve. You need to combine. You don't need to fight. This is the patient. I take the picture with her authorization. I'm very proud because the result was so good, and the facial nerve only mild palsy. But you need to publish this, okay? And you need to prove. This is an actual surgery. This is the only video that I will show to you. This is a mini. When you start, it's a mini terional, but when the surgery progress, you expose more the temporal lobe. What I did is I said to my fellows, open the sylvian fissure in the distal portion. After that, we leave the dura over the brain, but we don't need, with that kind of maneuver, we don't need the lumbar drain, because sometimes the lumbar drain is working. You can see here the special rangers. This peeling is made for my fellow. Okay, we take the anterior clinoid. You can see here using rangers. The good thing about the peeling is you can expose the tip of the clinoid. When you expose the tip of the clinoid, it's much easier to take it out. Even it's ossified like this case because of the tumor. Look at this. And after that, my fellow complete the peeling, the middle fossa peeling. I'm left-handed. That's why you can see this, not mine operating. It's a right-handed surgeon who is my fellow. And now you can use the classic fashion. And of course, exposing the B1, B2, B3, the GSPN, everything. After you always need to use very soft coagulation. This is the Kawase triangle. And after that, my fellow complete the opening of the dura in the bottom, like Ali Krish. And then we expose the carotid, the 3rd nerve. You will see here, he's still working. Now I am working. I'm left-handed. And I take, the exophytic portion of the tumor, the same thing that I showed you in the classic case 10 years ago. And after that, you can, without the use of too much retraction, this is a no retractor technique, because you relax the brain with the maneuver that I showed you. We go from normal to normal. This is the 3rd nerve, okay? This is the 3rd nerve, cisterna 3rd nerve. I follow the principle of Dr. Evandro. I open the 3rd nerve, and you can see the compression of the 3rd nerve that having the roof of the cavernous sinus. After that, I take the rest of the exophytic portion of the tumor, and you can know that the 4th nerve is intratentorial. And then what we do is trying to find the 4th nerve in the cistern. We found the 4th nerve there. And then you see then the 4th nerve in the cisternal portion. we go to the cavernous sinus, and we go from normal to normal. You can follow the fourth nerve. I think personally is much better from the cavernous sinus to the cistern. It's different to the third because the fourth is tiny and small. And now we can release the fourth nerve. Remember that the fourth nerve is inside the tentorium, and then you need to split the tentorium to properly expose. You need to be patient to expose the fourth nerve, and we follow the fourth nerve in this case and free using always try to use sharp, not pulling the fourth nerve, because you're going to cut it. You see, you just use to dissect, but after that you use the scissors and try to use knife blade and try to expose properly. Here we are mobilizing the fourth nerve. I will show you in a couple of seconds that it's very important to make the Parkinson triangle bigger, because we need that in order to achieve a very good resection of the portion related to the posterior bend of the carotid artery. Another reason why I don't want to go so down for the medial fossa is the preservation of the sixth nerve. The sixth nerve, unless you can see the sixth nerve in meningiomas, is very difficult. In non-meningiomatic pathology, it's easy to see the sixth nerve, but in meningiomas, when the meningioma is hard, it's very difficult to find the sixth nerve. When meningioma is soft, it's possible to find the sixth nerve. After that, you free the trigeminal nerve. It's very important for the trigeminal neuralgia. You need to remember that in between the fifth and the fourth, there's nothing. There's nothing there. Only the anterior part is the carotid and the sixth. But if you don't vulnerate the petrous apex and the Gruber ligament, you can take all that portion of the tumor without any trouble. You see here, we are taking out the tumor. Now you achieve the posterior fossa of the patient. You can see the basilar artery, for example. There is the basilar in the middle portion. And after that, we're finishing taking out the tumor that is related with the petrous apex. In this case, we don't take the petrous apex because we don't need it, and you can get proper decompression. That is the normal tentorium, proper decompression of the fifth nerve, the fourth nerve, the third nerve, and the brain stem. You see, of course, in this case, for me, it's not possible. There are surgeons who can take the intracavernous portion like Ali Krish. I rather prefer to leave that. I'm not irradiating the patient. I just follow and see what happened. And if we can see a second look, this is the closure that I told you with the pediculate fascia of the temporal muscle that is very good for reconstruction. This is published, our clinical results we published. Of course, Rafa did that in the two-stage surgery that I already showed you that got very good results. But this is nothing new. This is from Brazil. Dr. Evando published in 1995 with Mario Siqueira, the classical paper. Sorry, and this paper is a paper that Eduardo Sebane for Argentina, a very good friend, published with all the group, Elder, Wen, and Professor Evandro. And in the bottom, I just show you to see a couple of seconds. This is the classic videos from 1997 for Dr. Evandro, that he showed all the things that I show you today, the difference level. This is first he showed a paraclinoid aneurysm, after that a transcavernous route for basilar tip aneurysm, that the neck is below the dorsum sella, lower line aneurysms, and the concepts are very similar. But you can see here that he used in that time much more the Dolenz philosophy, using a combined cranioidectomy. And what I try to show you today is the Hakuba is more extradural philosophy, more Japanese. And of course, the Americans use more the intradural because of Charles Drake. It's a matter about history. And this paper is very recent, 2020, the same philosophy from of course, this is a people from Roton, Vincent Killis, and Sanford Su, the president of the just the last week in Taiwan, that just arrived to Santiago yesterday. And he showed very similar philosophy, the same thing, almost the same dissection, but using the classic approach, orbitozygomatic. Our philosophy is a little bit different. And this is the history of this kind of approaches. And the biggest series is 2026, from 2014, about this level 1 to 4 pathology, and I review our numbers, and if we combine the zone 1 to zone 4, we have 293 patients, almost 300. Only in transcavernous, in cavernous sinus meningioma, we have more than 100. In other pathologies, we have more. Paraclinoid, we have more than 450 aneurysms up to date. And the other thing is very important is to share with you the concept that the endoscopy can be combined with transcranial route, and even can combine at the same time. This is a patient that we operate at the same time, endoscopy, transnasal, transcranial, because was a terrible pituitary adenoma, and we can take all the tumor using this preservation of the cranial nerves. And now we are combining the microscope with the endoscope using robotic arm in order to use the cavernous route to the entry zone for the posterior fossa, like the cera is used, for example, for the transcavernous route in the transsphenoidal approach. The same thing, this is what happened with the epidermoid cysts, the combination with endoscopy. And why I show you this, because this is a fellow of mine that recently finished, and she made arranged these cases of giant epidermoid cysts, and we proved that we have more than 95% of resection combining mi-plata and endoscopy. And we can even see, in this case, you can see in epidermoid cyst, if you combine with endoscopy, you can see the foramen magnum. And then the instrumentation is very important, and that's why we need this robotic arm, because we cannot move too much, because we have the 5th nerve, the 4th nerve, and the 3rd nerve in the side of our endoscopy. And then it's very important not to make any lesion of the nerves in order to reach the posterior fossa. And you use, I'm going to finish with this, you can use this same philosophy for vascular pathology in the paracranial region, in the cavernous region, in the posterior fossa. We are using this this is a video I cannot show you for a matter of time, but we did using the mini pretemporal, we can do a bypass, we can do a trapping, and we can treat a giant paraclinoid aneurysm, because we use the extradural corridor. You don't need to open too much the brain, because you don't need for this kind of pathology. Of course, you need for AVM and gliomas, but we're not talking about that. We are talking about the skull base. And we can treat, of course, lesions of the posterior fossa. This is a failed endovascular treatment that we went from the BB junction to the basilar tip using middle fossa. Okay, and only to show you that these clips were put in the BB junction of the patient, because in this case I use a complete drill of the petrous apex, a mobilization of the 1st nerve, and I can preserve in this case the basilar tip. Here you can see the flow diverter, and I decompress the brainstem in this patient. We published this, of course. We will show this in the new book of the World Federation of Neurosurgical Societies that published this year about these techniques. And thank you to my fellows. They made me better. They give all the good ideas to me. Now we have 59. And I'm very proud, because in 2020 I was appointed as Master of the Children Neurosurgery, the only one in the 21st century, and the only one alive. Thank you for your attention, and any question I can answer. Thank you.
Thank you, Dr. Bo, for this excellent presentation. Is there any question? Thank you. And now we will shift to next speaker, Professor Ahmed Kanaan. Please start sharing your screen.
Good afternoon, Dr. Professor Sameh. Thanks for the great arrangements and coping with our schedule, as we were all, many of us, in Taiwan. It's 11:15 now p.m. Do you hear me, and do you see my slide?
Yes, sir.
Okay. My talks will be on management of giant epidermoid inclusion disease and the role of endoscopy, we said, revisited because endoscope has been a major contribution to manage these cases. This is the King Faisal Hospital that where I'm working out for the last more than 35 years. I hope you sometimes will come and visit. For the young generations, this is the direct talk for them, and I have to tell that classify the inclusion disease into 3 categories. If it's 1 layer, it's the epidermoid, 2 layers is the dermoid and lipoma. And 2 layers is the teratoid. Teratoma is the all germinal cells, and embryonoma is inclusion of twins, cytos inversus. This is how they looks like in the operative field on the right side. This is the pearls from the jewelry, and Dandy describe it as the most beautiful tumor of the body, and Cuvillier, the anatomist, he described that Beverly tumor in 1829. There are reports on cats, dogs, and other animals. They are rare lesions. 90% are intradural, and it represents 2 to almost 1% of all intracranial cavity. The embryogenesis of the epidermoid is a contamination of the ectoderm during the development, 3rd to 5 weeks of fetal development, while developing the neural tube. But we have also the same situation at the level of the otic vesicles and optic vesicles, and that's why we got the anterior or anterolateral epidermoid and suprasellar epidermoid and intraorbital epidermoid, as well as the CP angle region epidermoid related to the otic vesicle development and contamination of some of these ectodermal cells during invagination. The location, I put this analysis from 2 different sites and different time. Mahoney, 1936, put this location, and Maria Malhard, working closely with our friend, Professor Stefan Florian from Romania, just last year. You see they are almost identical. CP angle is almost 40%. The location site, pituitary area or pituitary region, 30%. And 4th ventricle here, they put it as rhomboid fossa. It comes about between 11 and 18%. Of course, there are reported cases on the spine and the diploia and other areas. Clinical presentation match and corresponds to the location. So the most common presentation is CP angle, lesion is ataxia, nystagmus, and of course, cranial nerve deficits represented mainly by the trigeminal neuralgia. And I have patients 3 months ago. He went to the dentist and he extracted 5 teeth from the upper jaw because he was having severe toothache. And finally, somebody drew the attention to do the MRI and showed a giant epidermoid in the CP angle extending up to the microscope. Pericellular region and pituitary region show, of course, visual deficits, different format, whether it's a bitemporal or homonymous hemianopia, can be occur and endocrine disturbance. And there are general features that can lead to symptoms like a seizure and the reaction to the cholesterol crystals in the epidermoid can cause chemical meningitis called molar chemical meningitis. And we can get adhesion due to these crystals and get hydrocephalus as a clinical presentation within the triad, headache, vomiting, and nausea. Headache is the most common among them. This is the MRI studies of epidermoid. In the old days, we used to confuse it with butterfly glioma, especially at the time of a CT scan. But MRI has identified the lesions. They are usually hyperintense on T1 weighted images. If they demonstrate some bleeding or high protein content, they might give a whiter signal on T1 weighted images, and this is where the description given tag it as white epidermoid cyst. On But the most important studies from all this is that you see the T1, T2, and the one on the right side is diffusion images. And this is the vital study to be done. I won't accept any comparative study about complete resection without having this one post-op. Anybody tell me that he has taken this completely out and with no symptoms, I'd like to see these images, the diffusion. And you will see with even the intention you felt that you take it complete, there might be speckles of remnant cholesterol crystal at the side or inside the vein, just subcapsular. So be careful with making comparative studies because most of the previous studies were based on MRI, T1, T2, and CT scan. These are not adequate for comparison. These are different location. This is, you see, it pushed the brainstem posterior. It went to the subtemporal area. And the tumor or this epidermoid, they are creeping tumors. They grow slowly around the vessels network. We used to call these vessels within the lesion and the cranial nerve the hanging vessels description. And these are giant one. They can reach big size because they follow the flow of all the compartment CSF systems. And that's why you can have an extensive lesion before it represents with clinical symptoms. In the old days, we used to do a PET scan on several lesions, and this is one of them done on PET just to show it for historical reason that they are not active metabolically. This is how it looks like on the pathology report. Wall of the epidermoid consists of a layer of stratified squamous epithelium surrounded by a thin layer of connective tissue. And this is contain less structureless waxy keratin material came from the disquamated epidermal cells, debris, and cholesterol crystal. Management, either you go for a simple microsurgical approaches, or you can do the solo or hybrid microsurgical endoscopic approach removal. I prefer the hybrid as you use the microscope as a microsurgical technique and the endoscope under microsurgical technique to have an extended visual arm to tackle corners without making a big approaches and complex approaches unnecessarily for this disease that is usually avascular and manageable and has a good outcome, long survival, years outcome, even with incomplete, at least 8 to 10 years. And you can always go back and operate on them if needed. But intention should be a gross total resection from the start and no place for radiation or any other alternative treatment. In recent years, there are some papers on some kind of oncological medication. It's under investigation. Retrosigmoid is the most powerhouse for the posterior fossa, and of course, subfrontal or arteriovenous approach is the most common for anterolateral things. Transpetrosal surgery has been used frequently for lesion within the pituitary fossa. These are the characteristics of epidermoid. Keep it in mind. It's the mother of appearance is a creeping, flowing tumor-like lesions, occupied multiple compartments, surrounded vessels and nerve, as I said, restricted on diffusion, do not suppress on flare, do not enhance post-contrast, and calcification is extremely rare. Definitive treatment is the complete surgical resection. This is a few examples of that case I showed you at the beginning. Midline lesion, mimic butterfly glioma, and you see this is a T1, is hyperintense, T2, and this is the diffusion. You see how extensive is the lesion. It's much bigger than what you see on the first one on MRI T1. And, sorry. And I thought I removed it completely, but after the MRI, you see this, the position of speckles of lesion is with not even seen here from outside, is with under the capsule toward the brain. So these are residual lesions that you can live with it, and I don't jump and go into attempt to remove them because it means I will enter the brain unnecessarily And if they showed growth, and most of them, they get their recurrence in 30%, then we go back if it's needed. And usually they manage with this up to 10 years without any major recurrence. It's another lesion, complete resection. See how it looks like. Again, thought completely removed. There is spicules within the capsule on this side. We always say you have to remove the capsule. It's easy said, difficult to practice, because sometimes the long-standing lesion and increment in the size, in case the vessel, it can infiltrate the surface of the brain, or it can hide, penetrate and hide under the layer around the lesion. And you don't want to cause ischemia of the brainstem specifically, and get a lesion which is a benign, can survive many years with less difficult, and get a hemiplegia or hemiparesis because of partial infarction of the brainstem. So be aware of this. Let me show if I can show this video. This 15 years old female, medically free, present with left facial nerve weakness. And this is the T2 weighted images. This compare diffusion. I did simple left restomastoid. This is complemented with endoscopic assisted tumor visualization. I opened the cistern at the beginning, like described by SFG, at the base, in the posterior fossa. I'm doing this in the lateral position, but I apply the rule of sitting position by elevating the trunk and make a rotation of the head necessary. This is the cistern, and then I will open a stern with a small needle or bended needle. It's the simplest instrument that you can do this arachnoidotomy. My concern, this is not edited video, that's why it's too long. And my concern, whenever I try to forward, it will freeze, and then I have to start again. But since I've seen all the previous presentations, they took their time with their videos. I want to show the young residents this video because it has some value. This is the opening of the dura that it shows, again, the system. And now, you see, there is the posterior wall of the porous acoustical where the lesion has gone in. You see where the lesion is under the arachnoid. I have to drill it, the roof of it, so I give space for that. It take a few minutes. Let me see if I can advance. I'll go to the other part. So now we are peeling the arachnoid, and we are trying to take the lesion, peeling the arachnoid toward the brain or toward the cerebellum. This is how it looks like under the microscope. And then see how they attach to the vessel. Then I used the two forceps technique described by Professor Majid Sami to mobilize all this. If you move the arachnoid, you see how the veins and vessels get away. So don't rush and put your coagulation on these things because you don't need to. This lesion should be taken out without any coagulation of any of the vessel or heat effect on the cranial nerve surrounding this area. My instrument for this procedure, usually the two forceps, ball dissectors, and the suction. A lot of irrigation always there. See, I'm holding the forceps, peeling the arachnoid, and I'll take it fragmented piece by piece. I call it the chopsticks technique because this is how it is. See how the vessel, you just peel, but not pull. Pull on the lesion, but peel the normal tissue. Again, arachnoid is your friend. So don't rush to coagulate and just give time to mobilize. Even these small perforator, they mobilized nicely with this technique. Once you empty good space, then that space becomes an additional convenient space for you to use the instrument. And you can dislocate the tumor into this cavity you are initiating rather than to retract. Always make use of the space you have decompressed and bring the tumor off the brain, not the brain off the tumor. Still some lesion on the trigeminal nerve. And you see the brainstem nicely pulsating. I think I'll move to the next slide for the sake. Let me see which one is this one. This is an interesting case of an occipital transorbital approach for a lesion, very giant. I sent this picture of this 39 years old female who has a shunt about 20 years ago after a trauma. She came with this lesion. You see how sizable, going everywhere, reaching the floor of the third ventricle. I will show these images later. See how extensive. And I asked the three famous neurosurgeons worldwide how they would approach it. I have something in mind. One gave me an anterior through the temporal horn, one gave me through the trigone, but I elected to go occipital transtentorial from the left side and use the endoscope. And it was, I think, a right decision. It gave me access to all the lesion in all these aspects from a single approach. I was happy because I was planning if I failed to do different multiple approaches. We put the position in lateral typical Haussmann position. The dependent side is the lesion side. So the left side is down. So we make use of the gravity in that one. And we make the gynotomy just at the edge of the sinuses. And this is the navigation during the procedure. After removing the bulk of the tumor, that video was not edited, and I am in the cavity. I made a flap of the falx, lifted with the stitch, occipital lobe on the side, and again, I'm navigating to go to the extremely lateral side, and now in the cavity of the resection. This is the cavity of resection. I said, you make use of it. And this is the posterior thalami on both sides, posterior third ventricle. And you see lesion under the occipital lobe on the side. And this on the medial side was extremely on the other side. So I resected the part. And from here, I could retrieve this lesion because I saw it under the endoscopy. This is the value of endoscope to make a thorough, complete resection under visualization. Let me see if I can come to the. So the outcome patient tolerate the procedure very well. I'm showing you now on the left side the pre-op and the right side the post-op. And you see how far the lesion went down. You see, I'm moving this edited by my resident, and you see the lesion. The bulk of the lesion is gone, and from down all the way up to the penile region. So I put two studies to evaluate the outcome. In the old publication, I forget from where I got it, but I think it was almost 15 years ago. That's why I don't have the record of that. But complete excision was achieved in 60 to 70%. But this is the time there was no MRI. I don't know how the decision was made, I think, on in situ observation of the surgeon, and you don't know how much biased opinion on that one. Recurrence-free survival was 13 years and 95%, but recurrence 8 years post subtotal excision was 30%. Recurrence-free survival at 13 was 65. He gives two reports. And surgical mortality 70% in 1936, 10% in 77. And if you go now, the latest publication is a retrograde retrospective evaluation from Romania, gross total resection 83%. Again, there were no immediate post-op MRI. MRI was done, I think, after 3 months, and they claim that there is some of the cases recurrence. They don't recur that fast, these lesions. Hydrocephalus and transient septic meningitis, 6.5. Complication, I found it is very high. In my practice, I rarely get that percentage of complication, and usually they get trivial complication and almost none in the recent years. Tumor recurrence, 22%, acceptable percentage. Mean time for recurrence remained the same, 7.5 years. Decreased percent of gross resection, and future attempt, the percentage is less. The mortality 0. Incidence of hydrocephalus in recurrence is high, and it's known. I think because of the inflammatory reaction to the cholesterol and keratin. Preoperatively, in 37%, post-op is 50%. These 2 points are of value because it reflect on the outcome. Multivariate analysis that they have made revealed that post-operative hydrocephalus and age less than 40 were prognostic factor of for recurrence. And medium location of epidermoid, they specified if it's medially located or laterally, has a higher risk of hydrocephalus. Understandable, it's near the aqueduct and the fourth ventricle, and increase in the likelihood of protracted hospitalization more than 10 days. So the outcome can be reflected negatively if there is hydrocephalus present before or during the surgery and the age less than 4. So in summary, the primary intracranial epidermoid carcinoma now is something else, is the malignant epidermoid are extremely rare. First case of malignant was reported in 1912 from the time of Cushing. Estimated 75% of the report cases, they should be a de novo intracranial carcinoma appear to have arisen from pre-existing benign epidermoid or epidermal cyst. And epidermoid carcinoma in the CP angle is the most frequent, and the manifestation is fifth nerve paresis. Symptoms and signs progress faster, and higher recurrence rate in carcinoma is understandable. Rapid and aggressive progression was versus indolent growth of epidermoid. Epidermoid is a very slow growing process, and the lesion in epidermoid carcinoma, they enhance on MRI study with gadolinium, on the contrary of regular epidermoid. Differential diagnosis are listed here. Arachnoid cyst, any cyst can be in differential diagnosis. This is one example, neuroenteric cyst that extend from the suprasellar area down to the foramen magnum. This is a teratoma that was diagnosed first as a craniopharyngioma, cystic craniopharyngioma in a child. And we published this case. We thought this is the craniopharyngioma. Almost this publication came 23 years ago with my colleague, Dr. Ash Jallo, was an associate of mine. And we thought this epidermoid, it is just dermoid cyst or craniopharyngioma, cystic craniopharyngioma. But if you notice, there is a dot sign here, and this dot sign is the tooth in long axis. When we operated on the patient, we found the tooth and the hair, so it's a teratoma, mature teratoma. Oji and Ozgen published their series 1991 on endoscopic transnasal approach for gross total resection of epidermoid in the pituitary area. So almost more than 20 years ago, 54% of the cases with endoscopic approach have achieved gross total resection. Weiss later on in Los Angeles gave a higher result up to 65-70%. Mortality reported 1989 was 5%, and new millennium 0%. These are the Result of Weiss and others on the transfer surgery for endoscopic resection of epidermoid. Number of patients were 39, total resection in 20. Brain and nerve deficits 2, CSF leak 7, relatively high. Post-op infection 5, endocrine deficit 3. So they are not without harm, but results are very encouraging with the endoscopic surgery. The conclusion for COVID-19 in 2007, almost 25 years or 30 years of follow-up, there is a decreased post-operative morbidity by use of endoscopy and mortality. Markin and Sweden's 2013 gave a complication rate was higher in the open case compared to endoscopy. My concern about this paper, such paper, endoscopy is a tool we'd like to promote. It's a very helpful visual extension to your surgical approach. But comparison is invalid if you don't compare it between microsurgical and hybrid use of endoscopy versus pure endoscopy, because you don't claim that a microscope is less result than the endoscopy. But the combination might, in my book, is the best from these practices. In conclusion, diagnostic value of MRI signal diffusion images is very important and far more important to compare a statistic. Simple approach for maximal safe removal nowadays with epidermoid. I don't go for complex approaches that would take time, complications, costs, unnecessarily for a benign disease that is manageable very well with the standard approaches. I mean, with the simple approaches, like the predecessor speakers, he gave very nice talks about we don't need to always go into my way or no way. There is always option, the third option, to use the combination of hybrid endoscopy to minimize bone removal unnecessarily. Tumor faucet microsurgical dissection, Sammy's technique is of great value. Hybrid use of endoscopy complement better resection. It's a judgment call after all. For aggressive capsule removal to prevent recurrence versus potential morbidity and deficit-free long-term survival with the high risk of recurrence. So we have to make the own judgment. Everyone has his own way of thinking of this. Myself, I don't like to take a patient to the OR and get out with facial palsy, trigeminal neuralgia that deprive them from sleep, the difficulty in swallowing unnecessarily for this benign lesion with relatively chronic progress. So in the home message, microscopic and endoscopic, use them combined is the third eye of the third option. I thank you very much for listening, and I'm open for answering questions.
Thank you, Professor Ahmed, for this excellent presentation. Is there any question?
I have a comment.
Go ahead. Who is speaking?
Yeah. Jorge Mura from Chile.
Hi. I just heard your talk.
Yeah.
Go ahead.
I just to say that I agree completely with you. Mainly this fight between microsurgery and endoscopy need to be end. I think that the epidermoid cyst is the most important example that you need to work together. Not only for the corners or try to achieve the different parts of these terrible tumors. You can show that in this kind of tumor that the gross total resection is the goal in order to avoid the meningitis and all the complications. It's very important to combine the techniques. For me, it's more than hybrid, is sequential surgery. It's the same. The concept is I do, for example, for my transcavernous root, the best microsurgery at the beginning, but in the point when I want to go to the posterior fossa, it's impossible. That's it. You need to use endoscopy. In my case, if in the operating room I'm not the best expert, I call to the guy who do endoscopy with me, and he can do a better work. we, the surgeons, are not used to chair the surgery. But for me, it's very important to chair. The best must do the work. And that's it. That's why your presentation is so good, because I completely agree that the patient made us better. Not we must try to put the patient in the box that we want to do because we are comfortable. No, the most important is have the patient comfortable and do all the techniques since the classic and finish in the I don't know what today, because the neurosurgery develops so much every day. And thank you for your presentation. It was outstanding.
Thank you, Dr. Thank you very much for staying and listen to this presentation.
Thank you once again for exposition.
Pleasure.
Is there another question? Thank you.
Thank you, Dr. Sameh, for the great arrangement and gathering the whole group better than the United Nations, that they all agreed on the same situation. Great work. Thank you.
Thank you, Dubu. Shift to speaker. Professor Brevedillo. Dr. Saeed will say welcome to him. Go ahead.
Yes, thank you very much, Sameh. I'm happy to present my friend Daniel Brevedillo from Ohio State University. He will he will talk about surgical management of chondrosarcomas. Thank you very much, my friend, and welcome to our presentations.
Thank you, sir. Thank you so much. Really an honor to be here. Been watching the presentations for the last couple of hours and has been amazing. Really amazing, Sami, initiative. I think I have to say, really an honor to be here, and congratulations to spread the knowledge around the world. And Saeed, Dr. Taha came here, spent some time with us. It's been a year, right?
Yes.
A little more, maybe. It was great.
Yeah, more, yes, 3 years.
Yeah. He's an amazing musician. But what was the name of the instrument you bought here?
The oud, Arabic oud.
Oh, amazing. Beautiful.
Thank you.
Yeah, we gotta emphasize things that is not only neurosurgery. We gotta have your hobbies and enjoy life as well. And I want to just start saying that I agree with a couple presentations, like Jorge Mura and Imad, showing the importance of really. I think the world is changing, valorizing the microscope and the endoscope. It's just there's tools for observation, and we have to be familiarized with all different tools. Now has the exoscope as well that give a different perspective in some approaches as well. I do think that some of these approaches are better depending on the disease as well. So I think we have to always study the disease. So that's why I decided, instead of talking about an approach, talk about a chondrosarcoma. And this should be a quick talk, because I realized that we're behind, and this is just focusing one disease. So I just want to share my thoughts. So chondrosarcomas, they are born on the petroclival synchondrosis. So they originate on the petroclival synchondrosis for the most part. And by starting on the synchondrosis, it can invade the petrous surface, the temporal bone. It can invade the occipital bone as well. It can always go down to the jugular foramen. So the jugular foramen is formed by half of the jugular foramen is the occipital bone. The other half is on the temporal bone. And it can enter those areas as well. So chondrosarcomas can keep invading. And they can even go to the cervical area. Because they originate from the bone, they are extradural diseases, and they are mainly ventrally located. That's why endonasal corridor or ventral corridors, if you don't want to use the endoscope, you could still go back to do microscopic coming from the front. Like, I think that will be independent, but the ventral corridor makes more sense. because the bony of the petroclival synchondrosis is really ventral located. And if you try to go from behind, you may need to open the dura twice to get to a chondrosarcoma versus just coming from where the tumor originates. It gives you an access directly. So most of them are eccentric, right? So it's not midline. The majority will be behind the carotid, which you can see here in this dissection from more than 15 years ago that we've done. And you can see the video nerve like a transpose here in this picture. And what is important is that we will do a transpterygoid approach endonasal to lateralize the pterygopalatine fossa, and we follow the video nerve to get access to this confluence where you have the roof of choana, you have the carotid artery, video nerve, V2 goes in that direction, and we can then expose the ventral aspect of lacerum foramen to then go behind the carotid. And usually when you get there, you start seeing chondrosarcoma. In this dissection, you see that you have the carotid, the parapharyngeal carotid artery going up, and then it bends and comes forward through the petrous carotid artery, and then on top of the lacerum foramen goes to become the paraclival carotid artery. So chondrosarcomas will invade all this bone inferiorly and posterior to the carotid, and you can see here the large eustachian tube with the torus tubarius that it basically guards a lot of the posterior fossa in front of the condyle and in front of the jugular foramen. So it's not unusual for chondrosarcomas that we will do the transpterygoid approach and then remove this eustachian tube to get access to the ventral aspect of the condyle and the jugular foramen. And in some small tumors, you can transpose it just by working medial posterior. But for larger chondrosarcomas, we will not hesitate. We'll just cut that eustachian tube to get access, always with a Doppler, being very careful to preserve and pay attention on the carotid artery. The other thing that we've been using, and I think is important, I think you can use in the entire world, is like any MRI, you have a DWI, diffusion. Is one of the principles of the MRI. And the MRI can identify cellularity. So if you see something that looks like water, looks like cyst, look like a T2 bright, but you have cellularity, like there's a brightness on DWI that you can confirm with a little darkness on the ADC, those are cells located on that area. So you know that you're dealing with a chondrosarcoma. And on the same way, that's the way we monitor if we obtain a good resection. So when you see post-op, you see, there's still a little DWI, sorry, a little T2 bright, a little water signal. But when you look at the DWI, there's no more cellularity there. That is just now post-op changes from your resection. So those are very good ways to monitor. I learned that from my brother. I work here with Lucio Prevedello, and he's a genius with the neuroradiology. These are very old like numbers. We've done, I think, more than 50 patients now, but I like to keep because proportion of these is all the same. 1/3 of our patients have surgery somewhere else, and that's what I like this slide here because this has not changed, if not getting worse, where people try to do little bites on the tumor and leave behind. They send to protons, and there's so much tumor there then that we got the referral to get the resection because they do much better if you remove the entire tumor. Although chondrosarcoma is very important to remember, they do respond well to radiation. But if you leave the 2/3 of the tumor there, it doesn't make any sense. So we try to get a good resection, ideally a complete resection. And then we look at the different grades. They can be grade 1, 2, or 3. If they're grade 1 with a complete resection, we have been just watching them. But if they're grade 2s or 3s, even with a complete resection, we tend to do proton beam in the tumor bed for control. Very rarely we have to associate other approaches. We've done a transoral and in another case we did pterional to access the skull base there. But the majority of the time, an endonasal approach, you can actually remove this entire tumor. So here's an example. Frequently, they're going to push the carotid anteriorly, and they can invade the dura posteriorly in the anterior part of the CP angle. So here, just to exemplify how we perform this is a quick video here to show. So first, we're going to lateralize the pterygopalatine fossa. For chondrosarcomas, we tend to sacrifice the video nerve in the majority of the cases. I would try to transpose the video nerve in cases for middle fossa, like trigeminal schwannomas, but rarely we will do try to waste time preserving, because chondrosarcomas are like low-grade cancers. So here you can see the video nerve got dissected there. The pterygopatin fossa is lateralized. And then we follow the choana. You can see here the choana, and you see the video nerve. And then progressively we'll drill around it, drill the floor of the sphenoid sinus as well. I tell my fellows not to jump and go into the tumor, start seeing tumor in the back, but it's very important to get a complete exposure before you start taking tumor out. Here then we are taking the eustachian tube. So by going lateral to the eustachian tube, rolling, the thoracic barrier is removed. And then we continue the dissection down in the foramen magnum, and then laterally in the direction of the condyle. So very frequently we go all the way to the hypoglossal in these cases. Here we are taking it more posteriorly from the median, keep going there. And then once you have a good exposure, then we will then take the tumor out. So here's the interesting part. The majority of these tumors are suckable, but there's some tumors that can be very, very firm and calcified. So you gotta be prepared. Usually the CAT scan can guide you, and you gotta be prepared to drill the tumor as well. Here we're working out behind the carotid using angle scope and angle drills and angle camera. So here we're just mobilizing extradurally all that tumor that came from the petroclival chondrosis, and then taking it out. And here the angle scope, you see the carotid artery paraclival is right here. So we are behind the carotid, in between the carotid and the dura. This is the petrous apex, triangular shape, and Dorello's canal is on top of it. And here I end up touching with the drill there on the dura, which actually no problem, like you decompress that dura, allow me to continue the drill out posterior. It's very important to drill these crests of the part of the bone that got invaded a tumor. So we basically, this is the carotid artery petrous, and we are with the angle scope working behind. And then once we drill out that petrous, then we're satisfied with the resection, and then put fat there in front of that dura of the posterior fossa, with DuraGen plugging that little hole that I caused with the drill. And then here, the nasoseptal flap for reconstruction, basically sealing that fat behind the carotid and avoid any leakage there. So this is a good example of a very standard right side transpterygoid approach with a complete resection of that tumor that was behind the carotid there. This is kind of a way. So now I'm just going to go show some glimpses. This is the technique. It most of the time is similar. There are situations where the tumor go all the way down to the cervical region. Here, same thing. We will expose. I'm just going to advance here some key portions of the video. I use the Q-tip because you're extradurally, and as you remove tumor, it's like a diaphragm in a pituitary surgery where it comes in your direction. So I like the Q-tip to push the dura back. And here is another example, like working behind the carotid. Very careful not to damage it at the apex, superior aspect of the petrous apex. You can have the sixth nerve running there. So I'm very respectful to the petrous posterior surface where the sixth nerve runs right here. We will drill all these with an angle drill. With the Q-tip, I can retract, and you can see the sixth nerve running right there through the interdural segment, and it jumps on top of the petrous, go to cavernous sinus. And as we work below and inferior to the carotid now, you see here the jugular vein, and we are taking that disease that progressed from the petroclival chondrosis into the cervical region. So here's a complete resection, removal of thoracic barriers in the eustachian tube, extradural disease, and extradural work with the nasoseptal flap, no CSF leakage on these cases as well. And you can see that we decompress like macules. We remove the posterior fossa component that was extradurally, ventrally, and the decompression of macules and a complete resection. So sometimes you have to drill more. The tumor can enter the dura. So this is an example where the tumor got into the dura there. And in these cases, we will need to drill and then enter the dura posteriorly. And the same way we put fat at the end with the complete resection for the patients. This is a patient had this large right side chondrosarcoma as well, with a major component intradurally. But because the tumor comes from ventral to posteriorly, we can follow the tumor. So I'm going to put it directly here at the point where we're taking the Eustachian tube. And you can see the same technique, like taking the Eustachian tube, allows exposure of the ventral aspect of the condyle on the right, and also that jugular foramen. And this is another suckable tumor, so I just follow. You can see the carotid here, and I'm retracting that carotid. That's why it's important to remove all the bone around it. And then we can follow this like posteriorly. That's jugular foramen there. And for the intracomponent of the tumor, I basically just kept following the tumor progressively, and we're able to get all the way intradural. And it was interesting because there was it was eroding through only one layer of dura, and there was this meningeal very thin layer that was pushed back. So we're able to get all that resected with no problems, no leakage actually. This is the hypoglossal canal. So we drilled on top of the hypoglossal nerve, and that gives us access to the jugular fossa there. So we continue the dissection and the jugular fossa all the way posteriorly, and you can see there's some sort of a membrane that was guarding the, preventing the tumor from spreading through the arachnoid. So this is the final corridor, basically working completely behind the carotid, cleaning all that now with the 70-degree endoscope behind the carotid, and we will always drill those diseased bone with the chondrosarcoma on it. So at the end, we have like a petroclival, the petrous apex completely gone, and the hypoglossal canal down here, lacerum foramen, completely, you know, like exposed and clean from tumor. And then the reconstruction with the fat graft in the corridor, and then the nasoseptal flap there. Of course, the meningioma there, you cannot reach endonasal. So, but you can see here in the video that we got a complete resection of the tumor all the way, including the intracranial component for this patient. This is my last video just to finalize, showing when the tumor invades the jugular vein. Sometimes it happens, and I'm going to go straight to that point since there's a lot of repetition here. We basically remove that here, the Eustachian tube, Doppler the carotid, and then you see the Eustachian tube, once you remove, is amazing how it gives you a monster corridor to expose the entire ventral aspect of these tumors. Here's taking that last piece of Eustachian. You see the jugular vein with tumor inside, ballooning. So we put a cut there, and now we're taking tumor from the inside of the jugular vein, coming endonasal. The beauty is, like Dr. Al-Mafti showed to us, if you stay ventral to the inside the vein, see the posterior part of the vein is preserved. That's where the cranial nerves are. So then by doing that, you preserve the cranial nerves, and there's no manipulation of cranial nerve 9, 10, 11. They're running down and posterior to that vein there. So this is a way to just stay on the core of the tumor. We follow the tumor intracranially as well. Here is the piece of the tumor that was going intradural. This is surface of the cerebellum that was kind of ventrally located there. And I've just put this last view here that I like to show you how it looks like there. You can see the exposure, and the entire carotid is there. Lacerum is here, Vidian is sacrificed, and then putting the fat in to replace the petrous bone with the reconstruction with the nasoseptal flap. So here's the jugular vein, free of tumor, no post-op. Very good. Now, just last picture showing that this part becomes not difficult. This is a case example that the tumor was going so low in the masticator space. The post-op, we got everything intracranial, everything in the petrous bone, like the other videos, but we left a little piece there that I was upset. And this is something that Ricky Corral looked at this and said, wow, this is in a carotid artery below the level of the palate. I can go transoral. So we came in transoral and endoscopic. This, I'm holding the endoscope for him here because I was not that familiar with that anatomy. So he actually dissected. He kept repeating, this is just a tonsillar approach area for the carotid. We exposed them transoral now, and through this cut on behind on the tonsillar area, and we got the residual tumor that was very low, difficult to reach from the top, using the endonasal approach. I'm going to skip this one just to finalize, showing that this chondrosarcoma surgery, it can be very well done as the main corridor using the endonasal endoscopic with low morbidity for these patients. I did have a couple patients that I have to mention. Every time you move carotid artery, you can have an emboli. So I have now a couple patients that have embolic events, little showering. One was dysphasic for some time, and got better afterwards, but definitely had a DWI hits by showering from the carotid. I do have one patient have an MI, had to have a hard stent after surgery as well. But in conclusion, it is nice to work with the ENT head neck team that really dominates this area as well. So I learned a lot from them. So multidisciplinary approach as we treat these patients also with the radiation oncology team that we have. The majority of the grade 2s and 3s, we indicate proton beam radiation. Thanks so much. I want to just bring attention that you all invited to come to New Orleans in February. We'll be from 13, 14, 15, 16 of February, the World Congress that we are helping to organize down there. And those interested in doing a hands-on course, we have our course here in May, the end of May of 2025. Thanks so much.
Thanks very much,
Thank
Daniel.
you, Buvudolo, for this excellent presentation.
I have a question.
Is there any question?
Yes. I want to know if there is any progress
Okay.
molecular level, as there is a study about molecular target for this chondrosarcomas.
Yeah, good question. Not that I'm aware, Dr. Taha. I know for chordomas, we are evolving a little faster. I think they're a little more common and more aggressive, so there's more interest in chordomas. So there's, genetic analysis sequencing done. Also, the brachyuria evolution, some trials with anti-brachyuria as well. But for chondrosarcomas, I'm not aware of any evolution there. Maybe in the systemic chondrosarcomas, because chondrosarcomas you can have in any joint of the body, right? Not just petroclival, but these are the skull-based tumors that we face. So far, I think the best treatment is resection. Any residual respond very well to radiation. My radiation oncologist here, they quote 95% control rate with radiation. But I don't know any molecular advancement on the chondrosarcomas, nothing that I'm aware at this point.
Okay, thank you very much.
Thank you, Buvudolo, for this discussion. Now shift to next speaker, Mauro Segura. Please, because he has a flight to catch. Could you please start, Mauro?
Yeah, hello.
Okay, go ahead.
Hi, good day to everybody in Latin America. And thank you, Professor Morsi, for this tremendous effort. Let me share my screen. The screen
Yes,
okay
please.
for you? Okay, I keep on my time, please. Saying that I have 15 minutes. So I want to share with you this topic because I believe that there is a misunderstanding about the approach. Of course, most of the people in this meeting are talking with very creativity in this area, the posterior fossa. So I dedicate some hours to investigate, and of course, all of you know the background. It's a quickly pass microsurgical anatomy of the inner surface of the petrol bone. The people who wrote this paper, Professor Fukushima, they, and many other, the next slide, from the last 20-25 years, this, of course, the people from the Watson laboratory, suprametal extension of the Retrosigmoid approach is another nomenclature. but they're talking about the same 1999 Retrosigmoid intradural suprametal approach. The famous Risa from SAMI, of course, and many other fellows wrote about that. Professor Chanda. And there is a very interesting word in this, this letter from Professor Kawase, that a few people from all the world is able to reach this area. He's talking about the petroclival region. The master of the anterior petrosal approach, Professor Kawase, is saying that it's very no one lands, and also he did it many surgical approaches for the anterior, and he said that the posterior approach, doing the transtubercular suprametal approach, was very complex. Some Mexican people, but all of them are talking about the same. In this case, a couple of years ago, we do this preliminary classification, but of course, now, and I know we are in a very beginning. This is just the beginning of the classification, because the topic is too much complex. So today I want to share with you this small experience from the last, this period, 6 year experience, and we review 626 de novo cases from retrosurgery approach. So in our institution, most of them primary or secondary to trigeminal neuralgia. So we're going to describe the finding of this. I call that transtubercular suprametal retrosigmoid approach. Why? Well, in our institution, we never use the sitting position. I prefer the lying position. As you can see, it's a very quickly and easy 10 minutes average to prepare each patient with an expert team. And from all these 626 patients for this retromaster approach, about 22 women and 4 men were operated for this transtubercular suprametal approach. So this is the epidemiology. 9 right side, 14 left side, and 3 of them bilateral. Most of them are for microvascular decompression for any different types. However, some of them included epidermal cysts, as we just listened, petrous region meningioma, even petrox apex, even petroclival meningioma, or tubercular meningioma, a small one, that the cases of Professor Campero said, and one very big calcificate case, and also one acoustic neurinoma. It was included. So, Dr. Prodelo, I will present this case in your meeting. So this is just the abstract, because more of the time. Can you hear the volume? Sorry?
Yes. Yes.
Can you hear?
Like facial pain on both sides of the face.
Yeah. You can raise the voice.
Yes.
Seizures on the right side. MRI revealed vascular contact of both trigeminal nerves, leading to a diagnosis of classic bilateral trigeminal neuralgia. The imaging study also demonstrated a lobulated osseous prominence on the right petrosal surface. Due to the severity of the pain and its refractory nature to the medication, the patient opted for immediate sequential microvascular decompression after an exhaustive medical evaluation. The left side was operated on fits without complications, followed by the right side, which required a transtubercular approach as shown in the surgical video. We begin by positioning the patient.
The right side. Let me check out the volume, but this is the right side. You can see the retrosigmoid approach, very small one, less than 20 millimeters in the right side as the figure. Sorry for the video. And this is the suprametal tubercle. As you can see, more than 4 or 5 millimeters is in the surgical corridor. So I decide to remove with the to drill. Maybe this is the smaller dispositive, and this is the beginning. Of course, we never use water because it's very dangerous. The second ball now 4 millimeters, and you can see about the size of this suprametal tubercle. In this case, you can see the final extension of the approach, and it's very easy to reach the trigeminal nerve in the entrance to the trigeminal porous and all the vascular structure, in this case, different supracerebral arteries, anteroinferior arteries. In some cases, we found different and atopic venous, we call innominate male. And this is just the example for the approach. After that, you are able to remove the tumor, one of the I said, and in this case, we are repairing the suprametal approach. We use bone graft, some surgical cell, and this is the control. It's very small hematocephalus, no problem with the patient, and it's just a little bit perceptible the transtubercular approach. However, it's enough space to reach some kind of tumors, as I show you. Next slide. You see. This is another case. I'm going to run faster. This is the left side, the same retrosigmoid approach, less than 2 centimeters. And this is the suprametal tubercle. We are drilling in very careful area. This is after for the young people. I know this video will be felt for many young people, fellows, and residents. This is just after hundreds laboratory hours, not for the beginner. Now we are removing the dura. So I don't like to call RISA intradural because all of the tumor, all the patient we operate is intradural, of course. And in this case, actually we are extradural. However, well, this is my opinion. Through this corridor, we can reach the petrous bone, we can reach the petroclival area, and also we can reach and do the Kawase reverse approach, as I showed you in other presentation. It's very easy, and I have to say it's very simple, easier than anterior transpetrosal approach. And just the last patient I just operated a couple of days ago. We have a very huge neurinoma. I realized transtubercular suprametal approach and interfascicular removal of total neurinoma. And this is the waking up from the anesthesia.
Enseña los dientes.
Okay, this was Listo, left cierra approach los ojos. With facial nerve preservation and acoustic nerve preservation as much as possible.
Muestra los dientes.
Okay, finally, in order to keep on my time, an experienced and well-trained skull-based surgeon, in my opinion, must spend time in cadaver laboratory and to dispose microsurgical tools to make interpretive decisions in a specific clinical situation. In my opinion, it's not only some tools, some attachment, we have to decide in the middle of the surgery how to do, and if we are prepared to do this transtubercular suprametal removal for any trigeminal cases, primary or secondary cases. So take time, and I want to if this invitation is for Hispanic people in the next weekend, Saturday, so please follow the link. And I'm very sorry for the time because I have to fly in a few minutes, Professor Sami. Thank you very much.
Hello, Sam. Are you there, Sam?
Thank you. Mo, for this excellent presentation. And sorry for delay. Is there any question?
Hold on, Sam. Let me do it, okay? Thank you very much, Mauro. We'll open the floor for questions or comments from the panelists. Any comments or questions from anybody?
Yes, I'm here.
Okay. Okay, thank you, Mauro. Let me introduce the next speaker.
Thank you, Mauro, for
Thank you. See you.
Okay. Now, Vascular will speak next. Thank you.
Hi, guys. Thank you for the invitation to speak here. It's an incredible lineup of speakers and an incredible day of events, so really appreciate it. I'm going to keep this relatively quick and short, a little bit to make up time, but also to really point out what I think about stock preservation, particularly when we talk about the surgical management of craniopharyngiomas. I have no disclosures, but I will say I'm colored by where I train and where I work, so something to keep in mind. The clinical presentation for most of these, a lot of us know, relate to either endocrinopathies, hypothalamic dysfunction, aseptic meningitis, or hydrocephalus. A lot of these patients can have issues with memory depending on where their tumors are. So we'll talk a little bit about positioning of the tumor in relation to the infundibulum and stock and how that impacts our thought process here. And this is just a general slide that a lot of us know about where these tumors are, what the normal anatomy is in this region, and really differentiating between the two different types of pathology, between the adamantinomatous type and your papillary types. Now, we know that BRAF inhibitors and other medications have really changed our approach to the more papillary type tumors. So we're really focusing on the adamantinomatous types, the types that really require us to have great surgical outcomes and keep relatively good quality of life. And so this is a great paper actually from Dr. Previdello and Dr. Bir Furlan in Neurosurgical Focus several years ago, looking at the classification types and showing where they believe these different classification types are in relation to the hypothalamus and the infundibulum, based off of work from 2008 onwards. And I think what really needs to be highlighted here is there's a different type of pathology when we're looking at type 2 and type 4 that have a lot more challenging approaches to preserving that stock. But the retroinfundibular and preinfundibular lesions are set for us to try to protect that stock at all costs and keep our pituitary function intact. So part of that discussion becomes the visibility of the stock. And so this slide really demonstrates where we see these lesions in relation to the hypothalamus, what nuclei may or may not be impacted, and from a visual standpoint on our neuroimaging models, where we see the pituitary stock and in its relation to these tumor shapes. And so this really highlights, one, how we visualize these preoperatively, plan for them preoperatively. And of course, our steps in resection here are primarily extracapsular dissection, countertraction and traction, blunt, as well as sharp dissection, particularly along the vascular structures of the infundibulum. And so realizing where it is in relation to that plays a pretty critical role. Again, this is a similar slide, but it highlights where the hypothalamic nuclei are, and the higher these tumors are, and I'll give it a couple examples of retroinfundibular lesions going into the third ventricle that demonstrate a good reason to protect the stock up front that helps us really visualize this significantly better. I know, again, the discussion between endoscopic versus open and microsurgical approaches, I don't really think is the key focus here, but I do, and I'm going to show endoscopic approaches here because I do think for at least type 1 and type 3A and 3B tumors, this is a very good approach to protect that infundibulum because it shows it to you first up and foremost, and you see the stock and protect it outright. This is a discussion of our experience, or at least my experience. Again, I'm an assistant professor, relatively junior in my approach here, but over the last couple of years, I've had about 21 cases, and you can see that the majority of these cases that have preservation of pituitary function after surgery are primarily the type 1 and type 3 tumors, as well as the type 0, which are primarily intracellular. And we've had a relatively good success, at least 8 out of 14 that preserved pituitary function. But again, after radiation therapy for some of these, especially for ones that have a higher Ki-67 or proliferative index, it becomes a little bit more of a challenge. And so really trying to preserve these up front with surgery is, I think, primarily the goal of endoscopic intranasal approaches for these tumors. And again, endoscopic approaches provide a natural corridor that's in line with craniopharyngiomas, which is why I'm going to highlight that here. So the first case is a 38-year-old gentleman who actually a pretty heavy drinker, but he was found to have really progressive headaches and vision changes. And you can see he's got this heterogeneous appearing lesion. And I'm just going to pause this for 1 second just to point it out. But we don't clearly know where the pituitary stalk is in this lesion. You can see that really on the sagittal image that he's got areas of enhancement that go both in front of and behind this lesion. But really the thought process is that his stalk is probably pushed forward and to the side based on his coronal image. And so we're going to see this up front when we do our exposure. And I'm going to speed up these videos a little bit to just save us a little bit of time here. But drilling the sella is pretty standard for an endoscopic approach. And once we get that exposed, we drill part of the tuberculum and planum to get a little bit more exposure. The lateral wall of the carotid here, going out towards the optic nerve on the patient's left side, which was his worst side. And then we open dura along the sella and get through our sinus, circular sinus there, coagulating that to allow us to open up further. And again, sharp dissection here early on. And we're able to identify with a little bit of dissection through the arachnoid, the infundibular stalk right away. And you can see there's small hypophyseal arteries and arteries from the carotid that go towards the stalk, go towards the chiasm, and go towards the gland. And these were preferentially dissected by where we believe they were going. So you can see these small arteries are not just coagulated and cut, but are actually dissected out to allow us to preferentially save them towards the stalk. And this allows us a natural corridor that allows us to go into the retroinfundibular region. And we see tumor capsule almost immediately. And then we're able to dissect this tumor capsule off in a circumferential manner. We, because of the size of this tumor, internally debulk it. And I'll show if I can move forward here where we see tumor content right away. And we start internally debulking this. I'm just going to move the video forward a little bit to show with that debulking allows us to slowly work around the tumor capsule. And this video is sped up to allow us to actually finish this within this time period. But seeing both laterally and into the third ventricle, we're able to remove and internally debulk the tumor. And this will allow us to actually get around the capsule a little bit better for the remainder of the resection of this tumor. And you'll see our typical approach for this, even though it is retroinfundibular, allows us to preserve the infundibulum of the pituitary gland. And in this situation, we had a large enough corridor that we didn't necessarily need a transcavernous approach to allow us to mobilize the pituitary gland. And to speed this video up a little bit, you see a really nice cavity up into the third ventricle, and you can see the amount of involvement of the hypothalamus here with some scarring. We used a fat graft in this patient just because of some of the social issues in this region, along with the fascial lata graft. So you'll see fat on our postoperative scans, but his vision dramatically improved and he did very well. He's now 4 years out and doing fantastic, and he retained all pituitary function. And you can see this is our fat right below the optic chiasm, and you can see that here as well. Another case example of a retroinfundibular lesion or a retro-stock lesion, another 38-year-old patient. And here we'll note that part of this tumor actually extends laterally into the middle fossa. And part of this tumor also involves tumor all the way back into the interpeduncular fossa. And really, to allow us to visualize that safely, you can see that we're drilling off bone along the optic nerve and along the carotid artery on the patient's left side to be able to access these lesions. But in these situations where we need a little bit more of an exposure, we actually take bone off of carotid, take out middle clinoid process on either side, and open up the cavernous sinus just enough to be able to allow us to visualize. So you see we're drilling planum and tuberculum. We expose the edge of the carotid artery, and we do this all with a diamond drill. Now this is sped up just for the sake of time, but this allows us to be able to dissect around this and actually flick this bone off instead of drilling directly onto the carotid. So you can see the middle clinoid process being removed, and a little bit of venous bleeding, which is not unexpected from both the circular sinus and cavernous sinus in this region. Middle clinoid on the opposite side, allowing us to make sure we decompress both nerves. And here we have the opening of the dural along the planum and tuberculum. And you can see we've already opened along the sella, and we do this in a Y-shaped manner at the end to allow us to have sufficient visualization in both aspects. You can see us turning there to create this Y-shaped opening, and now we open up the cavernous sinus on the patient's left side, the side that we want to go out into the middle fossa as well. And you can see that we get pretty significant bleeding, and we do this all with a feather knife. So this is opening into the cavernous sinus, and then we're able to quickly embolize that relatively safely. After we embolize it, we're able to actually see and visualize some of the ligaments to allow us to safely open up the cavernous sinus and the lateral aspect of the gland. See that we, with suction, are able to put these on stretch and open this up. And this allows us to really mobilize the pituitary gland. And you can see the stalk to the left, as well as the pituitary gland being mobilized inferiorly to allow for visualization into that retroinfundibular space and retrochiasmatic space. And you can see tumor capsule in the background there, which immediately presents to us a large enough corridor to visualize both the tumor as well as we get into the cyst laterally in the middle fossa. So benefits of tumors that have cystic components particularly benefit from an approach like this. And that's something that we'll talk about because it does offer some limitations in some cases. And so here you can see this is an internal debulking of the tumor, allows us to decompress this and then eventually work around the capsule of this tumor. And the entire time the gland is at the bottom of our surgical resection. And here we've entered the cystic cavity. You can see we are able to suction that out relatively quickly. And now along the back portion of the hypothalamus, we can have sharp dissection and blunt dissection using a combination of microinstruments. Large portion of the calcified tumor can become a little bit more challenging to resect because it's not as suctionable as the other portions of tumor. But this becomes a little bit of an issue when we're talking about hypothalamic dysfunction as well as the amount of traction that we need along the infundibulum. But now you can see we can rotate that capsule now that we've debulked the tumor, and this will allow us to circumferentially work around the tumor and remove it in a piecemeal manner. Now we work along that calcified portion of the tumor. And you can see the corridor that we have is large enough because we opened up the cavernous sinus and actually moved the pituitary gland and transposed it inferiorly and laterally to allow us to have a larger working corridor. And now you can see the back of our surgical site and cavity. The remainder of the tumor. And a view up into our ventricular system with the choroid plexus in your immediate view. And it shows you the lateral walls of the cavernous sinus that we can now dissect the tumor off of. We again close this with fascia lata, and that's typically what we do for our expanded endonasal cases with a nasoseptal flap and adherence technology. And our post-op image here, you'll see, will show you that the pituitary gland is actually still enhancing on the sagittal and still has some blood supply, which is an important aspect. And this patient did very well and is now 5 years out with full pituitary function. Similarly, and this is probably the last case I want to show out of our series, but this is a video of a type 1 lesion, again, showing you that this is in front of the infundibulum, and you can see on that postoperative image what it looked like afterwards. But here we drill out that tuberculum, relatively straightforward, and open up part of the planum. We open up using a sharp dissector along the sellar dura. And I think opening the tuberculum immediately allows us to identify tumor in a type 1 lesion like this. Tumor can be debulked, and once you find the top of the gland, it allows you to work back towards the infundibulum with sharp dissection to actually visualize where exactly the infundibulum is. So here we remove tumor, allows us to rotate the tumor capsule. And here you can see the infundibulum to the left of our suction, which allows us to preserve the infundibulum in a case like this and actually dissect and peel the tumor up. So tumors that are pre-infundibular are set for us to try to preserve pituitary function postoperatively. And you can see here that there's good vascularity along that infundibulum. And so we're able to ultrasonically aspirate or remove part of the tumor using multiple different techniques. And you can see the postoperative image here. And again, the patient retained all their pituitary function even 3 years later, and even following radiation therapy. And so in these kinds of situations, I think the benefit is that you really give them a different change in quality of life. Now, I'm going to end this on just one quick note saying that there are limitations, and obviously there's a learning curve to all of this. But the limitations here primarily are with type 2 and type 4 lesions, meaning ones that are within or encased within the infundibulum, and those that are intraventricular tumors that pose a challenge because of the endoscopic endonasal approach requires you to work through that stock. Calcified tumors require us to have a significant amount of dissection along the edges and borders of these tumors, which can be more challenging because of the amount of traction and retraction we need to be able to pull this out. So traction and counter traction are pretty important in these situations. And we discussed how in hypothalamic situations where you have tumors that are very aggressive, you can sometimes get some issues with dissection off the hypothalamus, but you have a very good view because of the axis of the tumor and the growth of the tumor from an endoscopic endonasal approach, which allows us a lot of benefit in these situations. And finally, knowing that vascularity in the hypophyseal and infundibular vessels is key to really preserving function in these cases. And that's something that we're continuing to get better and better at. So I appreciate the invitation to speak here. I'll take any questions, but again, Professor Sammy, thank you for the invitation and a great conference.
Thank you, Dr. Kunal, for this excellent presentation. Is there any question? Thank you. And now we'll shift to our next speaker, Professor Maurizio Angeli. Please start sharing your screen.
Thank you. Can you hear me?
Yes.
Okay. And I share my screen now. Okay. I don't know what's happened, but
Start things off. Okay, you got it.
Okay.
It's coming here.
Okay. Now should work, huh?
Yeah, perfect.
Okay, thank you, John. Thank you, Sameh, for this great opportunity, and it's a very pleasure to share our experience with the experts and friends. I just want to say a few words about the application of the skull-based philosophy for intraparenchymal lesion, not only for the classical skull-based approaches. As you can see, we have many options in our daily practice, and every approach could be good, not enough, or can be tailored for that patient. How can we survive in this jungle? Everybody needs a mentor, I think, and this was my experience. I had this giant mentor that apparently there were completely different personality, philosophy, way to approach the medicine. Al-Mefti was considered, he defined himself like a butcher. And Pernesky was some minimal invasive surgeon. Yassergil, of course, is a master. But at the end, if you say from their best sentences, the aim is to not manipulate the brain. So whenever we have to select an approach, the goal is to not manipulate the brain and try to follow the natural corridor, the natural way. And we have even to consider in selecting our approaches that the people change, because now the people, maybe not all over the world, they prefer to live less but without deficit. So we have to consider this. This does not mean that we must be minimalist, but in some way try to select the best approach in order to address the disease, but not to create some damage. Of course, we have to consider that the technology exists, but we have not to forget that the so-called classical approach must be done and can be indicated for that precise patient. This is the midfacial deglowing for a chordoma. As you can see in intraoperative room, the approach could be is supposed to be quite aggressive. But at the end, if you see the patient after 3 months, she's in very well condition without with the complete removal of the tumor, and you hardly recognize the scar in his face. So if it is indicated, we can not forget the so-called classical approach. Of course, one of the best corridor for the skull base, anterior skull base, and the craniovertebral junction is the nose, because if you see just cutting, this is the pointer of the neuronavigation during the operation, just cutting the mucosa of the rhinopharynx, you reach the clivus, lower clivus, up to the body of C2. So this is a grid and faster approach. Of course, we have to change a little bit our mind, because this is a funny figure that one of my residents provided to me. These 3 boxes looks different, but in reality are the same box, just rotated. So we have to try to reimagine the anatomy, but the anatomy is always the same. A few cases. This is a brainstem pontine cavernoma. In selecting this approach, we have to consider different factors. Of course, it could be approached with the anterior transpetrosal, suboccipital, far lateral. But if you look in detail the tractography, the only real safe zone was in the anterior part of the brainstem, because all the other fibers were dislocated laterally. So the best approach, the safest zone, was from anterior. This is why we approached this this, why now is blocked? We approached this patient through a anterior endoscopic transnasal approach. It's important in the approach to make a real plan, because you see the lesion is located just at the junction between the vertebral artery and the basilar artery. So intraoperatively, when we open the dura, it was not so evident, the lesion. There was not a discoloration, but with the high magnification of the endoscope, considering that the MRI showed us that the lesion was just at the cross between vertebro-basilar junction, with the stimulation, neuronavigation, and the high endoscopic magnification, we were able to find the lesion and remove the lesion accordingly. And in this case, we reconstruct all the layer, because one of the secrets is the reconstruction of the layer with some artificial bone and even resuturing the sutura, the mucosa. So real try to reconstruct layer by layer, but all the layer, even the mucosa. Based on our previous experience, this was another case, a similar case of pontine cavernoma. In this case, we were forced to, in some way, to select the anterior endoscopic endonasal approach, because this lady had a first bleeding. And we were thinking, okay, we perform the MRI, tomorrow morning we operate, and so on. But after 2 hours, the patient deteriorated because there was a rebleeding. So we have to select, in that case, a very fast approach in order to address the lesion. Even in this case, as you can see, we select the anterior endoscopic endonasal transclavial approach, because at the end, from the external word and the cavernoma, there is only a thin layer of bone of the clivus, and we are just in front of the lesion without without violating any eloquent anatomical structure. So this was our additional experience with the brainstem cavernomas. And this was really, as you can see on the postoperative CT scan, a quite straightforward operation just in front of the clivus. Considering this expansion, we were facing this additional case in which there was an ICA aneurysm. In this case, we were hesitant on which approach to select for 2 reasons. Because the sac of the aneurysm and the neck of the aneurysm were innovated inside the brainstem, so with the risk of manipulation of the brainstem. But based on our previous experience, that the anterior part, the anterior approach maybe will be the most indicated, because as you can see here, the neck of the aneurysm was just in front of us without manipulating anything. But it was, and of course, the aneurysm was not suitable for embolization. We tried, but was not our neuroradiologist colleague were not able to address the lesion. So we think about the endoscopic, and there was even some experience about this approach. But I try simulate this approach with the pituitary adenoma. It was quite difficult, the manipulation of the clip. But the concept is correct. And in this case, we select the transmaxillary transbasal approach that follow the same rule of the endoscopic endonasal approach, but with the additional space. But the philosophy is the same. We violate the bone, the other tissue, but not the manipulation of the brainstem. And you see here the transmaxillary transclival approach allowed us to clip the aneurysm in a very smooth way, as I show you in the what happened. What's
We
happened?
don't see your presentation.
Yes.
Could you please
There was something.
Start screen sharing again.
Yes, but okay.
With the screen share button, number 1. You got it.
I'm trying. Can you see something?
Yeah.
Okay.
We are seeing your screen.
Okay. I don't know what's happened, but I can see the presentation. But when I try to share, something happened. I try one more.
Something about auto update. So cancel it. Cancel.
I don't know. Maybe I really am sorry, but I cannot see the presentation again. I'll try to share again.
Yeah. Cancel this update.
Cancel. You see?
Yes. Full mode. It's something about update of your computer.
Maybe if you reset the PowerPoint, because everything, the Zoom.
Yeah,
Go out inside the Zoom.
Yeah, open up the PowerPoint.
The PowerPoint.
Yeah.
Cancel. Okay. I don't know, maybe later, but when I try to
Please try to close. Yeah. Okay. Just click on presentation again.
Right, click on the first one. That's it. Go ahead. Install the latest something. Oh boy. Itch.
maybe.
Yeah, okay, there you go. There you go.
Okay. So I'm sorry, but
It's okay.
No, okay. I'm sorry, but maybe later I try to make some update, but I'm sorry about this inconvenience. But I cannot stolen time to the other presenter. So I try to fix up, but maybe you can go further. unfortunately. But I
No,
stay.
we'll wait a second. Keep trying. Keep trying.
What?
Click on that first slide. Yeah, click on that like you did before.
Uh-huh.
Okay. Okay. Now you got it. Okay, you got it.
But
it goes away. Well, you detected a problem. Clicking, but don't click the OK button. Click the cancel. The
cancel.
cancel button. Yeah, cancel. Yeah. Okay. Now go.
See?
Oh, yeah.
At a certain time,
Yeah.
stop.
It's making you install that right in the middle of a
Yeah.
presentation.
Okay.
Okay, well, install
Thank
it and we'll be back. Okay, Sam?
Okay. Okay. I try to fix the problem, and then if there will be time, I will present the last part later.
Yeah, you
Sorry.
have to install Microsoft PowerPoint, looks like.
Uh-huh.
Okay.
Okay.
Okay, very
I'll
good.
try.
Okay, Sam.
Thank you.
Well, thank you.
Okay, we will shift to thank you with you. We
Thank
will wait
you.
for you for the next part.
Mm-hmm. I try.
Thank you. We will shift to next speaker, Karina Toledo. Karina Toledo, please start sharing your screen.
I close. It's better.
Okay. Perfect.
Okay, can you hear me?
Yes.
Okay, thank you. Hello to everybody. I'm so glad to be here with you. It's big pleasure to be part of Great Congress. Congratulations, Professor Same. You brought together all the leaders of the world of neurosurgery. Thank you so much. In the next minutes, I will to speak about microscopic approach of craniopharyngiomas. Dr. Kunal and Dr. Laco Angeli spoke perfectly about endoscopic endonasal approach. So the craniopharyngiomas are always a challenge. They arise a region of embryonic tissue around pituitary style. And in her history, benign, they threaten to compress and impair vital neighboring neurovascular structure. We had two theories about the etiology. The first is it arise of the craniopharyngeal conduct, and the second is the second it is the remaining tissue around pituitary gland. About epidemiology, up to 5% CNS tumor, and their incidence up to 2 cases for 100 million people, and the age presentation in children are 14 years old, in adults 65 or 74 years old. The more frequent localization or craniopharyngiomas are suprasellar, up to 75%, and the most frequent localization is intrasellar or infrasellar. The first classification is Morissaco, and this classification let me identify and choose the best approach for craniopharyngiomas. We had 4 types. The first type is intrasellar, the second type is prechiasmatic, the third type is retrochiasmatic, and the fourth type is intraventricular. We had another classification, it is Kazan. This classification is for endoscopic approach, and this classification is very similar than Morissaco classification, but it is described in endoscopic endonasal approach. We had other classification about the form. you can have a craniopharyngioma with form pedicle, seson, cat line, ring line, bow line, or circumferential. And we had another type that is not classified in previous classification, that is Gian. And the PUET classification, it is about hypothalamus invasion. We had 3 grades. The grade 0, it is a tumor. It's not in contact with the hypothalamus. The grade 1 it is a tumor, displays the hypothalamus, and in the grade 2, it is a tumor, involves the hypothalamus. So we had a histopathological classification, adenotinomatous and papillary, with their mutations. So in the treatment, it is important identify a neuron diagnosis or recurrent or case recurrent. In this case, the most important in the new diagnosis is do radical surgery. Radical surgery is up to 90%, but it's an option to do partial or subtotal resection with radiotherapy, or primary drainage of disease with or without radiotherapy. So then in recurrency, you have 3 options. Again, the surgery, radiotherapy with radiosurgery, or intracavitary instillation of radioactive phosphorus. You had always visual fields and hormone profile. It is indispensable in each patient. And one recommendation is one dose of corticosteroid the day before our surgery. We had transcranial approach, and we had endoscopic endonasal approach. And this talking is for transcranial approach. And this group, we had 4 groups: the anterolateral, the midline, intraventricular, and lateral. Disadvantage of the transcranial route, the endoscopic endonasal approach is shortest direct route to the tumor. There is not a rotation of frontal lobes, and the medial optic canal can be easily discompressed and explored. How can I choose the best approach for my patient? It depends on localization and invaders and localization of the hypothalamus and position with the pituitary style. We had again the Morissaco classification because this classification led me what approach is better for my patient. And the first case for intracellular type, I can use microscopic transsphenoidal approach or endoscopic and endonasal approach. For prechiasmatic type, I use transsphenoidal or anterolateral approach. For retrochiasmatic type, you can use anterolateral approach or lateral approach. And for intrathird ventricle type 2, you can use interhemispheric approach or translamina terminalis approach. The objective of anterolateral approach is centered deterrent. And that is the vision for anterolateral approach. In this picture, you can see the difference of vision between frontotemporal or orbitozygomatic approach. We had varieties of you can use transzygomatic approach or mini-terional approach. Transzygomatic approach was described by Camperostin, and the mini-terional approach was described by Natal-Steen. We had another approach between the the anterolateral approach. This is a supraorbital approach. And the access can be transsylvian, it is in sylvian cistern, sylvian fissure, and subfrontal approach. You can use another access, transcavernous, but it's not common use this access because the craniopharyngioma it is not common invade the cavernous sinus. Midline approach is for tumor in the central line. It doesn't have component lateral. There is interhemispheric transcallosal or transcortical transventricular. And the lateral approach, we had transpetrosal. That is this is for retrocellular or retrochival tip and without mobilization or transposition the pituitary star. The subtemporal approach is for retrocellular or retrochival type, but it is a narrow corridor and you can retract the temporal lobe. We had the first case. He's a male. He's 45 years old. You can see in the hemorrhage a lesion. This lesion is intracellular and supracellular, and they had a component retrochiasmatic. In this image, you can see the approach. I choose orbitozygomatic on right side, and you can see in the window between optic nerve and ACN, you can choose this corridor for reset the tumor. Another corridor is translamina terminalis. The lamina terminalis inside or the third ventricle, but you had blind spot. It's lateral to the surgeon. We had another case. She's 40 years old. In this case, I use a right side orbitozygomatic, and you can see the approach transsylvian in the system sylvian, and you can see the cut with microcisor and with a retractor. The frontal lobe, and you can see the resection of the capsule, and you can get a little pieces of the tumor between both optic nerve. You can see the second window. The second window is between the ACN and optic nerve and the optic nerve. It led you a good resection about these corridors. And the third corridor is about translamina terminalis. You can cut the tumor that is in the third ventricle. So you can the resection, a gross total resection, the hemostasis, and then the CT scan postoperative. Another case, and this woman is 45 years old. She has a history of her age, not visual deficit, not endocrine dysfunction. And this an MRI, and you can see and T1 on T1 a lesion, hyperintensity. It's very similar than cellular tuberculous meningioma, but the difference is in this case, the lesion in simple T1 are in hypertension. With the Morissaco classification, I use the approach. The approach I choose is right side terminal approach. In this case, I use two corridors. The first corridor is transsylvian fissure, and the second is subfrontal corridor. And you can see the cut of the capsule of the tumor, the capsule tumor, and you can see inside the tumor you can aspirate the more pieces as one as possible, and this is final view. With the resection, you can see the postoperative MRI, and it is a papillary craniopharyngioma. We had complication in the microscopic approaches. Yes. You know, the seizure, visual deficit blindness, hypothalamic lesion, stroke, psychological disorder, CNS leakage. It is a shell in the resection of craniopharyngioma. Always remember, up to 90% of postoperative patients will have hormone replacement therapy. And for the craniopharyngiomas purely cystic, we had stereotactic catheter placement and aspiration, or intracystic radiotherapy or chemotherapy. The morbidity rates for microsurgery treatment are 20%, and the mortality is 12%. The overall 5-year recurrence rate surgery only is the resection total. Total is up to 25%, and the partial resection is more 82%. Conclusion or mission to take home. We had 3 points. The first point, the surgery is the first line of treatment. We had 5 approach with advantage and disadvantage, and Morissaco classification is the principal classification for choose the best approach for the patient. We had individualized each case to offer the best treatment strategy for resection of the tumor. And thank you so much, Professor Same. Thank you so much, John, and thank you, everybody.
Thank you. Okay, Manuel, excuse me, Sammy, are you there?
Yes.
Right.
Thank you, Karina, for this excellent presentation. Is there any
Thank
question?
you so much, Professor. Congratulations.
Thank you. Now we'll shift to our next speaker, Professor Nicholas Khan. Please start sharing your screen.
Thank you, Senna. Let's see. It says someone else is sharing still, so.
Could you get off the screen? Yeah, Karina, could you exit the screen, please?
I think Karina will have to.
from your side.
Or Karina, could you please leave the screen?
You are the host.
Karina?
Okay.
Excuse me? Oh, okay. I'm sorry.
John.
Okay, that's okay.
Please
Okay,
make me
Nicholas,
host.
it's all yours.
Thank you.
There we go.
Please make
Great talk,
me
Karina.
host and I will manage it.
John, can you see and hear good here?
Yeah, that's fine.
Perfect. So I'm Nicholas Kahn. I'm the Associate Professor and Associate Residency Program Director here in Memphis, Tennessee. Certainly appreciate the invitation, Samet. Several
Yes.
years. I think you've done a fantastic job with this. So today I'm going to give a presentation on contemporary indications for intracranial and extracranial bypass surgery and our kind of microsurgical school of thought on this. I'd like to put a quick plug in for the meeting in New Orleans. So I'm the scientific chair of this meeting along with Jacques and Danny and Aaron. There's a great meeting which is combined with World Federation of Skull Base and North American Skull Base in New Orleans. It's going to be a huge meeting and we'd love to see everybody there. So just a brief overview of the talk, and we'll try to stick to time, but we'll go over indications, patient selection, some of the technical considerations, and then some case examples in order to summarize. So we'll start with just the basics. So, what are the indications in 2024 for cerebral revascularization and bypass surgery? So the most common is ischemic, either moya-moya or atherosclerotic, and we'll talk about each of those individually, or hemorrhagic, aneurysmal, oncologic tumors that are encasing vasculature, and then the unplanned injuries, the iatrogenic injuries. If there's a intraoperative injury during tumor surgery or spine surgery, that's an indication that sometimes happens too. So we'll start with the easiest and simplest. So symptomatic moya-moya disease and moya-moya syndrome. So when I have residents and fellows with me in clinic, 3 questions that always come up are, should you revascularize? When do you do it? And how do you do it? So we researched this. There was a great resident here, Vince Wynn, who did this paper with me, but we looked at this question. We did a meta-analysis that was published in Stroke, comparing all different modalities. And we came up with this conclusion, and we'll get to that. So combined strategy and direct strategy had clear benefits over indirect alone strategies in the adult moya-moya population. This is not randomized controlled trials. This is the neurosurgery literature, but that's what exists out there. So this is what the world literature says on this topic, but there's clear benefits if you look at the literature on this topic. This article was published in Stroke, and I encourage everybody that's interested in this to look at this. It's a nice summary of the literature on this topic. But in order, it's out of the scope of this talk to go through the nitty-gritty of that discussion, but I'd like to show this table. And this is kind of how we think about moya-moya disease and management now. So if they're symptomatic, they get revascularized. If they have a good STA with favorable collateral formation, then I'll do a combined procedure. If they don't have favorable collateral formation, they're not sprouting leptomeningeal collaterals and transdural collaterals, then I'll do a direct only. And there's different variations of how you do that, either one donor to recipient, single barrel, double barrel, and we can talk about some of the technical considerations. But this slide kind of summarized the decision-making involved in this. And these are just some ICG examples of each of the different modalities, either the double barrel in the top left or the single donor to recipient or the combined bypass. And this is a nice ICG just showing the flow differential that you can see between a direct and a indirect side by side. So, I think, having all the tools in your belt and using this in a nuanced fashion is how you get the best results. So that's our, thought process behind decision making of when do we do it, how do we do it, and what do we do. So all of this is published in a nice article summarizing the surgical techniques of how we do the procedures. And we're going to move on to atherosclerotic disease, which is a little bit more controversial topic, but I think there is still value in discussion of this. So 40% of patients with intracranial atherosclerosis have recurrent strokes in 2 years. In 2011, the COST study, the carotid occlusion study, really put the brakes on surgery for this. But, the COST study, I kind of see like Aruba or a sport trial. I think these are studies that, they have significant limitations. And I'll demonstrate, in some of these cases that we'll show, maybe where do we miss the mark with this. So, some of the limitations we'll just mention, lack of long-term follow-up, high perioperative stroke rates, the criteria for inclusion is only a single TIA or ischemic event. And then, how does that bring us to 2024, 13 years later? So this is modern clinical practice. This is a patient that has bilateral carotid occlusions 2 years post-op with a 1 donor 2 recipient with MRS of 0 and 0 recurrent ischemia. So I'd argue that, I'm not saying that everybody needs this, but there is a role for this in a select patient population. So we researched this topic. So we went to the world literature on this topic, just like last time, and looked at, well, what do the modern literature say on this topic? Since 2011, a lot of this has not been done at smaller centers. Most of this is being done at high volume centers. And we looked at this, we compared it to modern endovascular natural history cohorts from some of the intracranial stenting trials. There's not a great natural history cohort to compare to. We wanted to compare to, well, what does the medical arm of these studies show? So what do we find from this? And I'll encourage everybody, if you have time in your own time, to go and read it. Existing literature indicates that long-term stroke rates and favorable outcomes for revascularization for well-selected perfusion-dependent ischemia has improved over time. And improved patient selection, perioperative care, and surgical techniques may lead to improved outcomes. In my opinion, I think there's still a role for nuanced revascularization in select patients with atherosclerotic intracranial disease. And this is just a couple, just examples of that. So this is a double barrel for an MCA occlusion that's 1 year post-op. This is a radial jump graft for somebody that couldn't leave the ICU on Levophed that had recurrent ischemia, and every time her blood pressure dropped, she became hemiplegic. This is another double barrel 2 year post-op from an MCA occlusion. You can see the STA is hypertrophy to the size of the PCA. This is another 1 donor 2 recipient MCA occlusion 1 year post-op. And then, the list goes on. This is one I just did, last week, follow-up angiogram, 6 months post-op. This is a carotid occlusion that was symptomatic of perfusion ischemia. And how can you argue that there's not a role for this? So we can summarize this in this slide. So symptomatic atherosclerotic steno-occlusive disease in 2024. So they're all going to get medical management first. If they fail medical management and they have recurrent perfusion-dependent ischemia, if they have a focal stenotic lesion and it's a flow problem, then I think intracranial stenting is fine. If it's a very focal stenosis, though, if it's ratty and there's perforators and coming off of it, I think the results can be disastrous if you're not careful in how you select those patients. If they don't have favorable anatomy for stenting, then we go to the cases that I show you. And as you kind of walk down this pathway, the clinical reward and surgical risk, really kind of go in your favor the further you get down this pathway. And that'll lead us into oncological. So, these are cases of mine that have required balloon test occlusions, revascularization. So these are recurrent meningiomas, glomus tumors. These are the cases where you'll end up having to decide, is there a carotid sacrifice? That's where you do your balloon test occlusion. And, how do we do that? We do the standard balloon 3-second venous delay. There's a nice study several years ago that looked at this. And if patients have an ACOM and PCOM and there's certain anatomical circular Willis collaterals, you don't even need to do a balloon test occlusion. They're going to pass it. We still do it, obviously. And there's ones, if they don't have that, they're going to fail it. So in those situations, we'll go ahead and do the bypass up front. We're a selective kind of thought. There's universal versus selective, and selective, if they do pass the BTO, then we'll only do it if there's an EEG change or SSEP change during the time of surgery. If they fail the BTO, then we'll do the bypass up front. This is a nice article from a few years ago looking at the one donor 2 recipient configuration. This slide could have been a few slides earlier, but this is what I use in all the athero cases. I think this is really an elegant way in order to treat that disease because they're getting 2 vascular beds. The resistance is dropping. And I think this, the ones that have the best long-term outcomes and follow-up I've seen with this configuration. So this is what I do for pretty much all the direct-only cases. So we're going to go into a few case examples. We're going to try to stick to time here. So we'll skip this one. This was the radial jump graft from a while back. There's a couple I wanted to show. This was a nice case, so MCA stent with a recurrent stroke. So there's no endovascular option for this. The patient was stented. So we ended up doing a double barrel on him because he had recurrent ischemia. And we can show just some of the how that was done. If we actually use the endovascular transradial probe in order to map the STA, it gives really long graft sizes. So if you do all the stripping of the adventitia, sometimes we get flow rates up to 140 cc's from some of these donors just from the STA. And this is just some of the technique that's been shown by others in earlier talks, but this was a double barrel that we did for this patient. So we'll skip to the kind of conclusion on this one, but that was a nice indication for this. You can see the intracranial stent, you see the revascularization. Patient had 0 recurrent ischemia. This is an old case, probably a couple of years at least. This was, we'll skip this one. This was a pica vertebral artery aneurysm that we did occipital to pica bypass on. And we'll skip through this one because there's a couple other ones I wanted to end with. But actually, the one thing I did want to show in this was just the flow rate of the artery. So we'll skip to some of that, see if we can find where that exact point is. Here we go. So you can see it's 100 cc's a minute. So if you do a good job dissecting this donor out, it's hard to mess it up. It's going to be a great donor. And I think it's a great solution for this problem. So this patient's been seen long-term follow-up now, for this problem. No recurrent aneurysm, patent occipital to pica anastomosis. You can play it here. This was a more recent case, so this is just a few months ago. So this was a large ACOM aneurysm. Patient presented with bitemporal hemianopsia. Basically, he had a tuberculum cell meningioma, and he had this large ACOM aneurysm that you can see here. So we ended up taking him for an angiogram. We did a balloon test occlusion. This is his 3D anatomy that you can see here. So I was really not confident we were going to be able to preserve the ipsilateral A2 in this case from open surgical procedure. I did not think endovascular was good for this with his mass effect and the configuration. Really, the only option you would have would be a flow diverter, which I didn't think was good for this large aneurysm with the internal thrombosis that it already had. So this was his balloon test occlusion that we did, which basically proved that he had a patent ACOM. So the initial strategy was simple clip ligation and seeing if we can preserve the ACOM at the time of surgery. So I'll kind of show you some of the surgical video here. So you can see the optic nerves completely splayed, olfactory nerve, A1. So now we're going to go ahead and try to preserve the ACOMs. We're putting a fenestrated clip around the ipsilateral A2, and I'm not super happy. The aneurysm's trapped, but I do an intraop angiogram. There's not really good collateral flow. You see the pericallosal and closal marginal, but I don't see the opposite side filling. So I'd already prepared. I had interhemispheric cranie ready to go, so I went and Dopplered it, and it wasn't filling. So at that point, clips come off, and we have to escalate and do our A3 to A3 to move the ACOM up. And so that's what we did here. All through the same incision, we were prepared for this, but we escalated, incrementally the parts of the case. And this is the back wall, front wall, and nice ICG. So then now the case is actually quite simple. We just go and put the 2 trapping clips back on and we're done, and puncture the aneurysm to decompress it. And this was his post-op angio. So it's a nice dual volume angiogram. You can see on the left is red. So the left is a injection from the left side, but filling the right ACA, and the white on the right shows no filling of the aneurysm, no filling of the ACA. And you can see the anastomosis right there in the middle of the screen. And this patient's done great, no ischemic events, aneurysm's gone. This was him, maybe a month ago or so. This was another recent case from a few months ago. So this is a large MCA aneurysm with internal thrombosis, previously coiled from another institution. He had come to us with worsening mass effects. So you can see his 3D reconstructed angiogram in the middle. There was one inflow and outflow. You can see the previous coil. So basically he had a tumor. So our strategy here was surgery to remove the mass and remove the tumor, and also to preserve all the vasculature, not cause him any sort of perioperative ischemia in the process. I do not think there's another good endovascular solution for this. This was a picture of his STA, which we prepared on the way in. So this is kind of how we did the case here. So we'll skip through some of the harvest here of the STA. And you can see the aneurysm in the bottom left here. So now we've identified the inflow and outflow. We're going to go ahead and open the aneurysm, internally debulk it. You can see the coils from the prior procedures, and then we're going to remove the aneurysm once we cut the inflow and outflow off of it. So now that's removed, and now we have the inflow and outflow side by side. So actually, in this case, in order not, this is kind of a nice technical point, but not to move the artery, I clipped the old inflow slightly to the pia in order to, so it is not mobile. It holds it in place, and we just did it end to side with the outflow, and it was, I thought, a nice way to do that. We'll skip through some of the technical details. I'll take the outflow clip off in just a moment. You can see there's zero back bleeding from this. So we absolutely needed this, or we had a superior division MCA stroke. And there's the ICG showing patency of that. And he had another branch that we used the STA for, that can be seen there. And this was him in his post-operative period. Just to kind of conclude with a few points here. So if you do a good job stripping the adventitia on some of these ischemic cases, I mean, it's hard, like I said, it's hard to mess it up. I mean, the flow rate is really, really high here, but we've spent time removing the adventitia, getting a good donor. And I think that's a big part of your long-term success with these cases. This case is an interesting one too, so it shows that you can be creative. So this is a patient that had contralateral moya, and they had ACA ischemia because they had no A1. So we made a plan for revascularization of the ACA territory. So we did this by harvesting both the STA, frontal and parietal branches. This is interhemispheric, you can see. And then cutting the frontal branch. Then we do an end-to-end of the two branches, as you can see here. And even with that, there's great flow. Even with all that length, you think of Poiseuille's law, there's still great flow. And if you've done a good job with a donor, it really makes a big difference. So now we're going to go ahead and do our STA to STA to distal A4 anastomosis, and that can be seen here. And we've shown this several times. We won't go through all the technical details of that. But when all that's done, you can see a nice ICG filling the whole territory there and a patent long anastomosis. So a few concluding thoughts. So, who are the patients that benefit the most? I think those who have the most favorable pressure gradient, those with favorable recipient and donor anatomy. Which type of constructs work the best? We touched on that a little bit. I firmly believe there's nuance to this. Training, how do we rate surgeon readiness? And how do we use technology to assist in our outcomes? Occasionally, I'll use a Dyna stealth to select my recipient strategically in the area that is most ischemic with the most favorable pressure gradient. I think that makes a difference. And how do you have the best outcomes? It's a combination of not just the technique and the art of surgery, it's also a combination of the science of surgery. And you have to have both in order to get the best outcomes. You have to use the literature out there to choose the right patients and right patient selection. And you also have to have the right technique and the right practice in order to get the best results. And lastly, again, I'll put another plug in for the NASBS meeting in New Orleans. It's going to be a great meeting combined with all the World Federation societies, and we'd love to see everybody there. Thank you, Simon, and fantastic job setting all this up.
Thank you, Nicholas, for this excellent presentation. Is there any question? Thank you. Back again to Mauricio. Please start sharing your screen.
Okay, thank you. Thank you, Sameh. I hope to have fixed the technical issues. As I already explained to you, I try to apply the skull-base concept philosophy for intraparenchymal lesion. And one of the concepts is that, especially for the young generation, they identified the minimal invasiveness on endoscopy. Endoscopy is a part of skull base, but all the other approach, open approach, could be even less invasive than some endoscopic approach. This is the case of this aneurysm, in which the neck was just in front of us from the anterior approach, we could use the endoscopy, but the endoscopy in some time does not offer a great working angle. So we try to take advantage of the anterior approach, but with the transmaxillary approach. And as you can see, only a thin wall of bone separate the neck of the aneurysm that was innovated in the brainstem to our view. And we succeeded to fix the patient. And this is a short video of the approach. Looks quite an invasive approach. But if you see the patient 2 weeks after the operation, the patient is completely in good condition. Just you see the stitch in the mouth that document the recent operation. So we have to select all the possible instrument and approach that we have. This is the preparation of the aneurysm. You see just in front of us, and you see how the sac was innovated inside the brainstem. And but there was enough space, enough angle to prepare the aneurysm and clip it easily without manipulation of the brainstem. This is the important. Whenever approach we use, we have to avoid the manipulation of the healthy tissue of the structure. But sometimes the open approach and endoscopic approach can be work together. This is the case of a chordoma. The idea was to because the patient was having a fast deteriorating hemiparesis. The aim was to approach from the anterior the lesion, decompress the brainstem, and then make the anterolateral approach, Bernard George-like, or we use the submandibular, transmandibular approach. And this was a good choice because you see the lesion was strictly adherent to the vertebral artery. And can you imagine if we pull out this part of the tumor, but under endoscopic view, we cut the engulfed the vertebral artery, and then the lesion was removed. But it was quite risky to pull out the lesion without an efficient preparation. Then the patient was operated to a submandibular approach by our head and neck surgeon. We remove the lesion and then insert a bone bank bone graft in order to restore the anterior spine column. Sometimes the approach is made together with one open maximum invasive approach from above and one minimal invasive approach from the nose. And you see here the light of the endoscope, just to see that at the end we meet together from above and from below. So just to conclude, there is in the jungle of the possible approaches that we can select one rule, that we have not to touch the brain. We can drill the bone, we have to follow the corridor, and but the rule is try to not manipulate the brain. Even some quite old-fashioned or classical approach, even in the robotic era, in the endoscopic era, is not obsolete. Endoscopy and open microsurgery are not competitors, but are allied. And we always seems that we discover something, but If you look at the history of medicine, this is one sentence of Emil Kocher, Nobel Prize one century ago. And he said, approach should be as large as necessary and as small as possible. That is exactly the sentence of the minimally invasive philosophy and approach. I thank you, Sameh, and the organization for this wonderful meeting and occasion to meet friends from all over the world. Thank you.
Thank you, Mauricio, for this excellent presentation. Is there any question? Thank you.
Thank you.
And now we'll shift to next speaker, Dr. Ali Bangash.
Do we have the next speaker here, Sam?
It should be Ali Bangash. Okay, I will call him. You can play our promo until I call him.
I'm having a hard time understanding you, Sam. Can you text me or something? Who's the next speaker, Sam?
Ali Bangash. Okay, you can play the promo until I call him.
Okay, Sam, I can't understand you. I'm sorry. Can you write what you say? Text me.
Play the promotion video.
Sam, I can't understand you. You need to text me, please. Okay, Sam, text me the plans, please. Oh, no, no, not gonna do that. I don't want to do that, Sam. I don't want to mix that with the conference. Sorry about that. We can take a break if you want, or I can see if Manuel can come in early. You want me to call Manuel? Sam?
Yes, please. But Manuel has a technical problem.
Okay,
He can't join.
let me get a help. Let me call him right now, okay? So we just have Manuel and Michael, right?
Manuel or Michael. Any one of them.
Okay, Manuel must be tied up, not answering. And hold on, let me see if I can. We'll just call us a break, Sam.
Okay, I am calling Emmanuel and he will come now. He is just facing a technical problem in joining.
Can't understand the word you said, Sam. Can you write it down, please? I know it must be frustrating.
Manuel is coming.
Okay, Manuel's coming. Good. Okay, stand by. Oh, there's Manuel.
Hey, John, how are you?
Okay, Sam. Sam, are you there? Yeah, we've been wrestling with bad connections with Sam.
Yeah, I have a problem, John, with my Hotmail account. It was blocked, so I cannot receive anything by my Hotmail account, unfortunately.
Yeah, well, I can send it by you. I could send it by WhatsApp.
Yeah. Everything send it to me by WhatsApp because I was using VPN because, I am in Russia, so I have some issues.
Okay, very good. Can't get a hold of Sam here, so okay, let me introduce you and you can go ahead. Okay, Manuel?
Yeah.
Okay, Manuel, I've known for a while. He's been in Russia, he's been in Dominican Republic. He's on the edge of everything with new tech. Okay, Manuel, time's yours.
Yeah, thank you so much, John. It's a huge pleasure for me to be here. I will share my screen and you will see it now. Give me a second. Yeah. Are you seeing my screen now, John?
Hold on. Yes. Make
Yeah,
it
fantastic.
presentation mode, Manuel.
Yeah, everybody see my screen, right?
Yes.
Yeah, perfect. So I will start to talk about the metastasis in the craniovertebral junction and the implication. Here I am showing you the Parthenon of Athens. It's like the region of the craniovertebral junction. It have the pillars. Is what gives the support for our head. Okay, but if we make a surgery not properly, disaster. This is what we're gonna have, the instability. And the instability in the craniovertebral junction is quite difficult, okay? So first, and no less important, is learn neuroanatomy. Go to the cadaver lab. Go to the cadaver lab. And when you think you know everything, go back to the cadaver lab. Remember, the metastases of the craniovertebral junction are the most affected tumors are metastases in less than 1%. Less than 1% are metastases. 35% of this amount of tumors are from breast cancer. 30% prostate cancer, and 10% is lung cancer. The route this metastasis take is hematogenous, okay, by blood. And usually it's people over 60 years old. 22%, even more, even 30% of the patient will have a myelopathy, okay? And all of them usually gonna have the axial subluxation. So remember this. In some cases, this patient gonna just receive palliative care, okay? Remember the dislocation in the fracture dislocation, it will if it's more than 5 millimeter, or if the subluxation is 3.5 or more than 11 degrees, yeah, it will need to have some surgeries. Remember, spinal cord compression, and the tumors are radio resistant, okay? So remember, this is some of the data. A retrospective study by Anderson shows 19 patients with metastasis from the 1994 to 2001. This is the result. The survival rate of this patient is 6.1 months, okay? Occipital-cervical stabilization provide lasting pain relief, and the patient can have his life ambulatory through the rest of these 6 months, okay? So remember, subsequent instrumentation. Not all of them need instrumentation. We need to pay attention to that part because remember, this is the end of the skull base, okay? Usually in the skull base, you say no instrumentation, but this is the end. This is the end of the skull base, the beginning of the spine, okay, of the cervical spine. Remember, the mechanical pain, the rotation, the torticollis the patient will feel after we make the surgery, okay? And pay attention to this, if we remove more than 70% of the condyle, absolutely we provoke an instabilization. Then we will need to make an stabilization, okay? So remember, for the metastasis of the craniovertebral junction, we will have different ways to go there, different ways. You choose. Anterior, posterior, all depends in a lot of factors, okay? For example, we can go endonasal, transoral, transmandibular, cervical. Posteriorly, we will go for lateral or lateral approach. All of them taking care. Remember, all patients are different, all metastases are different. And then what will be after we perform the surgery? It's going to be stability, instability, or even though the patient need the surgery, okay, we made the surgery, it's palliative care. So let's go move forward and let's talk about it. This is the first case, was a male of 52 years old, have a melanoma metastasis. And look this case. As you can see, the patient have this, sorry about the sound. Yeah. You can see the mass was an osteoclastic mass, involved all lateral mass of the left cervical vertebra, the left condyle, and also involved all the vertebral artery. You can see it here. You can see in here also. Yeah, in this case, which one will be the best approach we can perform from this surgery? It's an open question. Yeah, in this patient, we believe for lateral approach will be better. Yeah, you can see here the the long incision. But during this surgery, you remember when the metastasis involve all the vessels get more soft. Then we have inadvertent injury of the vertebral artery. And I will tell you, I will explain you what we did in that case. And after we was performing the transcondylar approach, also we have the inadvertent injury of the jugular vein. So what we do in this case? In this case, what we did, you can see we remove all the all the mass, all the tumor. And then for this bleeding, what we did was muscle. In this case, what we did was coagulate muscles. Why? Because remember, when we use the coagulate muscles, it activates the factor 10A and the factor the factor 5A of the coagulation and activate the myosin. It's a very affordable, very fast, and function absolutely amazing with this kind of patient. You can see here some of the articles talking about this kind of case, and you can see the patient. This video was with the permission of the patient. The patient after the surgery, you can see here the result. Of course, we make the stabilization. Sorry, because I didn't show to you the the post-CT scan. Then we make the occipital plate, and we make instrumentation in 2, 3, and 4.
Yeah, excuse me, Manuel, your slides aren't moving.
Beg your pardon?
Your slides are not moving.
It's not moving. I put the video. Do you see the video?
Okay, now I do.
Yeah. Okay, did you saw this one?
I didn't see that before, no.
Oh, sorry. Okay. This is the part of the procedure while we was removing the tumor. You can see here the tumor, and we make a instrumentation occipital. We put the occipital plate and instrumentation in C2, C3, and C4. You see my screen, right?
I see the screen,
Yeah.
right.
Then for this bleeding, what we used was a coagulate muscle, because the coagulate muscle activate the factor 10A and factor 5A of the coagulation and finish becoming a myosin. Then it's coagulate very well in this kind of patient. It's a very affordable method for coagulation in this kind of cases. Here, I am showing the video of the patient. The patient have this bleeding of the vertebral artery and don't have any neurological sequels. You can see here the patient.
Okay, we're on the same slide.
Sorry?
You can see the slide, right? That's what the slide we're on.
Yeah, the video. You see the video, right?
No, the video's not working.
Okay, now you see the video?
Yes.
Okay, so I am showing the patient after the surgery. You can see the patient don't have any neurological, any neurological deficit. Yeah, so this is an example of the bleeding I was explaining you. As my professor Herbie say, keep calm, take muscles, relax, coagulate, and put it there. It's a very good patch for this kind of bleeding. So I will go for another case. John, please remember me with the time, okay? So yes. 59 years old patient, positive infiltration of the ductal type 3 tumors, Karnovko 70%. So, sorry. Remember also, I put this because in some kind of cases, we believe it's better to perform a pre-surgical preparation of the self-patient 3D printing. Very affordable, very easy to do, and very fast to do. 2, 3, even 1 week before of heart surgeries, especially in young neurosurgeons, is very good for practice this kind of heart cases. So here you can see a long stabilization and with the cylinder with cement. Another case, as you can see here, a plasmacytoma. Remember, with this kind of patient with plasmacytoma, myeloma, we have a lot of this kind of patient, and we have the problem of the bone density, of the quality of the bone. So we need to remember it and put this kind of patient in celedronic acid, for example, treatment before we're going to perform the surgery. You can see here, again, a long instrumentation. Another chordoma patient. So then you're gonna need to think, okay, I go anteriorly, I go posteriorly, or I go laterally. In which way is gonna be better? So remember, wrong operation, be aware of the 3WE. Wrong operation on the wrong patient and the wrong surgeon. Another patient with the metastasis, you can see here. What we do in these cases, the metastasis is outside of is compression the spinal cord laterally, posteriorly to laterally.
I'm sorry,
So
Manuel,
in this case,
the slides are not moving.
yeah. So you see him.
You've got to manually do it because you know.
Oh, okay, no problem. Sorry.
Okay, no
so
problem.
As you can see here, another patient metastasis. You can see here. You can see here the metastasis is more posterior and laterally, and this metastasis was anteriorly to the spinal cord nerve, to the root. Okay, so what we do in very affordable way, we can do it. We did in 2 centimeter incision. We use a syringe here. You can see here, and we use as a tubular retractor. In that way, we remove this metastasis because it wasn't isolate one metastasis. So we don't need to make a long instrumentation in a patient. We know the quality of the metastasis of the patient. Remember also the economic situation of some patients is something we need to always think about it. So for this, sometimes we use only decompression surgery, and we make a corpectomy, but we use only cement. Why no use the cage? Because not all the patient can afford to pay the cage, or not all the public system have the possibility. Another one, as you can see here, sorry, this is, you see here? So this is the same patient after we remove the isolate metastasis here. Again, another way we can use for reduce our time preparation is augmented reality. With augmented reality for some kind of tumors, we use it, and it can save more time for preparation, and it can save more time during the operation room if we don't have a very fancy and expensive navigation system. So another kind of patient, when we will go transoral or transnasal approach, yeah, if we have some kind of tumors, it's very anteriorly to the spinal cord, and here is give us a very soft plane of dissection. We don't need to go posteriorly and make a long instrumentation. If we, in this case, you can see here the pathology was anteriorly to the spinal cord and very attached to the posterior border of the axis. Then what we do is transnasal approach, and here you can see the result. We remove the inferior border of the bastion. We remove also the anterior arc, part of the anterior arc of the atlas and the axis. Then you can see here, and we can remove all the pathology by this endoscopic transnasal approach. Why in this kind of patient, maybe you can ask why you don't make a long instrumentation? Because this you can see the quality of the bone of this patient was a multiple myeloma patient. Something else we are working is, this is something in the future, we're making a line cellular tumors in marine patient of the breast cancer metastasis to the vertebra. And we are studying this kind of metastasis tumor. So this is something it's coming up next. John, I am good with time? Okay, so sorry. The take-home message is the craniovertebral junction and the majority of the tumor are the breast cancer, prostate, and lung cancer. We need to pay attention to the instability we can make after the surgery to the patient. Then we need to think which kind of approach we will make, which one is the most advantageous for the patient, anteriorly, posteriorly, or laterally. Anteriorly, we have a huge possibility: transnasal, transoral, cervical. Posteriorly, we can go posterolateral, we go just posteriorly or laterally. So thank you so much here.
Okay, very good. Thank you very much.
Remember because I always need to put this, John. Remember, one day when you are not here, you will be what you have done, and in the way we change other people's life.
Yes. Okay. Okay, Manuel, can you get off the slide share there for a sec?
Yeah.
Very good. Thanks very much. Any comments or questions for Manuel from the panel? Okay, if not,
Yes.
go ahead, Maurizio.
How do you select properly the transoral and the transnasal approach? From the transnasal endoscopic approach, which region you can control? I'm talking about metastasis, not meningioma.
Yeah.
Metastasis.
Yeah. For example, if it's the superior cervical segment, for example, no inferiorly to the inferior border of C2, and it's in the bastion, I can go easily transnasally, for example.
Mm-hmm. And what the transoral approach add something more, if not,
more space.
And do you modify the split of the soft pala is not necessary in the transoral approach, I mean?
No. That's for example, in the way I learned with Professor Hervis, we don't need to split the soft palatine. What we do is we can just separate or make a suture it in and separately, and you will have a lot of space for work.
Okay, when you stabilize the patient, posterior or anterior, or
for example,
the transcervical screw.
So something we figured out is, metastasis patient bone density is not very good. It's not very good. Usually, all these patients we put in celedronic acid better than denosumab, and then some of them we put a cylinder. In some of these patients, after we make a transoral or a transoral approach, we put a cylinder in the bastion to the body of C2, for example. Or if the quality of the bone is good, and then we can go posteriorly for occipitocervical stabilization. But usually in this posterior stabilization, we prefer more the transpedicular screw position.
C1, you mean, or C2?
No. For example, we don't touch. Usually, we don't touch C1. We left C1 free. For example, in the first case I present, we left C1 free, but we put till C4 the screw position, the screw stabilization.
You mean the pedicular screw?
Yeah. The pedicular screw. We put occipital till C4.
You make this freehand or by the neuronavigation, under neuronavigation, the pedicle screw?
No, we make a freehand. We make with freehand.
Okay.
But if there is a navigation, of course, it's going to be always
Safely.
better, of course. Because, the risk of the vascular injury is that's the problem.
That's the problem.
But yes, but it fits better. The pedicular one fits better than to the lateral mass.
Lateral mass, of course, yes.
Yeah.
Thank you.
Yeah, to you. Thank you.
Thank you for this nice discussion. And now we'll shift to next speaker, Dr. Ali Bangash. Please start sharing your screen.
You know, Sam, I didn't see him. Is he in the panel? Do you see
Yeah,
him?
please upgrade him to panel.
Oh, okay. I don't recognize the name up there. You're the host, Sam, so I don't see him in the panel. I don't see him in the attendees either.
Now he is coming. Okay, Dr. Ali, please start sharing your screen.
For sure. Can you see it fine now?
Yes.
Great.
Okay, you want to put it on presentation mode, please?
You got it.
There you go. Perfect.
Good evening, everybody. Thank you for providing me with the opportunity to present a brief overview of applications and challenges of machine learning for delayed cerebral ischemia prediction in subarachnoid hemorrhage patients. Subarachnoid hemorrhage, often caused by ruptured aneurysms, is a severe condition with high mortality rates. And its major complication, delayed cerebral ischemia, affects 30% of survivors within 3 to 14 days post-subarachnoid hemorrhage. Given that DCI is characterized by reduced blood flow to brain regions and can lead to stroke, early detection is crucial, which is where our discussion on machine learning applications comes into play. Early prediction of DCI is not just about improving individual patient outcomes, but also about optimizing healthcare resources and tailoring treatment strategies. By identifying high-risk patients early, we can implement proactive management, potentially reducing hospital stays and long-term complications, which also ensures more efficient use of intensive care resources. It is a powerful tool for enhancing clinical decision-making and advancing research by supporting evidence-based management strategies and facilitating the development of new preventive therapies. Early prediction methods can significantly contribute to our understanding of DCI pathophysiology and thus improve the overall outcomes for this patient cohort. While traditional methods for predicting DCI, such as clinical scoring systems and neurological monitoring, have been valuable, they come with significant limitations in accuracy, continuity, and resource efficiency. Advanced imaging techniques offer more detailed insights but are often resource intensive and may expose patients to radiation, highlighting the need for more sophisticated and less invasive predictive approaches. Machine learning approaches offer compelling advantages, including the ability to integrate diverse data sources, recognize complex patterns, and provide continuous personalized risk assessments. These capabilities, coupled with improved predictive accuracy and the potential for automated monitoring, positions machine learning as a powerful tool to overcome the limitations of traditional methods. In the realm of healthcare event prediction, a diverse array of machine learning algorithms have been employed, ranging from traditional supervised learning methods, including logistic regression and support vector machines, to more complex approaches such as artificial neural networks and deep learning architectures. Each of these algorithmic approaches offer unique strengths in handling different aspects of medical data, may it be the interpretability of decision trees, the pattern recognition capabilities of neural networks, or the dimensionality reduction offered by unsupervised learning techniques. Beyond the choice of algorithm, the effectiveness of machine learning in healthcare prediction often hinges on sophisticated hyperparameter tuning and feature selection techniques. Ensemble methods, including boosting and bagging, can significantly enhance predictive performance, whereas techniques such as lasso regression and recursive feature elimination help in identifying the most relevant predictors, which are crucial to the complex landscape of DCI prediction. When applying machine learning to healthcare events, such as DCI, we're often dealing with tasks such as binary classification, risk stratification, and our time to event prediction, each requiring careful consideration of the approach. Equally crucial are the broader implications of these models, including their interpretability, their ability to handle imbalanced data sets, common in medical contexts, and the critical need for robust external validation to ensure generalizability in the diverse patient populations. The power of machine learning in DCI prediction lies in its ability to integrate and to analyze a wide array of patient data, encompassing both clinical and radiological features, from demographic factors and medical history to detailed neurological assessment and imaging findings. These models can potentially capture complex interactions between variables that might elude traditional predictive methods. The scope of data utilized in ML models for DCI prediction extends beyond clinical and radiological features to encompass laboratory parameters, physiological monitoring data, and treatment-related factors. And this comprehensive approach allows these models to capture subtle interactions between various biological markers, hemodynamic variables, and therapeutic interventions, potentially offering a more nuanced and dynamic prediction of DCI risk. Logistic regression and support vector machines. They represent two fundamental supervised learning approaches in DCI prediction, each with its own strengths and limitations. While logistic regression offers interpretability and efficiency, particularly valuable in clinical settings, SVMs excel in handling complex, high-dimensional data, though at the cost of reduced interpretability and increased computational demands. Megajani et al. Adopted a machine learning ensemble approach, integrating logistic regression and support vector machine classifiers to generate hourly risk scores based on vital sign data. And performance across the institution showed high predictive accuracy, with external validation achieving as high as 90.9% of accuracy in detecting DCI events up to 12 hours before clinical confirmation, enhancing early intervention potential. Thus, it achieved the highest AURC curves, especially when trained with data from the 7 days leading to DCI onset. And this ensemble model was chosen for generating hourly risk scores due to its balance of sensitivity and specificity across the validation datasets, outperforming individual models by reducing overfitting risks. Decision trees, random forests, and artificial neural networks represent a spectrum of supervised learning approaches, each offering unique advantages in DCI prediction. While decision trees provide high interpretability, random forests enhance predictive power through ensemble learning, whereas artificial neural networks excel in capturing complex patterns, though each comes with its own set of limitations, ranging from overfitting risks to reduced interpretability. The decision tree model developed by Hugh P. et al. Exhibited moderate performance for DCI prediction with an AURC of 0.83. In the internal validation, however, it underperformed in external validation with the AURC of 0.76, making it less generalizable than other algorithmic models. While the decision tree was outperformed by ensemble methods, including random forest and extreme gradient boosting, it provided interpretable predictions that highlight key factors, including subarachnoid clot density and white blood cell count. The multi-layer perceptron neural network developed by Azam AY et al. Demonstrated significant predictive performance in identifying DCI cases, achieving an accuracy as high as 93% and an F1 score of 0.85. Its ability to capture complex, non-linear relationships among multiple input variables, including WSBC and other clinical metrics, underscored its potential as a valuable tool. Martini et al. Employed gradient boosting models to predict DCI, leveraging a hierarchical clustering approach based on SHAP values to quantify the feature importance and interaction effects. This hierarchical clustering enabled the identification of key predictors, including age, GCS score, and cerebral infarction, which facilitated insights into patient profiles most likely to benefit from tailored rescue therapies. While we have explored various machine learning algorithmic models developed so far, it's crucial to recognize that the foundation of any successful prediction model lies in the quality and preparation of its input data. Let's just discuss that in the context of DCI prediction. The landscape of data sources for DCI prediction is vast and it's diverse, ranging from structured electronic health records to complex physiological monitoring data and advanced medical imaging. While each source offers unique insights from the longitudinal patient history in EHRs to the real-time physiological status from monitoring devices, the integration of these varied data types, including the promising but currently limited use of genomic data, presents both opportunities and challenges in developing comprehensive prediction models. Pre-processing techniques form the critical bridge between raw data and effective machine learning models, encompassing a range of methods from basic data cleaning to sophisticated feature engineering and dimensionality reduction. And these techniques should not only address common challenges such as missing values and outliers, but also they should also enable the extraction of meaningful patterns and the development of robust features, ultimately enhancing the performance and reliability of our predictive models. When dealing with complex medical data from subarachnoid hemorrhage patients, proper temporal alignment and text processing are fundamental steps that will ensure our machine learning models are able to effectively integrate diverse data streams, including continuous monitoring data and clinical documentation. The transformation of unstructured clinical notes into structured machine-readable features, combined with the careful synchronization of time series data, will allow us to capture both the temporal dynamics of patient conditions as well as the rich contextual information which is contained in clinical observations. The development of optimized prediction models for DCI subarachnoid hemorrhage patients presents several unique challenges which require careful consideration and innovative solutions. I shall take some time to discuss these critical challenges and their implications for machine learning implementation in this specific clinical context, highlighting both current limitations and potential pathways forward. The major data quality challenges that are encountered in subarachnoid hemorrhage prediction modeling or DCI prediction includes missing data, which is particularly prevalent in clinical settings, inconsistencies across institutions and time periods, measurement noise and entry errors in both physiological and manual data, as well as the inherent class imbalance in DCI occurrence. These challenges are interconnected. For instance, missing data patterns may correlate with institutional practices, whereas class imbalance can become more pronounced when dealing with noisy or incomplete data, making it critical to address these through a comprehensive, systematic approach. The development of a robust prediction model for DCI is significantly hampered by data quantity limitations too, with most studies restricted to small sample sizes, under 500 patients, and often confined to single institutions, which fundamentally constrains both the model performance and generalizability. And now this challenge is further compounded by the relatively rare occurrence of DCI events, as I indicated earlier, making it difficult to capture the full spectrum of clinical presentations and potentially limiting the ability of models to recognize various manifestations of the condition. Feature selection in subarachnoid hemorrhage prediction modeling should achieve a complex balance between managing high-dimensional data with limited samples, identifying truly predictive features, and appropriately capturing temporal dynamics that are crucial for DCI prediction. The challenge is further complicated by the presence of multicollinearity in clinical variables, requiring us to carefully navigate between maintaining clinical relevance and statistical robustness, while also ensuring our models remain both interpretable and stable across different patient populations. While advanced machine learning models can achieve high predictive performance for DCI, their clinical adoption is often hindered by interpretability challenges, particularly explaining how complex nonlinear relationships between features contribute to individual predictions over time. This tension between model complexity and interpretability is especially critical in the clinical context of subarachnoid hemorrhage, where healthcare providers are required to understand and trust the model's decision-making process, necessitating sophisticated approaches to feature importance analysis and the visualization of temporal prediction patterns. External validation represents one of the most critical yet under-addressed challenges in DCI prediction modeling. where the scarcity of independent datasets coupled with significant variations in patient population, care protocols, and feature availability across institutions severely limits our ability to assess true model generalizability. This challenge is further complicated by the temporal evolution of clinical practices and inconsistent performance reporting across studies, highlighting the urgent need for standardized validation frameworks and multi-institutional collaborations to advance the field towards clinically implementable solutions. To overcome the multifaceted challenges in DCI prediction modeling, we can implement a comprehensive strategy combining advanced statistical methods, including sophisticated imputational techniques and robust feature selection, collaborative approaches that facilitate multi-center validation and data sharing. Equally important is the integration of modern interpretability tools, including shape values and line, which can transform complex models into more transparent and clinically actionable decision support systems, bridging the gap between statistical performance and practical clinical utility. Implementing robust external validation requires multi-center collaborations and standardized reporting frameworks, including TRAPPED guidelines, to ensure our prediction models stay reliable, generalized across different clinical settings, as well as time periods. By leveraging public datasets when available and employing rigorous time-based validation methods, we can better assess and enhance the real-world applicability of our models, ultimately working towards more reliable and clinically useful prediction tools for delayed cerebral ischemia. The future of DCI prediction modeling lies in the convergence of multi-center collaborations, dynamic prediction capabilities, and advanced interpretability techniques, working together to create more robust and clinically applicable solutions. By integrating diverse data sources and leveraging sophisticated methodologies, including explainable AI and real-time analysis, we can move towards comprehensive prediction systems that not only achieve high performance, but also seamlessly integrate into clinical workflows while maintaining both transparency and interpretability. The evolution of data prediction requires to move towards more sophisticated yet clinically integrated approaches, combining personalized risk stratification and federated learning with causal inference methods, all while maintaining strict ethical standards and data protection protocols. These advancements, particularly when implemented through user-friendly clinical decision support systems, promise to bridge the current gap between predictive analytics and practical clinical applications. Though success will depend heavily on carefully balancing the model complexity with clinical utility and ensuring continuous validation of these systems. Unsupervised learning approaches do also offer promising avenues for discovering natural patterns and subgroups within subarachnoid hemorrhage patient populations, with techniques including k-means clustering allowing us to identify distinct DCI risk profiles, whereas dimensionality reduction methods such as PCA-TSNE providing us powerful tools for visualizing and understanding these complex patient groupings. The application of these techniques should represent a paradigm shift from purely predictive modeling to a more nuanced understanding of patient subgroups, potentially leading to more targeted preventive strategies and personalized treatment approaches. Unsupervised learning techniques shall potentially offer unique advantages in DCI prediction by uncovering inherent patterns in patient data that might be missed by traditional supervised approaches, potentially revealing novel patient subgroups and informing more targeted feature selection strategies for predictive models. However, these methods come with important limitations, particularly in critical interpretability and parameter selection, highlighting their role as complementary tools rather than standalone solutions in the broader landscape of DCI prediction modeling. And I will leave you all with these points. So while the machine learning shows tremendous promise for improving DCI prediction and risk stratification in subarachnoid hemorrhage patients, its successful clinical implementation depends on addressing critical challenges through standardized modeling approaches, rigorous external validation, and systematic exploration of both supervised and unsupervised learning techniques. The path forward requires a balanced approach which combines methodological rigor with practical clinical applicability, ensuring that these advanced analytical tools can be effectively translated into improved patient outcomes through validated, standardized protocols. I thank you all for your attention, and I would be happy to take on any questions. Thank you.
Okay, thank you very much. Any comments or questions from the panel? Okay, thank you. Okay, one more webcast. Kristen Akani, are you there? Could you come on the screen?
Yes, I'm here. Thank you.
Okay, it's all yours.
Okay, great. Thank you so much. Okay. We'll get started. Thank you so much for having me today. My name is Kristen Eshanique. I am now at Rutgers Health. I'm an assistant professor in the Department of Facial Plastics and Reconstructive Surgery, Department of Otolaryngology, Head and Neck Surgery. I did my fellowship training at Cleveland Clinic with Dr. Patrick Byrne, and I'm going to be going over what we used for decision-making regarding early intervention with facial reanimation surgery following CPA tumor resection. I have no disclosures. So today we'll talk very briefly about vestibular schwannoma resection, those that involve an intact facial nerve at the conclusion of the case, and those that result in facial paralysis. We'll go over nerve grafting and talk about early versus late strategies, what your options are when there's been a time elapsed of greater than 24 months, and then we'll end with some conclusions. So as you all know much better than I do, vestibular schwannoma surgery has taken a drastic change over the last entire century rather. In the first half of the century, the surgery was centered around resecting the tumor and reducing surgical mortality, which still remains paramount, but now we're very focused on minimizing cranial neuropathies for these patients with benign tumors. We want to limit hearing loss and we want to preserve facial nerve function. Over time, the history of vestibular schwannoma surgery has evolved. In the early 1900s, the facial nerve was often sacrificed, invariably, because we were not yet using microscopes. In 1931, Dr. Kames reported the first preserved facial nerve following a resection of a vestibular schwannoma. And in 1961, the operating microscope was introduced. 1979, we started using intraoperative EMG monitoring, and all of these things together led to improved rates of facial nerve preservation. While today we can preserve greater than 90% of facial nerves when resecting vestibular schwannomas, that doesn't always translate into preserved function upon awaking from anesthesia. So facial paralysis is a significant issue for patients. Some patients with vestibular schwannomas present with facial paralysis. Some of them, this is a sequela of the surgery, even if the nerve is left intact. This leads to significant psychosocial effects, functional and cosmetic consequences. These patients struggle with oral incompetence and cannot eat in public or even at home. They can undergo issues with the cornea from the cornea being exposed and can lead to blindness. Overall, they have adverse impacts on their quality of life, increased rates of depression, poor self-esteem. And interestingly, in a study asking about the patient's perspective after resection of acoustic neuromas, they reported that the facial paralysis that they struggled with postoperatively was one of the most difficult aspects of their recovery. So in these patients with postoperative weakness, when they wake up with some function, a high number of those patients will recover spontaneously and regain what we consider satisfactory facial movement that maybe does not require intervention. Patients who have a complete paralysis postoperatively can go one of two ways usually. Some will recover spontaneously without any intervention, but others will experience no recovery whatsoever despite an intact nerve and will go on to require intervention. When we think about postoperative nerve grafting, there's two main things that we can do in the early period. So one of them is a hypoglossal nerve transfer, where you can see here outlined, we have our neuro-otology colleagues drill out the nerve for us in the temporal bone, and then we reflect it down and we anastomosis to the side of the hypoglossal nerve, as you can see here, demarcated by this arrow. There are issues with taking the hypoglossal nerve, and so we no longer use the entire nerve you can take 30% of the axons and actually, anastomose it higher up on the face, but a lot of times we'll just do an axonotomy here and attach it here. This will restore tone in patients where this is successful, but this does not contribute to postoperative facial motion. For those patients, we do a selective nerve to the masseter transfer, where we take the masseteric nerve in its entirety, dissected here, and we find a selective buccal branch that's going to allow the patient to have oral commissure excursion and have a normal smile. This requires postoperative physical therapy. They have to work closely with a PT, and they learn to bite, and they can have excursion of their oral commissure. And so this restores function. So the timing of these grafts is incredibly important to restore facial tone and animation. And the goal is to minimize irreversible degeneration of facial muscles and minimize poor functional outcomes after these types of surgeries. So early nerve grafting is classically thought we wait 1 year before we do anything. That's what a lot of people thought and still do some places. But we've found that early intervention may yield better results by limiting the degenerative effects of denervation, enhancing accelerated regeneration of motor neurons. But the challenge is that there's no clear patient, tumor, or intraoperative factors that over time had been reliably predictive. This is just an intraoperative video of us doing a nerve anastomosis in which we put a small piece of a vein on top to protect the anastomosis. So the dilemma becomes, what do we do? Do we wait for spontaneous recovery greater than 1 year, or do we proceed with early grafting? The risk of waiting is that you risk increased degeneration. The motor end plates of the muscles may atrophy and be non-functional ultimately if too much time has elapsed, and you decrease the success of subsequent facial reanimation surgery. If you proceed with early grafting, there's a risk of premature intervention, perhaps, and you can be injuring a recovering nerve that may otherwise have come back on its own and therefore performing unnecessary surgery. So to study this more, my mentor, Dr. Patrick Byrne, and his colleagues at Hopkins, Dr. Bohini, wondered and did a study looking at early nerve grafting for facial nerve CPA tumor resections with preserved facial nerve continuity. They basically used a postoperative rate of recovery model and selected patients who would be candidates for early nerve grafting. These were in patients who had intact facial nerves, and they hypothesized that patients undergoing early facial nerve exploration for grafting would have no contraction after direct EMG stimulation at the time of surgery. And they thereby hypothesized that if there was no clinical return of function after 6 months from the resection, then the facial nerve function would likely remain poor after 18 months or longer without any intervention. So they looked at 62 patients with facial paralysis immediately following tumor resection. The majority of them were from vestibular schwannomas. The average tumor size was 2.8 centimeters. Recovery after resection was variable. So 57% of patients had some recovery over 6 months, and therefore they were not candidates for surgery. But 43.5% had no recovery by 6 months. And for these patients, they offered them all surgery. So 19 patients agreed to proceed with surgery, and 8 of them declined. What's interesting is the 8 that declined surgery that had no surgical or had no recovery in the first 6 months went on to have no improvement, no meaningful improvement after 20 months, and were at House-Brackman 5 or 6. So inclusion criteria, they included patients that were House-Brackman 2 or higher at the onset of paralysis, but the majority of the patients that underwent surgery were House-Brackman 5 or 6, and they excluded anyone with a pre-existing facial weakness, prior radiation, or transected facial nerve. Patients that had no clinical recovery in the first 6 months, as I mentioned, were offered surgery, and this was by 12 months after resection, and then another group of them had surgery after 12 months. And they either had a masseteric nerve transfer or a hypoglossal nerve transfer, as we went over, and the choice of which is patient-dependent based on a number of factors that are beyond the scope of this talk right now. All patients intraoperatively underwent EMG to check for facial nerve response. So in these 62 patients, 27 had no recovery by 6 months. Again, 19 agreed to surgery and 8 declined. We measured, or they measured in their study, improvement and change by looking at the oral commissure excursion. And you can see here they measured from the lateral medial canthus to the oral commissure in these patients. And then they looked at the difference in the measurements on both sides for symmetry. 10 patients had reanimation surgery in less than 12 months, so that's the early group, and 9 had it in greater than 12 months. So 100% of surgical patients that had their facial nerve explored, whether it were less than 12 months or greater than 12 months, had no detectable EMG response intraoperative, which is important, and there were no false negatives therefore found. These are photos from their paper, just showing you on the top row, A through D, you can see this is a postoperative result. He has complete paralysis of the left side of the face. He's 6 out of 6 House-Brackman. And you can see following a masseteric nerve transfer, this is approximately 9 months postoperatively, you can see that he has really good movement when he's biting, and he has really, really nice oral commissure excursion here. So in summary, we found that delaying nerve grafting after 12 months yielded actually similar smile recovery and correction of asymmetry when they compared them to nerve grafting in the greater than 12 months and the less than 12-month groups. They did find that masseteric nerve graft recipients recovered earlier than the hypoglossal nerve grafts, which makes sense because the masseteric nerve is much closer to the intrinsic facial musculature. So those patients, that takes less time for the regeneration to occur. And this was similar in those that underwent less than 12 or greater than 12-month intervention. It should be noted that when you perform these surgeries later, however, especially a hypoglossal to facial nerve transfer, this takes much longer to regenerate given the time. And if you think about the duration of that being 10.8 months, if you did the surgery on a patient greater than 12 months, you may be out of the window in terms of the musculature and may have a poor outcome. What they hypothesized was, since every patient that they stimulated intraoperatively had no EMG result or function at the time of surgery, they're saying that we now advocate for early intervention and that waiting is an unnecessary prolongation of paralysis for these patients. Patients should be counseled early for nerve grafting as early as 6 months in those patients who have, like in this study, an uninterrupted facial nerve, and if they've had no significant clinical recovery up until that point. And that satisfactory facial function recovery is unlikely when there's no clinical evidence of spontaneous regeneration within that first 6-month time period. So let's talk about what we do in patients who have had paralysis for greater than 24 months. Perhaps they had an intact facial nerve and they were lost to follow-up and they come back to you and they're 2 years out now. Now we have to talk about, the facial muscles have been irreversibly injured. The motor end plates have degenerated and there's been atrophy. So you can no longer just do a nerve transfer to the intrinsic musculature. We have to do smile restoration surgery at this point, which is going to usually and often, almost always, require a transfer of a functional muscle unit. And we want one that's going to mimic the function of the paralyzed facial musculature. And we do this with a gracilis free flap. This is an image from Stanford's Facial Nerve Center, but in general, historically, the gracilis was harvested as a single vector muscle, and it was placed and inset in a space to kind of mimic the zygomaticus major muscle, which we know is not the only muscle that contributes to smile. So in this flap, we have found that the muscle fibers run parallel to the facial musculature. So it's really a fantastic option for facial reanimation, and that it has a really great force generation and excursion for smile. It's bulky. It requires modifications intraoperatively that we do during harvest and inset. And prior to 2010, this was designed as a single paddle with one vector of excursion to mimic the zygomaticus. But this limited the natural Duchenne smile that I've been referring to, which involves not only the zygomaticus, but also the levator labii. So my mentor, Dr. Patrick Byrne, kind of put a spin on this and created what he calls the trivector gracilis free flap. And so we harvest the gracilis in a similar fashion, and we break it into 3 vectors. We then inset it in the face, not just with one vector, but with 3 separate vectors. And the third actually goes on to mimic the orbicularis oculi muscle. We innervate it using the masseteric nerve and a cross-face nerve graft that usually has been placed prior. And we attach, we do neurovascular anastomosis to those arteries and veins in the face. Let's go back here. And we find that this really gives quite an excellent result when compared to a univector gracilis free flap. And again, this is in patients who have not been innervated before. This is intraoperative stimulation of a gracilis. This is a dual vector. You can see we haven't yet dissected out the third vector, but you can notice that you can actually kind of manipulate this gracilis, and when you place it on the face intraoperatively, you can mimic those muscles really nicely. This is one of Dr. Burns' results using this method. So you can see on the left postoperatively complete paralysis of the face. You can see a lower lid ectropion. She has scleral show. There's almost no dental display on the right side when comparing the incisors. And if you see on the photo on the right, you know, not only does she have oral commissure excursion, creation of a nasolabial fold, but she has really nice periocular wrinkling that has never before been possible without using this technique. So you can really give them a smile that looks natural, not just in the lower half of their face, but also in the upper. And this is what we're calling that Duchenne smile. So in conclusion, we recommend counseling patients at 6 months for early nerve grafting in uninterrupted facial nerve patients after CPA resection with no clinical recovery during that time. Recovery is unlikely when there's no evidence of spontaneous nerve regeneration in 6 months. And if you go in early and do grafting, you can stimulate at that time of function and at the time of the surgery and abort if necessary. Outcomes are similar when you do it 12 months, greater than 12 months, or less than 12 months. However, if you wait too long after 12 months, you have to think about that hypoglossal nerve transfer and whether or not the motor end plates of the muscles are going to be functional by the time your signal reaches there. And so doing this early, we will decrease the duration of paralysis and increase the quality of life and functional recovery for these patients. And then just remember that patients that are outside of this transfer window should be undergoing free muscle transfer with a gracilis flap if they're appropriate candidates, and that innovations with dual or trivector gracilis from Dr. Byrne produce this more natural Duchenne smile that we now are able to offer patients. So with that, I'd like to thank you for having me today speak, and thanks to Dr. James Liu for getting me involved in this. I would appreciate any questions, and thank you so much for your time.
Yeah, thank you, Kristen. Pretty impressive. Okay, any comments or questions from the panel?
Thank you, Kristen, for your valuable presentation. Thank you.
Thank you.
Okay, thank you, Sam. Okay, we move to the last speaker of the day, Michael Sabel. Thanks for waiting, Michael. Michael is a neurosurgeon from Dusseldorf. He specializes in neuro-oncology. Okay, Michael, it's all yours.
Thank you very much. So, I think you can see me and hear me?
Yes,
okay.
Good.
Okay, I need to start with a confession. I'm not a skull-based surgeon. I'm just made it to neuro-oncological neurosurgeon, but nevertheless, I guess that me and my group have something to discuss, which might be interesting for the skull-based community. And that is, to some extent, neuro-oncological neurosurgery is fluorescence-guided neurosurgery. And I just want to refresh your memory because we are talking about fluorescence-guided surgery towards the two major players that we have, the 5LA and the sodium fluorescence. So 5LA is well known, and it is basically working by degradation 5-aminoleic acid to protoporphyrin 9, and this accumulates within the malignant glioma cells very specifically and can be detected by putting blue light on the brain. And that was definitely a game changer in neuro-oncological neurosurgery because using this technology, we were able to definitely identify the tumor cells. Now, this resulted by the work of Walter Stummer, who was at that time working in our department, into the results of a study that showed that if you use 5LA, you have a much better chance to get a complete resection of the tumor, gross total resection. That resulted ultimately into better and superior survival of our patients with a glioblastoma. And that is also to some extent true for sodium fluorescence, which is a different fluorescence, which works, gives another signal, and which works completely different because it's basically only indicator of the disruption of the blood-brain barrier. However, the intraoperative visualization of this dye is basically corresponding to the T1 contrast enhancement of the lesion. And it's highly specific and sensitive for GBMs. And there are some data indicating not on the level that we have for 5LA, but nevertheless that it's very useful for the resection or achieving gross total resection of glioblastoma patient, the glioblastoma patient. So what is interesting for skull-based neurosurgeons, obviously, the role that this fluorescence-guided resection plays for meningiomas and metastasis. There are some data. So sodium fluorescein resection of brain metastasis definitely resulted in a superior resection of metastasis. However, 5LA, and that is the work of my group, demonstrated that we could identify the tumor, but the crucial interface between tumor and surrounding tissue was controversial. And what we discovered is that you cannot really rely on that.